the non-pharma counter. It's near the non-pharma. Please collect it because we have a wonderful fashion show this evening. So while we learn really hard, we'll party really hard in the evening. So make sure that you come dressed for the occasion. Please do pick up your outfits. Thank you so very much. Over to you, sir.
Okay. Good morning, everyone. So shall we begin? Yeah. May I now request our first speaker, Dr. Ranjan Kumar Patel, to please come on stage and discuss about transjugular versus transfemoral liver biopsy. It will be a case-based discussion. Dr. Ranjan.
A very good morning to all and thank you to the ISVIR for giving me the opportunity. So in the next 10 minutes we'll discuss about the transjugular versus transfemoral liver biopsy, when to consider transfemoral and when to consider transjugular. All of us know what is transvenous liver biopsy and what are the indications of transjugular liver biopsy. As an alternative to transjugular liver biopsy, we can perform transfemoral liver biopsy, either it can be through transcaval or through hepatic vein. So the first question is transfemoral liver biopsy a viable alternative to transjugular liver biopsy? So till date we have enough data to say yes, the transfemoral liver biopsy is as good as transjugular liver biopsy in terms of technical success and also in terms of histopathological success. And particularly in certain situations like Fontaine circulations, where hepatic vein cannulation from the jugular aspect is difficult, in such cases transfemoral remains the biopsy of choice while needing a liver biopsy. So one of the recent data that compares transfemoral transcaval versus transjugular liver biopsy, it says transfemoral liver biopsy is non-inferior to transjugular, and interestingly if you see the timing of the transfemoral liver biopsy is faster than transjugular, and major complications is also less as compared to transjugular, because in transfemoral route we are not going through the cardiac aspect, so the risk of cardiac arrhythmia is almost ruled out. And as we puncture from the below to up from the femoral aspect, the chances of injury to the central hepatic vessels in the porta hepatis is less. So the chances of hepatic arterial or venous related bleeding is also less in transfemoral biopsy. So this is one of the case. Initially we attempt from the jugular aspect, but due to the difficult angulation of the hepatic vein with the IVC, we could not cannulate the hepatic vein. So we also tried the transcaval, but the waist position of the stiffening cannula is not stable. So we thought to go ahead with the femoral aspect. So you can see from the femoral, the cannulation of the hepatic vein was very easy, and after the cannulation we insert the long sheath, and then we take a venogram, and then we did the biopsy from the transfemoral route. Simultaneously, like transjugular, we also simultaneously see under the ultrasound guidance where the needle is passing while we are advancing the needle. And you can see we could obtain a good biopsy core like transjugular liver biopsy. So this was done via the right hepatic vein. So from the femoral to cava to the right hepatic vein, and then we did the biopsy. Again, this is a second case. Initially, we thought to go ahead with the transjugular aspect, but on ultrasound, there was a acute angulation of the hepatic vein, right and middle hepatic vein. Fortunately, we found a right inferior accessory hepatic vein which had a favorable angle with the IVC. So in this case, upfront we thought to go ahead with the transfemoral approach. So initially we cannulate the inferior accessory hepatic vein, and then we did the biopsy from the inferior accessory hepatic vein. So we have done 4 to 5 cases of transfemoral liver biopsy through inferior accessory hepatic vein, and we have noticed that the presence of inferior accessory hepatic veins provide better wedging, as well as we are wedging the inferior hepatic vein, we have a longer length of hepatic parenchyma in the cranial aspect, so there is a less chances of transcapsular puncture also. So this was done by right inferior accessory hepatic vein. This is a recent case On CT and ultrasound, there was hepatomegaly and there was congestion in the liver. We suspected there is something at the RA-IVC junction, and the CT and ultrasound was not conformatic, so we planned for a simultaneous hepatic and IVC venogram. So initially we take a femoral excess, and then we took IVC as well as hepatic venogram. The IVC and hepatic veins were fine. So we thought to take a biopsy. So as we had a transfemoral excess in situ, we thought to take biopsy simultaneously in the same setting. So using that rope set, again we give a little bit more angle to the rope set and then directly puncture from the cava to take a transfemoral transcaval liver biopsy. So this was a transcaval transfemoral liver biopsy. We did this because we had a transfemoral excess in situ for the IVC venogram. And this case turned out to be a hepatic amyloidosis. So one point to remember, when we are doing a transfemoral transcaval liver biopsy, the first thing you have to do, you have to give a little bit more bend to the stiffening cannula of the TJLV gun. And whenever you have a IVC and RHV junction, you have to take the pass at least one vertebral body below the hepatic vein ostium. If you puncture the cava more below than that, then there is a chances of puncture extrahepatically, and there is a more chances of injury to the adjacent structures and vessels. So this point has to be remembered. One vertebral body below the level of hepatic veins, you start puncturing. This is not the transfemoral liver biopsy, but this is the extension of the transfemoral puncture. We had a case of Badkari with hepatic vein ostium occlusion. So we could not cross the occlusion from the transjugular route. As an alternative to percutaneous route, what we did, we give more bend to the stiffening cannula. We puncture the hepatic vein from the transcaval route via the transfemoral route, and then antegradally we cross the stricture into the heart, and then we did the we did the hepatic vein plasty through the transjugular loop. So this can be used as an alternative to percutaneous hepatic vein access if you are comfortable with the transfemoral puncture. So to summarize, what are the indications of transfemoral liver biopsy? Obviously, if you don't have any transjugular excess like IJB or SPC thrombosis, if you are planning for a simultaneously IVC intervention, then also you can go ahead with the transfemoral liver biopsy. Fontaine circulations in patients with hypoplastic left heart syndrome were top cases where there is difficult angulation of the hepatic vein from the jugular route. In such cases also, transfemoral liver biopsy remains the choice of biopsy. And obviously, if you have difficulty in transcaval liver biopsy, then alternatively you can go ahead by a transfemoral route. So what are the advantages of transfemoral route? You have a faster hepatic vein recatheterization, and if there is a very shrunken liver and there is upturn of the MHV or RHV, then you may have a favorable angle of the hepatic vein cannulation from the femoral route. So you can attempt an transfemoral route. If you are planning for simultaneously IVC intervention, again transfemoral has an advantage and Fontaine related circulation. But there are certain challenges. What are those? In transfemoral and transcaval liver biopsy, often you need to have a more angle of the stiffening cannula because you need more better wedging across the cava. And in patients with very firm liver, then you may face inadequate wedging and difficulty in passing the needles.
Last 2 minutes.
As you are going through a transfemoral route, then you have to take bed rest for the 1 to 2 hours because you are taking a femoral route. So immediate ambulation may be an issue if you are doing in a OPD procedures. So to take home message, transfemoral liver biopsy is a viable alternative. And in terms of technical and histopathological success, it is not inferior to TJLV. The preliminary imagings can help choose whether you have to go ahead with the transfemoral or transjugular. And as you are not going through the heart, it eliminates the risk of cardiac arrhythmia, particularly in vulnerable patients. And in terms of hepatic vein cannulation, the hepatic vein cannulation is much more easier through the transfemoral route. So it is less time consuming, and you can attempt a transfemoral liver biopsy if there are situations where jugular liver biopsy seems difficult. Thank you.
So, Ranjan, yes, very nice presentation. You have given a very good overview of the transfemoral, and it will be more exciting. I'm sure a lot of people will be doing that. So, do you have a head-on like comparison of the transjugular access and transfemoral access? How much time it will require to complete the procedure, and how much fluoro-dependent you are? Because most of the time transjugular you are very less fluoro-dependent. So, in transfemoral access, how much fluoro time you need?
Sir, actually, we haven't compared head-to-head transjugular versus transfemoral, but in our case of around 25 to 26 cases, what we have noticed, the hepatic vein cannulation time is very less, and if you have a favorable angle to the hepatic vein from the IBC, then the transfemoral liver biopsy seems to be much faster than the transjugular liver biopsy.
So, you favorable angle you decide on the CT scan or on
CT
the
scan and ultrasound, sir,
ultrasound
whenever
both.
the veins looks good.
And my second question is because most of the time your needle is directing towards the diaphragm and towards the lung. So if there is a diaphragmatic excursion, your patient is taking breathing, normal breathing. So there is every chance sometimes you can hit the diaphragm and there might be a possible fistula with the lung. So do you ask the patient to stop the breathing when you take the biopsy?
Yes, sir. We ask the patient to stop the breath for a while we are passing the biopsy needle, and also simultaneously we see under the ultrasound guidance where the needle is actually traversing.
Like you performed 20-25 cases transfemoral liver biopsy. So are all these cases which you performed subsequent to failure of the transjugular approach, or I mean you had based on the imaging itself you had decided, okay, these cases I'm going as a first approach as a transfemoral approach?
Sir, most of the cases when we found difficulty in transjugular liver biopsy, then only we converted into transfemoral liver biopsy. In few cases where
Time is up.
inferior accessory hepatic veins were seen on CT and ultrasound, then upfront we tried for transfemoral, and in certain cases where simultaneously IVC angioplasty and IVC run was to be planned, then in such cases we attend. But most of the cases we did only after failure of transjugular liver biopsy.
And almost all cases were technical success with transfemoral?
Around, sir, 2-3 cases we didn't achieve the adequate wedging against the IBC, so that case failed. 2 cases.
Okay, thank you.
Thank you.
Now I call upon the next speaker, Dr. Rajesh Shashidharan, to dwell on optimizing patient selection for tips, and he would be dwelling on simplified algorithmic approach for the same. I think he's not here.
Good morning. I'll be talking about a simplified algorithmic approach to selecting patients for TIPS. TIPS is a procedure that can affect multiple organ systems. It affects the liver because it's going to divert the portal flow, decrease the portal perfusion, and it can cause acute liver dysfunction or even liver failure. It affects the brain because it can cause hepatic encephalopathy since it is a portosystemic shunt. It affects the heart because after TIPS, all the mesenteric blood is now going to bypass the liver and go into the heart, increasing the cardiac preload, and it can precipitate congestive heart failure or pulmonary artery hypertension in patients who already have pre-existing cardiac issues. And it affects the kidneys, usually in a positive way, but since we are using contrast, it can precipitate acute kidney injury. Now, TIPS is very effective at reducing portal pressures, we all know that. But since TIPS is going to affect multiple organ systems and it can cause complications, some of which can be potentially life-threatening, you have to be very careful when you are selecting patients for TIPS. It's like walking a tightrope. You have to weigh the risks against the benefits. And multiple studies have shown that the outcomes of TIPS are more dependent on the TIPS patient selection rather than the technique itself. So how do you select patients for this? To begin with, it's a good idea to stratify your patients according to the indication of TIPS. So we can broadly have an emergency TIPS or an elective TIPS. Emergency is usually for variceal bleed, salvage, rescue or preemptive TIPS. And elective is either for secondary prophylaxis of varicose bleed, which is like a semi-urgent situation. And the most common indication for elective tips is ascites. Now, as a general rule, it is easier to select patients for an emergency tips because these patients are quite sick. If you don't do tips in them, they are likely to die. So the usual contraindications of tips that we keep talking about, they do not apply here. You can say yes to pretty much anything. But as we move down from emergency to a more elective setting, like tips for ascites, things become much more complex. Because here you are not trying to save the life of the patient, you are trying to improve the quality of life of the patient. So if a complication occurs, it will be less acceptable to the patient and the relatives. Moreover, these patients usually have multiple comorbidities and they have exhausted their liver reserves. So they are more prone to develop complications. So that is why if you see the arrow on the right, it goes from green to red, because when you are moving from emergency to an elective setting, the chances of complications will rise and the list of contraindications will also rise. So let's talk about the emergency situations where we do tips first, because that's the easier part. In order to understand when we do tips in varicose bleed, we need to know the timeline of the bleed. You have a patient coming to you with a bleed. You try an endoscopy. It was not successful because the stomach was full of blood. They could not band, could not glue. They send the patient straight away for a tips. That is called as a salvage tips. Second situation, the initial endoscopy was successful, but the patient had a rebleed within the first 5 days. And you do a tips. That is called as a rescue tips. So there is a subtle difference between the salvage tips and the rescue tips, and accordingly the prognosis will also vary. The third situation is when the initial endoscopy was successful, but since the patient is at a very high risk of developing a rebleed, either because of poor liver functions or very high liver pressures, you do a tips to prevent a rebleed within the first 5 days. That is called as a preemptive tips. So all these three are emergency indications of tips. Even a preemptive tips should ideally be done within the first 24 hours or at least within the first 72 hours. The fourth situation is when the endoscopy was successful, patient went home, but he had recurrent bouts of bleeding which were more or less well controlled. So this is like a semi-urgent tips, which is called as tips for secondary prophylaxis. Now, emergency tips or salvage, rescue or preemptive tips, like I said before, this is a life-saving intervention. So the usual contraindications of tips like hyperbilirubinemia, hepatic encephalopathy, even active severe hepatic encephalopathy, coagulopathy, acute on chronic liver failure and severe pulmonary hypertension, these are not contraindications to an emergency tips because you are trying to save the life. If something happens due to tips, you can always manage it later. This is not me saying, it's there in the guidelines. Having said that, there are some situations where you would not want to do even an emergency tips. First is an arterial lactate of more than 12, and second, which is written last, is uncorrectable hemorrhagic shock. So these are two situations where you would rather not do even an emergency tips because the outcomes have been shown to be uniformly poor. The other three factors, MELD of more than 30, CTP more than 13 and Apache 2 score of more than 20, these are relative contraindications. You can go ahead, but you have to counsel the patient and the relatives accordingly. So if we summarize the emergency tip scenario, try to rule out the absolute contraindications first, get an arterial lactate, see whether the patient is responding to fluids. If that is okay, you can go ahead. Coming to elective tips, of which ascites is the most common indication. Now when a cirrhotic patient comes to you with ascites, we don't straight away send for tips. We do what is called as a step-up approach. The first step is dietary sodium restriction or salt restriction. Then we add albumin and diuretics. Once the patient stops responding to diuretics or develops some complication to diuretics, that is when we start tapping the patient. And when this tapping frequency reaches a certain level, we try to send the patient for a transplant. If, however, the transplant is not possible for some reason, that is when you would try to persuade the patient for a TIPS. Now, the advantage of this approach is that you can delay transplant and TIPS in a significant proportion of patients. But the obvious disadvantage is that by the time the patient reaches you for a TIPS for ascites, he or she has already developed multiple issues. Sarcopenia, renal dysfunction, dyselectrolemia, they might have had multiple episodes of encephalopathy, even sepsis. So they are poor candidates for TIPS. They are more likely to develop complications. That is why, contrary to the emergency situation where you do a TIPS, in the elective setting, you have to be much more careful. Now, we have already seen that TIPS affects multiple organ systems.
Last 2 minutes.
So when you are trying to, I thought I had 15 minutes. I'm sorry. I was told I have 15 minutes.
Yeah, you can carry on.
And carry on, because one speaker is also missing.
Okay, thank you. So before you say yes to a TIPS for ascites, you have to evaluate all these organs separately. We'll start with liver. One thing I want to highlight here is that there is no absolute MELD cutoff beyond which you will not do a TIPS. Don't let anybody tell you that this patient has a MELD of 20, so you should not do a TIPS. The reason is MELD is dynamic. Creatinine and sodium can change if you medically manage the patient properly, especially if it is due to hepatorenal syndrome. Having said that, a MELD of more than 24, CTP of more than 11, and total bilirubin of more than 3, here you would be a little careful. You can still go ahead, but you would be careful. A MELD of more than 30, CTP of more than 13, that would be a situation you would rather not do an elective TIPS. So I think that is where you have to draw a line at a MELD of 30, not at a MELD of 18, which much of the older literature suggests. Second is hepatic encephalopathy, which is the most common complication of TIPS. One thing to remember here is that apart from liver, kidney and muscles have a role in ammonia metabolism. That is why you are seeing all these factors. It has liver related factors, kidney related factors like hyponatremia and renal dysfunction, and sarcopenia. All these are going to increase the risk of post-TIPS hepatic encephalopathy. And on the top of all this, any prior history of unprovoked hepatic encephalopathy, the patient would be at risk of developing HE again.
Time is up.
Third is cardiac workup, which is often ignored, but it's very important. You have to get an ECG and a comprehensive echo. What you're trying to see is ejection fraction, diastolic dysfunction, pulmonary hypertension, and valvular disease. So any of these are positive, it would be a contraindication to TIPS. Pro-BNP is optional, just gives you additional information. And last is renal factors. Again, just like liver, there is no absolute cutoff for serum creatinine, eGFR, or even CKD stage. You can go ahead with the TIPS. The problems are that, like I said before, kidney has a role in ammonia metabolism. So these patients will be at risk of developing encephalopathy more. Plus, they have a heightened risk of infections and pulmonary edema. So you have to manage these patients accordingly. AKI is a strict contraindication. Any patient who has an acute kidney injury, you have to find out why it is there, correct it, and then go ahead with TIPS. So once you have evaluated all the organs, just like in emergency TIPS, rule out the absolute contraindications for elective TIPS. Mainly cardiac, congestive heart failure with an EF of less than 50, severe pulmonary hypertension, pulmonary artery pressure. pressure of more than 45 and right atrial pressure of more than 15. Severe uncontrolled hepatic encephalopathy. Uncontrolled sepsis, very important. CTP of more than 13, basically very poor liver functions. And any anatomical barriers to shunt creation like tumors or unresolved biliary obstruction or cysts. Now, once you have ruled out all these absolute contraindications, you try to fit in your patient into one of these three boxes. The green one is where the benefit would be more than risk of TIPS. Orange is where the risk and benefit would be equal, and red is where the risk would be more. You can go ahead with an elective TIPS in any of these scenarios, but the patient and the relative counseling is going to become very important. Now, I promised you an algorithm. Here it is. You get a referral for a TIPS. See the indication first. Is it for variceal bleed or for difficult to treat ascites? If it's for
Time is up.
variceal bleed, whether it's an emergency TIPS or it's for secondary prophylaxis, which is like semi-urgent. If it's an emergency TIPS, rule out the absolute contraindications first. Most important, get an arterial lactate more than 12, it's an absolute no-no. MELD more than 30, CTP more than 13, and uncorrectable hemorrhagic shock, equally bad. Remember the usual contraindications: bilirubin more than 5, active hepatic encephalopathy and coagulopathy are not contraindications to an emergency TIPS, and please don't transfuse FFPs to these patients, it's not going to help. If it's an elective setting like secondary prophylaxis of bleed or difficult to treat ascites, again rule out the absolute contraindications first, get all the workup done, see whether the heart is working okay, any recurrent or active hepatic encephalopathy, sepsis, extremely poor liver functions. If these are all okay, then you stratify the risk according to the three boxes I showed and counsel the patient accordingly. Thank you.
Yeah, thank you, Dr. Rajesh, for your wonderful presentations, and thank you for showing this algorithm. I'm sure it will be very helpful. So do you have any evidence-based this algorithm when you prepared this?
The boxes that I showed, the risk stratification, that is taken from the EASL guidelines, which
Okay.
came out last year on TIPS, and the algorithm is all mine.
Okay. So another question is, when you were just preparing the this algorithm, you did not show anything regarding to inflow modulation like splenic artery embolization. So in what context you will say that you will not go for TIPS, rather you will go for an inflow modulation, like go for a splenic artery embolization, something like
Okay,
that?
I think
That will
depends.
also sometimes it will come in the context of TIPS.
Yeah, so since my talk was focused on TIPS, I didn't talk about splenic artery embolization.
No,
I
no,
think
just in
there
the
are-
algorithm. I was asking, for example, if showing you said encephalopathy, hepatic encephalopathy. So if a patient has a recurrent hepatic encephalopathy, in that case, you will go for a TIPS or maybe a splenic artery embolization will help in this context.
I think there is still not enough evidence that tells you that splenic artery embolization is going to prevent the development of HE or even resolve an active HE. Depending on the indication, if it's a bleeder, I will not worry about the encephalopathy. If it's for ascites, then there are some things that we can do. If we have to do a TIPS, smaller diameter TIPS, work out the anatomy well, do your technique well, do prophylaxis of 2 weeks for rifaximin if it's an elective setting. Those kind of things can be done.
And
I
you said
would
you
rather go
depend-
for that rather than doing a splenic artery embolization.
You said you are looking at the MELD score. So have you tried MELD sodium score? Because there are a lot of literature coming with a
So-
modified MELD score in the form of MELD sodium score.
Yeah, so there is MELD, there is MELD sodium, and now there is MELD 3.0, and even there are multiple other scores also like FIPS. So we still prefer MELD sodium, not MELD 3.0 or MELD. Although MELD sodium is more dynamic, and the studies are all on MELD rather than MELD sodium, but we tend to prefer that. And like I said before, we don't calculate MELD at all. We look at all the individual factors. We look at the bilirubin, we look at the creat, sodium, all these things, and see whether there are any modifiable risk factors. If you have a patient with hepatorenal syndrome related acute kidney disease, the creat is 2.1, sodium is 114 or 115, You start early pressing, the creat settles. The sodium usually improves with medical management. So that MELD is going to come down. After tips also, the sodium is going to improve, the creat is going to
Time
improve.
is up.
So that is why we actually do not look at MELD at all. We look at the individual factors and then decide what to do.
Yeah, that was a very nice presentation, Dr. Rajesh. What is the reason you think is for the substantial increase in the MELD score from 19 as such, which we used to conventionally consider, and 30 now? So what is the, I mean, there is a substantial increase in the, when you are talking about contraindication or when to be careful not to go for.
Yeah.
So there's such a high jump as such in the score.
So like I said, there are 3 stages, or rather 3 stations, MELD 18, 24 and 30. Between 18 to 24, I would be careful. I would see, suppose I have a patient with a bilirubin of 10 and MELD is high because of that. I would not do a TIPS because that bilirubin is unlikely to come down. But if there are modifiable risk factors and then MELD can come below 24 and close to 18, because like you know, most of our patients who come to us for ascites, they will have a MELD of more than 18, most of them. So you can't say no to everybody. But 30 would be where I would draw a line, because even if you modify all the risk factors, still it is too high to get, give the patient any sort of a benefit. So it's all arbitrary, but like I said, we don't look at MELD at all. Since I was talking about an algorithm, I thought I'll give some values, but I would rather look at the individual parameters rather than a score.
Okay, thank you. Any questions from the house, if anybody has?
Dr. Rajesh.
Thank you. My first question is to Ranjan. In any experience with post-transplant transfemoral liver biopsies, and how soon can you do? Second question is to Dr. Rajesh. So in a patient who is a very high-risk candidate for hepatic encephalopathy, I'm just asking, thinking out loud, if you deploy an 8 mm stent and dilate it up to 6 or 7 mm and then wait for it and then go in, is that a strategy that would seems reasonable? Or will the stent eventually open up to 8, just like in the peripheral vascular, considering the stiffness of the liver, will it stay at 6?
Okay.
So is it a reasonable strategy?
So I'll answer first. So there is a lot of controversy about passive expansion of tip stents. The initial studies told you that even if you dilate it to 6 mm or 7 mm, after 3 to 6 months, ultimately the stent is going to become 10 mm. But then some studies came up which told you that it depends on the patient, it depends on the liver. Not all stents are going to expand, first. Secondly, even if the stent expands after 3 to 6 months, you still have time, in the sense that liver can accommodate the factors which are going to increase the risk of HE, can be modified, it might get better. Like sarcopenia, studies have shown that post-tips 1 month sarcopenia will improve. So
Time is up.
since we do not have controlled expansion stents till now in India, we at our center, we still do calibrated stent expansions. We'll still put a 10 mm stent, dilate it to 6 mm, see the pressures, and then dilate more if needed.
Thank you.
Thank you.
Sir, in post-transplant setting, actually, I don't have personal experience, but presently the anastomosis is more to the lateral caval wall. So usually what happens during transjugular liver biopsy, we have a downward and then upward angle. So it's getting difficult to get into the hepatic veins from the jugular. So in that cases, transfemoral liver biopsy seems to be more easier and feasible than transjugular. But personally, I don't have any experience.
Yeah, now I think we have discussed it enough. I'll thank both the speakers, Dr. Ranjan and Dr. Rajesh, for the beautiful sessions, and thank you for the algorithm as well.
Thank you.
Thank you.
Thank you so very much to our chair people and to our wonderful speakers. Ladies and gentlemen, next up we're going to have a panel discussion. The moderator for this session will be Dr. Sanjeeva Kalwa. They're going to be discussing portal hypertension, and I invite our wonderful panelists to join us on the stage, Professor Mohammad Rela, Dr. Saad, Dr. Ashwin Ramohan, Dr. Amar Mukund, Dr. Rajesh Sasidaran, Dr. S.S. Bejal. May I please invite all of you onto the dais? Ladies and gentlemen, with a big round of applause.
Welcome to ISVIR 2026 Mahabalipuram. Hi, I am Ira, your interventional radiology assistant from MEDAG, and I will be your time ninja for the entire conference.
Well done.
Just a gentle reminder, please download the app. You can leave your questions there in case we don't have time. Our experts will answer it later, and some of the questions will also be flashed right here on the screen. So just a gentle reminder for that. Thank you so very much. Over to you, sir.
Good morning, everyone. Thank you for coming to the HBP session. This is a panel discussion. We have distinguished panelists here. I'm so happy to see two surgeons, Dr. Rayla and Ashwin here, and 3 interventional radiologists, actually 4 interventional radiologists there. We will have a good discussion. I'll start with an interesting case that I have done this almost a year ago, and we'll ask what panel would do. And none of them had seen this case. It will be very new for them too. So it will be open, real, true, open discussion of the case. So we'll start here, the history. This is a 73-year-old Asian woman. Patient was diagnosed with non-cirrhotic portal hypertension due to chronic portal vein thrombosis, and the patient was on anticoagulation. Medical history was significant for interstitial lung disease and polymyositis. Patient presented to the hospital with recurrent right pleural effusion and diagnosed hepatic hydrothorax and requiring thoracentesis every 3 to 4 days, and each time they were draining 1 to 2 liters. Her life was miserable because she has to come to hospital for thora every 3rd day, and they wanted some permanent solution. And labs were normal bilirubin, INR was 2, platelets were 70, and she is child A. I didn't calculate the MELD, probably around 12 to 13 MELD. So patient underwent a CT scan here. As you could see, this is an arterial phase CT of the abdomen, and most of you can easily recognize this is arterial phase. And in the arterial phase, you see early opacification of the right portal vein. The left portal vein is normal, main portal vein is normal, and the splenic vein is normal, and the supramesenteric vein is normal. At least in the arterial phase, all the blood in the right portal vein is coming from the right hepatic arterial circulation. So our instant diagnosis is some sort of fistulous communication between the hepatic artery and the right portal vein. And then with the portal venous phase, which showed intrahepatic portal veins and hepatic veins being patent, but the extrahepatic main portal vein has thrombus. So first question to Dr. Weil Saad. So in this case, given that there is early opacification of the right portal vein, what would be your differentials in this case, and what would you do next in this case?
So there's a, it's an arterioportal fistula. It's intrahepatic arterioportal fistula. You've got areas of enhancement out in the periphery. Your portal hypertension may be from the fistula itself and not kind of generalized portal hypertension. To look at it and kind of try to quantify the arterioportal fistula's connection.
Thank you. That's what that was done. So this is done at a different hospital. So this is the first angiogram, transradial approach. The celiac angiography clearly shows an abnormal arteriovenous communication in the right lobe of the liver with draining into the portal system. The entire reversal of flow in the main portal vein, all the hepatic arterial flow is coming, which increases the portal hypertension, and then that leads to hepatic hydrothorax. So now I would like to ask one of the surgeons, either Rela or Dr. Rela or Ashwin, to see what would they consider in these patients. Would you still approach any endovascular therapies, or would you consider this patient for transplant or any other stuff?
Why would you consider this patient for a transplant? That would be the last thing that I would think about. Actually, this is a little unrecognized problem. I mean, this was very obvious because this was presented as a non-cirrhotic portal hypertension. In fact, there are many patients with HCC who has this phenomenon. They look like they are decompensated from ascites. Actually, it's the large fistula. You can see the portal hypertension. The portal hypertension you would get out of a large arteriovenous fistula is much more severe than the portal hypertension, that cirrhosis you get. And it really looks like severe decompensation. I would embolize it, and I'm sure Deepashri has done many of those. And I even saw a patient in the clinic 2 days ago with the HCC and an embolus who's got recurrence of the fistula, going to come back to you again. So symptomatically, they would improve dramatically. I don't think the thrombus there is related to this anyway. I would ask if there is a history of biopsy really in this patient, liver biopsy in this patient. And the other thing you would think about really is a HCC, which may even be small in size. But usually they will have venous embolus as well associated with it.
Thank you. So as Weil and Dr. L has mentioned, the differential could be post-biopsy arteriovenous fistula or congenital classic arteriovenous malformation with multiple feeders, and the third thing is intrahepatic tumor that is shunting blood. If it is a fistula, it's only one artery to one vein. If it is a malformation, you will have multiple feeders and multiple draining veins. If it is a tumor, you will see the tumor enhancement even in the venous phase. Washout will be seen better. So those are three different.
This cannot be congenital. I've seen them congenital. They present with severe portal hypertension at a very early age.
Yeah.
In fact, when they present at a very early age, the portal vein becomes arterialized. The portal vein looks like an artery and very small. And one thing that I would advise people who go for surgery following that in the future is the portal vein is kept open by the arterial pressure. And when you actually divide the artery and anastomose the portal vein, the flow, the wall is so thick, the portal vein, the forward flow through the portal vein will be so small, they thrombose post-transplant. So arterialization of the portal vein is a common problem in very long-standing arteriovenous fistula.
And because you have multiple feeders, that doesn't mean it's not a biopsy. So some of these arterial portal fistulae from biopsies are malformatous. They look like malformations. And with time become hyperdynamic with multiple feeders. So one fistulous area does not necessarily it's a biopsy. Multiple does not necessarily mean it's not a biopsy.
Very good point. So I think I want to re-emphasize what Dr. Ella said. When it is arterialized, the pressure really goes up. In this particular patient, when we measured the portal vein pressure directly by placing a catheter in the portal vein pressure was 90. And nobody believed when I said it's a 90. It's a systolic pressure of the arteries. The hepatic artery pressure was 120. The portal vein was 90 there. So that's what happens in this patient. And when it has such a high portal vein pressure, all the complications come in. So next, Dr. Basil, question for you. Now we know the patient has arteriovenous malformation or fistulas in the liver, and then we all agree that endovascular approach is the best approach. And how would you approach this patient from now?
I would have looked at this probably frame by frame to try and identify which are the arterial feeders going to this fistulous communication and try to go out as far peripheral as I would and could to probably consider glue or a liquid embolic there. And if I'm so far out and if it's a direct communication, maybe even consider any form of plug or coil. My concern would be that near total portal vein thrombus sitting there and this sudden reduction in this blood supply here, could it precipitate a complete portal thrombosis? That's something that I would keep in mind and would probably be ready to do a portal vein recanalization as well in the same session if necessary.
Interesting. So I think at least we could consider anticoagulation post-embolization to prevent thrombosis, right? Dr. Varela.
Yeah, I don't understand what you mean by portal vein revascularization. Oh, at the bottom. Oh, that is okay.
I think he wants
I
to-
think it's an important point what he said, that there is a risk of portal vein thrombosis. And again, the risk of portal vein thrombosis would be when it's long-standing and the wall is really very thickened. So you will, here the portal vein is still reasonably dilated. So then there would be, but you can also test by really putting a balloon on the right artery to see if you still get an antegrade flow in the portal vein. That is one way of knowing whether there is a risk. Personally, I would go for the right artery. This is a non-cirrhotic patient.
Yeah.
The risk of recurrence is so high. I would go for the risk of liver dysfunction or liver failure post right artery embolization is negligible in this patient. I mean, I would think that the liver function tests are normal and the MELD is low. So if you want to go in one go, I would prefer to go for a right artery embolization.
Thank you. So, as everybody mentioned, this patient underwent hepatic arterial directed embolization at an outside hospital. This is a post-embolization angiography showing almost near complete disappearance of the arteriovenous communication. I can show it again. But what is conspicuous at the end is that there isn't much portal inflow. Main portal vein is not opacified. The splenic vein, inframesenteric vein, and supramesenteric vein are opacified, but we don't see blood coming into the main portal vein. So what Dr. Sanjay Betal mentioned is, did the patient thrombose after embolization because there's no longer arterial flow coming into the area, which is used to have so much, and the thrombus that is already present has continued to propagate up during the post-operative course. So patient was put on anticoagulation immediately. They didn't attempt any endovascular therapy for the treatment of portal thrombosis, thinking it's acute thrombus may be resolved on anticoagulation. So there wasn't any much significant improvement in hepatic hydrothorax. Patient was continued on anticoagulation, and then this is the time when the patient was referred to me to do a TIPS procedure on this patient, because they thought, okay, hey, the hepatic arterial malformation is incidental. He has mainly extrahepatic, non-cirrhotic, portal vein thrombus related portal hypertension. That must be relieved by doing a TIPS procedure. That's how it was presented to us. So question to Amar Mukund now, given that this patient has not improved, how would you approach this patient now?
So now what we understand, the pressures which were 90 previously has been taken care of. So now it's not the pressure, it's more of liver dysfunction, and mostly it's the arterialized liver and not getting a portal flow. So maybe TIPS would be a better therapy. Having said that, TIPS with thrombectomy would be how we go about it, because thrombus is there. We need to clear the thrombus and then continue the anticoagulation. So I'll put it in like do a TIPS and continue anticoagulation. Maybe for 3 months or 6 months, we follow it up and then we...
Yeah, that was my thinking. But then I thought, why don't I just do a hepatic angiogram to see whether there is still any residual AVM or AV fistula, just to take it away before I start putting a TIPS in the place. So this is when this is my angiography, this is what I did angio, and then here you can see the arteriovenous malformation is still present. Whatever was embolized, which was transient, and other vessels took over, and there is a blood coming backward flow in the main portal vein. So my thinking here when I did the angiogram is that, well, I think the portal vein thrombus isn't the primary problem right now. It is still the flow is present. Still there is arterialization of the portal vein. So whatever the malformation that wasn't completely eliminated by prior endovascular therapy. I did a selective angiography here at the time just to show it again. So proper hepatic angiography here again shows the same finding, arteriovenous communication draining the portal system. Now the situation is exactly what it was when the patient presented outside hospital. So Dr. Rela, now what should we do now?
There is an important finding in this that you're not said. I want you to tell me that. There's a very important finding here.
Very important finding. There is splenomegaly. What else are you looking at?
Now, you've got a reverse flow in the portal vein.
Yes.
But the reverse flow should go into the left portal vein. Because there is, if the resistance in the liver is normal, because this is a high pressure system, it's still not going into the left portal vein. That means the liver itself is extremely fibrotic, which is why everything is coming into the main system. The left portal vein not filling is an indication of severe liver fibrosis.
Or the left portal vein is thrombosed. This portal vein is thrombosing more so, this is not the same. This is not the same portal vein as you had before. This portal vein is a little bit more chronic and it's more thrombosed. And if you don't see the left portal vein, that left portal vein may be thrombosed or not.
Is this CT after the embolization?
No, this
before?
CT was very, very early, not before. So
Yeah, this is not the one.
So I think that's a very good point. That is, why would not the blood flow to the left portal vein unless there is an increased portal hypertension, that's liver is fibrotic and not allowing blood to go in. So anyway, my thinking was there is still arteriovenous malformation. I need to fix it before I go on day tips in this case. So now, what different approach one would you consider when the hepatic arterial approach didn't succeed in treating these arteriovenous malformations? So I think, Rajesh, what do you think we should do here now?
Sir, I would still want to embolize the artery first and see how it goes. Because I think the previous embolization, did it cover the initial fistula? I'm not sure, because the glue cast looks to be in different place than the previous fistula. So I would still go ahead with the arterial embolization first and see how it goes.
So what I thought here was, the new thinking about any arteriovenous malformation is, you can always try the venous approach. If there is a single venous drainage, and if you are able to occlude the venous drainage of arteriovenous malformation, that would take away the malformation complete, which is practically applied in many of the peripheral arteriovenous malformations. So I thought, why don't I test that here in the liver to see it holds true or not. So how can I test it? So what I thought was, I will put a balloon occlusion catheter in the right portal system and repeat the hepatic angiography. So that's what I did. I put a Fogarty balloon in the right portal vein and did the hepatic angiogram. And you can see the complete disappearance of the arteriovenous malformation. So now I got a confidence that, okay, hey, instead of targeting the hepatic arterial approach here, I could target the portal venous approach to treat the hepatic arteriovenous malformation. Rajesh, do you think it's reasonable now to go ahead with the portal venous approach? Thinking this has come up, do you still consider to try the hepatic arterial approach?
Looks good, sir. Only issue, I think that segment 6 is still showing some persistence of fistula, I guess.
Yep.
I agree, and I would, in fact, when you mentioned, I thought I should bring another case where we had a similar approach, but that was a much bigger aneurysm where we had no hardware where it can fit into the artery. The artery was so hypertrophied. So combined approach in hepatobiliary system is actually a wonderful thing, and it does wonders. So yeah, I would totally agree with this particular approach.
So Dr. Rela, now left portal vein is not opacified, and now I'm going to occlude the right portal vein. What would be the implications? That also means that we should do TIPS immediately now.
The symptoms are not going to improve for the patient. If the left portal vein is occluded, and you're going to occlude the right portal vein also, the patient is going to have portal hypertension. This liver is entirely dependent on an arterial blood flow to the left side alone. So you're risking liver failure as well. I mean, even if there is no liver failure, this liver is used to only the arterial blood flow, because the arterial blood flow has been huge in this liver. It'll be a hypertrophied artery. So if you embolize now the venous side, I don't believe you will sort out the symptoms for the patient.
And what other options exist for us now?
I would try it.
You wouldn't do transplant now?
No, because there is no liver failure. I mean, you have to explore every route, and I'd be happy for you to try it, and then if it doesn't work, we think about the next step.
That's exactly the discussion we had with the transplant surgeon, that if he really fails, then we'll think about transplant, but we should try your approach first. So here, we selected the venous, the branch, segment 6 branch, where the entire AV malformation drained into, and then coiled very tightly that venous system. So this is the venous branch that the portal branch we coiled, sorry. And this is the post embolization right hepatic angiogram, shows no more AV malformation. So everything looks great. So then we came back and did the hepatic celiac angiogram, and now good flow to liver, arterial flow, no more portal venous opacification coming from the liver, but conspicuously there is no main portal vein. Delayed phase, I don't see portal vein. Then I thought, okay, let us give it time, give anticoagulation and see how she does. So she did improve hepatic hydrothorax immediately, but recurred within a month. Then I thought, okay, fine, now I have a solid indication to go ahead and do a TIPS. You can see the intravascular ultrasound using the intracardiac echo machine. So this is the liver, this is the portal vein with thrombus. We stuck from the hepatic vein, usually middle hepatic vein, to the right portal vein here with a thrombosed portal system, and then deployed a TIPS there. After TIPS, there is a complete resolution of hepatic hydrothorax, improved portal vein thrombosis, but developed hepatic encephalopathy. Not respond to medical therapy, and the family came to her and said she's on the bed, in the bed 20 hours of a day and wakes up only to go to bathroom. So she needs some life. So Dr. Basil, what do you think we should do now?
Still try not sending the patient to Prof. And therefore, we would consider reducing the stent. Not occluding the tips, but at least reducing it and trying to strike a balance somewhere.
Can I ask, sorry, when you were planning the tips, did you think of doing a biopsy at that point to just see how bad the liver was?
Yes, we did.
That would have given you an assessment, isn't it?
Yeah. I think we did biopsy liver even before that itself. There was some fibrosis, stage 2 fibrosis, but no frank cirrhosis. People consider that as probably extrahepatic portal venous occlusion leading to some sort of liver changes, like trophic changes in the liver.
And what was the diameter of your original tips?
Sorry?
What was the diameter of your original tips?
8.
It was an 8?
8 millimeters. I wish we had 6. The one you placed recently, then you go to 6, 10, but that time it wasn't there, so we used 8 to 10 and then only to 8. So we followed Dr. Basil's advice and we said, okay, why don't we just go and reduce the shunt, see what he does. So it's always try and try and try. So we went ahead and reduced the tips using a double stent technique. I think most of you know what it is. So we place a balloon expandable stent inside the existing stent, and adjacent to it we deploy another Viator graft and slowly expand the balloon expandable stent to constrict the central portion of the newly placed Viator. So we reduced it to I think 4 millimeter diameter from original 8 millimeters. And now we can see a slight flow into the right portal vein. So you can see some flow coming in. So you can see difference when you injected here, everything was going to the shunt. Now we can see some blood going here, some blood going here, some blood. So slight improvement. So now patient improved hepatic encephalopathy. She became completely normal, no more sleeping 20 hours, no more pleural effusions, improved quality of life, She preserved her liver function, remained child A. So at the end it was a successful story, but it took us to multiple steps of thinking, trialing, iterative process of doing procedures. So I wanted you to think about this way. We may not have the answer very early to begin with, but the pathophysiological thinking is key to get to success. Every time you have to reiterate what we need to do at this present moment, what is the best benefit versus risk ratio here for the treatment approach you take in, and then take it each time. And that only will tell you at the end what you need to do and how success will come through. So, Dr. Saad.
You didn't tell us what was going on with the left portal vein. Was it ever opened when you got in? Was it thrombosed?
Good question. I don't remember it. I'm sorry. Dr. Rela, any closing comments on this case before we go to the next case?
I think you've done well. You have persevered and achieved what you wanted to achieve and avoided a transplant. But in all of this, I know you're persisting on interventional. At some point, you should have thought about an open shunt as well. That would have solved everything, the thrombectomy and everything it would have solved. A straightforward mesocable shunt would have worked as well as all of this. So that's all my comment as a surgeon.
Yeah,
because it's not irrelevant.
Yeah.
No, open shunts are still good and they work well. And they work long term.
Your comment?
Yeah, so I'll just share a companion case where we had a similar patient 6 months back. A patient who had a rapidly refilling ascites, who need a tapping twice a week, getting cachexic and literally not fit for transplant. He was referred for transplant, but he was not fit for transplant. When we see the artery was hypertrophied to almost 13. The right branch was 13 millimeter. And we tried placing any hardware, we were unable, and there was no sheath which was navigating into the tortuosity where we could place a plug. So we tried putting some of the coils, the larger one, but they migrated into the portal venous side. So we started from the venous side. The next day we went from the transsplenic route. We first grabbed all those coils which were there into the portal vein. Then we placed a 22 millimeter plug onto that particular cavity because it was a huge cavity which was formed, aneurysmal cavity. Put some glue over there. And then in a staged procedure, after 15 days, when the patient had very minimal ascites, but still he was needing tapping maybe once in 2 weeks, then we embolized to the arterial side. And because of this staged approach, we could, and anticoagulation, the thrombus didn't progress much. And after 3 months, even the right, left main portal vein were free of thrombus. Ascites was gone. The patient was eating. So sometimes staged procedures do work, not going on for complete right hepatic artery, rather than if it is a pinpoint approach, like what Dr. Bajal mentioned initially, like we will go try into deep. So, sir, Rela sir, I would just like to say, when we see such kind of liver where we understand that probably it is a non-cirrhotic, but because of high pressure, like you said, it would be a fibrosed liver. Yes, sometimes they are fibrosed, they don't look like that. So still going a very super selective, maybe a good idea. That is only, experience with 2 such cases in our institute. But these are anecdotal cases. We don't know. We don't have the answers. So yes, the patient was counseled that he may need a transplant, but we tried to salvage. So now we have 3-4 cases like that where there's such kind of therapy where you have a venous approach first, followed by arterial approach. That works.
Thank you. We'll move on to the next case, presentation by Rajesh.
Okay, so from exotic to more mundane management of refractory ascites, we have a 59-year-old male, metabolic dysfunction associated steatohepatitis, related CLD, detected in 2017. Prior decompensation in the form of an upper GI bleed in 21, had encephalopathy during that time. Endoscopy done in Jan 23, had grade 1 varices, esophageal, mild portal hypertensive gastropathy. And CT was done in August 22, cirrhosis, no lesions, portal vein patent, no shunts, mild ascites. The current issue is that since June 23, The patient's needing large volume paracentesis every 2 to 3 weeks, despite optimal salt restriction and optimal diuretic therapy. Should have gone for a transplant, not willing currently because his daughter's marriage is coming up. He wants something to be done in the meantime. Labs, bilirubin of 2, albumin low, INR borderline, creat again borderline, sodium 132, high sag ascites, CTP of 10 and MELD sodium of 19. Now, I don't think we have a hepatologist in the panel, so I'll ask Dr. Ashwin if it's okay. In real world, most of our patients, Indian patients, do not tolerate the diuretic doses that define refractory ascites. So, in your practice, when do you call someone as having refractory ascites? Because we are not able to give the diuretics that should be given.
Yeah. I'll start with the disclaimer that I'm a surgeon and this is not my area of expertise. But having said that, every 4 weeks if you need to tap, then it's called refractory. And if you achieve the highest dose of diuretic, which is 40 and 100, and you can also go up a little further, and still either the patient is not able to be on that dose because of the complications of the drug, or in spite of the higher dose still has this ascites, then it's called refractory.
Thank you. So how do you, again to you only, how do you ensure patient compliance? Any role of routine albumin infusions and beta blockers?
We should have got a hepatologist.
I'm sorry, we don't have a hepatologist, that's why. Anyway, I'll skip these questions.
I'll try locuming in. The thing is, with regards to sodium restriction, it needs to be 80 millimoles and below, or ideally, what is possible is 2 grams per day, which can be restricted to, which is basically a pinch of salt. So that's not so easy to actually ask our patients to be on, but they do keep to that kind of restriction. No role for routine albumin infusions, and use of non-selective beta blockers, we do use them, and they are essentially effective, but again you do have other issues of non-selective beta blockers like hypertension and other things which need to be kept in mind. Again, I'm just locuming in for a hepatologist, I'm not
Thank you so much.
You also have to look at the patient holistically on a nutritional status as well, like liver frailty index, sarcopenia. So they may be tolerating, dietary restriction and diuretics, but they may be wasting as well, which is a poor indication for transplant and outcomes, whether for TIPS or without any procedures, whether TIPS or transplant. So also look at their are they truly wasting or not? What's their frailty index and such?
So do you build them up? If it's an elective TIPS, would you rather wait for a month or two, try to build them nutritionally better and then do a TIPS? Would it make sense?
Yes, but if you're still tapping them, they're still going to be losing a lot of protein. So it all depends. Catching them early before they get into sarcopenia with a high frailty index is also key.
Since we are on that question, do you wait for the ascites to become refractory to offer TIPS, or are you doing it for recurrent ascites as well, if the patient doesn't want a transplant?
I'm still doing them if there's continued sarcopenia and frailty. Despite that, we're actually doing early TIPS to try to maintain their nutritional status, whether they choose later on or not to go to transplant or not.
Okay. Thank you. Dr. Kalwa, do you feel he's a candidate for TIPS? 1 episode of prior encephalopathy, MELD of 19, CTP of 10.
I think MELD-wise and CTP-wise, he's a good candidate. And the prior encephalopathy was in the setting of upper GI bleed, which we know can precipitate hepatic encephalopathy. But apart from that single episode, which was not a normal episode, so I wouldn't consider that as a contraindication to do a TIPS.
Okay, thank you. Baijal sir, do you use any MELD cutoff to identify the ideal candidates for TIPS? He has a MELD of 19.
I would have gone and opened up your algorithm to see where this patient would be placed. But I don't think we have a very specific MELD. And like you said, actual real world, the way we are practicing, we look at each of the identifiers and any of the factors that can be corrected before we do it. Yeah.
Thank you. This Dr. Kalwa has already mentioned. Amar sir, do you use any risk scores to predict post-TIPS HE?
So, mostly such cases are discussed in a multidisciplinary meeting, and there are no specific risk scores, but yes, sarcopenia is one of the important determinants. So there are three things which we look into: the age, those sarcopenia, and whether even if there is any kind of, what is the performance status. So three things are very, very important, especially the age. If age is more than 70, we are always skeptical. If pre-TIPS HE may not be a criteria, and if you go by the guideline, especially from registries coming from Europe, you'll find that there is a conflicting data, and now it is said that pre-TIPS HE has nothing to do with post-TIPS HE. In fact, the number of HE you have and how early you have, that will determine the mortality and the outcomes. So pre-TIPS HE may not be the right way to go ahead. However, sarcopenia, as Dr. Saad mentioned, so frailty index and sarcopenia, as well as age, should be definitely taken into account rather than only sticking to CTP and MELD score. So those are other factors. Sometimes even CTP and MELD score is on a higher side. Then probably optimization may be an answer. You can wait for some couple of days, maybe a week or two, and try to improve and bring down the scores, and then go ahead. So it may be a planned procedure. It is not like a bleed where you need to do it very urgently. You can wait for a couple of days, more on different kind of agents like midodrine, somatostatin, albumin infusion, no diuretics, improve the sodium and gradually. So such things do help. So, but no, not exactly going by any kind of scores.
So how much weightage would you give to sarcopenia and age? If the CTP and MELD are pretty okay, you have a 70-year-old with sarcopenia, would you say no, or would you rather wait and tell the rest and do?
Yeah, that's a wonderful question. So I'll go by my institutional protocol, where we see any scores are higher, then we go for a smaller diameter tips. Even for hepatic encephalopathy, we are in patients having history of hepatic encephalopathy, we go for 6 millimeter stent. But simultaneously, we go for additional proximal splenic artery embolization to help reduce the portal pressure. So it's a combined approach wherein we just do a tips, wait for some time, see how the patient does. Still having ascites, probably a combined approach where we go and do a proximal splenic artery embolization. Sometimes it's like we don't have a constrained, controlled expansion tips in India, but we take a 8 mm stent, Cavera, put it, dilate it only by 6 millimeter, and depending upon, we can go up to 7 or 8 as per the requirement and as the adaptability of the patient. So this is how we go. So depending on how the risk factors are, we take a call.
Okay, I think this has already been covered by you. Titrating the pressures. Any role of simultaneously occluding the large shunts? Again, Amar sir, if the patient is at risk of HE, how would you define a large shunt? Whether you would occlude it in all cases?
So any shunt more than 8 millimeter, if amenable for embolization, should be embolized. So the aim should be reduce and make the flow more towards the tips. So that will, adequately solve the issue. Though this is a very contentious issue, whether actually embolizing really helps or not, because we have seen a couple of patients where all the shunts have been embolized, still having chances of hepatic encephalopathy. But having said that, there are data to suggest that if you embolize, the chances of encephalopathy is lower. So yes, it's a good idea when you are doing a high-risk case, probably close more shunts which are not actually contributing to reducing the pressure, and keep one of the shunt functional, which is directly taking with a very less gradient, very small track where the blood flows just directly into the IVC and into the right atrium. So that strategy works.
Can
So for
I,
this, sorry,
can I,
sorry.
before you go on to all the details of your tips, if one look at that picture, I would say that patient's sarcopenic, having ascites drained all the time, and needs a transplant for sure. Everything else we are offering is suboptimal for that patient. And you're saying the son's wedding is coming up, and therefore she doesn't want a transplant. So the question that I want to ask you are two things. What is the risk of mortality for this patient? It's the first thing I want to know with your procedures. The second question I want to know is, what is the risk of encephalopathy that she's not even able to attend her son's wedding? You answer those two questions and then I will send the patient to you.
Those are all valid questions, sir, but the patient has to take the decision. We obviously tell everything.
You need to tell what the risks are. I want to hear that. Risk of mortality, risk of encephalopathy. Because the whole reason why she's putting off the transplant is to attend the son's wedding.
Those are usually excuses, sir. I think they just want to avoid the surgery.
Answer is very simple. So in case transplant is possible and it has to be delayed, then there is a different strategy rather than having no option of a transplant. So whatever we were discussing when there is no option of a transplant. But however, having said that, the patient can...
Here, potentially, it's a delayed tactic, not no option.
So if it is a delay tactics, then probably I'll go by like not the proximal splenic artery embolization, not as an additional procedure, but the only procedure which will help reduce some pressure, maybe have some role in hepatic encephalopathy with good management by hepatologist till the time she is fit for a transplant. It will be my approach, but I think Dr. Kalwa wants to add to it.
I think all are valid questions. The risk of encephalopathy in this particular patient is probably in the order of 10%. A patient who has already had one episode of encephalopathy, the chance of getting encephalopathy is 1 in 4, 25%. If that is not associated with any prior precipitating episode, it is 1 in 8, so 10%, approximately 12% of the risk. So off the bat, her risk is just minimum 12%, our maximum is up to 25% risk of hepatic encephalopathy. If you look at the mortality, she's close to child C. So when MELD is almost 19 now, so her mortality at 6 months is close to 50% actually. So it's quite high. So what is the best approach here? If the patient is willing for transplant, I think the best approach is to continue paracentesis until she gets the transplant. Get the marriage done, get the transplant. If she observably does not want a TIPS procedure, then there's honest discussion. What is the benefit of TIPS in this particular patient? Is she willing to have a TIPS just because 6 months mortality is similar whether you do TIPS or not TIPS? So those are things that we have to discuss openly and then agree upon that.
Sorry, I don't mean to hijack this whole conversation, but I just want to take it away from TIPS. We obviously know that this patient needs a transplant. We're just buying time for some time. And what you're driving at is to try and avoid encephalopathy as much as possible and ways and means to do that. I know Prof has done that quite a bit in the past, and we have also done that in the post-transplant setting. Why aren't you thinking of a Denver shunt? A simple peritoneovenous shunt, and I know it's not very fashionable, but if you do that, and you can actually buy time, and you are refeeding the fluid, all the protein is going back, and this patient's going to be quite okay to go in for a transplant. It's just an open question, and Prof, I would like your opinion as well.
I don't know the experience of Denver shunt here in India, but in the US it's not favored because we had a terrible DICs in those patients. So I know, well, how many you do per year? I do less than 1 per year in Denver shunts there.
I've never done one. They've stopped manufacturing them in the US. Very high maintenance problems, technical issues. They've stopped making them. I mean, there's now this alpha pump that's now being promulgated in the United States. We'll see how that goes, but VP shunts, no.
It's unfortunate that the technique is dying. It's not being done often enough for surgeons to understand how to put it in. It's not as simple as people think it is. It's not just putting it in. All you need to have is have a little air bubble in the system, in the pump, and it'll fail. And people don't know how to avoid it. People don't know how to position a patient. If I want to tell you a personal story, my father died of advanced HCC with ascites, and my colleague at King's put in a Denver shunt. He was alive for 6 months and never had ascites post that. And I've done this for many patients with portomesenteric thrombosis without liver failure, whose main problem is actually ascites. And it works extremely well, but it's prone for high technical failures, and therefore it's earned a bad name, and the company has not been able to make money out of it. And the less of it is performed, the less is the experience of surgeons, and it's now unfortunately disappearing. I mean, you may have heard of a pump which actually pumps ascites into the urine.
Yeah, that's alpha pump.
You use that?
We're about to use it.
I can tell you, I reviewed when they were manufacturing it. The data, I don't know if I'm allowed to say that, was extremely poor. And the only advantage of a pump which drains into the bladder is that you don't have to put a needle percutaneously and introduce infection. That's the only advantage. But the huge disadvantage is you have no control of the protein loss. The patients will come in with severe hypoalbuminemia and hyponatremia. So personally, I'm absolutely not for those pumps. You can use it. They cost as much as the cost of liver transplant in India. $25,000 to $40,000. I don't know how much it costs to put
$65,000.
$65,000. I will do 2 transplants for that price. So,
And they have very high complication rates.
Yeah,
technical complication.
implantable
out of
devices.
Europe, very high.
So I think if only surgeons will learn how to put in Denver and Levine shunts, that would be much better.
Prof, sorry. So in this case, would you suggest doing that?
I would still, see, it's an implantable
Time is
device. Risk of infections, bacterial peritonitis, all that is an issue. Personally, I will not advise that patient anything else but transplant, and no, I will not personally take responsibility for complications of any inferior treatment for this patient. I would say you go and take an advice of somebody else who will do tips. I will not send this patient for tips.
Sir, one last question, Professor Rela, to you. So what are your thoughts about splenic artery ligation, akin approximal?
I like that. Actually, if there is anything that I will do for this patient, would be a proximal splenic artery embolization. Proximal. That's very important.
Now we are in this topic. I think we're time up, but I want to ask one question. When you embolize the proximal splenic artery, what is the absolute reduction in the portal venous pressure? I measured it myself. I was so aghast. The reduction is only 2 to 3 millimeters of mercury, not much.
Yeah, that is absolutely right. We do that all the time intraoperatively. Reduction in pressure may not be significant, but reduction in flow would be significant. So you can have a 30% reduction in flow, but only a reduction in pressure of 1 to 2 millimeters. That is why it still works, and it is important.
So just echoing the same thing, yes, what you say is absolutely right. It's 2 millimeter to be, on the mean if we measure, we are doing. So we have done around 30 patients, and we have seen at least 60% of the patient responding to ascites. At least the, time to tap has reduced. They need a tapping maybe once a month, who are requiring 4 times a month. So definitely there is some improvement. It may be a short-term improvement, but yes, does some good to the patient without much harm.
Time is up, I guess.
Yes. Thank you. The time is up, and I would like to thank all the panel members for the expert opinions and reviewing the cases together. I hope you had learned something from the cases. Thank you.
Ladies and gentlemen, a nice big round of applause. What a fabulous session. So many questions. I know many of you want to, ask and wish that session keeps on going. It was really amazing. And we have another amazing session awaiting you at ISVIR 2026. And I would like to invite the chair people for this session. Ladies and gentlemen, before that, let me remind you that you can leave your thoughts, your questions on the ISVIR app. Please remember to download it, and you have sessions where you can ask questions. It's really that simple. May I please invite Dr. B. Jignesh Reddy, Dr. Naveen Chandrasekhar, Colonel Narendra Kumar Jain, Dr. Kartikeyan Damodran, the chair people for the next session, onto the dais.
Okay, good morning, everybody. We had an exciting panel discussion, and we're going to follow up with another amazing session. There's only a slight change of speakers in a session because they have some other conflicting commitments. So first up, we have Dr. Sandeep Punamia from Singapore, who is going to be talking about defining success in tips, procedural and clinical endpoints in modern practice. Over to you, Dr. Sandeep. Yeah.
Thanks, and good morning, everyone. It's lovely to be here in Chennai. The topic that I'm going to be talking on is actually something that's very, very important. In fact, in my opinion, there are two factors that define the long-term success rather than the short-term success of patients who undergo TIPS. First is patient selection, and second is getting the endpoints correct when we're doing a TIPS procedure. So TIPS has evolved now over the last 30 plus years from just being a pure salvage procedure in patients who are bleeding. And now we're doing it in more sicker patients, patients who have coming for an elective procedure for patients for ascites and hydrothorax. And these patients, when we want a better long-term outcome, we just don't want the pressure to drop substantially to reduce the bleeding, but you want a better longevity for the patient itself. So the focus has now changed from a procedure-based outcome to a patient-based outcome. And the endpoints of the procedure actually guide you on the degree of decompression, the need for any adjunctive procedures, and also the device selection, and that's what I'm going to talk on the next few slides. So the categories of endpoints, I think the one thing that is very well known is the clinical endpoints. The patients coming for bleeding, ascites, hydrothorax, what you want is control of these portal hypertension related complications, and also secondary endpoints as impact on the liver function, encephalopathy, and the quality of life. My talk will actually be concentrating on the procedural endpoints, that is on the angiographic results as well as hemodynamic targets. Now, in cirrhosis, the portosystemic gradient is very well known. I think hepatologists have studied this in detail in using wedged hepatic venography and found that when patients have a wedge pressure of more than 12 millimeters of mercury, there's an increased risk of rupture of the esophageal varices as well as increasing mortality. And that is very well documented. So when we are doing a TIPS, what we want is what the hepatologists did with beta blockers. They want the pressure lower than 12 millimeters. And with TIPS, that is the endpoint we want. We want a portosystemic gradient of less than 12 millimeters. Mind you, not too much decompression, because if it's too much decompression, this diversion of flow leads to patients getting portal hepatic encephalopathy as well as hepatic decompensation. So if you look at the optimal pressure gradient, we said it's 5 to 12, right? But if you look at it closely, this gradient was determined using wedged hepatic pressures from the hepatic vein to the portal vein. So in reality, when you're doing a TIPS, you put the TIPS device going all the way to the hepatocaval junction. So you're measuring it typically from the IVC or even perhaps the right atrium and taking the difference from the portal vein. Now we know for certain is that the IVC, the pressure is less than that in the hepatic vein. At the right atrium is even less than it is in the IVC. So typically if we're measuring the pressure from the right atrium to the portal vein, then we land up with a porto-atrial gradient, which is almost 3 millimeters higher than it would be from, say, the portocaval gradient. And that's important because if you're going to use the atrial gradient, you are going to dilate the shunt further and create more decompression
and therefore leading to more complications. So you would prefer using a portocaval gradient, and in fact, this should be done usually done immediately after the procedure. But when we're doing a procedure, I think majority of the people in the audience who are doing TIPS would be doing it under GA, or giving more deeper sedation. Now, it is known that the portosystemic gradients are inaccurate when you're using them, when you're doing procedures under this form of sedation or anesthesia. So in fact, if the validity of the post-TIPS results you're not too sure of, or this patient is using it as a prognostic indicator, using this gradient as a prognostic indicator, you need to repeat the measurement under local anesthesia. And that's typically, not immediately, but typically more than 24 hours later. And in fact, this recent paper has shown that if you do it 24 to 72 hours post-procedure, it's a far better predictive outcome than doing an immediate portocaval gradient. Also, this gradient was developed for prognosticating patients with esophageal variceal bleeding. Okay, now that's very important. It is not for gastric varices, it's not for ectopic varices, and it is not for ascites hydrothorax. I'll give you examples of these. Now, the portosystemic gradient in the left-sided portal hypertension, those patients who have gastric varices, in fact, might be normal or even subnormal. So as in this case, you can see TIPS was being done for gastric varices. Splenic vein, superior mesenteric vein injection, you are not seeing any varices at all. The gradient was just 10 millimeters. Yes, it's portal hypertension, but it's not significant enough to cause bleeding. The moment you inject in the splenic vein, you see the gastric varices fill up. Okay? It doesn't mean the gradient is low, you don't do TIPS. You have to do TIPS and you will have to embolize the varix. And when you have a varix, typically in the ectopic location, or in the gastric varices, you lower the portal gradient to normal levels, despite which the varices can fill. So you don't use just the gradient to determine whether that's the endpoint for the procedure. In ascites hydrothorax, this optimal gradient is again not very well established. We know for certain that when patients have ascites, they are in the lower spectrum of the disease, of the cirrhotic disease. These patients are a lot sicker. They have more impaired function of the liver, impaired kidney function, they have hyponatremia, severe sarcopenia. And these patients, if we create a shunt and create portosystemic decompression and the diversion, then the outcome is usually far poorer. So, do we use 12 millimeter gradient in every such patient, these sicker patients? Well, not really. In fact, people used to do about 50% reduction, thought was enough. But now we know in this recent study which said that you need actually something like a 60% to 80% reduction in the pressure to achieve adequate decompression for relief of symptoms without much increase in the degree of hepatic encephalopathy. However, we are still very, very uncertain about this because we have very sick patients. We have patients who have come for an elective procedure, who are coming for improvement of quality of life, for repeated admissions for tapping, and we don't want them to have repeated admissions now for hepatic encephalopathy. So you look back and see, well, where do I start and where do I stop? If you look at this formula for determining flow through a tube, if you take the TIPS shunt itself, the flow is increased not times 4, but to the square of 4. I mean, it's the power of 4 with every millimeter increase in the size of the shunt. So if you go from 7 to 8, 8 to 9, the quantum flow increases dramatically, which means that you get much more portal decompression, but also the risk of encephalopathy and hepatic deterioration. So if we really want to see that group of patients, whether we can get a good degree of decompression without impacting the patient's outcome, we need to have what we call a tailored decompression. In the past, we used to use the legacy Viator devices, which were 10 millimeters, and we just dilate to probably 7 or 8 and leave it at that. We had a great gradient on table, but then we realized over a period of time that these are self-expandable stents, and even in the hard cirrhotic liver, it does continue to expand. And typically within 6 months to a year, they would have achieved full 10 millimeters, and these patients come back for repeated admissions. So then we started creating what you call a constrained stent. We place a balloon expandable stent within which we place the Viator, and typically started something like 8 millimeters. We thought we were doing pretty well, but then these patients again came back. But Viator, that's Gore, actually then changed the device. And what they did was, they had a special device called the Viator Controlled Expansion, or the Viator CX, VCX as we call it. And this one, it doesn't dilate fully to 8. Doesn't dilate fully
Last
to 10.
2 minutes.
It starts with 8, and then you can bring it up slowly to 9 or 10, depending on the outcome that you're getting. But then 8 probably in ascites is not enough, and we know for now is that we can actually need to go smaller. So we are now using the balloon expandable stent, constrained one, with the current Viator. But then just 6 weeks ago, we had this release of the new Viator, which is starting at 6 and can go up to 8. So you can put a 6 millimeter device. Look at the degree of decompression that you get. If you got a gradient typically about 50, 40%, you can 50% or so in ascites patients, you can leave it alone and then see whether you need to dilate depending on whether the patient is diuresing enough or whether the patient is having encephalopathy or hepatic dysfunction. So I just want to move to the angiographic endpoints. As I mentioned earlier, gradient is not the only thing. What do we look for in angiographic endpoints? First thing is placing the device, making sure there's a brisk flow. That's number one. Number two, when the patients come for variceal bleeding, we're looking for reversal of flow in the shunt. So if there is a reversal of flow in the esophageal varix or the gastric varix, you pre-tips, and once you place the tips, so you can see that there is no further filling of the varix, so you know you're pretty good. But if you get persistent flow in the varix after the tips has been placed, that means there is still some amount of portal diversion there, and these patients still run a risk of bleeding. And these cases we would like to embolize. In this case, you can see the gastric vein filling up the varix. We went selectively, balloon occluded, and did a Bartow. Next is when you place the device, make sure that you place the covered portion completely within the covered segment. If you do not do that, as in this case where a small portion of the bare part was outside, was within the parenchyma, these patients can land with tips thrombosis. That's something you have to look at before you leave the angio suite. And when we are placing the stent, make sure it goes to the hepatocaval junction, because if they don't, there's a higher risk of developing either stenosis, or as in this case, if it doesn't go up all the way, you'll find the device sitting up and popping and abutting the superior wall of the hepatic vein, leading to tips dysfunction. And this patient, you can see, is further developing, is having recurrent filling of the duodenal varix. And these patients, then you have to extend the device further, going into the IVC and getting a better flow without any filling of the duodenal varix. I'll end my talk here. Thank you very much.
Thank you, Dr. Sandeep, for the nice talk. So regarding the gradient for ascites, do you bring it down to 50% or you straight away go for 60-80% reduction?
Sorry?
No, for the gradient reduction for ascitic patients, recurrent ascites. You said you bring, for the ascites patients, when you bring down the gradient, you aim for 50% reduction in gradient or 60 to 80%?
For ascites, whether stage it or?
Yeah, ascites.
Yeah, so typically it all depends if the liver function, we start with that first. And if the liver function is otherwise very pristine, we probably just start with the 8 millimeter stent. But if the liver function is not that great, MELD scores a little on the higher side, then we would probably start with the 6 and then watch.
Then watch in. Okay. Thank you. So next up, we have a change in the speaker. So we're going to have Dr. Shyam Kumar speaking next. So he's going to be talking about recanalization of chronically occluded tips, a troubleshooting guide. It's a case-based discussion. Over to you, Dr. Shyam. Thank you.
Good morning, everybody. Thank you for the opportunity. So I'm going to tell about tips or dips recanalization, few case examples. This is a 49-year-old lady present with the hematemesis, and this is the initial tips what we have done, where we have connected from hepatic vein to the portal vein, and it is almost at the confluence of the portal vein. This is on day 6, where we do not see the flow on check Doppler. So we have gone through the stent. There is no flow through the stent. So then what we have done is we did a balloon plasty, and we have taken a Fogarty balloon, and we inflate the Fogarty balloon and just clear the shunt. So this is what we can do in the immediate post-procedure period, and we do it for about 2 to 3 weeks when the thrombus is soft. So this is how we have dilated the Fogarty balloon. This is the 5 French Fogarty balloon, which is over a 6 French sheath. It is 80 centimeters in length and it is easily accessible. So this is the post-recanalization image, what you see here. And this is the post-procedure Doppler, which is showing good flow. So I'll show some more case examples. So this is a child who has got a gross ascites, 5-year-old child, and we have checked the pulmonary arterial pressure, IVC gram, then we created the tract, and we placed the shunt. This child showed very good response, and she was solid for some time, few months, and subsequently she came with the stent occlusion. So we have gone through the shunt, and we did a balloon angioplasty. With the balloon angioplasty, there is good recanalization. So this is the flow on the color Doppler. So moving on to some other examples. So if you see the portal venous anatomy here, so we are quite at the division of the right branch of portal vein. We have gone through the shunt. Then there is a shunt occlusion. And when shunt occlusion was there, when you look at the anatomy, the upper end of the stent is quite high and we did not have adequate stability to go in. So what we have done is we kept a tips cannula at the upper end and we used a 2-wire technique. 1 wire we have kept in the IVC so that it gives stability to the IVC, the cannula at the upper end of the IVC, and we took the back end of another wire and we have gone through the shunt and with balloon angioplasty and the flow was restored. So this is the line diagram drawn by my colleague Dr. Kumar Muthukumar showing the same procedure, how we kept a stability wire in the IVC and then we have taken a wire, clear the thrombus with the balloon catheter and show the flow. So this is how the flow is established and this patient shows good flow during the follow-up. This is another type of example where the patient has come with the blockage of the shunt, gross ascites. This patient had a stent in the in the right hepatic vein placed earlier for Budd-Chiari syndrome. So we have gone by the side of it and this is the original shunt what we have. She did not come for follow-up for nearly 2 years. 2 years later when she came, there is a good flow in the inferior vena cava and we did not have good access to get into the upper end of the shunt. So what we have done is we tried a percutaneous access here, percutaneous transhepatic into the shunt. We are localizing the shunt. So we have taken a needle here, which is an 18 gauge needle. When we puncture with the 18 gauge needle, we have to direct this needle cranially so that when we pass the wire goes up and as soon as it gets inside, if a loop is formed, we can push the loop. Since there is no other way for the wire to go, it will go through the shunt. And once the wire goes higher up, you take it to the right atrium, go to the superior vena cava, snare it, and once we have snared it, we get the wire downwards. So it is a combination of retrograde and antegrade. So we get into the portal vein, balloon angioplasty. Here what we have to do is, since we have made a puncture into the shunt, there is a discontinuity in the membranous portion of the shunt, so we cannot leave it open. So after we do the balloon angioplasty, we usually place a new shunt, new covered stent within it, so that there is no chance of biliary leakage. So this is how we have done, and towards the end we have put a glue into that part of the liver and we have come out. So this is again linear line diagrams representing the same. So if you see here, the needle is directed cranially and we have passed the wire, we snared and put a new shunt. So this is the follow-up and patient is showing good flow and clinically patient is doing well. So this is another example where we have placed a tip shunt and for a long time patient did not come and this upper end of the stent is buried within the liver parenchyma. So what has happened is this patient came after a long time and there was some change in the dynamics and shunt has become shorter the stent has become shorter with relation to the size of the liver. So we try to come from above. There is a gap between the IVC and to this shunt, and we are not able to get in. So what we have done is, we again went into a percutaneous approach. Here, when we tried percutaneous approach, there was no approach to put this needle cranially directed. So if you see this needle, it is almost horizontal. So then what we did was, we kept the bevel of the needle, we could see it. Bevel we directed cranially. We did some manipulation. The wire of choice for us is a stiff glide wire. So conventionally, if you see, we should not be putting a stiff glide wire, which has got a coating over the wire, into a metal needle, because it can be scraped. But this is the best combination in our experience, what works. So we push the wire above, so you can see it is gone above, and subsequent plasty we are doing from the cranial end. So I'll show one more case, maybe. So this was how this patient had the original shunt, 12-year-old child. Sorry, patient came after 12 years. We can see the IVC gram. We can see the tip shunt. So in this particular patient, what you see here is, compared to the previous case, the shunt has gone medially. It is buried into the medial wall of the IVC, compared to the previous case where it was buried to the lateral wall. We did not have a percutaneous access, because if you have taken a percutaneous access, there is no way that it can exit. And what we have done is, we have taken a new tips cannula here. We punctured the upper portion of the shunt, and we plastered it, and we placed a new shunt. So it is showing a Y-shaped configuration at the upper end of the stent. There are two stents there, so one stent is in the other. So if you see case examples, our first choice is to try with a catheter guide wire combination or a glide wire combination. If it works, it is most minimally invasive.
Last 2 minutes.
Okay. The next choice is a cannula assisted, and if necessary, you keep a safety wire, safety body wire in the IVC. Percutaneous is the next choice what you have tried. So it is a transhepatic puncture. Initially, it is going in the antegrade direction and convert into retrograde. So when I say antegrade, it is from the portal vein to IVC. And finally, if these do not work, we can try a transmesenteric. So if you see why these stents are getting blocked, there can be various factors. Some are related to the technical factors. The covered, uncovered junction of the shunt may not be in the correct location. It may be more to the parenchyma, patient-related factors, or rapport with the patient. Patient should be on good anticoagulation. Just to say that when we put a tip shunt, the patient recovers. But remember that this solution, what we give to the patient, can be the beginning of new set of problems. So patient should be knowing that there is a continuous follow-up which is required. This is not the end of the treatment. So we need to carefully see where is the anatomical upper end of the shunt, where is it in the IVC, is it facing adequately cranial, so that the re-entry is good. And if you look at the shape of the shunt, as far as possible, try to keep a C shape, so that the flow dynamics will be good. Whereas if it is a V shape or L shape, the flow dynamics may not be all that good. And type of the stent also could matter. So with these case examples, I would like to conclude my talk. Thank you for your attention.
Very nice talk, sir. Regarding, there's one doubt for me. In the second direct puncture recannulation case, the stent was short of the cavitrral junction, and on the CT there were some veins in the subcutaneous vein. Okay. So we did a plasty, you did a plasty, but not a stent extension.
Yeah.
So was it an option, but probably no, because it would have saved?
No, we have placed a new stent within.
No, the second one.
Yes. Okay. All these cases, when you are recanalizing, if the flow is not good, and if the stent is not adequately inside the IVC lumen, we have placed a new stent. And all percutaneous punctures, we have put a new stent.
Okay. Yeah. And covered versus uncovered because of the cost constraints here?
Yeah. We are placing covered, uncovered combination, covered, uncovered, single stent. That's what we are doing.
The extension stent,
yes,
you place it the second time.
It has to be covered.
Sir, for your case where you showed about Fogarty clearance and that too in all of the acute tips occlusions, how safe is it to combat the pulmonary complications? Do we adequately anticoagulate them, or is it only for patients with ascites and not for bleeding?
Yeah, that's a very important question. And so the experience what we got in this are from the dialysis access patients for whom we do balloon plasty. So if you see overall clot burden here, the quantity of the clot is very small. So initially we do the balloon plasty so that this clot is broken into smaller pieces. Subsequently we do Fogarty technique. So what we think is this quantity will be very small, and always we monitor this patient and look at the pulse oxygen oximeter. If there is any fall in the oxygenation, then it is very important to check any pulmonary embolism is happening. We have reconstructed maybe nearly 100 cases so far, and pulmonary thrombosis did not happen as a complication in any of these cases. Yes. All right.
So what is your choice of anticoagulation after you follow them up closely, but do you start them on anticoagulation of the tips thrombosis? What's your choice?
We give heparinization on table, heparinization, then continue to anticoagulation.
You go for warfarin or you go for the DOACs?
Yeah, we give heparinization during the procedure, and then we change to long-term anticoagulation.
Thank you, sir, for a wonderful talk.
Thank you.
Thank you. For the next talk, we'll invite Dr. Sanjeev Kalwa for his talk on splenic venous dissociation, concept, technique, and evidence.
Good morning again. Most of you would know the two terms, proximal and distal splenorenal shunts, which surgeons used to do before the introduction of TIPS procedure. So in a proximal splenorenal shunt, they disconnect the splenic vein and connect the splenic vein to the renal vein. The connection between the superior mesenteric vein and the splenic vein is kept intact. That is called the proximal splenorenal shunt. The distal, on the other hand, they disconnect the splenic vein from the superior mesenteric vein and then connect that to the renal venous system. So, in the first case, there is a higher decompression of the portal system because the superior mesenteric venous flow will go into the shunt and drain systemic venous system. In the second stent, it is mainly the splenic venous flow that goes into the renal vein to drain into systemic circulation. The superior mesenteric flow will still remain to go to the liver, so the risk of encephalopathy is slightly lower with the distal renal shunt compared to proximal renal shunt. Make sense? So, the word splenorenal shunt is both proximal and distal, but in general, we prefer to do a distal splenorenal shunt. It's also called a selective renal shunt. Most surgeons would prefer to do that because it's slightly less associated with hepatic encephalopathy compared to the proximal one. So subsequently, Warren discovered, this is the Warren shunt, his own description of the Warren shunt. The Henderson works with Warren at the time in 1990s. So a description of what Warren drew this picture, this is what he did the procedure. So when you do the angiography, that's what it looks like. From the renal vein, you can go into splenic vein. You can see the splenic vein drains the left renal vein there. And the arteriography shows the superior mesenteric venous flow is going into the liver, not into the shunt. This is the classic distal splenorenal shunt. Subsequently, what Warren discovered is that once you do this procedure, a lot more collaterals form inside the spleen, inside the pancreas, that divert the sum of the flow from the superior mesenteric vein to intrapancreatic collaterals to the distal splenic vein and then drains it. So what he realized that, okay, listen, not just this one, we need to do something more. So he started what is called splenopancreatic disconnection. So at the end, the philosophy is that you want to disconnect the superior mesenteric flow from the shunt. So the superior mesenteric flow will go to the liver, the splenic venous flow will go to the renal venous system. So that's the same concept in the splenic venous dissociation. So instead of a surgeon doing it, in a patient who has a good splenoidal shunt, we use that to divert the splenic venous flow into the renal venous system by proximally occluding the splenic vein. It is also called shunt preserving splenic vein embolization or shunt preserving disconnection of splenic vein, portosplenic blood flow separation with splenoidal shunt preservation, or endovascular distal splenoidal flow diversion. You can use any of these words, but the main thing is you are disconnecting the splenic vein from the superior mesenteric vein or the portal vein. When you disconnect it, you want to preserve the splenic venous flow to go to somewhere that is where the preserving the shunt is important. So again, the concept is preserve the splenoidal shunt, let the splenic flow go into the renal venous system. That means it will decrease the portal pressure, at least 2 to 3 millimeters mercury, at a 30% blood flow will reduce. So instead of embolizing the splenoidal shunt, you preserve the shunt but disconnect it from the portal system. That is the concept of splenic venous dissociation. When should you do that? You should only do that when there is a functioning splenoidal shunt and the patient has hepatic encephalopathy. Presence of gastric varices may not be contraindication. If the flow from the superior mesenteric vein is going into the shunt and causing the variceal enlargement, that may not be a problem, because once you disconnect, superior mesenteric venous flow will not go it, and the splenic venous flow is not that big enough to continue to enlarge the gastric varices. It will just go to the shunt and drain the renal system. So it's an example published by Mejua in 2004. He has some 9 cases, and where he has done a classic splenic venous dissociation and preserved the shunt. The first case, here you can see this splenic arteriogram showing the shunt draining into the renal venous system, and he went ahead and embolized it one, and post embolization still preserve the shunt. So post embolization SMA angiogram shows superior mesenteric venous flow going into the liver, but splenic venous flow going into the shunt and draining into the renal venous system. Another example of the same kind. So another example by another author by Kekwi, and same thing here, transhepatic approach here. He injected a splenic vein here. All the splenic venous flow is going into the shunt, into splenic vein, and in injected a superior mesenteric vein, same thing. All the blood is going into the shunt. He did embolize the proximal splenic vein. Now when he injected a superior mesenteric vein, all the blood is going to the liver now. So it will improve the liver function. It will decrease the hepatic encephalopathy, but it won't increase the portal pressure because the splenic venous flow is draining into systemic circulation. So it can be combined with antegrade embolization esophageal varices, and it can also be combined with TIPS if required. You want to decrease the pressure even more than that. So another example here where the authors have done a TIPS and also disconnect the splenic vein. So this is one of the 2 cases I have done. So one case here you can see this patient has hepatic encephalopathy and a very large splenoidal shunt in the MRI scan. You can see there. And in the transhepatic approach here, you can see a splenic venous injection, so it's large shunt. This is the main splenic vein. This is the shunt going here, and the shunt is draining into the renal venous system. So we went ahead and coil embolized the proximal splenic vein, and we preserved the shunt. And you can see nice the superior mesenteric venous flow going into the liver, and subsequent MRI does show that there is good flow to the liver from superior mesenteric venous approach, and we did preserve the shunt, which is draining the spleen. Another example here, this patient has cirrhosis with ascites, recurrent refractory to diuretic therapy, and there are a lot of varices here draining the splenic venous system. So what we thought was this patient pressure is so high, we would do a TIPS procedure, and that's what we did. We did the TIPS procedure first, and then the continuous flow through the variceal complex. Instead of embolizing the variceal itself, what we did was we occluded the proximal splenic vein using a balloon ambulatory vascular plug, and you can see the post embolization there is nice flow to the tips, and we did preserve the shunt. The splenic venous flow will just go on to the renal vein, and we need to put a very small diameter tips here, so we used the 8 millimeter tips there. And the post picture you can see very clearly a very widely patent tips there and very small diameter. We did preserve the collateral in the splenic hilum that drains into the renal venous system. So this is the evidence, a very small number of case series by 3 separate authors, each are doing less than 10 cases. Overall, there is a complete improvement or resolution of hepatic encephalopathy in all patients, and portal venous pressure increased very minimally in these patients, and they did not develop any ascites or varices
Last 2
after
minutes.
the shunt reduction, after this occlusion of the splenic venous system. So overall, this, compared to BRTO or CARTO or PARTO, preserving the shunt and excluding the splenic vein from the portal circulation is less morbid and mortality compared to other procedures. And it improves the blood flow to the liver, so that liver function would improve over a period of time. So, in conclusion, splenic venous dissociation is alternative to retrograde transvenous obliterative procedures such as BRTO, CARTO or PARTO to treat patients with hepatic encephalopathy and a large splenorenal shunt. The specific advantages over RTO include no significant increase in the portal venous pressure and no recurrence of ascites or other varices, especially esophageal other stuff. It can be combined with variceal embolization and TIPS procedure as needed. Thank you.
Thank you, sir, for the wonderful talk. Any questions from the audience we can take?
One question, this is actually regarding post-DIPS. So, and in acute thrombosis, how often and what is the threshold for us to diagnose heparin-induced thrombocytosis and thrombocytopenia? This is something that rarely we see, but yes, we see. So,
I'm confused.
So, this is regarding a question about acute thrombosis of the TIPS or DIP stent. What is our threshold to diagnose or think of HIT?
HIT?
Yeah.
Oh.
This is a generalized question.
I think HIT is quite rare, first of all. I think we overdiagnose it. I think, I think it's very rare, first of all. So we need hematology to look into that one. So we did a study a long time ago in 2007 in Mass General. What is the reason? What is the reason for acute TIPS thrombosis? And within the first 1 month. So what we found was there are 2 main reasons. Number 1 is technical reason, either you used a bare metallic stent or the acute kink in the stent. That's the first. Second reason is a competing shunt. In more than 70% of the patients who had acute TIPS thrombosis within the first month, 50 to 70% of them had a competing shunt. So disconnecting the shunt or embolizing the shunt is important to preserve the TIPS.
Thank you, sir. If no further questions, then we'll close the session and continue with the next.
Ladies and gentlemen, a quick group photograph. If you're part of these, one of the speakers, please join us here. Thank you, Dr. Sant. Big round of applause, ladies and gentlemen. Yet another amazing session at ISVIR 2026. Thank you, that was absolutely fabulous. A gentle reminder, ladies and gentlemen, some of you have forgotten to switch off your mobile phones. I even heard an alarm. So please put your mobile phones on silent. That's a humble request so we can enjoy the sessions further. Thank you so very much. And also got to know that Dr. Khera completed 7 kilometers on the beach in terms of a beach marathon. No pressure, but remember to complete your 12K steps so you get that voucher from GRT. Moving on, ladies and gentlemen, may I please invite the chair people for the next session, Dr. Uttapa, Dr. Indushekar and Dr. CPS Chauhan to please join us on the stage with a nice big round of applause. We definitely can do better than that. Come on, the sessions have been fabulous. Our speakers are fabulous. Thank you. Thank you so very much.
Right, so we'll continue with the portal hypertension, I think. I think there's a little bit of jiggle with the talks. So we've been given a mandate that we're going to have 3 talks in this session. The first one is understanding portosystemic shunts, anatomy and pathophysiology in the context of image-guided intervention. And the speaker is going to be Dr. Jagdish Singh, who I don't think needs introduction. So over to Dr. Jagdish, please.
Hello. Good morning, everyone. So, I have been given the topic of trying to make myself understand first and make you also understand the anatomy and pathophysiology regarding in the context of management of portosystemic shunts. So, as we know that portal hypertension is defined as a pressure of at least having 5 mm above with respect to the IVC. And when the portosystemic gradient becomes more than 10 mm, definitely we see the clinical manifestations of the same. And as we know, the most common cause being cirrhosis as the most common cause of portal hypertension in approximately 90% of these patients. So, what is that what we look at when we are talking about portal hypertension? With this particular topic, what I am telling, we need to have some clarity regarding what do you call, when do you call it as a varix and when you call it as a shunt. A varix being a dilated end organ vein with a high risk of rupture depending upon the pressure or not, and shunts are distended vascular channels that connect the portal with the systemic circulation. So, what are actually these shunts? These can be the recanalization or reopening of the embryonic channels, or reversal of flow in the venous systems leading to the portosystemic collateral formation. And this can be as a bypass of an occlusion or a distortion from a high pressure gradient to the low pressure gradient. So, liver cirrhosis, as we know, we can see about 10 to 20% of the patients do have this spontaneous portosystemic shunts, which act as a release valves or a bypass to the normal liver flow. Also, as we can see that portal hypertension, as it progresses, these SPSs grow further and they add more blood into the systemic circulation, and at a point it reaches such that it starts contributing to the progression of the liver disease. So, how do we actually visualize? Can we visualize these shunts is what we need to know. So, how much each imaging modality would contribute? One is the ultrasound. As we see, we can see very big shunts which are quite obvious, like the parambolical recanalized or the splenorenal can be easily visualized, although it is more of operator dependent when it comes to smaller shunts. The go-to imaging would be the MDCT or the MRI, more with MDCT because we can plan in a better way as to which shunts to be tackled in which particular way. You go for the retrograde approach or the antegrade approach, that way. So, how do we classify it? Although there are previous classifications of taking the surface area, recent tell that 8 mm as the cutoff with respect to a smaller or a larger shunts. And as we can see, these spontaneous portosystemic shunts, you might have seen that they usually go into the systemic circulation, that is usually IVC. They find their way into IVC. Whereas the variceal extra portosystemic shunt, they usually go into the superior vena cava. So, what is the amount of portosystemic shunt which is actually considered to be abnormal? It is still unknown. It varies from person to person, and also it varies from one portal circulation to another. So, the cause of variation may not be limited only to the underlying liver disease or the location of the shunt. It depends. It is multifactorial. So, we need to take into account the compliance of the portal circulation, the compliance of the hepatic parenchyma, the presence of other portosystemic shunts, the size of length of the shunts. So, how do we actually analyze these things? It's still an enigma. So, we get to know as to how we do this obliteration of the shunts and get the desired results. So, what else do we see along with the shunts is more common is splenomegaly and thrombocytopenia is seen in more than 90%, especially with the large shunts. And in late stage, you can see even the hepatic atrophy as well as splenomegaly. So what actually defines certain times in an imaging? In an imaging, you can see that the spontaneous photosystemic shunts, the Doppler demonstrates a 20 centimeter per second hepatopetal blood flow in the main portal vein with paucity. As it goes further, it may become bidirectional, there will be reversal of the flow with diminutive portal vein or the collapsed portal vein. So many might have been quite familiar with these recent articles by Kim and Lee, where they showed the pathophysiology with respect to an electric circuit with respect to the Ohm's law, where in a normal state the shunt resistance is sufficiently high enough to maintain, due to which the shunt flow is negligible. So what are the other factors which contribute to these shunts? Are they still just the shunts which are existing are going, or there is any factor providing them to have a neoangiogenesis? So what are the factors? So in view of these large shunts, there is significant hypoxia, oxidative stress leading to nitric oxide production by the endothelial nitric oxide synthase, increase the vascular permeability and promote angiogenesis. Apart from this, even the platelet-derived growth factors and the placental growth factors have been known to be the contributory factors. So these collateral vessels ultimately contribute to the decrease in perfusion, as I told, the hypoxia, and this forms a vicious cycle. It's a conundrum basically. This leads to a positive feedback with progressive amplification of the mechanisms, and then what we call it as a photosystemic shunt syndrome, which was usually primarily coined by Kumamoto and further exemplified by Dr. Saad. So it has been seen that there are multiple stages at which what particular modality actually comes in way of how to tackle these shunts, with the early stage being the relatively medical, the late or the stage B is when the shunt embolization takes care, and in the later stages it's the transplantation which is the ideal modality of choice. So this bypass or the shunts can be classified again with respect to intrahepatic, which can be a recanalized paraumbilical vein or a tip shunt, or a prehepatic, which comes as a spontaneous photosystemic shunts. So in the setting of this intrahepatic photosystemic shunt, what actually do we see? We see in the portal vein flow is always hepatopetal, unless there is some coexisting or a prehepatic shunt. So a word of two regarding how much these shunts contribute to hepatic encephalopathy, how important is that we should manage these shunts with respect to tackling this hepatic encephalopathy. As we know that hepatic encephalopathy has got a very poor prognosis, with 1 to 3 year survival rates being about 42 and 23%. We have seen what we see in imaging and also by IR, that is the splenorenal and the mesorenal shunts, which have been to be most commonly associated with HE. And another concern with respect to the large SPSS is the presence of the patent portal vein, which over a period of time, due to the competency, they get diminutive. So there has been multiple studies which show that how important we need to manage these shunts. So it has been seen that by multiple studies that in majority of those with episodic HE or even recurrent or persistent HE, it's the contributing factor being the large photosystemic shunts. So when the patients were stratified by MELD score also, it has been seen, it has been found to be, the shunts were found to be independent of liver function. So another thing is the presence of hepatofugal blood flow. It has also been considered to be an important contributing factor in the development of hepatic encephalopathy. Another terminology what it has been coined is the cirrhosis related Parkinsonism, where you see more of extrapyramidal symptoms or cerebellar symptoms which have been seen, and on management of these shunts they have found to be normalized. So which are the usual common collateral pathways which usually come? One is the esophageal varices, which I think all are quite familiar with, where the afferent vein is the coronary vein and the efferent being the azygous vein. As you can see in this figure, that there is the coronary vein which is contributing, and you can see the efferent being the azygous, and you can see the posterior paragastric vein which is contributing to the paraesophageal varices. Then the gastric varices is one thing which we commonly encounter whenever you see a gastrorenal shunt, for which, in the absence of which we need to go from the antegrade way through the portal vein circulations. So the contributory factors or the afferents are usually the LGV or the short and posterior gastric veins, and the efferent being the left renal vein, which is the most common. And the endoscopic classification, although I wouldn't go into the details of it in this particular talk, we will go to the gastric varices per se. It can happen even in the sinistral hypertension, where there is isolated splenic vein occlusion, which we get more common in the pancreatitis related. So as you can see, this is a splenic vein occlusion. We can see multiple collaterals through which the LGV is being contributing. The same thing, as you can see, the multiple gastric varices have been seen. And here you can see a gastrorenal shunt, which is contributing to the gastric varices. The other one being the, apart from the gastrorenal shunt, we can see the paraesophageal varices also. So there is, I think even this we completely know, the hemodynamic classification, which was more important as to the QOS, how you do the type 1, type 2 and type 3. In type 1 it is more or less pretty straightforward. In type 2 there will be two competing things, the low pressure efferents and the high pressure draining veins. And then the type 3 where we may have to employ separate approaches to manage the same. So this is another splenorenal shunt, where the efferent will be the splenic vein and the efferent will be the left renal vein. And the paraumbilical shunt, which is also quite common, which we come across in management. So you can see it goes into the abdominal wall collaterals through into the iliac veins. And then the rectal varices, they have been found to be more contributory rather than bleed to the encephalopathy. So you can see the rectal varices also contributing significantly to the encephalopathy, for which you need to go through the antegrade approaches. The other common pathways, I think I wouldn't go much into the details of this particular table. The uncommon pathways which you usually encounter will be the mesogonadal shunts, in which the afferent will be the mesenteric, for which you go through the antegrade transhepatic portal vein. And then the efferents will be the gonadal vein, draining ultimately into the systemic circulations. Duodenal paraduodenal varices, where the afferent can be the pancreatic or duodenal veins, and the efferent again through the veins of Retzius into the IVC. And then ultimately the stomal varices, which are also quite common, where the tributaries of the SMV form the afferents, and the efferents being the superior epigastric veins. So aberrant left gastric collaterals is also a rare thing, but still if you need to have a good imaging modality to quite visualize and accordingly treat the same thing. So the uncommon pathways, I wouldn't again not go into the details of this. So another important thing, I think this particular topic has been touched by our previous speakers as to, do we manage the spontaneous portosystemic trends when you come across in a TIPS patient? So there have been multiple studies to show that yes, you need to treat it, and they have got a good follow-up, and the incidence of overt HE was significantly lower in the TIPS group. So SPSS and PVT again, the portal vein diminution with or with left-sided portosystemic shunts. Hypersplenism is considered to be an associative factor. There have been studies to show that PVT was independently and significantly associated with the presence of a spontaneous portosystemic shunt of any size, and was statistically associated with, especially when the shunt size was more than 1 centimeter. So the presence of collateral vessels with a flow volume of more than 400 ml and a flow velocity of more than 10 centimeters seconds proved to be a significant risk factor for the occurrence of the portal vein thrombosis. Another thing, I think that this was also a debatable thing, whether we need to occlude or ligate the shunts prior to transplant. There have been multiple studies which go for that you need to go and occlude the shunts, or they have been contrasting views by Sachs and Rodriguez, where show that shunt ligation does not influence the graft survival or morbidity. So in a recent retrospective study, although it has been seen that without small or large SPSS, No statistical difference was found for overall patient survival or the graft survival. So with this, I would like to conclude my message telling that all cirrhotic patients should be studied with the radiological imaging in order to detect the becomes crucial in selected cases in which the embolization of the large shunt is associated with improved survival and liver function. And due to the complex and dynamic nature of this particular liver function, the influence of both the variceal extra portosystemic shunt and the spontaneous portosystemic shunt, the individual patient characteristics, management decisions need to be made on a case-to-case basis. Thank you.
Thank you, Dr. Jagdish. We got 13 seconds. You have any questions? Any questions from the audience? I think it was very clear. So you convinced everybody, right, that there's no. Just with imaging, do you ever, all your images were, with CT. In portal hypertension, is there with modern imaging with MR, do you think we can substitute CT with MR if we can't give contrast to these patients?
Yeah, to some extent, yes.
Yeah.
Yes, definitely we can do where there are.
I sometimes feel we don't use it enough, but we can.
It's not this thing, it is definitely it can be used. It can't be just negated. But since I think the availability and as I told that we are more used to seeing on CT planning everything, MR is definitely not this thing. Yes, we can definitely consider on MR.
Should be able to get as much information
Yeah.
with the MRs, especially
Absolutely.
with patients we can't give contrast.
Definitely.
Okay, thank you, Dr. Jagdish.
Call upon Dr. Walsai for giving a talk on.
Take this one.
He's going to speak on cardiofundal gastric varices approach to management, case-based discussions.
Thank you, Mr. Chairman, and thank you for the invitation. This is a long talk talking about how to approach gastric varices endovascularly. GV bleeding, what's really at stake, and where does IR really fit in? With gastric variceal bleeding, it is less common than esophageal variceal bleeding, but has a very higher mortality. On the first bleed, the mortality is about 15%. The second bleed, it's about cumulatively over 30%. And by the third time, it's about 50% mortality. IR is usually a secondary prophylaxis after the first sentinel bleed. Rarely do we do primary prophylaxis for high-risk GVs determined by endoscopy. And then what is it, and this is what the whole talk is about, is what do you do? Do you do TIPS? Do you do BRTO? Do you do partial splenic embolization or combinations of thereof? Looking generally between TIPS and BRTO or BATO, one is loss of a shunt and one is creation of a shunt. The advantages and disadvantages of both of them are exact opposite of one another. One is creation of a shunt and one is closure of a shunt. And then where does splenic embolization fit in? And you have to basically tailor it, and that's the conclusion of the talk, tailor it to the patient's presentation and needs. Once you consider combining TIPS and BRTO, then what do you do first? Do you do a TIPS first? Do you do a BRTO first? And if you're going to do them together, are you going to do them together concomitantly in the same procedure or not? And then where does splenic embolization fit in? So this is a far more complicated debate than TIPS versus BRTO. And you basically have to tailor it to many factors: hepatic reserve, presentation of the patient, comorbidities, the size of the shunts, is there thrombosis in the portal vein or in the splenic vein? One of the classifications to help you wrap your head around this is the Saad-Caldwell classification. That's part of the ASLD guidelines. And this can be applied to any form of varices. Here you have to your far left is any generic GIT. This could be the esophagus. Feeders to the esophagus would be like a coronary vein or left gastric vein. And if there's any shunting, like Dr. Singh showed,
it could be shunting to the azygous or hemiazygous system, for example. If it's a stomach, then this is basically gastric varices, and the feeders would be a posterior gastric vein, short gastric vein, or left gastric vein. And if there is a shunt, it's a gastrorenal shunt emptying into the renal vein. Generally, a type A, basically, there is patency of the portal circulation, and a type B, there is some form of occlusion, either partial or complete occlusion of the splanchnic circulation. So, how do you approach this? Well, it depends on how much time do you have. Do you have a shunt or not? What are the presentations of the patient? What is the hepatic reserve? What's the splanchnic anatomy? Pathology? Is there thrombosis? Is there occlusion? Where is the occlusion? All of this has to be factored in. And then you apply our entire IR, intervention radiology, and or surgical armamentarium to tailor it to the patient's needs. So scenario number one, unstable patients, failed endoscopic measures, bleeding everywhere. They don't actually know whether it's esophageal varices or gastric varices. Do you care about the MELD? It's really a salvage, heroic procedure to try to control the bleeding. What do? You do a TIPS. You don't know where the source is. You don't know if there's a shunt or not. This is a salvage procedure to try to save the patient. Next, stable patients. There is time for endoscopy. They actually identified as gastric varices. Then you can start asking, what's the hepatic reserve? Does the patient have hepatic encephalopathy? Imaging. Does the patient have shunts, thrombosis or not thrombosis? And that's where your classification system kicks in. Under that, there are three subgroups that we're going to triage through this. Patent portal circulation, thrombosed portal vein, and then isolated thrombosed splenic vein. Starting off with the first group, the patent portal circulation. Patient is not a TIPS candidate. MELD is above 18, for example, has hepatic encephalopathy or cardiac disease, and the patient does have a gastrorenal shunt. So it's a good candidate for a conventional BRTO. So what do? You do a BRTO. It's not a TIPS candidate. Patient is a TIPS candidate in the next scenario, and there is no clear gastrorenal shunt. So what do? It's very simple. You do a TIPS, and then you do a trans-TIPS sclerosis, a BATO. And we'll come back to that in a minute. Patient is a TIPS candidate and is a BRTO candidate, and this is the most controversial. Which do? Do you do a TIPS or do you do a BRTO? That's the controversy. Do you start off with a BRTO and see how things go and then do a TIPS if need be? Okay? Or do you do a TIPS and a BATO on the sclerosis? Okay? Or do you do a combination, a surf and turf, TIPS and a BRTO combination? What do? What's your patient selection? To talk about this, let's step back between TIPS decompression for EVs and GVs. TIPS is far more effective in decompressing esophageal varices compared to gastric varices for some reason. Here's the hypothesis. Looking at it, bleeding is very high and very high mortality with gastric varices. Remember, it's about 30 to 45% on the second and third bleeds. BRTO is very effective in controlling and stopping rebleeding from gastric varices. It is less than 3%, and that is an intent to treat analysis. In other words, after a successful BRTO, the rebleed rate at 3 years from gastric varices is 0. Nothing beats 0. It's like a fraud. It's 0, okay? Nothing is more effective than BRTO in stopping the bleeds from gastric varices. I've seen out of 200 BRTOs, 1 bleed that occurred 6.5 years later after the BRTO. Only 1 bleed in 15 years with 200 BRTOs. So you want to be as effective as possible. Here's a case, TIPS, gastric varices, bleeding gastric varices still despite a TIPS and hepatic encephalopathy with a wide open gastrorenal shunt. I can show you case after case after case of TIPS with bleeding and or hepatic encephalopathy after TIPS for gastric varices. Okay, we did a BRTO after that. We did not reduce it's more morbid hepatic encephalopathy. Redirected flow did not affect the tips, and actually encephalopathy improved, and of course the bleeding stopped as well. Okay, here's another case where gastric variceal bleeding, wide open tips, and still a gastrorenal shunt and bleeding from the gastric varices. The theory behind why TIPS is better for esophageal varices compared to gastric varices is that these are shunts that are completing with one another along the splenoportal axis. Okay? You need to look at these shunts in a different way. And this is another case just to show you the anatomy of a TIPS, wide open TIPS, and then you have esophageal varices and gastric varices. The afferent feeder of the esophageal varices to the gastric varices is half the distance compared to the tips. Gastric varices is further away. It's far, far on the left. So you need to look at these shunts not only as the size of the shunt, but is the proximity to that shunt. It is like a sump. It is like a sinkhole or a black hole in space. It's not only the size of the shunt, it is how close are you to that shunt. If the shunts are equal to one another, if you're closer to that shunt, you're going to get sucked into by that shunt itself. So the shunts is not only size, but it's also location and its vicinity. With gastrorenal shunts, the shunt is closer to the gastric varices. There is actually schism of the flow and schism of the portal circulation between left and right. Okay, and here you have it as kind of another example, just showing you these shunts. Then you have to look at laterality dominance of the gastric varices. Some feeders are actually complete left from the short gastric and from the posterior gastric, and other feeders are complete rights. Okay, and so there is actually either you're a left side dominant or a right side dominant, and then there's a third type, which is there is no dominance. There are major feeders on both sides, left and right. Okay, can't go through the details, but there's another Saad-Caldwell classification in the ASLD guidelines. A type A has no gastrorenal shunt. A type B has gastrorenal shunt. A type 1 is right dominant, a type 2 is left dominant, and a type 3 is non-dominant, major feeders on all sides. The least effective for TIPS is a left dominant feeder with a large gastrorenal shunt. That one will not be decompressed by a TIPS appropriately, okay? So, if you look at the results, 20% of patients after a BRTO need a TIPS in 3 years, and it's usually for ascites, not for variceal bleeding, sometimes early on esophageal varices. And over 12% of patients that get a TIPS actually do need a BRTO within a year. The results are leaning towards do a BRTO or at least do a sclerosis and not just TIPS the patient in general, okay? The key thing is, and the take-home point is, you have to sclerose these varices or gel foam these varices. Whether you TIPS them or not is secondary, but you have to do a BRTO or a BATO. You cannot just coil these or plug these varices. So when do you do the TIPS? What will sway you towards doing a TIPS? Other concomitant things, esophageal varices, ascites, very large gastrorenal shunt that are larger than your plugs or balloon, portal vein stagnation where you need an outflow to the portal circulation because you've got pending thrombosis, or emergent Blakemore. If there's a bleeding and your Blakemore is up, you cannot do a BRTO or a BATO with your Blakemore balloon up. It effaces and compresses the varices. You cannot fill the varices. You cannot see the varices with the balloon up. You have to disengage the balloon or deflate the balloon. With portal vein thrombosis, if it's acute portal vein thrombosis, you do a TIPS, a portal vein lysis, and a BRTO. Which do you do first? You do the BRTO first because you might lyse. You need to secure the bleed first. But if it's chronic occlusion, you still do opening the portal vein, a TIPS, and a BRTO, but you do the BRTO last. You recanalize first, reestablish flow, and then you do the BRTO lyse. You're not lysing. And then you have compensated chronic, either through collaterals or through partial thrombosis. This is where you do splenic embolization, a combination of BRTO. This is a case, for example, where we did a BRTO overwhelming a partially thrombosed portal vein in a child. We then did a splenic embolization to temper the flow and to temper the pressure. Isolated splenic vein thrombosis. In isolated splenic vein thrombosis, the portal vein is open. This is sinistral portal hypertension or left-sided portal hypertension. Again, you're going to apply this classification system. It's basically usually it's a 1B. The spleen is emptying through the stomach, the coronary vein is reversed, and it's basically bypassing the splenic vein occlusion. Okay? Usually type 1B, rarely is it a type 3 with a portosystemic shunt. The first thing you do
Last 2 minutes.
is you go transsplenic, and you do not try to open up the spleen. The flow is preferentially going to the varices. You sclerose the varices, you take advantage of the flow, and then you address the splenic vein occlusion and open it up. If you are unsuccessful in opening it up after sclerosing the varices, then you do a splenic artery embolization to reduce the flow. If you are successful in opening up the splenic vein and sclerosing the varices, you stop there and you do not do a splenic artery embolization. So here's an example. This is subacute clots in the splenic vein with gastric varices. There is no shunt. The spleen is emptying through the stomach. We sclerosed the varices and coiled them, and then put a stent at the very end and opened up the splenic vein. This is where you stop and not do a splenic embolization. Another case where you have splenic vein occlusion, go transsplenic, sclerose the varices, then open up the splenic vein, and then you stop doing any embolization. You're done. No splenic embolization. Here's another case. Transsplenic access, we sclerose the varices firsthand. We then fail in recanalizing the splenic vein, and in this case, we basically revert to a splenic artery embolization to reduce the flow. We've sclerosed the varices and embolized the splenic artery. Okay? So in conclusion, high risk, high mortality, you need to do your very best to actually reduce the bleeding. You need to sclerose the varices and not just decompress them when it comes to gastric varices. Look at this classification system to just understand and wrap your head around things, and tailor it to the patient's anatomy, the patient's needs, and the patient's presentation. Thank you.
Time is up.
Thank you for a brilliant presentation. We're run out of time. So I suppose if there's any questions for Dr. Saad, I'm sure you're around for a few more days, so thank you so much. You want to introduce the last speaker?
Which is the last one? So Dr. Yashwant Padidar, who is the Professor of Intervention Radiology at ILBS, Delhi, he'll be speaking about the too late for tips. Dr. Yashwant Padidar.
Good morning all. So today I am going to speak about the role of tips in the difficult to treat ascites in cirrhosis. And title of my topic is Too Late for Tips and rethinking timing in the difficult to treat ascites. So my task in this lecture is to identify the ideal window time and suitable patient who can benefit from the tips. Ascites is one of the most common and major complication of the cirrhosis, and transition of the or development of ascites marks the transition from the compensated to decompensation of the liver. And if refractory ascites develop, it has approx 40 to 50% of mortality at 1 year. We all know that tips improve survival. Our optimal time point for tips is still unknown by many of us, and because of this we often consider tips as a late mortality, and patient with a high risk of ascites progression also not known to many of us. Initial standard management is clear that salt restriction and diuretic, if not improved, then LVP with albumin infusion. But sometimes patient continuously on the repeated LVP, but it has very disadvantage because it does not correct the portal pressure, which is the main culprit for the ascites. And there is always a risk of infection, and quality of life of patient is also very poor because of the repeated procedures. So we can consider LVP as an initial symptomatic relief only, and we should consider TIPS because it modifies the basic etiology, that is it decompress the portal pressure. And if we say ideal time is that when the diuretic responsive ascites is translate into diuretic refractory ascites, which may be 1 year, 2 year, whenever the patient underlying liver deteriorate and diuretic response is converted to diuretic refractory. This is the ideal window. Then TIPS work, that if organ are very in good position, then TIPS work best. However, in the current practice, we often use, or clinician often use as a last resort therapy after multiple paracentesis and often in the advanced disease of the patient. So if we delay the TIPS, then it indirectly increases the incidence of the post-TIPS complication in the form of liver failure, encephalopathy, and oral transplant-free survival also less. So it again blamed to the TIPS, which is originally not, because the physiological reservoir of the patient in later disease is lost. If we see the literature, it is clear cut that TIPS is overcome the other standard therapy, and literature show that approx 40 to 50% decrease in mortality at 1 year if we consider TIPS at an appropriate time. So what is the ideal time? These both international guidelines, European Association and American Association, also consider that early TIPS whenever the recurrent or refractory ascites develop, and we should start evaluating the TIPS before any organ deteriorate. This is the one of the prospective study which compare the TIPS versus LVP, and it show that TIPS group show approx 93% survival at 1 year as compared to LVP which show 52% survival. So at least double survival at 1 year. Another study which highlight the which patient are a high risk of decomposition in the ascites and which can be prevented by TIPS. According to this study, patient with ascites grade 3 and either sodium less than 135 and MELD more than 12. So our lower limit is if patient is MELD more than 12 with refractive or recurrent ascites, we should offer TIPS to prevent post-TIPS complication, to prevent the ascites complication. This is another study which highlight the what is the number of frequency we require prior to TIPS. So according to this study, that ascites controlled by TIPS is more successful patient with the lower paracentesis frequency. And if we do TIPS in lower paracentesis group, it show more survival as compared to high paracentesis group. So again, that we should evaluate patient at early ascites group. What is the paracentesis frequency, which clearly mentioned by this recent guideline in 2024 by French Association, that more than 3 LVP, recurrent LVP, and patient with refractory ascites are ideal for the TIPS. And if we introduce TIPS in the early in the disease of the cirrhotic patient, it improves the survival. Another guideline published in 21 in the gut, which set the upper limit for the TIPS. So they advise precaution, that is either you use the partial TIP in this high risk patient, if patient is having age more than 70, bilirubin more than 5, MELD score more than 18, patient having current HE and acute active infection. So our initial limit is more than 12 MELD and upper limit is 18. So 12 to 18 is the ideal window. So if we choose this patient less than 18 MELD, bilirubin less than 3, sodium more than 130, this patient demonstrate largest survival without significant risk of HE. When we can say that too late, that is very high risk, a patient having MELD more than 22, bilirubin more than 4, severe hyponatremia and severe sarcopenia. This type of patient may not improve with the survival, so we choose wisely or offer the transplant. What is the optimal post-TIPS portal pressure gradient? Again, another questionable answer by many of us during the creation of TIPS, and very good answer by this study 2025, that if PPG of less than 7 we achieve, then it increases the risk of liver related death. If PPG is more than 11, it increases the chance of recurrence of ascites. So ideal PPG according to this study is 7 to 11. Or if patient is having more than 18, then you can achieve target PPG of more than 12, 13. Another study we also show that PPG reduction of 60 to 80% is showing good overall survival with least chances of the HE. So all this PPG gradient, PPG reduction are for the ascites, not for the gastric varices bleeding or patients. So what we learned from our experience of 15 years in our institute, that when we started the TIPS in the 2010 to 15, patient usually very well tolerated the 10 mm stent, and we are very happy with the very low gradient approx 5 to 8, because we identified that time patient usually refer in the early ascites phase, because initially clinician only have 1 or 2 diuretic, and MELD also of this patient also very low, usually less than 14. So these patients usually tolerated well the
Last 2
TIPS.
minutes.
After 2016 and more, we changed many technical, because we think that patient develop our many complications during TIPS. So we modify or we use 6 mm, 8 mm, 10 mm diameter stents, and we find that because patients are referred late, so there is always a risk of the high post-TIPS complication. And at present time, we switch to the 8 mm stent for the ascites. Our target PPG is 7 to 11 mmHg, and we accept the patient up to 80 or 20 ml for the TIPS in the ascites. So algorithm is that if patient is having refractory ascites or recurrent ascites with more than 3 LVP, if eligible for TIPS, that is male less than 18 and more than 12, bilirubin less than 3, we should offer the TIPS. If patient is not eligible for TIPS, we can optimize the patient and reconsider for TIPS later on. If patient is not optimized by this optimized therapy, we can send the patient to the transplant. So my take-home message is that early TIPS improve outcome. We should ideally identify the patient who is benefit from the TIPS, and late TIPS, that is more than 22 for the ascites, increases the TIPS complication and lower benefit on long term. And we should not think that TIPS should be a last resort. It should be in the treatment option to prevent the to increase the survival of the patient. Thank you.
So we have time for probably one question.
Yes.
Brilliant talk, Ash. Thank you for the talk. I think this talk is not only useful for the youngsters who can go to MDTs and convince your gastroenterologist to please refer TIPS early, because we all know from our own experience, particularly in India, that a lot of them come very late. So thanks for sharing that. I have one question. Which are the cases in the last few years at your center where you use 6 mm stents specifically?
When patient having age more than 75 or MELD more than 20, then we initially did the TIPS with 6 mm, but no improvement of ascites. So now we switch to the 8 mm, place the 8 mm stent and dilate up to 7 mm or 6 mm if patient age is more than 75. If patient age is less than 75, we dilate to 7 or 8 according to patient situation. If no sarcopenia, everything is okay, we dilate up to 8. If patient is sarcopenic, age more than 75, we initially dilate up to 7 or 6 mm, wait for 1-2 months. If patient not improve, then dilate to 8 mm. So it directly a control expansion stent in our country. That's all.
Thank you. Any questions from the audience? Okay, no questions. Thank you very much. We'll end the session here. Thanks one and all.
Thank you so very much. Can we have a quick group photo, please? We thank our chair people for this wonderful session. Thank you so very much. Dr. CPS Chauhan and our very youthful IRs from Bengaluru, Dr. Uttapa and Dr. Indu, and the other speakers who are part of this session. May I please invite you to join us on stage for that group picture, please. Meanwhile, the chair people for the next session, I urge you to be ready. Dr. Saurabh Kumar, Dr. Arun Gupta, Dr. Bejal, Colonel K. Uday Banu, I request you to please be ready. Thank you once again for that thought-provoking session at ISVIR 2026. Ladies and gentlemen, give them a nice big round of applause. Thank you.
Okay, so we are starting with this next session again on portal hypertension. I would like to call Professor Veal Shah for trans-mesenteric approach for PVR tips. Professor Veal Shah, yours is next. Are you not, Professor? Are you? Okay, okay, I'll call you in the next talk. So, Professor Rajiv Priyadarshi, and he is going to treat or wait rethinking the approach for asymptomatic but carry syndrome. Dr. Rajiv Priyadarshi. Yes, so I think we should start with Dr. Shivanand. Oh,
sorry.
Sorry, I'm sorry.
Can you pull up my my talk? And it's a 15-minute talk, not a 10-minute talk. Sorry for the mix-up. This is a very complex case, complex talk. Yep. And hopefully 10 minutes, 15 minutes.
Please fix the time for 15 minutes.
So portal vein recanalization. The first line really is transplantic TIPS PVR. The second line would be transhepatic TIPS PVR, probably kind of a second line or an adjunct to the first line. It's either because the spleen doesn't exist, status quo splenectomy in cirrhotics, not uncommon. The spleen is small and very high up, or you can't find your way from the splenic side to find the portal vein itself. And you need a combination transhepatic, transplantic rendezvous. Or there is mesenteric discontinuation from the spleen and the splenoportal axis that we talked about in a prior one. The most common is that you just couldn't find your way. What's common is common. Also not uncommon is a splenectomy. A surgeon had a go at the spleen before you did the recanalization. And the least common is to have a small spleen in a cirrhotic patient. The last line is transmesenteric, which is the subject of this talk. Okay, it's higher risk, and it's usually because of mesenteric discontinuation. And a combination transhepatic, trans-TIPS, or transmesenteric rendezvous is required. So it's primarily for mesenteric discontinuation. If you look at the mesenteric discontinuation, first line is transhepatic, second line is percutaneous transmesenteric, and then in the third line is actually surgical
through a mini laparotomy, and we're going to try to go through all of these. As far as indication for mesenteric and portal vein recanalization, usually is variceal bleeding. In the United States, it's also a prelude to a transplant. You're trying to open up the portal vein in preparation for a transplantation and a direct hookup. The least is ascites in the United States, primarily because of risk stratification. When it comes to varices, they usually, where the confusion is duodenal varices, or they're varices in the hepatico-J in the roux. It's a central varices close to the hepatic hilum, where there's either varices along the splenoportal axis or varices along the mesoportal axis. And after doing a splenic embolization, for example, or recanalization from spleen to liver, if there continues to be bleeding, then you need to do a mesoportal axis because the varices are along the mesoportal axis. So here's an example, patient with a spleen, but we were unable to get into the portal vein from the splenic side, but you see kind of like thrombosis of the of the portal vein inside the liver. We go transhepatic, access it, push through, access the portal vein, branch, push through, and find our way down. Lots of pictures. There's that kind of cord of that portal vein. Seek it out, push down, and find our way down into the mesenteric vein. Okay? We can't get to the splenic vein on either side. We failed in getting to the splenic vein on either side. This is a middle-aged woman with about 18 MELD score, and we're just trying to reduce the bleeding by doing a TIPS mesenteric PVR, and this is a retrograde approach, transhepatic, and we were successful in doing transhepatic, going into the IMV, angioplasty, and then landing a TIPS on to the snare, and then buckling it in through, pushing it in through, and then we've basically got access through the TIPS, landing the TIPS, getting the sheath down, deploying the TIPS, and then we find competing collaterals, which we basically embolize. You don't have to embolize all the collaterals, but you're trying to get preferential flow through the TIPS and through the portal vein to keep it, and the mesenteric vein to keep it open. Patient came back with hepatic vein narrowing. We angioplasty that, put a stent, embolize more collaterals, not all collaterals, and basically with pretty good results. One of the issues is you will get successful results after a while, so we bring them back and take a look. They actually look a lot better after a while. Not as good as splenoportal recanalizations because there's not a lot of flow from the mesentery. It's actually very good post-op, especially in men, especially men with big bellies, is to have them eat very early on after the procedure to get flow through. Patency is an issue with mesenteric recanalization without any splenic inflow. Here is a very complicated case, just to show you kind of the runs of things. This is a patient without a spleen, splenectomy, with variceal bleeding, who's doing an SMA run all the way to the venous phase, and what you have is mesenteric to portal discontinuation. What you have is mesenteric to portal discontinuation where the mesentery is not reaching the portal vein and there's a lot of collaterals. We basically do an access of the SMV and try to get up. And what we have is a collateral and not the main portal vein. Okay? It is actually the collateral. We're not in the main portal vein here. We tried a wire. We found our way up in a collateral. We did a run. It's in the collateral. It is not in the main portal vein from the SMV approach. But we did so that's kind of the collateral, but not the main portal vein itself. Basically the SMV and the IMV are discontinued, we think, and leading to the portal vein. What we
what we did, what I can't show you, we don't have images for, is that our wire was actually able to go into the IMV from the SMV, showing that it's actually open. We never saw it by angiography, but it is actually open. So what we did is a second stick into the IMV and did a run, and that's basically the portal vein that we have. So it's a kind of a double stick mesentery, one time in the SMV, one time in the IMV, once we figured out that the IMV is the one that has a straight shot to the real portal vein. We couldn't get to the portal vein from that. And then we know that these are connected. We don't see it by angiography yet, but we know that the IMV and the SMV are connected here. So that's just a coronary vein collateral with gastric varices, a gastroesophageal varices, and that's the portal vein itself, and it's a straight shot to the portal vein. We basically access the SMV, retrograde, do a run, so the SMV is actually quite prominent. We pass a wire from the IMV all the way up, basically put a snare up, and what you have is, this is a micro snare through a quick cross catheter. Next to it is just a wire, as a safety wire adjacent to it, and we're targeting the snare with the tips, trying to land the tips in this. We use a 21 gauge Chiba needle coaxially through the colopinto needle, because usually the colopinto needle is as large as the micro snare itself. So we want a smaller needle, access it, pull through, and we basically have a tips landing onto the IMV with a communication, do a run, that's basically the coronary vein. Here's your repeat run showing a coronary vein, a nice portal vein, an intrahepatic portal vein. Another run just to show you all the anatomy, and show you the gastroesophageal varices, and now the IMV and SMV. For the first time, we actually see that they are combined, and they're open to one another. The smooth tips landing on the portal vein is also very crucial. And then you have these gastroesophageal varices. We basically angioplasty to put the tips in. We haven't put the tips in yet. Select the coronary vein. We're not putting the tips because there's preferential flow going to the varices, so we're going to take advantage of that. We're going to sclerose these gastroesophageal varices with a sclerosant, and then top it off a coil, and then place the tips at the very end. We're relying on the preferential flow, and this is basically the run. Doesn't look very good. So we repeat the angioplasty with larger balloon, heparinized, long angioplasty, about two minutes angioplasty in each station to open it up with an 8mm balloon followed by a 10mm balloon with some improvement in the flow. You don't see any collaterals. The patient basically kept a portal velocity of above 20 centimeters a second. That is very important, is to keep that portal vein velocity above 20 centimeters a second. In a little under 15 months, there was follow-up CT and ultrasound showed high velocity in the portal venous end of the stent, and the CT confirmed that. This is kind of the repeat run. It shows you it actually looks better. There is a narrowing there at the portal venous end of the stent, which we basically angioplastied with a cutting balloon followed by a high pressure balloon. We also used a cleaner device to remove the clot in the proximal portion of the tips, and put a hepatic venous stent as well, extension of the tips, and this is basically the result. And it actually looks better than we first left it 15 months ago. 3 months later, we brought the patient back automatically. No need for anything, just bring him back for another venogram. They usually need repeated venograms because you don't have enough inflow from the spleen. The spleen in this patient, it's basically a splenectomy, so you have to stay on top of this. And as you see, it's getting better and better over time as long as you stay on top of these narrowings and keep them open. Okay? Next is duodenal varices. This is the last kind of approach. We talked about this classification system, type B. There's actually thromboses with
Duodenal varices, you're either they're either occurring on the splenoportal axis or the mesoportal axis, and then you will basically apply our armamentarium, tailoring it to the patient's needs. This is a patient actually that is a non-cirrhotic, very healthy 40-year-old. He has a body of a 25-year-old man. He's very healthy, and basically has portal collaterals with duodenal varices. We embolize the spleen to try to reduce the flow on the splenoportal axis, but he bled again within 6 weeks. So what we did, and this is a mini laparotomy, have the surgeons come in with a mini laparotomy, bring out a mesentery, and then access the mesenteric tributaries, and then go up through the mesenteric tributaries and recanalize, meeting in the middle through a transhepatic and transmesenteric ciliotomy access. Never have we needed to use sharp dissections, usually with a glide wire and a snare, capture and pull through. And then if you're going to stent these patients, because it's a non-cirrhotic, non-transplant patient, you put a stent. It's not a covered stent because you need those tributaries, the mesenteric tributaries, to go through these. You don't know where the mesenteric tributaries are. Put that stent and then embolize some collaterals, not necessarily all the collaterals, to get preferential flow through the bare stent to keep it open. And this patient stayed open by CT and by ultrasound without any bleeding for 2 years afterwards. So in conclusion, transmesenteric is a last resort, is the highest risk. The first line is transplenic. Transhepatic is in the middle. With mesenteric discontinuation, your first line is transhepatic, trying to go retrograde, and if that doesn't work, you need to do a rendezvous with an antegrade percutaneous transmesenteric access. Last resort is a mini laparotomy.
Last 2 minutes.
Indications are primarily varices, or in the United States, as a prelude to transplant. If it's a prelude to transplant, consider it as a diagnostic therapeutic. In other words, we have had cases where we were able to open the mesentery to the portal vein, but the velocity was less than 20 centimeters a second. When they did the transplant, it thrombosed. The transplant thrombosed. You need enough flow to keep the transplant open, and what you need is 20 centimeters a second at least to keep that transplant open. So even when you open them up, it's a diagnostic therapeutic to make sure that the portal flow is at least 20 centimeters. If it's not, we don't transplant them. We actually don't transplant them. Try to get the patient to eat early, especially men with big bellies. They will actually eat and actually keep that flow going. Thank you very much.
So, when we are using the transmesenteric approach, if we are able to cross it, fix it, the pressure decreases, it's okay. What if we fail and we have made an excess of 5 French compression, and what to do for the access closure of transmesenteric?
So what I'm showing you is trying to access through needles, 21 gauge needles. What Riyadh, for example, is doing is he's upsizing with 6 French sheath. So if that case, if we would have gone with a 6 French sheath with the SMV, we probably would have been able to do it and not needed a second stick. And he does it well, and we do it well now with 6 French sheath. I just showed you a case that's complicated with a double stick, just to show you the whole rigmarole. But you can access with a 6 French sheath and recanalize without anything. It's basically made that case that I showed you with a mini laparotomy basically obsolete.
Thank you for that lecture. Just a couple of follow-ups on this question. In the eventuality, what Dr. Arun was asking, that if we would have failed after upsizing to 6 French or 7 French, what should be the armamentarium we should have ready for exiting that mesenteric vein?
Well, if you can't access it, the only last armamentarium is to do a mini laparotomy. which is what I showed you. Bring the surgeons in, do a mini laparotomy, and access from above, and actually go from the mesentery and actually go through, because you'll have a lot more running room.
Sure.
You can put bigger sheaths, and you can get a lot more aggressive with that. So that will be your last resort.
Right. We've done a somewhat similar procedure like this with the transplant surgeons during a transplant, where we recanalized in the OR and then they went ahead and put the new liver in.
Time is up.
If I can ask one question. In the situation where patients have very often undergone devascularization and splenectomy procedures, the dominant gastric outflow is the coronary vein. And after that, if we were to have embolized that coronary vein as well to prevent a kind of a competing shunt, what happens to the gastric outflow predominantly?
The gastric outflow itself?
Yeah, because the short gastric and the posterior gastric have very often been ligated by the surgeon during the devascularization and splenectomy surgery, and we then occlude the coronary, which is the dominant outflow.
If you're dealing with varices and there's that splenic discontinuation, you do a splenic embolization.
Sorry,
to reduce all that flow, because you're telling me what the outflow is, you basically do a splenic embolization for that.
Maybe I think I'll ask, I'm not being able to get through to you. The question was, in a EHPVO patient who has undergone surgery in the past,
Okay.
and a splenectomy has been done,
Okay.
and that person also has had a devascularization procedure during that splenectomy, where very often they ligate the posterior gastric veins and the short gastric veins.
Yeah.
So the dominant outflow is now the coronary.
Okay.
And if we were to embolize that during our procedure,
Yeah.
what finally is the outflow of the stomach?
I wouldn't know, because I've never encountered those. So we don't, I've never seen any of these cases in the US. So I can't tell you.
Thank you.
Okay.
Thank you, Dr. Shan. Next is Dr. Rajiv Priyadarshi, Treat or Treat, rethinking the approach of asymptomatic Bhatkiyari.
Good afternoon. The topic of presentation today is asymptomatic Budd-Chiari syndrome, whether to treat or to wait. If you look at the data, literature says that up to 20% of the patients are asymptomatic. This is quite a high proportion, and it's very important to know that whom actually we are calling asymptomatic. Because there is still controversy in many of the literature. Are those where the detection is incidental, or those where the case was diagnosed as a part of investigation for the abnormal LFT, or those who became asymptomatic after being treated medically by the diuretics or by the other drugs? The truly asymptomatic patients are those where the detection is incidental and LFT is near normal and there is no significant signs of the congestion or any varices, but such patients are not that common. So considering the treatment based on the symptoms is not a good idea. Ideally, the treatment should proceed with the anatomy, with the degree of the underlying liver disease, not based on the symptoms, because many of the asymptomatic patients do have underlying liver disease, do have advanced disease. So we should look at the pathophysiology and anatomy before taking any decision. So before we go to the asymptomatic cases, let's look at why some patients are symptomatic and why some are asymptomatic, and how collaterals are going to play a big role in making some patients asymptomatic. So most symptomatic patients are those who present acutely, and in these patients there is sudden outflow tract obstruction of all the 3 hepatic veins, and there is no chance for the collateralization to develop. So they have effectively no collaterals. The all outflow are occluded, but the inflow is intact, as a result of which the liver gets congested, enlarged, there is capsular stretching, and that capsular stretching actually causes a lot of pain, and often there is transudation of the fluid that leads to a lot of edema. So in this stage, there is no, most of the time we see there is perfusion abnormality on the CT scan. As you can see on this image, there is gross hypoperfusion, except the areas where the perfusion is maintained due to intact drainage by the caudate veins. So in this stage, because there is no collateral channels, so we have to place dips, we all know that, and how the liver is congested can be demonstrated by this fact that when we place a dip stent, immediately everything in a matter of few months gets back to normal, and liver gets almost same size. There is no sign of the congestion, and there is all homogeneity of the liver parenchyma, and there is no more heterogeneity, indicating there is no underlying fibrosis. So this was the extreme case, acute presentations with all outflow occluded at a time. But fortunately, this extreme is not seen. Most of the time what we see is the chronic presentation where the occlusion of the hepatic vein is a kind of sequential event. There is maybe one hepatic vein is patent, then it allows the liver to develop collaterals. And because of these collaterals, these patients are not that symptomatic. Many a times there is pinhole kind of arrangements which still allows the flow of the blood. So this gives actually the time for the liver to develop collaterals. So the presentation actually not depends actually depends on the degree of the collateralization and the speed of the collateralization, rather the pathology itself. So major outflow in cases of the chronic presentation is actually the veno-venous collaterals, and it drains mainly through the caudate lobe veins and accessory hepatic vein. And when these are patents that keep the patient asymptomatic for a long time. And the two collaterals which are really important are for the veno-venous collaterals are caudate and accessory hepatic vein. But when they are not developed, the major outflow is through the subdiaphragmatic and the subphrenic vein, and finally it goes via the paracardiac vein to the superior vena cava. But they are not as efficient as collaterals as we see in case of the veno-venous collaterals draining through the accessory hepatic or the caudate lobe. The patient who have IVC occlusion as well along with the hepatic vein occlusions, then all the collaterals drain to the IVC, but the final outdoor or the drainage outflow is obstructed by the occlusion of the IVC. In that case, the main collaterals that take care of the drainage is the azygous, which are much more efficient than the anterior abdominal wall collaterals. So even though patients are asymptomatic or maybe mildly symptomatic, the congestion is still there. This keeps progressing, and after some time, although patient is asymptomatic, they will develop chronic liver disease, and the patient will then have the features of the chronic portal hypertension and all those varices and ascites. So this was chronic presentation. Now let's check what causes asymptomatic presentation. This is one example who presented incidentally during the investigations for some other disease. You can see the membranous outflow tract obstruction is here. And all liver is basically getting drainage through the accessory hepatic vein. And this patient is completely asymptomatic and there is no signs of the congestion. Another case, this patient was diagnosed incidentally with the esophageal malignancy, you can see here, but there is no sign of the congestions. The patient is absolutely fine and liver function test is absolutely normal. One more case. This was also detected incidentally. You can see again, the liver is draining well through the caudate lobe veins and through the accessory hepatic vein. IVC was patent in this case and there is no signs of the conditions. So real dilemma is what to do with these cases where the patient is absolutely fine. The patient is surviving well on the collaterals. What we have to know that collaterals are not the absolute proof or absolute guarantee for the stable disease for the long time. They can get occluded, they can get thrombosed, and in that case it becomes a big problem when the patient presents to us with the thrombosis of that collaterals on which the patient was surviving. This is one such case who was surviving on this caudate vein collateral, which was very much dilated, but she was fine. She was a chronic Budd-Chiari case, and she was in the follow-up. Suddenly she presented with acute symptoms, and you see the thrombosed caudate vein because she was surviving on that vein. You can see the signs of the chronicity and the good perfusion on the left side, but the right side, even the caudate lobe, is congested and it's hypoperfused because of this, the emergency collaterals is thrombosed now. So what should we do with these cases? We should follow the same stepwise management as we do for the routine Budd-Chiari cases. Whether the patient is symptomatic or not symptomatic, all the patient should receive anticoagulation, and all the patients should be treated medically for the underlying disease. In most of the patients, there is underlying prothrombotic condition that must be treated. And most important, all the patients should be actively searched for the recanalizable vein. And whenever we see a good recanalizable dominant hepatic vein, we should go ahead to do angioplasty to restore the physiological outflow, even the patient is completely asymptomatic. Because the patient still is having that underlying thrombotic disorder, and anytime that collateral may subside.
Last 2 minutes.
So the collaterals are not a safeguard forever. And in this patient, we should not go for the tips because it's a step 2, and since the patient is asymptomatic, we should not go for the tips procedure because it will be too much treatment for these asymptomatic patients. So major problem is how to identify that whether the patient is having a dominant hepatic vein available for the recanalization or the angioplasty or not. Often we do mistake in identifying the dominant hepatic vein. Actually, in the dominant hepatic vein, you will see that most of the collaterals actually converge on the dominant vein, maybe the right hepatic vein or left hepatic vein or sometimes accessory or the caudate. All collaterals, which are the veno-venous collaterals, must look converging of that vein, and that will itself declare that it's a dominant hepatic vein. That should be recanalized. If we are not selecting a good recanalizable vein, maybe the diameter is less, then it may thrombose. And when you do the angioplasty of that dominant vein, tips is almost never required. So angioplasty, you know, right hepatic vein, when there is a short segment ostial occlusion, which is seen with the chronic asymptomatic patient, is easy. Most of the time, transjugular approach is enough. On the left side, it may be a little difficult. Maybe many a times we can fail. In that case, we need to do percutaneous approach. And IBC angioplasty is an easy procedure, and most of the time, almost always, there is success by the multiple techniques. I think the next talk is over that. And what we should remember that whenever the patient is asymptomatic, there is no signs of decompensation, we should not go for the DIPS procedure. We should not place shunt because of its inherent complication of the procedure. And there is also a very limited life of the shunt. It can get thrombosed at any time, and there is fixed life of a stent. So we should not go and we should not move ahead for the DIPS.
Time is up.
So in conclusion, all the asymptomatic patient must receive treatment, and whenever the recanalizable vein is available, we should go for the restoration of that vein, and DIPS should be avoided in these patients. Thank you very much for your attention.
I think we have a little bit time for any questions from the audiences. No. If there are none of the questions, then we'll ask for the next speaker.
I have a question. Rajiv, is there any role
Yeah,
for
yeah.
an asymptomatic patient? Will you look at the fibroscan before contemplating whether the patient is totally asymptomatic, diffuse pattern of a BCS? If the fibros or elastography is abnormal, will you treat or not treat?
Sir, a partial guideline says that we should look objectively using the fibroscan, that if the patient is not having any signs of the fibrosis or congestion, we can wait. But latest the Baveno classification says, guideline says that all the patient, irrespective of the congestion, irrespective of the fibrosis, should undergo recanalization if that vein is available. If there is short segment or membranous occlusion, we must go irrespective of the degree of the fibrosis.
Thank you, Dr. Raji.
Okay, we'll call the next speaker. Next session is going to be a case-based discussion on IVC recannulation. Yeah, IVC recannulation Budd-Chiari syndrome. So now I'll invite first Dr. Shivanand for the talk. Dr. Shivanand?
Yeah. So, good afternoon. Can you hear me? Hello. Okay. So this is continuation of the what Rajiv. So I will be speaking on the IVC part. Okay, thank you. So this brief introduction, the occlusion can happen at a different level, hepatic vein, IVC, or a combination. So IVC obstructions, they usually have a long duration. They present with pedal edema or a dilated flank veins, whereas hepatic veins obstruction, they tend to have a short duration. So obviously in treatment planning, the imaging plays an important role that will guide you the approach and also your hardware selections. So the IVC occlusion may be a short segment narrowing or a complete occlusion or a long segment one, or it may be just a simple web. Sometimes it may get complicated by a secondary thrombosis, either it could be a small segment or a long segment. Again, the CT and MR, they complement your imaging of a Doppler, which help you to look at the extent of the disease and the extent of the thrombus. So over the last 20 years, we have accumulated about 1,200 cases. If you look at the spectrum, the combined disease is the highest one. IVC was mainly the lowest category, which is about 200 cases. Majority of the cases were in membranous or a short segment. So we did a primary angioplasty in the majority of cases and primary stenting in only 2 cases. And in 22 patients, we had repeat angioplasties, and secondary stenting were done in 12 patients. So this was published in JVR, a part of it. So let us come to the talk. Broadly, these IVC obstruction can be divided into membranous or segmental obstructions. The segmental obstruction could be short segment and a long segment one. So these are the various diagrammatic representation of the IVC disease in Budd-Chiari. It could be just membranous, or membrane may involve one of the ostium, or it may be a narrowing, or it may be a complicated one with occlusion with a secondary thrombosis extending it to the hepatic vein, or you may have a fibrotic occlusions involving the IVC as well as the hepatic vein ostium, or entire hepatic vein system as well as IVC, or it may be a pinhole membranous obstruction. Why it is so important to identify the morphology? Because it will guide you your treatment approach. One of the classification of the IVC occlusion is that the occlusion may get complicated by a thrombus. Either it may be a partial thrombus or a long segment thrombus. The long segment thrombus may be remotely from the hepatic vein ostium, or it may extend to the hepatic vein itself. So what are the key points you should answer yourself before entering the cath lab is that, is it a narrowing, or is it a occlusion, or is it a simple web? Or if it is occlusion, again, we have to look at whether it is a short segment or a long segment. Is it complicated by a thrombus, or you want to have hepatic recanalization in the same sitting? Because this is very important to question yourself so that you can select your hardwares and also the approach. Broadly, from the IAS perspective, what we can divide them into the membranous, where the membrane is usually described as an obstruction which is less than 1 centimeter length, or it may be a narrowing, just a narrowing. It could be again a short segment, long segment. The length is short and long segment is based upon the length of the segment involved. Short segment is called as 1 to 2 centimeter, long segment is about more than 2 centimeter. So the fourth category is the occlusion may be having a thrombus, and you may have a occlusion with a collateral sitting at the top of the occlusion. So this I will show you with the angiographic picture. So this is just a simple web where we have a thin membrane with the suprahepatic IVC and the infrahepatic IVC. This is a narrowing short segment and the long segment ones. This is a short segment occlusion which is about 1 centimeter. If you see here the combined angiogram, the dilator placed from the transjugular and the transfemoral route, that shows a occlusion of less than 1 centimeter. This is long segment. And these are all the examples with the occlusions complicated by the secondary thrombosis. And if you see here, these are the occlusions of the IVC with the collaterals at the top. So this needs a special attention. We will see these cases one by one. The approach could be top to bottom, where you are approaching from the transjugular route, or from the bottom to top. So these are the two widely used approach. Sometimes we land up in using both the transjugular as well as the transfemoral approaches. So usually what is done, whether it is a membranous or a short segment or a segmental obstruction, more or less we do a getaway with the balloon angioplasties. If there is a residual stenosis or a recurrence, then we go for a stenting. Most of the 80 to 90% of the cases we get away with the balloon angioplasties. So these are just an example to show the balloon angioplasty. And indication for in our setup is the elastic recoil or a secondary restenosis or a residual stenosis after initial angioplasty. These are the indications. So this was an example to show that there was a residual stenosis even after the angioplasty. We did a stenting. So now coming to the hardwares, this is the long sheet what we use 45 centimeter, and this is the stiffening cannula what we use RUPS part. So in case of what we use it for tips, and this is the trocar with a stillet. In not all the cases we use it, in a select group of cases. We need a high pressure balloons and a self-expandable stents and inflation devices. Now to the most critical step of the IVC angioplasty is to cross the occlusion. So for that we can have a soft end of the straight guide wire in cases where we have a simple narrowings or a conical type of short segment occlusions. I will show those examples. You will understand. Or you can use a hard end of the guide wire for the web and the blunt type of a short segment occlusions. Or for the long segment occlusions, we tend to use a trocar stillet with a sharp needle, what we call it as a sharp needle angioplasties. So apart from the guide wire, we need a support to system. Either we can use a dilator of the sheath or a metallic cannula to support, and in order to negotiate the chronic occlusions, we need to, without the support of any the tough hardware like a dilator or without a metallic cannula, you will not be able to penetrate these occlusions. So we need to have support this, fit this dilator or a metallic cannula at the level of the occlusion so that you can easily negotiate direct your guide wire. So let us see. One of the, as I said, crucial step is the crossing the occlusion. So in angiography, you try to identify the conical shape of the conical side of your occlusion. So that should be the preferred site of your puncture. So if you have a conical side either from the suprahepatic IVC or a distal segment, either of will work very well. But there are situations where we go for from bottom to top approach. So one has to be very careful that if there is any collateral sitting at the top, you may inadvertently puncture that collateral, may lead to collateral rupture, bleeding, or you may create a false track, enter into the pericardium, you may create a hemopericardium. So you have to be very careful if you are planning your IVC angioplasty from bottom to top approach. And top to bottom approach, what we call it as from the transjugular route, is always safe and reliable, provided if you have a stump. Okay? So let us see. So this is a typical diagrammatic representation, simple conical shape of narrowings, both proximal and the distal segment. Here one end is conical, other is the blunt. Similarly, the suprahepatic part is conical. So in such cases, simple, soft and straight guide wire will suffice to negotiate these narrowings. Use the dilator to support your guide wire and use a straight tip guide wire to negotiate these narrowings. Coming to the tougher ones, where we have a segmental occlusion, short segment or a web, in such cases, soft-ended guide wire will not suffice. So you need to use a hardened guide wire or a sharp needle angioplasty. For that, prerequisite is that you use your dilator, both transjugular route and the transfemoral route, match them both in the lateral view as well as in the anterior posterior view, and then target your occlusion, cross that under ultrasound guidance. So this is the ultrasound guide picture where needle is being directed from the top to bottom approach. We are entering into the distal part of the IVC. So that is the way you should target your occlusions. Suppose if you have a long segment occlusion, like in this case, if you see here, the segment is about 2 centimeter. So in such cases, the dilator itself will not work. In such cases, we have to use this metallic cannula. This metallic cannula is actually, it has already bent. You need to straighten up so that it fits in the occluded segment, and then use the trocar stellate to cross the occluded segment. So it has to be graded, gradual, under continuous ultrasound guidance. So that will prevent your inadvertent puncturing into the retroperitoneum or creating a false track. So that's how you should cross these occlusion. So let's see this. So I will just show a short clip. So this patient we approached through the transfemoral route, but there was a blunt end. We could not, and this was a long segment occlusion. So we came from the transjugular route. So this was the combined angiogram shows there was a segmental occlusion here. So what we did, we used this metallic cannula, little bit straightened up. Okay, and this metallic cannula will be made to sit at the site of the occlusion. This is the trocar stellate.
Last 2 minutes.
So then, once the metallic cannula is made to sit in the site of the occlusion, we use this trocar with stellate. And this metallic cannula has to be very, very stabilized. You should not keep it holding loose. It has to be firmly fixed at the site of occlusion, and you give a thrust at the site of occlusion, and use ultrasound guidance while crossing the occlusion. So once we cross the occlusion, confirm it by aspirating the blood and pass a metallic guide wire. Initially, do angioplasty with a small caliber balloon and a large balloon caliber, and this was the complete angioplasty. So let us see some complicated case which was complicated because of shortage of time, I will run it. So this is one of the typical case where some rare cases where occlusion get complicated by the thrombus. So there is a risk of thromboembolism if you just open the IVC. So what we do is we try to aspirate the thrombus as much as possible and do a small caliber balloon angioplasty and give a good anticoagulation, wait for a month. And in this case, we waited for a month. After 1 month, if you see, there's a complete disappearance of the entire thrombus. We did a completion angioplasty. So if you have a mechanical thrombectomy device, that's well and good. And even after aspiration, there will be a residual thrombus. In such cases, do a small caliber angioplasty. In this case, again, this was a long segment thrombus. We did a mechanical thromboaspiration, small caliber balloon angioplasty, waited for a month. So there was a good clearance of the thrombus. And finally, we completed it with a large balloon angioplasty.
Time is up.
So that's it, sir. Thank you.
Thank you, Dr. Shiva.
So, sorry, my co-speaker Aman is not here because of emergency. He had to leave. So, thank you.
Thank you, Dr. Shiva. So I think we are out of time, so we close this session. Thank you. Thank you all the speakers.
Thank you so very much for yet another enlightening session at ISVIR 2026. And the speakers were part of the session. I invite you to please join us on stage for a quick group photo. We're getting ready for our next session on advanced lymphatic interventions. Ladies and gentlemen, I request you to applaud our wonderful chair people and the speakers who've been sharing their incredible insights. Thank you so very much. And before we progress to the next session, we have a recap of what day one looked like. Can we please have the AV? I can hear it. It's a yes. So yes, cheer, ladies and gentlemen. It's day 2 of ISVR 2026. Can I feel the energy in the room? Come on. Show me the energy that you have. Just only for you, sir. Thank you. The only person to cheer so much. Thank you so very much. It is my absolute proud privilege to invite Dr. Maxim Edkin to lead us through the session of advanced lymphatic interventions. Ladies and gentlemen, you know what to do.
Thank you very much. It's a great honor to be here. So my slide's coming up right now. I go directly to the point. So the main problem of lymphatic system, of course I'm not talking about traumatic, but non-traumatic is lymphatic obstruction. So similar to the arteries and veins, the lymphatic system is a system that transfers the flow from the tissues, collecting all the flow from the tissue, all the fluid from the tissue and delivered back into venous circulation. So when you have obstruction, collaterals develop, and that they result in the lymphatic leaks, proteinous enteropathy, calothorax, calosositis, and organ edema. So, of course, future of lymphatic field is lymphatic decompression, by all means. Of course, it's much more complicated than just obstruction because there's clearly we see people that lymphatic flow is very increased in them, or I'm absolutely sure that contractility of the lymphatic system is important there as well. But it's very, very difficult for us to see that. So this is an example of the patient that with Noonan syndrome, and you can see how fast lymphatic flow. So imagine yourself, you have a huge amount of lymphatic flow, obstruction, and of course, collaterals develop even more. So why thoracic duct occluded or stenosed? So there's different reasons for that. The most important one is lymphatic clots. We clearly start to see that lymphatic system has a coagulation. If you take lymph from a thoracic duct, put it on the side, it will clot within half an hour. And here you can see an example of the patient that have calosositis. And at the tip of the thoracic duct there is a clot. Here's another example of patient with severe abdominal pain and clot at the tip of the thoracic duct. The other cause is thoracic duct compression but vascular structures. You can see it here. Sometimes congenital stenosis. This is a patient with calosositis for the last 15-20 years, and this patient has a stenosis of the thoracic duct and multiple lymphatic malformation in the abdomen. Sometimes it's surgery, the clipping of thoracic duct in this lady, because when she had a removal of subtumor, caused again severe abdominal pain. Another quite common cause, this is a patient with protein-losing enteropathy, is the venous obstruction. So you have, of course, venous obstruction and the increased pressure, and there is no flow from the thoracic duct into vein. So all conditions that have a fluid retention has some type of lymphatic component. Any ascites, any edema, CHF, liver, abdominal bloating, lower extremity edema, but also protein-losing enteropathy. So how do we evaluate flow in thoracic duct? Very, very difficult to do. Why? Because it's low flow, low pressure. So when we do pressure gradient across the thoracic duct venous junction, that's where you're supposed to measure the difference, it actually does not work unless you have a heart failure. Because in heart failure, the flow in thoracic duct increases significantly. Can you see our conventional imaging that we do right now? MR lymphangiography, CT lymphangiography, kind of. We don't see exactly, it's very hard to calculate, we just see secondary signs. For example, tortuosity or dilation of the thoracic duct, or sometimes collaterals. And sometimes it just looks normal. You say, okay, let's say we put catheter inside the thoracic duct. Can we see obstruction? Still not, because when you inject an overpressurized thoracic duct, you can see passage of the contrast. So what we usually do, that's what we do. We actually look at the thoracic duct, see the contrast doesn't go that fast, and sometimes we see collaterals. You can see it on the left. So we need to develop organ-specific lymphatic imaging. Specifically, sorry, it's not my slide, it's my old slides, so I have to readjust myself. So we need to develop imaging that will be organ-specific one. So the two most important organs, lymphatic organs, it's liver and intestine. And we need to develop imaging that will be delivered into interstitial tissue, picked up, imaging agent, sorry, picked up by lymphatic system and transferred to the venous circulation. So similar to the urinary system, where we inject IV contrast, the nuclear medicine agent, and you can see excretion of the lymph in the kidneys, urine in the kidneys. And we have it. This is our first attempt to develop this PET scanning imaging. It's the compound called 18-FTHA, where the people drink that, and you can see the flow in the thoracic duct. And you actually can evaluate the dynamics of the flow. You can see it here. The red line is the flow in the thoracic duct. It picks up after 2 hours and goes down. So it's usually 4 hours. We also can measure the flow in the thoracic duct based on CT. And we have a big grant right now, CT imaging, CT lymphangiography. We grant right now where we going to get this introduced in clinical practice. So how do you open the thoracic duct? We have a few options. We have a surgical bypass. Of course, we always perform it with image guidance, where we put the catheter first. We do lymphoplasty, angioplasty. The new one, the super important one, lympholysis. Actually, TPA works for lymphatic system. Remember I told you we have see a lot of clots? We actually can use altiplase to do that. Stenting at this moment don't work. What kind of condition right now we treat with thoracic duct venous junction balloon decompression? Ascites, callus and not callus. Protein losing enteropathy, chronic abdominal pain, super important. We started to treat more and more lymphedema. We realized the obstruction of the thoracic duct can cause lymphedema. And of course, future is heart failure, ascites, and liver cirrhosis. This is an example of a patient with occlusion of the thoracic duct. You can see on MRI, nothing goes beyond this dilation. And when we put catheter inside, it's totally occluded unless we inject very hard, and you can see all these clots and debris, we flush them out. And then we do angioplasty of the thoracic duct. First, we pass a wire through the thoracic duct venous junction, snare it from the femoral vein. Here how it works. You can see it here. Passing the wire, snare it from the femoral vein, and then we advance the balloon into the thoracic duct venous junction. Right now we're using 5mm balloon. We tried 3mm, it didn't work. And the patient has complete resolution of the symptoms. So abdominal pain, 30% of the population have abdominal pain, and most of them undiagnosed. So within a lot of patients that have abdominal pain has obstruction of the thoracic duct. This is our paper, first 8 patients. And you can see when these patients have a severe abdominal pain, they have an infiltration of retroperitoneal lymphatics and balloon angioplasty. Here we go. This is another patient. Or bypass surgery works very, very, very well, and that's our first 8 patients. We're starting study soon, recruiting more patients for the abdominal pain. It will be very, very controlled because it's very, very subjective, so it's hard for us to understand who has actually have real obstruction of the thoracic duct. And of course, it's very difficult to evaluate the improvement because psychological factors are very, very important here. The same thing goes with lower extremity edema. So people clog their thoracic duct because of variety of reasons. Sometimes out of nowhere, sometimes because of surgery, COVID, and so on, and develop lower trunk edema, lower extremity edema. This is on the left, you can see before, balloon, and here is before and after. Clearly improvement of the flow in thoracic duct. However, as I said multiple times today already, is that lymphatic fluid can clot, and we started to realize that clotting is very important. So of course, we need to understand the mechanism of clotting much better, but we already know the thoracic duct can lyse the clots, TPA can lyse these clots. Here's an example of a patient. Actually, he had a bypass, he has a liver transplant in India 12 years before he presented to us, and he presented after the pacemaker was placed, and he immediately developed horrible ascites. And you can see this is before TPA and this is after. A little bit improvement, but huge improvement of clinical symptoms. Here's a patient with severe abdominal pain. On the left before, on the right after thrombolysis. Kind of not a big difference, but look, he's actually on the first one, he refluxing back in thoracic duct. On the second one, after thrombolysis, he's not. So, and of course, his symptoms disappeared. So it's quite amazing how it works. We're still evaluating. We did right now 25 patients, so we're analyzing the data. The results of thoracic duct venous junction plasty they are okay. We can help people, 75% of the patients, but we still, recurrence rate is very, very high. Stents don't work right now. They're almost immediately clogged because of this thrombogenicity of the lymph. So we right now, recently we got a quite significant grant from government to develop a lymphatic stent. It will be specially covered with anticoagulation, probably between thoracic duct azygos vein and also in thoracic duct venous junction. And this is our preliminary experiments. You can see we connect jugular azygos vein with a stent in the thoracic duct. So future lymphatic decompression, surgical works well. However, it's not scalable, very difficult, so stents and thrombolysis will be the answer. Different topics, protein-losing enteropathy. Very undiagnosed disease, probably much more people out there with protein-losing enteropathy than we know. Diagnosis, low seroalbumin, of course, elevated random alpha-1 antitrypsin in stool, and of course an endoscopy, intestinal lymphangiectasia. We started with cardiac PLE, the concept of the cardiac PLE was if you have congested liver and intestine, you increase lymphatic flow, and somehow it leaks into the jejunum. And indeed, we found this leakage. This is schematics of the same of his patient, and you can see here we inject doing liver lymphangiography with blue dye, and you can see it leaking into the duodenum using endoscope. Right now, we're doing endoscopic embolization. We just, this is two examples of a leakage, the pinpoint and diffuse leakage. And endoscopically, we inject glue exactly submucosal where the people leaking. It's a very easy technique, and it works relatively well. Unfortunately, recurrence rate at this moment also 40%, but it's very easy to tolerate technique. What about non-cardiac protein-losing enteropathy? That's majority of our patients right now. It's all about obstruction again. And the question is where there's obstruction. Thoracic duct obstruction, very easy for us to treat. If it's a thoracic duct venous junction, we can use different techniques. Of course, then sometimes people just don't have thoracic duct. Mesenteric lymphatic obstruction, we see it for a variety of reasons. One of them pancreatitis, or people with on immunotherapy. Sometimes it's just retroperitoneal lymphatic masses, and sometimes it's elevated central venous pressure. So here's an example of the obstruction of the thoracic duct. It's injection before and after. Again, not a huge difference, but clinically enormous difference. This is a patient with Noonan syndrome, very young, 2 years. Albumin is very, very low, and when we inject MR lymphangiography, we don't see any thoracic duct. We see a reflux of the lymph inside the intestine. We inject his masses with contrast with a special needle. We have this developed this hooked needle for mesenteric lymphatics, and then we again inject glue inside these masses endoscopically together with gastroenterologist. And we did several patients like that. It works extraordinarily well. Mesenteric lymphatic obstruction can be because of chronic volvulus in this patient, and resection this part can cure the patient. So this is our preliminary result of non-congenital protein-losing enteropathy. It's a little bit old, 2003 we summarized it. By now we have almost 60 patients, so we come in with a new summary. We pretty much can understand in majority of the patient what's the problem, and successfully treat quite a lot of them. Protein-using enteropathy is our future because at least 30% of the patient in the hospital right now have a low albumin, and the cause is unknown. So this is another interesting thing we discovered recently, ascites in heart failure. This is the patient. By now we did 7 patients, and we submitted to GVIR. This patient with ejection fraction is pretty good. Has multiple heart surgeries, but aside is 6 liters a week. Sorry. And you can see here what's important is the SAG is very, very low. So that means we automatically assume that it's coming from the liver. So we performed liver lymphangiography on the right, normal. But when we did it on the left, we immediately started to see this leakage of the accumulation of the contrast under the liver. Then we injected Lapidol, because that's what we do, right? We inject contrast and Lapidol. And you can see on the CT clearly leakage under the liver. And we said, okay, let's bring this patient in 2 weeks because he is not consented for the embolization. And 3 weeks later, he came for embolization and he has no ascites. So in this case, and there's actually a paper in the GVR that said, they reported of post-surgical chyluria where the patient just get Lapidol injected in their liver lymphatics and they cured. So the next topic, I'll talk about a few words about chyluria. Yesterday people said there's a lot of chyluria in India, so I will have some experience. So why chyluria happens? Because there's a reflux, there's obstruction of the lymphatic system, probably because of filaris. Of course, I don't see filaris, and obstruction of the thoracic duct and a reflux develop. Most of the time, you can see it on MRI. If you do MRI, you actually can see this reflux. How can you address that? There's a different way. Number one, you can actually inject access the lymphatics retroperitoneal and inject contrast, and it's reflexing in the kidney, as you can see here, and then you can inject glue. This was our original technique, but then Carlos Guevara came with the idea of retrograde access, and we use it in few patients. Again, we do it exactly the same like balloon. We pass the wire first from the thoracic duct into vein, capture from the arm, and go advance the microcatheter. And here it goes. This is a capture from the arm, as you can see here, because our vector is much go down, so we could do it from the arm. When we do balloon, we do it from the leg. This is the catheter goes inside the thoracic duct, microcatheter. And then we try to navigate all the way down to the lymphatics that reflexing into the kidney, like that, and inject glue. It works amazingly, amazingly well. But unfortunately, not everybody has beautiful thoracic duct. Here's an example of the patient that doesn't have thoracic duct, and you can see it's a retroperitoneal lymphatics. When we inject contrast, access percutaneous with very dilated lymphatics, we actually, with a second needle, we access those, advance the wire, oops, sorry. Advance the wire here, and we advance the catheter over the wire. Oops, sorry. And then inject glue. So this is a catheter this time placed from below into the kidney lymphatics and inject glue. And sometimes you just don't see communication. You can see it on MRI, but on the regular lymphangiography, you could not see the lymphatics. You can see absolutely no communication between the retroperitoneal lymphatics and the
last 2 minutes.
Thank you. So you don't see this communication. We inject this retroperitoneal lymphatic mass, and slowly you can see that there is actually thoracic duct. Here it goes, but pretty much it's impossible for us to catheterize that. I continue to inject these masses and trying to push my contrast towards the kidney. And it does not work. So I said, okay, let's just do blindly, because I know there's a communication here between the retroperitoneal masses and lymphatics. And here we go. We inject blindly contrast. We just access blindly based on MRI findings and just a little bit contrast, and you can immediately see the catheterization, filling of these lymphatic vessels of the kidney that goes into the calyces. And what you do, of course, you inject glue, sorry. Okay, so, and this is after glue injection. You actually can see very well the delineation of the lymphatics. Thank you very much. This is definitely changing times in the lymphatic world, because we've been lucky to get a lot of funding from the government right now to develop all these imaging techniques, stents, catheters. So in 2-3 years, we'll be in a different space. Thank you very much, and it's always a pleasure to be at ISVIR. Okay, I'll try. Should I sit there, or how does it work? No, just.
Thank you so very much, Dr. Maxim. You actually saved time as well. Thank you for that. Ladies and gentlemen, our next session is going to be peri-anastomotic AVF angioplasty and dialysis access failure, a 10-year outcome analysis, and this will be led by Dr. Shuvro Roy Chaudhary. May I please have you on stage, Doctor?
Thank you very much to the ISVIR team. Sorry, I've got a broken voice from a Viennese flu. So I'm just going to go through the results of our last 10 to 12 years of hard work. And I'm going to talk to you about the results of a composite protocol that was actually devised or rather developed in India. And I'm very grateful to at least 3 or 4 of my colleagues who have been part and parcel of this entire development process. So we talk about AV fistula and the overall strategy of an AV fistula. We talk about this all the time. So about an artery joining up to a vein, and then we have the juxta-anastomotic region, which is 1 centimeter of the artery, and then the anastomosis, and then 2 centimeters of the vein. Then we have the cannulation zone and the cephalic arch and the central vein. So today we are going to talk about this particular segment. I'm not going to talk about the cannulation zone, cephalic arch or central vein. So today's talk is essentially about AV angioplasty of a peri-anastomotic failure of a dialysis axis. Now this is the world's busiest slide, but I just wanted to show you that this is the overall result of the peri-anastomotic anastomosis treated both by surgery and angioplasty. And you look at the rather dismal results that we often have. Results are not long-term, results are not great, and surgery generally outperforms angioplasty, particularly if you look at this Monsef paper from a while ago, and that has led to various guidelines saying that if an AVF fails, then surgical proximalization or surgical revision is the best way to go. Now, I would like to say that this is something that can be challenged, and can be challenged quite successfully if the technical aspects are made. So with that in view, over the course of the last 10 years, this is an acronym that we have developed called Clean Up AV, and it is a composite of various technical modifications that we do to standard AVF angioplasty. So C represents advanced crossing, and I'll show you some advanced crossing techniques. Adequate lumen gain, treating the entire circuit and not just treating the anastomosis, and I will show you examples why that is the case. Always treat the anastomosis. Typically in the UK, I was taught that AVF failure, you go into the vein and treat the upstream vein, but always treat the anastomosis. Leave no residual waste. And again, existing literature will tell you that 30% of residual waste is acceptable. That is incorrect, and that is the reason why you have got failure. And then the other most important thing is that as IRs, what we are really good at is ultrasound. So using ultrasound to diagnose, plan, do the procedure, because I'll show you how we use ultrasound to cross, and then to judge your endpoint using ultrasound and not DSA and fluoro. So, and then supplant that, again, slightly controversial, to add aspirin, clopidogrel plus minus apixaban 2.5 milligram BD as appropriate in the post-operative period. Again, we are taught that venous disease does not need aspirin. Again, that is not true. I won't go into the discussion and the scientific content. I'll just talk about what we did. So very quickly, so this is actually happens to be the largest series reported so far in the world. 852 cases presented to us. For the sake of time, I'm not going to go through the various exclusions. Suffice it to say that we did have 30 technical failures, and those technical failures were excluded from the primary analysis, although they were included in a secondary intention to treat analysis with a separate Kaplan-Meier graph. Suffice it to say that we had a total of 457 patients that we were looking at. Now, how do we define, and one of the key aspects is that in fistuloplasty literature, mostly people talk about stenosis. If there's an occlusion, that the patient gets a revascularization. And in our series, this is stenosis. Of course, as you can identify a stenosis here. But we did occlusions. The occlusions could be thrombotic expansile, like this. It could be thrombotic non-expansile, whereby there is a thrombus and a stricture, or stenosis and occlusion. It could be with a stump, or it could be without a stump. And I've got the numbers down below. So we have even taken on long occlusions without stumps. So there was no patients that were actually refused. We have taken on fistula that were occluded 2 years ago, and we have tried to open this. So that is why you understand that there is a technical failure, because some of these were virtually uncrossable. So when it comes to expansile thrombus, this is our go-to technique, percutaneous lysis. There are various techniques, I won't go through all of them, but percutaneous lysis using either urokinase in the past, TPA currently, and then you do the angioplasty and you open it up. This is great for AVG2. You obviously have to be careful with your lysis contraindications. A little bit more resistant thrombus like this, we would use devices, we would use the cleaner, we would use angiojet, we would even use a penumbra, we would even use lysis in the old days. But you can see that how it clears up thrombus, and this is the sort of result you get. I'm just trying to give you the broad methods that we used. And then when it comes to your standard, the routine fistuloplasty, our go-to technique was a brachial axis coming downwards to do a U angioplasty. We would sometimes do a radial axis going upwards and a V angioplasty, and that is a U configuration angioplasty. It could be done either from the brachial artery going around the corner, or coming from the vein going back around the corner, or it could be a V from the radial artery going once up the vein and once up the artery, but always treating the anastomosis, always treating the anastomosis. For those of you who will question that brachial artery axis is dangerous, Dr. Sundar is here, and this is a recent publication in CVIR about a specific technique we use to close the brachial axis hole, where very, very little bleeding risk. So access was very important, and access was very well planned. So depending upon the location, the length, and the complexity of the occlusion, the access was brachial artery, radial artery, upstream vein coming from above, basilic vein going back across. I'll show you some pictures. So all of these combined, and sometimes 2 or 3 accesses to try to cross. So here is an example of an occluded outflow. Can you see? This is a collateral. The outflow here is occluded. I can see my arrow. So that is not, see, we're trying to cross. We are not able to cross. So we cross a little bit, but then we go up the collateral, but the collateral has now got this curvilinear insertion at the cephalic arch. We can't come, so we puncture the basilic. So we do the central vein, then we puncture the basilic with a rim catheter, come up like this, and then reverse, snare the catheter, go across, and then do the U of the brachial artery like this. So there are various forms of accesses. Sometimes if we are not able to recanalize the main pathway, we have found a good antecubital collateral pathway like this. So we will go and open this collateral pathway, and even these fistulas will last. And as you can see, this is the outflow on the, I'm just going to go a little bit quickly. Now this is slightly more complex. See, this is the occluded fistula with no stump. We are trying to cross, but we are not able to. So now we are trying here, see, but we are not able to. So now we come from above, and again we are not able to. So we're coming from below and above, but we're not able to meet. So what we did manage to do in this case, you can see that there is a localized extravasation. One thing about fistula is that because it is a superficial structure, it is actually quite forgiving, so you can manage quite a lot of complication. But you see, the wire has now gone to a collateral. Now, if I can send this wire into the collateral, both can be snared, grabbed, and then angioplastied. And then you do the top-up angioplasty, and I'm not going to go through all the pictures. Do the top-up angioplasty, and then the post-plasty run. Slightly underdilated, so slightly bigger balloon, and then you can see that you need that bigger balloon. And this is the point about correct luminal gain. This is very, very important, and then you get the final angiogram. Sorry. Right. Very quickly, so this is now another occlusion. You can see that the fistula outflow is completely occluded, not crossable. Again, focal extrav. So then what we try to do is we try to come from the other side, like we do. We're still not able to cross. Then, from both sides we are able to cross, snare, balloon, angioplasty. Right, so crossing, like we are IRs, right? We get sort of an adrenal rush when we're able to cross big occlusions. And so AV fistula is a place where you can practice all your adrenaline rush in terms of your crossability of AV of occlusions. Now here is a more complex one. This is a thrombotic occlusion. There is a little thrombus, so we first do this thing, we do a bit of a cleaner. Now we're trying to cross with the back of a terumo, and here you can use the ultrasound probe to guide your needle, so to point your needle to the occlusion. So you see your back of a terumo here into the occlusion, and here you're trying to poke, and you're not getting, then you can guide your ultrasound, press the ultrasound to point the terumo in the right direction, and then you can cross. So here is a sister technique. Here is my MPA catheter. We are trying to cross from above and below, but we can't. You see the wire going in, and it's trying to poke the back end of a terumo is also not able to cross this, right? So this is Sundar's modification, beautiful technique. So he comes percutaneously using a second needle access, and as you can see now through the needle, you puncture the occlusion through the needle. So here is my catheter, you puncture the occlusion, then get the wire in, then do the angioplasty there, then cross the big occlusion, do the cleaner XT, and then Bob's your uncle. This is the following day. So it is possible to do lots of these sort of complex occlusions. This is a case I would like to show you that illustrates the whole concept of cleanup AV. So here is an occlusion, thrombotic, large volume thrombus, trying to cross from above and below, failed. Again, not able to. So look, we are trying to get it here, can't do. So here is the catheter from above and needle from below, and you point the needle into the lumen of the catheter, and then you get a wire through. So did you see that you can then get a wire through? Once you have a wire through, you do a balloon, but you still have to come from the radial artery there, so you still have to cross, cleaner. And again, like I treat the whole circuit, and you look like the artery looked good, but there is a stenosis in the artery. So you open the artery and then the result is good. So even when you think the result is good, you do an ultrasound and you see a little bit of aliasing, and see this subtle stenosis here, it needs a larger balloon. See that larger balloon, the wasting that you get? Unless you do all of this, you need to treat the entire circuit. This is an unsuspecting upstream cephalic stenosis. You treat that and then the result is much better. You need to prepare your vessel well. So adequate size, adequate pressure, high pressure balloons, but sometimes even a 40 conquest will not do the trick. And there we would puncture like the Pierce technique in the artery. We will puncture like there, the vein wall, so that we give some give to the vein wall, so that you can then open that to make a successful angioplasty. So we have this pyramid approach of using luminal gain, starting from semi-compliant to high pressure to ultra-high pressure. We will keep a wire alongside, we'll use a cutting balloon, and if not, then we'll do the needle pierce technique. So the last few minutes, I'm going to talk about the results. There's a baseline data without going into a lot of details. It is to say that there were a lot of occlusions that we did. Most were radiocephalic fistula. But there are very, very few cases where there was quick recurrences where we put a supera, but that was much rarer. Collateral vein laser, that was also done. Post-operatively, they had a Doppler the following day, and aspirin and clopidogrel was prescribed for at least 3 months. In the old days, I was doing it for 12 months, but at least for 3 months, and then aspirin continued. If there was a residual thrombus, then apixaban 2.5 BD was given for at least 3 months, if not contraindicated. So these are the results. The technical success, excluding some uncrossable occlusions or extravs that were not safe, was 95%. Clinical failure, which means the patient failed to have a dialysis, of all the technical successes was 0.8%. We use high pressure balloon in 47%. Adjunctive procedure means we did a concomitant central vein plasty, etc. in 16%. Complication rate was 4%.
Last 2 minutes.
But look at these numbers. The Kaplan-Meier primary and secondary patency rate at 1, 2, 3, 4 and 5 years was 85, 82, 75, 74 and 67%. You compare that, this is primary patency. You compare that to the original literature that I showed you. This is 2 to 2.5 times better if you incorporate each and every one of those components. 74 patients did fail and they went on to have up to 4 re-interventions. So these are the Kaplan-Meier curves for the primary and secondary patency. I will not go into details of stenosis versus occlusion, brachiocephalic versus radiocephalic for the sake of time. They're all there, the data is all there. But you know, the 60-month estimated Kaplan-Meier, and when we talk about Kaplan-Meier, of course, the patient was censored if the patient died with a patent dialysis fistula. So we called them up, and if the patient died with the patent dialysis, the patient was censored. And of all the factors, only high pressure balloon usage was statistically significant as a predictive factor. Adverse events were not zero, and you know, bailout stenting and circuit rupture we had to do some pseudoaneurysm in the initial half of our management, hematoma management, we had to do some ice pack and all that. So they were there, but it was not insurmountable. So in conclusion, significant improvement over standard angioplasty protocols can be done if most occlusions can be crossed, anastomosis is treated, the correct size balloon is used to the correct pressure, the waste is always obliterated, and pharmacotherapy is added. Thank you very much for your attention.
Thank you so very much, Doctor, for sharing us that incredible research, and many congratulations to you and your team. Ladies and gentlemen, we now have the plenary session by Singapore Society. Singapore, as you know, the country that has one of the best healthcare systems in the world and is also home to some of the best IRs in the world. And most importantly, ladies and gentlemen, they celebrate my mother tongue, Tamil. So it gives me absolute pleasure to invite Dr. Farah Irani to tell us about the history of IR in Singapore. I know that many of you are eating, but I request you to applaud as we invite our international speaker onto the dais.
Good afternoon, ladies and gentlemen, and it gives me great pleasure to be representing the cardiovascular and interventional subsection of the Singapore Radiological Society, and we really thank ISVR for inviting Singapore to this plenary session. My name is Farah Irani, and I'm the chair for the subsection. And today I'll be speaking to you on Singapore IR, where we started and where we have reached. History is very important, and we need to know where we come from. So Singapore is the little red dot. It is a tiny island nation situated at the southern tip of the Malaya Peninsula, and it is one of the 4 Asian tigers. We are a multicultural, multiracial society having a population of about 6 million with a very diverse ethnic distribution. But we have one of the highest life expectancies and the highest GDP growth rate and per capita income. We have many attractions, and therefore it's a very nice place to come and visit with all these amazing attractions that are present. And we do have very extreme sports in the form of shopping, which is one of our best kind of extracurricular activities, along with eating. Shopping is stressful, eating is not very healthy, but in spite of all that, We are one of the 6th blue zones in this Netflix series, where we have one of the highest longevity rates. And one of the reasons for that is because of our policy incentives, our health spectrum, and landscape. So we're not a natural blue zone, but we are an engineered blue zone. And the reason for that is that we have a very good healthcare system. The mission of our Ministry of Health is to promote good health, reduce illness, ensure access to good and affordable care, and pursue medical excellence. And for that, you need to understand where we started. So the history of radiology and IR in Singapore goes all the way back to 1898, where the first X-ray machine was set up in the municipal office. This is just 3 years after Röntgen discovered X-rays. We had the X-ray apparatus, which was located in 1913, and then had the Coleridge tube, which came in 1920. Right, very early on, right from 1934 to 1937, we knew that education is important, and radiology courses, both for medical students and anatomy course, were run that far behind. In 1950 was when we set up the independent radiology department, because till then we were a paraclinical specialty being mainly run by surgeons and medics. In the mid-1950s, angiography started with direct needle punctures and injections, and in 1959 was when the Seldinger technique was brought to the shores of Singapore by Dr. Chow Kun Wai, who is considered almost like the father of IR. In the 1960s, radiology became a clinical specialty, and then we had expansion of IR procedures in the 1960s and 70s. 70s saw a resurgence of IR, where we had super selective catheterization and the first selective embolization of a massive GI bleed in 1976. And FNAs occurred from both FNA and Chiba needles.
Last 2 minutes.
And in 1990s is when we saw a subspecialization in IR, with neurointervention actually cleaving off main IR. So these are our doyens, or the shoulders on which are the giants of today. Our healthcare system is divided into 3 clusters. We have 10 public hospitals and 6 national specialist centers. These are hospitals, they're all modern built, they're very sleek, very, very modern, and all of them have IR suites. These are, we are all high-end. We have 7 hybrid angio CTs on the island with biplane angios, and also a negative pressure angiography suite in our infectious disease hospital, which was utilized massively during COVID-19. We run outpatient clinics, where we have dedicated outpatient clinics with our name written out there within the outpatient center, so patients know who we are and where we exist. This is just a snapshot of the amount of work that we do. You can see that in the major 3 hospitals, that is Singapore General Hospital, Tan Tock Seng Hospital, and National University Hospital, we have a large number of IR suites, being 8, 5, and 4, and we do almost about 30,000 procedures in just these 3 hospitals. The rest of the 3 hospitals are smaller hospitals, where you can see that we still do a fair number of IR procedures. We've been rated the world's best hospital, with Singapore General Hospital coming in 9th, with both the National University and Tan Tock Seng hospitals coming in the hundreds of the best world hospitals. So even though we're a small nation, we're quite out there. We've been accredited with the ASIOS certification in 2021, and we are only the 2nd center in the world which is been given the Center of Excellence by ASIOS, and the 1st center in Asia for that. Our organization is varied. In one of the hospitals, we have our own independent department of interventional radiology, whereas in other situations, we are basically a subsection within the Department of Radiology. IR research is important, whereby we do a fair number of research with multiple publications. This is just a snapshot from the last 5 years. We also are important in education, and we want to pay that forward. So we do run a fellowship program, whereby we have trained fellows from far and wide, both from the Asia-Pacific region, but also from the Caribbean and Africa. And these are some of the pictures of our fellows and faculties from around the world who have come and enriched our system, but have also taken back to enrich their own systems. The Vascular and Interventional Radiology subsection of the Singapore Radiological Society was founded in 2000 with only 10 IRs. Today, we are a robust society with 91 members, and we hold meetings where we share interesting cases and M&Ms, and we love food, so all our meetings are dinner meetings, and you can see here we're both learning as well as eating at the same time. We organize an annual conference which is called WIRES, and I invite you to the next WIRES conference, which will be held from August 20th to 23rd in Singapore, where we're talking about sustainable future. So please do come and join us in Singapore, and with that, we would like to progress to the rest of the plenary session. Thank you. So with that, I'd like to invite Dr. Sham, who will be our co-chair for this session, to please come on stage. Our next speaker is Professor Tae Kyung Yong, who doesn't need any introduction. He's the incoming president, held many leadership programs, leadership roles in his lifetime. He's just stepped down as the head of the Department of Vascular and Interventional Radiology and is the senior consultant in Singapore General Hospital. He will be talking to us on the endovascular management of chronic type B aortic dissection.
Thanks, Farah. First of all, I'd like to thank the Indian Society for this great honor to have a session in the plenary session. Without further ado, I'll go on to my talk. These are my disclosures. Today, I'll try to cover when and why we need to treat chronic type B aortic dissection, how we do it, does it really work, look at some data for that, is it safe, and is there any impact on survival? So this is the definition of aortic dissection. I think I won't do it, as most of you are familiar. So the management of type B aortic dissection traditionally has been divided into whether it's acute and whether it's complicated, uncomplicated, and then the chronic. For the acute complicated, I think it's fairly straightforward. Many level 1 have shown that TIVA is the first line treatment option. It's as effective as surgery and less invasive. However, on the uncomplicated acute type B dissection is a bit more controversial, despite increasingly, I think people are advocating to veer towards more TIVA rather than medical therapy, especially when there are the so-called high-risk features for late complication. And recently, what is also known, if we need to do a TIVA, it's better to do in the subacute phase to reduce the risk of complication, in particular retrograde type A dissection. And as for chronic type B dissection, which is the topic we are discussing today, whether it's TIVA or open repair is still very much controversial. Let's look at the natural history of chronic TBAD. There are multiple publications on this, and these I just highlighted a few. Essentially, it is not that benign. A significant proportion of them develop aneurysmal degeneration, and with that, there is a risk of rupture. The 5-year mortality is also not insignificant. It's around 50 to 60%, and around 40% of these patients would eventually need treatment. So it's not really disease. So these are the summary of current guidelines from all these various societies. It's a very small slide. I will summarize it for you. So essentially, currently for chronic type B, most society would recommend treatment if the aortic diameter is more than 55 millimeters or 60 millimeters, depending on the society that you will look at. Currently, the recommendation is still open repair if the patient is fit for surgery, and only consider endovascular repair if there are moderate risks or high risk for surgery. But in the same breath, the guidelines also suggest that these treatments should be done at dedicated centers, because the data out there is quite clear that those centers with high volume tend to do better in terms of outcomes and lower complication. Endovascular technique for chronic type B dissection is TIVA, and this is one such example. Some considerations for the proximal landing zone, we need to land it in the normal aorta and preferably at least 2 cm. Oversizing wise, we are still quite conservative in 10% in order to avoid the retrograde type A complication. The left subclavian artery coverage, we try to preserve it because again, it's associated with risk of spinal cord ischemia if it is covered. For the controversial, how low you land the stent, the problem is that the lower you land it, the chance of spinal cord ischemia will increase. The other important consideration is to avoid oversizing to prevent a sign or the stent-induced re-entry. So the TIVA technique has leaps and bounds over the years, and now we have fenestrated techniques, branch technique, physician modified, or even in situ fenestration what all these techniques has allowed us is to enable now proximal landing even in zone 0. Similarly, this technology has also enabled us to extend the distal landing zone beyond the visceral segment. The other development in the last 10 years, the strategies for forced lumen occlusion. So the first such technique was candy plug, and then followed by Knickerbocker technique, and the so-called endo-trash movement with anything that we can find literally. So this is a typical case of a chronic type B with a forced lumen enlarging over time. And for this case, we use a double arch fenestration to the carotid and the left subclavian. And this is again a typical finding where there is reduced flow in the forced lumen, but not entirely obliterated. So this is something that we accept and not try to chase for a perfect result. And if invariably over time, the forced lumen will thrombose. And in this particular case, over time, the forced lumen has also decreased in size. Dr. Cobell described the candid plug technique in 2013. Essentially, in those early days, it is a surgeon-modified or a homemade kind of a technique where the thoracic stent graft is constrained, and then unpluxer plug is used to occlude that constraint. So this is like plug to occlude the forced lumen. So these are some pictures from the publication. And then we now have a commercially available candid. The first generation is much like the surgeon modified, but the later two generations, we have a fabric tube inside that will collapse. So it's a self-sealing kind of a design. We did our first candy plug in 2019. So this is a patient with chronic type B. After TIVA, the forced lumen flow persisted. So we did a homemade candy plug. And I could see that the forced lumen thrombosed after that. And over time, it decreased in size. The Knickerbocker technique, again, is using a customized stent graft where there is a bulbous lower end, and a balloon is used to rupture the tear such that the stent graft now opposes the aortic wall and hence lead to forced lumen occlusion. Lumen to thrombose off. Unpluxer are also used to close off entry and re-entry tear like this case with good results. However, TIVA in TBAT is not without complication, and the most feared is retrograde type A and spinal cord ischemia. And these are not oversizing and avoiding a bare span to reduce this. And again, the extent of coverage may help to decrease spinal cord ischemia. The rest of the complications are not as dire as the first two. And then there's this unique entity of the sign, which I'll show you an example. So this patient had a standard TIVA. In the early days, I think we used too short a device, and over time, a re-entry tear got created.
Last 2 minutes.
Actually, we didn't pick it up at 12 months, and by 18 months, it was obvious. But these are easily treated with extension of the graft. This one is a retrograde type A dissection, our only retrograde type A. Essentially, he had a TIVA previously, had a type 1 leak. We used a fenestrated device to treat this. There was a lot of manipulation. And after the procedure, while angiographically looks good, the anesthetist says that the right arm art line, the tracing went flat. So we were worried that the innominate got covered, so we punctured the brachial, and true enough, there was occlusion here, so we stented it. But on the completion run, there was clearly a retrograde type A dissection. And if we look back here, actually the type A already occurred on this. So on table, this was converted to an open repair. Let's look at some data. There are quite a few publications. I'm just going to go through a few. So with regards to whether TIVA works, in terms of forced lumen thrombosis, a large proportion do thrombose, but the reduction in the thoracic diameter is quite dismal. What is also good is that the complication seems to be quite low. This paper compare open surgical repair, TIVA, and fenestrated TIVA for chronic type B. If you look at the numbers, they are all fairly similar. So the authors concluded that actually the optimal treatment of chronic type B is still debatable. and basically we need to go by a patient-specific decision. As to the data on forced lumen occlusion, they are all case series, so we really can't read too much into it. But what is clear is that they seems to be quite successful, but we need a long-term study. So in conclusion, TIVA for chronic type B is still controversial. Advances in stent graft technology have expanded the options for chronic type B.
Time is up.
The data increasingly shows that TIVA is a safe and good outcomes in chronic TBAD. Forced lumen occlusion techniques are also useful. The thing is that aortic remodeling is not as good in chronic TBAD. So I think there is an increasing movement to argue for early TIVA in any form of type B dissection. Thank you very much for your attention.
Can you come to the podium, Prof, and sit at the top? We'll continue, and just as a note, can you keep your questions to the end of the session so we can keep to time? I'd like to invite our next speaker, Dr. Shi Hayun. Dr. Shi is a consultant interventional radiologist from the Changi General Hospital. He is one of our up-and-coming leading interventional radiologists. He is the head of the Breast Imaging Center as well as an interventional radiologist, and today he will be speaking to us on breast cancer cryoablation. Are we ready for prime time?
Hey, hi friends. I wonder if you have heard about this brand new technique coming from the Western Hemisphere. There's this non-surgical treatment modality that can kill breast cancers without the need to go for surgery. Well, of course, it sounds like snake oil, right? But beneath all the hype, there's a bit of truth, and there's a lot of potential for us. So again, good afternoon. I'm Hayuan from Changi General Hospital, Singapore. I'm very honored to be here at ISVIR. These are just some of my ramblings. It's data light, but thought heavy. I have nothing to disclose. Well, despite what some of you may think, cryoablation, ablation for breast cancers existed and has been studied for a long time. The first paper was published sometime around 20 years ago, and there has been ongoing research since. Advantages include, it can be done in the outpatient setting, done under local anesthesia. It's safe, patients recover fast, goes home on the same day, and there's excellent cosmesis, as you can see in the image below. But unfortunately, for some reason, over the past 20 years, service of cryoablation did not pick up. Now, what's the reason? We know ablation work. We know how extreme heat, how extreme cold kills tumor cells. But then surgery is just so good. It has been the historical gold standard with good evidence. There is well-established pathway workflows with medical and radiation oncology. And it is truly a low morbidity surgery, placing ablation right at the back seat. So what has changed for this article, for this news to come out recently? Well, one, we are getting high quality evidence. And this is the only study I'm going to quote, that's the ISVIR' trial. And it took 20 years to complete. It is the first and only, as of now, multi-center prospective trial involving almost 200 patients. Without going to the details, we are looking at a local recurrence rate of about 4%, hovering around 4% at 5 years. And that is incredible because it compares very well with the current standard of wide excision surgery. We are looking at a complication rate of 0%, well, of course. Now, second point is the concept of de-escalation. You're going to hear this again at tomorrow's breast session. And really credit to the surgeons. They've taken 100 years to come from the brutal radical mastectomy to the current form-conserving and life-saving breast-conserving surgeries of today. In fact, our breast surgeons no longer call themselves breast surgeons. They are called oncoplastic surgeons. So at the pinnacle of oncoplastic surgery, at the pinnacle of de-escalation, what is it going to be? It's percutaneous cryoablation because we are removing zero tissue from the body. Right, before 2024, I'm very stuck at the multidisciplinary meetings because I've got no evidence. I can only offer cryoablation to a select group of patients who are not suitable for surgery and for the indication of local control, palliation. This is my first case, 90-year-old patient, not fit for surgery, 1.5 centimeter tumor, perfect size, according to the ISVIR trial, but unfortunately it's 1.5 centimeter from the skin. Well, went ahead and did it with the nitrogen system, nothing to talk about with regard to the technique. You stick the needle in, let the eyes grow, and as the eyes front merges with the skin, approaches the skin, we stick in one hydrodissection needle, that's an 18-gauge needle, and push away the skin from the eyes front. Very easy to do, and we're all used to doing this as IRs. Now, the patient did excellent. Day 1, she was discharged with some bruising. At day 14, her breast has returned back to normal, and she's walking around happily despite her old age. Even though we saw this procedure as a palliative procedure, you can see 4 years down the road, her tumor has resolved, and there's no hint of recurrence anywhere. She's still healthy and alive at 92 years old, so we know that this is curative. So right now, with evidence, what can I say at the MDT? Whether the patient's fit or unfit, we can now offer a cure. We can now offer cryoablation alongside surgery with a curative intent, especially if the tumor is small, of low-risk biology, and the patient is clinically node negative. So then, sorry. Somehow I've jumped to the last slide. Can we pause for a while? Okay, now we're going to restart here. So then, going back to the main topic of discussion, are we ready for prime time? Well, unfortunately not so. I'm going to bring up 3 key points why this is not so. Number 1, the lack of surgical margin, and this is something that's troubling the surgeons, the oncologists, as well as the pathologists. We do not have histological marginal clearance. There are 2 strategies currently on how we at least partially assuage the fears of the surgeons, of our clinician colleagues, as well as ensure that we have optimal outcome. Number 1 is the deliberate overablation for confidence of margins. With that, if you, for example, have a 1 centimeter tumor, you're not going for 1 millimeter margin, you're going for a 1 centimeter circumferential margin, which would then translate to an eyeball, eventual eyeball size of 5 centimeters. That is huge for someone who's not doing cryoablation. Number 2, we want frequent functional imaging, which means we are giving contrast, some form of contrast, whether MRI or contrast-enhanced mammography, with the low threshold for targeted biopsies. That is where you want to catch the early recurrences and the residual disease. Number 2, axillary nodal management, we know is currently the standard of care for breast cancer management. It is part and parcel of breast cancer surgery. Well, the Japanese says that you can do it this way. If you have a small IDC cancer, clinically node negative, you can bring the patient to the OT and do the sentinel lymph node biopsy under local anesthesia. Depending on whether it turns out positive or negative, then you can proceed with wide excision or cryoablation. But you can see immediately why this is disadvantageous to us as radiologists, because it brings the patients to the OT. Fortunately, there's 2 sides of the argument. A lot of people are recognizing, in line with the escalation, that maybe we don't need sentinel lymph node biopsy. The Surgical Oncology Society of the States have recommended that, and this is supported by the recently published SOUND trial, in which small, low-risk cancers may probably not benefit from axillary clearance or axillary management. Lastly, we're looking at adjuvant RT. The concept of adjuvant RT is to clear all those tiny little microscopic disease around your primary tumor, and that has been integral framework around surgery. Unfortunately, this has been built around surgery and not around our radiology ablations. So it is very hard to convince our radiation oncology colleagues to offer the same adjuvant treatment for our post-cryo patients. Again, fortunately, we have 2 sides of the coin. Along the same concept of de-escalation, perhaps we don't need adjuvant RT. Now, we have a hint of that through the ISVIR trial, where we only have 4% local recurrence rate at 5 years, and that is comparable to people who had wide excision with RTs before. Now, on the radiation oncology side, they are also looking at this. And they have churned out some
Last 2 minutes.
They have churned out some RCTs demonstrating the lack of benefit with, in certain populations with regard to adjuvant RT. So, but then I must also offer you the counterpoint. The Japanese, headed by Prof. E. Fukuma from Kameda Medical Center, he disagreed. He says, if you give me whole breast RT following cryoablation, I'm going to give you a local recurrence rate of less than 1%. But again, I want to emphasize this is yet unpublished data, and it has remained unpublished for the past 2 years. So whatever the answer is, I think we'll find out in the future, but I think the answer to adjuvant RT probably lies somewhere in between these 2 points. I'm going on to the last point. This may be something that causes some discomfort because then we're going to talk about who's going to be the operator. If we look at the skill set required, it's very simple. Number one, you must have ultrasound spatial awareness, meaning you must picture a 3D structure from your 2D plane ultrasound scans. Number two, you must have hand-eye coordination, good hand-eye coordination, especially if you are inserting the needles in an off-center trajectory, like what we are doing with the current Argon system, bracketing the tumors. Now, I must say that, our well-trained radiologists are well-versed in this, but actually the technical barrier is not very high. For a motivated surgeon, they can do the same, at least on an equal level, if not superiorly. So then, what is truly the skill set that is required? It is really getting out of your comfort zone, grabbing your breast surgical colleagues for tea, reaching out, keeping them interested, keeping them involved, and perhaps sharing some of your ablation cases with them. But then, I'm truly coming to the end. But then you have got to make them realize somehow that you are actually the better operator at this, somehow. And then perhaps their time is better spent in the OT. So I just want to show you this map. These are the areas in the world where ablation for breast has reached a mature state of service. Singapore, we're just starting out. And I'm looking forward to India driving the next wave of transformation in Asia. Just the last one, if you are interested in getting some hands-on, can come to Singapore, look for us at the AOCR, SGCR, WIRES combined conference. We're gonna do some hands-on, have some fun in the daytime, and then we're gonna have some fun at night, party, and let me show you around the Singapore night scene. Thank you, guys. Hayun.
Thanks, Hayun. Can you please come up and sit at the podium? Hayun. Our next speaker is Associate Professor Tu Cha Wei. He is a senior consultant in the Department of Vascular and Interventional Radiology at the Singapore General Hospital. His main interest is in interventional oncology, and he is the lead IR for our newly opening Interventional Radiology Center at the National Cancer Center, Singapore. Dr. Cha Wei will speak to us on the approach to pelvic pain.
Good afternoon, and thank you, Farah. So we're going to go through the pelvic pain and how we approach them. These are my disclosures. Now, the pelvic pain spectrum is a wide one. Whether you're dealing with cancer or non-cancer, there are a lot of things in the pelvis that can cause pain. And actually, in non-cancer, chronic pelvic pain actually troubles a lot of women. The goal here is to interrupt the pain signal with the available interventional tools that we have. We'll go through them later. With regards to malignant pain, actually there are lots of things that can cause us trouble as well, whether it is the colon, whether it's the gynae cancer. I forgot prostate when I was doing this. Pelvis is a common area for metastases, lymph node, bones, and then also in the region, it's a junctional space, isn't it, with vessels and nerves that go through the body. The first thing we want to do with pelvic pain is to localize the pain. And it's really because your referrers may not know how to do so. And it's really the combination of clinical imaging clinical information and imaging that we can do this. So the first thing, we want to hear what is the pain, what's the nature and the characteristics. We want to then look at the imaging and see whether there's any lesion causing it, and finally treat the nerve. Now, we will start with this example. Where is this pain coming from? So this is a young lady, 42 years old, metastatic cervical cancer. They have lesions across the various regions of the pelvis, but what is actually troubling her? The next question we ask is whether the pain is somatic or visceral. Now, this is what we learn in medical school. Somatic pain is well-defined. You can point to it. You can do something about it. The visceral pain is ill-defined. It's a bloat. It's a dull. It's a pressure. And it goes to the deep in the pelvis at the end of the day. There are many, many somatic nerve supply in the pelvis, and these are but a few. So sometimes we'd actually find it quite better if we show the patient a picture and ask them tell us what their distribution is. And this is actually quite helpful. Some of my colleagues have find out. Or you can show them another one. So from there, you're able to localize the pain and treat it. Some of the best resources are actually from anesthesia, from the pain side of the house. This is a good site whereby they show you a lot of ultrasound-guided injections. A lot of them can be achieved by ultrasound. For example, the iliohypogastric, the ilioinguinal, they're quite close to each other. You can actually either block them or ablate them on ultrasound at the same time. It's just different levels where they are in the abdominal muscles. Next, we go to the splenic nerves. These are the the visceral type of pain, and you have the superior hypogastric, the inferior hypogastric, as well as the ganglion in par. Now, they are kind of divided by where they influence. For example, the superior hypogastric at the uterus, the inferior hypogastric somewhere below at the rectum, vagina, prostate. The ganglion in par, the perineum and the anal area is very important. So anytime someone comes to you pointing the perineal pain, you need to think of the ganglion in par. So we go to the tools of the trade. And really at the end of the day, if we want to treat pain, then we really should cover a wide spectrum from the left and to the right. Very simply, you can land a needle, you can inject LA, corticosteroids, even D5 has shown to be neuromodulating. If you wish to preserve the patient's motor function, the same needle that you put in, you can do pulse RF, 42 degrees pulse frequency ablations that really wouldn't destroy any nerves, but it does neuromodulate. Potentially reversible, this is where cryoneurolysis comes. And what we want to do, sometimes when the pain is cancer pain, it is permanent, then we will go to chemical neurolysis, we will probably ablate it with heat. And finally, if the patient is still very poorly managed, you may need to put an intrathecal pump, spinal cord stimulator, or cervical cordotomy. There are a lot of others that we can treat pain. We have no time, including local regional treatment that we can do, as well as cementoplasty, as well as osteosynthesis, and we could save them another day. First of all, why cryoneurolysis? So number one, you can see the ice ball. Number two, it is better tolerated than heat. So most cryoneurolysis, you can done under LA or just minimal sedation. What I really like is that with cryoneurolysis, what you inject into a very vascular space around the tumor doesn't leak. So your LA doesn't leak, your alcohol doesn't leak, and we have some problems with that before. And also number three is potentially reversible at the end of the day if the patient does want some function back. Now, cryoneurolysis, for the standard machines that we have, we only can induce a Sunderland 2 type injury, which is under here, axonotmesis. So this is still potentially reversible because at the end of the day, while the nerves will die, the endoneurium is preserved. There is a chance of regeneration. Now, for these two, it's quite a standard that we do. So this is a metastatic colorectal cancer. The patient has pain, to the front, to the vagina, as well as the perineum areas. It's identified, and then we went ahead to do cryoneurolysis of the ganglion in par, and that is the junction between the sacrum as the coccygeal, as well as the pudendal nerve in the Alcott's canal. So again, the risk of LA alcohol toxicity is real when you're injecting into a cancer bed. It's a little bit different if it's non-cancer, because you're injecting the fat, but cancer is very vascular. A hypogastric block for this example is during a UFE, a uterine fibroembolization, whereby I put the needle directly under anterior through the fibroid to just below the iliac bifurcation to do the block. You can do it posteriorly as well through the discs, that's fine. The obturator block, this pain goes to the medial side of the thigh, and that's a lot of times where the cancer is as well. Now, going back, what is causing this patient's pain, right? If they're telling you it's an upper visceral pain, then it's most likely this side, and then, a superior hypogastric block will work. If it's a lower visceral pain, and then maybe you need an inferior hypogastric block, that is S3 under CT guidance, you can just go through the foramina. If the patient have a left thigh pain and you know it's the femoral nerve, it's a somatic supply. So at the end of the day, after a good history, it was an L4, L5 dermatomal. But to ablate this area, the patient may likely be paralyzed in the leg. So we chose a lesser procedure. We went for a pulse RF at the dermatomes. Unfortunately, we only have pain relief for 4 days. We offered more options to the patients, but the patient wished to wait. So it brings me back that at the end of the day, spine and pain service is a part of interventional oncology. So I think this is very clear. And spine pain and cancer pain deserves its own MDT. The various other MDTs that you attend is organ specific. They may not have the surgeons or the IRs that's required. So in SGH, we have a dedicated MDT whereby we get all these people in the room and we have a weekly conference. It's hosted by us. You know, they tell us what's the issue. We run through the images. We tell them what's the source of the pain. If you want some more urgent stuff, you can get us through the chats. It is a robust discussion whereby we want the pain score, we want the SIN score, we want life expectancy. We want to know what other treatments the patient is going to have, right? And the goals of treatment, what are we getting the patient to? Sometimes the patient will tell you, you know, I have this pain, I need to go Bangkok next week with my kids. That's it. You do something simple. At the end of the day, it is about doing something, the most simple thing that you can get the patient away with. Because a lot of these patients with cancer don't have much time. Spine and MSK and pain interventions are growing, and you know, there's so much to do here, and your referrers really cannot possibly know to ask for all the time. So at the end of the day, we really should be a referral service rather than a procedural request. And hopefully we do better than Lucy here. We have some time. So metastatic RCC, this is a right ileal lesions that's progressed on systemic treatment, pain on moving. So when I saw the patient in the clinic, he was very miserable. So I started off with SI block. So you just block the entire chain outside the femoral, the sacral foramina, the patient was well. After that, I offered embolization to the mass, because it's a little big. If I will cryo this, I might crack something. So I just did embolization. And finally, for stability, because we needed to transfer load from the sacrum to the ileum, we chose to do osteosynthesis, and Dr. Chong Kun Ta here, our expert, is kind enough to do the procedure with me. Next is this patient has a 10-10 pain for osteosarcoma, 35-year-old Chinese male. The left leg has already been amputated, but there's a whole bunch of tumor coming down the left side, and he's causing a lot of pain. So we did the simplest thing first. So one of my colleagues went ahead to do the pulse RF. Again, minimal improvement, temporary relief. And then we talked to him and said, well, we don't have a left leg anymore. We're just going to do cryoneurolysis from L1 to L5, all the way down. So we put needles in, we cryo all his nerve roots. The result was pain-free. He was pain-free. His pain was 0 to 2 for 5 days, and he died 5 days later. For those of you who do this, it's not uncommon actually. So this is something that maybe within the department you have to think about, do you want to offer these treatments, right? Is that M&M going to be a question? Why are you offering treatment to a patient that is already quite sick in the first place? More importantly, could we have been more aggressive earlier? Could this patient have reached us earlier so that he can enjoy more of his time pain-free? In summary, localizing pelvic pain is key to treatment. There are many tools available. We want a multidisciplinary approach to cancer pain, which involves the IR. Spine, bone pain is a growing part of the service, and we should adopt a mindset of a pain physician. Thank you very much. This is the team. Please come for AOCR as well as YS next year.
Thanks, Chawei, for that excellent presentation. Our next speaker is Dr. Sandeep Panamia, who needs no introduction to this audience. Dr. Panamia is a senior consultant at the National University Hospital and is one of the 4 leaders in portal hypertension and TIPS. Today, he will be speaking on percutaneous biliary neoanastomosis, tools, tactics, and technical pearls.
Thanks, Farah. It's been an incredibly proud moment for me. I know any of you know. Having a rare opportunity of representing 2 societies at different meetings, represent ISVIR at CERC many years ago, and this time with the SRS at ISVR. So I do thank both these societies. I'm very grateful for this opportunity. Thanks. So this procedure of percutaneous neoanastomosis is fortunately not required that commonly, is because surgeons have become pretty good at this. But when it's needed, I think it requires a lot of planning and a lot of tools in hands, and machinery also needs to be adequate for you to do this. It's uncommon following hepatobiliary and transplant surgery, and traditionally we've always been managing it surgically with a higher degree of morbidity and mortality in most cases. Endoscopic approach is usually the next best option, but unfortunately, because all the alternate anatomy, typically with the HA anastomosis, is very difficult for them to get that. And that's why now the interventional radiological solution of PBNA is beginning to gain traction. So the concept is to create a track between 2 segments. the proximal and distal segments, so the disconnected biliary segments under fluoroscopic and or endoscopic, that's cholangioscopic guidance. So by doing that, you restore biliary drainage and maintain the continuity between the ducts along with the main biliary tree or the GI tract. And we usually consider it when there's a failure of regular traversal of the guide wire through the stricture or the disconnected segment, but provided these patients are non-surgical candidates. So we usually have this in a multidisciplinary approach to see which is a better option. The pre-procedure evaluation is extremely vital. I think planning of this case is the most crucial part of this procedure as such. So you need to delineate the entire biliary anatomy properly, and a good quality MRCP, and I usually, honestly, I prefer contrast CT. It helps us decide as to which approach is best. Once the tubes are in, when we have PTC tubes or an endoscopic approach, have a close look at the cholangiograms. What you need to see again is the proximal and the distal end. So you need to connect two pieces. You have to see both sides, either through contrast or through direct vision. And as I mentioned earlier, we always do this in an MDT setting. So the overview is, first of all, creating an access from a percutaneous approach for either a fluoroscopic technique or a cholangioscopic technique. Sometimes we mean a retrograde approach, either through percutaneously into the bowel or through an endoscopic approach. Once we've got that, we've seen the two ends, then we have to create a track between those two blind ends and use various systems, like the stiff end of the wires. We use needles, that's Chiba needles, use larger gauge needles, use the BBAC, the re-entry devices, whatever you may. Once you enter into the other side, then we just pass a wire, and then it's pretty easy. You just have to get a balloon through, sometimes needing a snare, getting a through and through access. After ballooning, we place drains, and then for better durability, we usually place stents, either covered stents, which are usually retrievable, sometimes bare stents in patients who have cancers, and biodegradable stents as well, which are now on the market. So just showing you a bunch of cases. I know the time is really limited, so I'll just try to rush through some of them and apologize if they're a bit too quick. So this is a male who had a HCC in segment 4, had a left hepatectomy with the hepatogorge, persistently high bilious output post-op day 7. The suspected leak ultrasound CT done, which showed that there was absolutely no obstruction, and there was no biliary dilatation. So did a PTC, and the first thing we see, it looks smack normal, but turns out this looks like the only anterior duct that we've injected, and the anastomosis is wide and patent. We look for the other one, and bingo, we get that there is a posterior duct which is leaking. So we place tubes on both sides, and now we can see clearly when you turn oblique that there is a disconnection between the right posterior duct and the hepatogorginostomy, and that's simply because it was inadvertently ligated during surgery. So the next best approach would be to place drains in, patient goes in for an op. So that's what we decided to do. We place tubes inside, okay, one external, internal, the other is pure external, and patient was supposed to go for surgery. Unfortunately, post-op day 9, that's 2 days after the biliary drainage, patient had a heart attack, and surgery was then deferred for a longish time. So this was the approach that was there, and the surgeon said, can you do something? So this was done way back, almost like 15 years ago. It's one of our cases that we had done. We can see here that this is the ligated right posterior duct, and that's the distance from there to the jejunum, to the hepatogorginostomy. We have 2 access catheters, anterior division and posterior division. Through the anterior, we would have placed a snare, percutaneously puncture into the snare and direct it towards the posterior duct. Sounds very simple. Wire in, snare the wire out, balloon the track, and then place a stent, which then later we remove, and that should keep it open. So it sounds very easy. Unfortunately for us, anatomy wasn't very helpful, because between the two, that's the dot that you can see in front, is the catheter in the hepatogorge, and the posterior duct, you can see there's a biggish structure, there's a portal vein, which is sitting right in the middle. So we held back, but fortunately for us, we held back for almost like a month and a half, and by then the liver grew, it regenerated. So everything changed. I unfortunately can't show you the CT, but there was a change in the anatomy. Now we had an access between the two, and that's what we did. We used what I mentioned earlier, the 2 access catheters, got them both aligned in what we call the gun sight approach, okay? And then we moved the needle from the skin,
directed towards the first snare and then into the second catheter and pulled it out from the right duct. And that's the cone beam CT showing that we have not traversed through the portal vein or through any other structure. And then it was very simple. That 1 centimeter track was then balloon dilated and a covered stent was placed, which then after 8 weeks was removed. And these are the T-Mung stents which had this loop snare which you could take out, and then the stent was removed, and that's what it looked like afterwards. So this patient actually had a patent duct for almost 3 years before had a recurrence. So next case is this female who had a segment, had a right hepatectomy done for this malignant cancer metastases, and had a large collection post-operatively. And when they did the CT, found that actually, and the MR, only saw the left duct. The right obviously had a hepatectomy, but there was no continuation with the common duct at all. Simply it's because it was inadvertently ligated. So again, placed a drain and sent them for surgery, but the patient declined surgery. So he said, let's try going percutaneously. So he tried a few times, once, twice, thrice, landed up in all other places besides the bile duct. So what do? We called the endoscopy guys next day. So let's try doing it in our angio suite. We got them there, and we knew that it was totally occluded, wouldn't go up, and then...
Last 2 minutes.
But the wire did go up to the area that we would like it to target. So from there, being a tips man, I thought, let's try a tips approach. So we used not something like a ring needle because it'd be too big. So we made our own, like what I call a Jugaad mini ring set, using a 18-gauge trocar needle and a 22-gauge Shiba. Give it a bend, like how you do with a tips needle, and this is what it looks like. And we insert that from the perk approach and then target that towards the wire that the endoscopist has placed for us. And, sorry, did I go back? Yeah. And once that's through, then the wire is slipped inside the duct, balloon dilated, everything looks okay. Unfortunately, patient had METS, which was detected a few weeks later, and just had a palliative stenting done. So I'll just jump over to this case. So this is a 60-year-old female who had a transverse colon tumor, came in an emergency with a ruptured tumor, and it was a mega epic surgery, 6 hours. They managed to do en bloc resection of the tumor, including the colon, duodenum, pancreas, wedge resected the liver mets, and it's something like what you preferred, like a Whipple's. Only difference was instead of doing a common bile duct anastomosis, they did a cholecystojejunostomy. So this used to be done in the past, but it was done here. Post-op, fever, and got a CT done showing multiple collections, drains inserted, and at the time of CT we noticed that there was common bile duct dilatation and opening directly into a collection in the pancreatic bed. So what do? Place a PTC. Placing the drain in, now we see what is not seen rather is a cystic duct, because the cystic duct should have been draining, and that's because that was disconnected. There was a low insertion of cystic duct, so when they transected that portion, it just slipped off. It's like having a tail which is cut off, and there's a disconnection now, and that's the reason the patient had biliary dilatation and was leaking. So again, this patient was a very high risk for surgery. 6-hour op, entire thing is all frozen over. So what do? Well, we thought, we ever played the game of connect? Just connect 4 dots, CBD to collection to the
Time is up.
and down to the bowel. So this is not exactly new, because if you actually read, you will find somewhere somebody has done something like this. And this was a surgical approach where they used to do this. There was some old paper which showed a hepaticocholecystostomy and cholecystojejunostomy anyway. So it's very similar. What we did on ultrasound, we could see the gallbladder and collection were very close to each other. So percutaneously punctured the gallbladder, opacified it, and then now we could, sorry, my bad. Yeah. Then we could take a second needle, go through the gallbladder fundus, which is now opacified, and directly towards the snare, which was placed in the collection from the common bile duct approach. And that was then pulled out. And once it's pulled out, now we can see there's a complete connection between the two. Then all we had to do is reverse the wire from the percutaneous site and enter back into the gallbladder and going through the cholecystojejunostomy, and then ballooned and just placed covered stents inside, and that turned quite well. So I'll just conclude by, sorry for that, yeah, that the outcomes in this procedure are, I won't say this is a bit modest, 80 to 95%. We hope to get closer to 100, but I think that would be really far out because of the complexity of the anatomy that's often there. When they do succeed, the clinical success is pretty good. The long-term patency, however, is very variable and would require repeated dilatations and follow-ups, stent exchanges, etc. complications because it's a perk approach under vision. The bleeding and sepsis rates are not that very high, and bile also is hardly seen. So I just like to conclude that PBNA provides a minimally invasive alternative to a surgical approach in biliary discontinuity. So it requires, however, precise imaging, technical skill, and a multidisciplinary approach. It offers high technical and clinical success, but unfortunately, the Achilles heel still right now is the long-term durability. Hopefully, the biodegradable stents, we may have that as an answer. Thank you.
Thank you, Sandeep. If we have any questions for the speakers, please come up to the mics and you can ask them. We will just give this session another 5 minutes before we conclude it, just to keep to time. Thank you.
On behalf of Indian Society of Vascular and Interventional Radiology, we thank you, the Singapore team, Dr. Farah leading the team, and who is the chair for Singapore Society of Radiology. And we learned many things from you. And Dr. Nitin, can you please come over the stage? Please come. And we thank you on behalf of ISVR, and we'll have a group photo, and then we'll end the session.
Thank you so very much, ladies and gentlemen. A big round of applause. What a great session it was indeed. Thank you. And we wish you the best for your conference. Thank you for the warm invitation. From all of us here at ISVIR, we extend our gratitude and we wish you the best. Thank you so much. Thank you, thank you. Ladies and gentlemen, the very basic thing about a human being is their ability to express their emotions. And next up we have our music therapist. I know many of you here are great singers, great dancers. And yes, we're going to bring all of that out in the open. Give it up for Aditya Kamakshinada.
Check.
Check.
Hello, check. 1, 2.
Sounds familiar? We've all heard this, right? At some point or the other. How many of you have heard the constant wail of a baby in a silent AC train? Or when you had to accompany a co-passenger who's a new mother and you had a very long flight. I mean, we've definitely come across all of these instances, right? But whenever we hear the cry of a wailing baby, we immediately get annoyed. We get frustrated. There he goes again. That's how we react. But have you ever thought, why does a baby cry? A baby cries just for two reasons: when it's hungry and when it's sleepy. But we are always like, okay, he's crying all the time. But how else can a baby communicate? We started using words later. We only started communicating using sounds way before we started using words in order to communicate how we feel. We've been here for 2 days and we've been listening to, over to the next slide. I would like to conclude with, right? This is how much we've been using our voices. But we, as human beings, have extreme potential of our human voice. And God has gifted us this beautiful instrument called the human voice. So I want all of you to loosen up, open up your voices, become a kid again, and just let your inner child out. Are you guys ready? Ha ha ha. You can laugh louder. We have not been laughing all day. Are you guys ready? Yes. Are you guys ready? Come on, open up your voices, guys. Can I get a huge, loud yes? On the count of 1, 2, 3. Much better. So, let's do some vocal warm-up. Okay? Very simple. I'm just going to use sounds and you have to repeat those sounds. We'll see how we have a conversation. Again, nobody's judging you. Let yourselves loose. Okay? Loosen up your muscles. Open up that voice and we'll see how it goes. Who? Who? Rrr. Ha. Ha. Trrr. Trrr. Cuckoo. Cuckoo. Hee 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 hee. Ooh, ooh, ooh. Ah. Ah. Oh. Ooh, ooh. Ha ha. Nice. Warmed up? After we used sounds in order to communicate, we used alphabets before we used words. And we'll keep it simple. I don't want to start with ABCDs. We definitely know that. Let's have like a game of sorts where I'm doing like a rhythm pattern and you guys are singing just the alphabets. And any guesses on what the alphabets are? It's not going to be random. So the alphabets are going to be I, S, V, I, R. Right? We've seen this all around the campus here, so it's not new to any of us. So I'm going to split you guys into two groups. This is group A. This is group B, the whole of this side. Okay? Let's see who does it better. So this group is IS. Okay? IS, and this group is VIR. Okay? So on the count of every 4 beats, I want you guys to go IS. And after that, the count of 4 beats, I want you guys to go Sattamela. VIR. Let's go. Superb. So, guys, you just have to look at my hand and you'll know when to do that. Let's go. Just loosen up, guys. I'm not doing any presentation. Let's go. Din, kadin, chikadin, kadin, chikadin, kadin, chik. IS. Din, kadin, chikadin, kadin, chikadin, kadin, chik. VIR. Din, kadin, chikadin, kadin, chikadin, kadin, chik. Din, kadin, chikadin, kadin, chikadin, kadin, chik. Din, kadin, chika, din, kadin, chika, din, kadin, chika. Din, kadin, chika, din, kadin, chika, din, kadin, chika. Din, kadin, chika, din, kadin, chika, din, kadin, chika. Din, kadin, chika, din, kadin, chika, din, kadin, chika. Din, kadin, chika. Din, kadin, chika. Din, kadin, chika. Yes. Din, kadin, chika. Din, kadin, chika. Dun, dun, dun. Din, din. Din, din, din. Din, 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 din. Din, 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 din. Let's slowly increase that. Din, din. Din, din, din. Din, din. Din, din, din. Din, din. Din, din, din. Let's clap along. So you guys have to clap twice. You folks have to clap thrice. Okay, let's see how that vocal hand coordination goes. Okay, I want you to clap a little bit more because you've not been clapping the whole day, guys. Come on. Let's hear a round of applause. Warm up. Louder. Louder. We can do louder. Superb. So your beat pattern is 1, 2, 3. Okay, VIR. And I want you to do this on top of saying that. Okay. So 1, 2, 1, 2, 3. 1, 2, 1, 2, 3, and 1 IS and VIR. Let's go. Just look at my hand. 1, 2, 1, 2, 3, 4. Now, ISVIR, let's see who wins. Okay? 1, 2, 3, 4. ISVIR, IS. Together. ISVIR, ISVIR, I. Louder. ISVIR. Superb. Give you guys a round of applause. Wow, you guys are actually competitive. When I said let's see who wins, you're like, ISVIR, let's go. Love the spirit. So thank you so much, guys. You saw how much that made a difference, just opening up your voices. We're always like limited. Okay, hi sir, how are you? This is how we speak. Whatever, like, hi sir, how are you? That makes a sea of difference, right? Your confidence levels, the way you're approaching someone, and the way they talk back to you, everything changes. So this is just a gentle reminder to use the maximum potential of your human voice. Thank you so much. That's been my time. I'm Aditya Kamakshnada, a certified music therapist, and I make people realize their rhythm. Thank you so much.
Absolutely fabulous, Aditya. And of course, your wonderful vocalist. Could you introduce her as well, please?
Yes, she's Srimati Jagannathan on the vocals. Thank you so much, my fellow teammate. Thank you.
Give this wonderful team an amazing big round of applause, Damon, for bringing out the energy at ISVIR 2026. And a big round of applause to that special group over there. You were outstanding. You brought in all the energy. So I'm giving the award to you. Moving on, ladies and gentlemen, we are ready for our HPB session. May I please take this opportunity to invite the chairpersons for this? Dr. Kalpana R., Dr. Ajit Yadav, Professor Devara Anil Kashi Vishnuvardhan, Dr. Ravi Kumar Radhakrishnan, Dr. Jeet Minocha. May I please have you on the dais? Ladies and gentlemen, I know you've been practicing clapping, so you know what to do. Oh, come on, I know you can do better than that. Come on. That group over there. Yes.
Yeah. Now I would like to invite Dr. Suraj. Is Dr. Suraj here? Yeah. Suraj to present his next talk.
Very good afternoon to everyone. Now let's start up this session with the good positive vibes and energy. So I'll be talking on the evolutionary journey of the transarterial chemoembolization over the last few years in liver tumors. So as all of you know, liver is a major challenge for us because it is the 6th most common cause of cancer. It is the 4th leading cause of cancer related deaths globally. And when we see future predictions, by 2040, there will be a projected increase in cancer or 64%, which will account around 1.28 million. The unfortunate part is majority of these cases are diagnosed at the intermediate or advanced stage of the cancer. And when it comes to HCC, it shares the major burden of 75% amongst all liver cancers. So the main foundational idea behind developing TACE was HCC tumor derives around 90% of blood supply from the arterial side, while the rest of the liver healthy parenchyma gets the blood supply from the portal area. So this is how the idea evolved, and the first case of TAE was performed back in 1974, where tumor ischemia was induced by blocking the arterial supply to the tumor. However, in 1979, Yamada added chemotherapy to this combination and coining the term of transarterial chemoembolization. However, the problem was that we need to have refinement to this procedure. So then in 1985, Onishi pioneered the prototype for developing modern C-test, which is called as a conventional test. So here we use lipidol combined with the chemotherapy, most commonly doxorubicin. This backed up by the embolic agents, most commonly used PVA particles and gelatin sponge. The main benefit of this therapy will be tumor will be deprived of the oxygen and its nutrients, which will create the ischemic effect. Followed by there will be local concentration of the doxorubicin, which will have the more localized effect rather than systemic side effects. So these two effects led to the evolutionary development of the conventional C-test. In the year of 2002, there was a landmark year for the test where 2 papers were published, which helped test to develop as a superior treatment modality as compared to the supportive care in cases of unresectable HCC. In 2003, there were multiple meta-analyses were done which showed that there was absolute reduction in risk of death by 19 to 26% at 1 year. So because of this landmark trials and meta-analysis, TACE was developed as a standard of care in BCLCs, for BCLC-B category patients. But always there was a precision, there was a problem with the lobar approach where majority of the healthy parenchyma was exposed to the chemotherapy drugs, which led to the liver failure high rates. So solution for that, we came up with multiple microcatheters which help us to deliver chemotherapy drugs specifically into the tumor feeders, into the 2nd or 3rd order branches, which led to the high concentration of this targeted chemotherapy inside the tumor. However, even with the help of selective tests, we had a challenge with for the unpredictable emulsion in the form of instability. So whenever we inject this emulsion inside the tumor, there was a high surge of doxorubicin followed by less longitudinal long-term effects. Also, there were the unpredictabilities in the case of pharmacokinetics for this unpredictable emulsion. This led to the high systemic toxicity immediately after drug infusion. And there were multiple cases of post-emulsion syndrome. So we need something called as a stable solution, stable emulsion, which will have the sustained period over the period of time, which will have the less systemic side effects. So here comes the CERSI guidelines for all of you know, there will be more stability for water in oil emulsion rather than oil in water emulsion. However, when you prepare these solutions, there is a technique where you combine both these syringes with the help of 3-way, and you mix it across the 3-way. More than 20 exchanges are recommended. And when you combine the lipidol to the drug, there is always a ratio of 3:1 or 2:1. So lipidol should be more in the combination. And since these emulsions are very unstable, before injecting chemotherapy drug or before just injecting set these solutions so as to make it more stable. After this classical and conventional chemotherapy, we have a revolutionary year in 2006 where there was a development of the drug-eluting microspheres, which led to a combination of chemotherapy electrostatically, which bound to the microspheres, which led therapy of drug-eluting trace. Here, microcatheters are selectively parked inside the tumor feeders, which led to the lodging of these bits inside the tumor. And because of this, there will be more sustained local effect and more reduced systemic side effects. When it comes to the beads, we have multiple commercially available products in the market in the form of HEPA spares, where microspheres expand on contact with the fluid, releasing loaded drugs inside the tumor. DC beads are again hydrogel beads, which again diffuse into the tumor, giving over the period of time good chemotherapeutic effect. Life pulse are from the Thermo, which again these are injectable beads which have a systemic sustained release of these drugs. Lumi beads has a property of radio opacity, which will help us to give the good radio opacity during the chemotherapy. Again, 2010 was a landmark year for this depth test where Precision 5 trial came into the play. This was a landmark randomized control trial comparing depth test to the CTs. The crux of this trial was overall when we compare the depth test with the CTS, there was no overall significant difference in the form of efficacy. However, depth test has multiple advantages in the form of it has a fewer liver toxicities and fewer doxorubicin, that is chemotherapy related adverse effects. When the subgroup analysis was done, there were more benefits of depth test in cases of advance where patients were from the child B category, patients with the bilateral HCC and with the case of recurrent cases. Expanding our armamentarium, we have now advanced imaging like cone beam CT, with the help of which we can precisely calculate the tumor feeders, and we can go into selecting all these tumor feeders. Also, this technique helps us to do the volumetry for tear therapy. We have now balloon occludators where we inflate the temporary occluded balloon into the primary tumor feeders, because of which there will be change in the hemodynamics and more drug will be delivered to the HCC. This technique is mostly developed for the cases of recurrent or refractory HCCs. So again, with the development of small bits, we have now bits which are less than 300. So more the smaller bits, there will be good distal penetration inside the tumor, which will lead to the good anoxic or ischemic effects. Regarding success, how to measure success, we have now major critical shift from RECIST 1, where we only measure tumor in the form of quantity. So we used to measure the tumor on the basis of size. Now we have the M-RECIST, which is a modified criteria where we give more preference to the quantity, rather than quantity, we give preference to the quality of tumor, measuring the arterial enhancing viable portion of the tumor. Again, more going towards a more personalized and predictive therapy. Now we know that when we treat the patients in intermediate HCC stage, we have few patients who will respond to test, but there will be again subset of patients who will not respond to the test. Those patients are called as the test refractory cases, and on the basis of that we can study all these cases and we can predict whether before doing the test whether the patient will benefit to the test or not. So the main challenge in these cases will be to integrate the complex pre-treatment data, which includes from the clinical parameters, from the imaging parameters, lab parameters, and to predict the likelihood of the response for these cases. With the AI coming in a big way, now we can combine all these parameters like preclinical treatment information, baseline MRI scans, and all pre-planned treatment characteristics, which can lead us to the prediction of the test, whether this patient will respond better to the test or not. So the continuing journey into the future, now we have multiple drug therapies and multiple targeted catheters and devices available that can change the future for this test therapy. Again, when you do the test therapy, there will be release of the vascular growth factors. Again, because of that will be because of the ischemic effect. When you combine the anti-VEGF agents in the form of systemic therapy combined with the test, patient will have the better response. And there are multiple ongoing trials like Emerald 1, Lipan, Checkmate in the form of multiple combination therapies with the test. So in conclusion, we have seen over the last few years multiple challenges which have tackled with the help of multiple innovations. But the future lies in the combination with systemic therapy, where we can combine the multiple systemic factors with the help of tests. Thank you.
you, Dr. Suraj. Shall we keep the questions to the end of the session, please? Next, I call upon Dr. Arun Gupta, who will be enlightening us on integration into BCLC algorithm and real-world practice, do's and don'ts.
So, good afternoon. So, the topic is integration into the BCLC algorithm and real-world practice. So, what we should follow, how much we should follow, what we do, what we don't do. So, if you see any conference, any talk with SCC starts with the BCLC classification, that this is the staging system, this is the treatment should be offered to these patients, and it becomes a universal language talk. And but if we see the algorithm is basically a starting point of communication, and it is not to be considered as the final word of treatment. So we all know this BCLC 22 has updated the stages from stage 0, A, B, C, D, and the early stage, very early stage, and early stage gives the cure of ablation, resection, transplant options, where we consider prognosis reaching more than 5 years. The intermediate stage where the STACE is the standard of therapy, of course it is further subclassified, and advanced stage systemic therapy, and the last BCLC 22 classification gives the possibility of treatment stage migration, making it more flexible so that we can treat it more efficiently. Like this is the case of 2 centimeter SCC here in the diaphragm. So possibly what we can offer to these patients, possibly TACE plus ablation, radiation segmentectomy, resection, even if the patient have clinically significant portal hypertension, lap resection or transplant options, all are there. So what to choose in this patient remains a controversy. But if we check the reality, the BCLC is the staging system. So this article suggests that with the MDT, 75% of the patient doesn't go exactly along what BCLC is suggesting, and only 25% of the patients treated according to the BCLC. And even the survival matches what the BCLC says. Right, and there are various factors which leads to this, the clinical factors, the liver functions, the overall performance score, the tumor biology, as well as the technical factors also, local expertise, what are the policies there, and what are the patient preferences. So it changes according to various other things. Like in this example, this is a data from the Korean study. They have treated the tumor which are more than 5 centimeter, treated with the tear, and they compared the similar propensity match score with the surgery, and they found that minimally invasive tear procedure gives almost equal 30 months overall survival in this patient. So what's good to the patient can be even minimally invasive, but not according to the guidelines. Similarly, legacy study has shown that with high dose of radiation segmentectomy small tumors can get a survival benefit of 93% of in 3-year survival benefit. And if we compare the legacy data with historical trials, you will see the equivalent results of the surgery. So basically, there is an update that has come up in hepatology, Journal of Hepatology, by the BCLC groups. They have made an algorithm. So they have simplified the stages. They have kept the stages same, and that remains the backbone of the treatment. But also this update has make it more validated in the form of individualized care treatment, and I will explain it in the further slides. The focus has shifts from what is required for a particular specific patient. So there is a very interesting cues framework that is suggested by this new BCLC update. So what is cues? Cues is basically complexity, uncertainty, subjectivity, and emotions. Complexity like patient multifactorial factors, the liver functions, overall performance, uncertainty. There are various cases in the day-to-day practice where you find where the data is not there to suggest a particular treatment. So this ambiguity is taken care of by the cues. Subjectivity. individual practices, local healthcare possibilities are there, and of course the patient factors, what patient wants, what the patient's affordability, and what is the expectation from the treatment. So what is QS? QS is basically AI assisted web tool who takes care of this. So when to apply the QS? It is basically when there is ambiguity that both the treatments, different treatments are giving equivalent results, or there is no suggested guideline, there is not enough evidence, then possibly you can use the QS. So it basically combines the AI neuroscience. It is basically to enhance the human judgment, not to replace the human judgment. So how it works? So basically all the data when the patient comes to the OPD, taken it from the while doing the counseling, all the data, what MDT has suggested, taken into it, the patient factor, cost factor, local health policies, they also given to the algorithm, and this AI model gives us the most possible 1, 2, 3 options to the patients that becomes more definitive. Right. So if this is the update that has come up, and if you see there are some so on the clinical decision making, there is a QS approach, and there is a website bclc.use.ai, and they have, you can see some dotted lines going down there. So basically when there is ambiguity, you have the option of changing the treatment using the help of the eye and using your own MDT team decisions also. So basically it has increased, you have to, it has become more patient specific, and it allowed the treatment stage migration easily. And what has to be justified for a particular patient, it takes the granular liver functions, tumor biology, all the factors together along with the clinical evaluation of these factors. Just for example, what the treatment stage, like in the Talentop study, there is a new concept that BCLC has given, is treatable tumor regression. So like
last 2 minutes
with portal vein invasion, this is Chinese data, they have given immunotherapy to the patient, and then they have underwent surgery, and compared with the data who continued with immunotherapy, shown that the patient who responds can get a better survival benefit. And similarly, like with the Vedanta data, we know that the patients with PVT are treated with TARE and SBRT to downstage and transplant. So this is an option in the previous BSLC, but it actually happens. Like in the portal ISVIR' trial had the patient, 33% of the patient can go for transplant. So what are the key innovations of the BCLCs? They have formed the QS framework for complex decision making, AI build. They have refined the patient selection criteria using the various granular functions, LB, MELD, and child score. Official definition and encouragement of the tumor stage migration has been given. The immunotherapy combination as a first line in stage C has properly incorporated. It has enhanced the bridging and downstaging protocol for liver transplant. So what should we do? The MDT has become must. Define the goals of the patient treatment, palliative, curative, or downsizing at the initial part of the therapy. Comprehensive assessment of patient factors, treatment stage migration is validated, and consider the factors that are modifiable. So these are the do's when we go for the BCLC. Don't consider it as a rigid prescription. Just don't look at the classification. Don't just look at the images. Also, don't overlook the subjectivity and the patient emotional factors, financial capacity, and don't continue a local regional therapy that the patient, for example, don't take the patient up to a taste refractive stage, and don't be enthusiastic. Choose the treatment wisely so there is no high compensation risk. So BCLC now is in. With this update, the BCLC is in your hands. There is more individualization of the treatment. It has become more patient-friendly, and patient has a role in making decisions of these treatments. So you can structure your judgment accordingly. Thank you.
We'll go to the next talk by Dr. Kunal Galla, Future Direction in Liver Volume Modulation, LVD, Combined Techniques versus Conventional PVE.
Excuse me, it's not here actually.
Excuse me. The technical team, can you just help, please?
No. It's not there.
Team, they're looking for Dr. Kunal Gala's presentation.
Good afternoon, everyone. I will be talking on fusion. I'm Dr. Varun Yadav. Dr. Kunal Gala could not be here, so I'm presenting on his behalf. As we know, major hepatectomy has become the standard of care for primary liver cancer as well as secondaries. And preoperative assessment of the volumetry is essential in preventing post-operative hepatic insufficiency and liver failure. This is a nice article published in 2024 which talks about how liver volumetry techniques and liver regenerative techniques have evolved over the years. It gives us a good point that standardized FLR measurement is more accurate than our usual measured FLR that we take. So the problem with that is we are not taking into account patient's body weight and size, that is the patient's metabolic demands. But with standardized FLR, we are taking into account the body surface area as well. We are not calculating the total liver volume, we are taking into account the total expected or the estimated liver volume. So cutoff FLR values for hepatectomy are, as you all know, 20% for a healthy liver, 30% if prior chemotherapy has been given, or 40% in the case of a cirrhotic liver. Liver augmentation techniques, the purpose they solve is we proactively want to induce hypertrophy of the liver so as to increase the eligibility of surgical candidates as well as reduce the risk of post-hepatectomy liver failure, and at the same time enable downstaging of tumor biology during the hypertrophy period. This is especially useful in cases when TARE is used as a bridge to resection option. So in 1986, this was one of the first articles that showed that actually there in case of portal vein obstruction, and they call it the atrophy hypertrophy complex. So basically what happens is that portal venous flow is getting blocked to one side, so there is ischemia, apoptosis and necrosis, both are happening. At the same time, there is diversion of portal blood flow to the other side, which is not only causing hepatocellular swelling, but at the same time causing stress on the endothelial wall, resulting in the production of these inflammatory cytokines, nitric oxide, which are through a cascade of inflammatory cytokines, are causing regeneration. Although we use the term hypertrophy, both hypertrophy and hyperplasia are taking place. Portal vein embolization is the oldest and the most studied technique for liver volume augmentation. And one of the earliest studies which was published was back in 1990, where these people, Makushi et al., did it safely in 14 patients. They could do it safely. There were two mortalities and both of them were not related to the procedure. They were related to the cholangitis and later on jaundice developing. So again, a study published in 2022 which again reinforced that there is significant increase in FLR, percentage FLR after portal vein embolization, while at the same time there is no increase in any post-operative complications, post-procedure outcomes. So the axis that we usually take is a transhepatic axis. You can take both ipsilateral as well as contralateral, but ipsilateral, we prefer ipsilateral because we're not damaging the future liver. Obviously, it makes it a little more challenging selecting the ipsilateral branches. So sometimes we can also go for a transsplenic axis as well, but we have to be careful of the bleeding complication. So embolization using catheters, microcatheters, different studies have shown that they've used different embolic materials. So what to use? I think the answer is pretty clear on this. Glue with lipidol works the best. This is a very large meta-analysis including more than 50 studies and a sum total of almost 3,000 patients, which clearly showed that glue shows superior hypertrophy, and at the same time, the procedure cost, the procedure time, the fluoroscopy time, radiation dose are all less with glue embolization, while at the same time complications are similar to particles or coil that we commonly use otherwise. This was reinforced with the best FLR trial on 21, single center RCT, which was performed in Portugal, and it also gave a new finding that glue embolization not only causes a greater liver hypertrophy but a faster liver hypertrophy, as we can see that there was statistically significant difference even at 2 weeks. So portal vein embolization is great, it works very well. Then why do we need other therapies, other combinations? Because there is a dropout rate. In 15 to 20% cases, there is dropout because of inadequate FLR despite portal vein embolization. Another 15 to 20% may also drop out because of disease progression. So we want greater FLR hypertrophy, but at the same time faster FLR hypertrophy. This was one study published in 2015, which in Japan, which combined portal vein embolization with dietary augmentation of branch chain amino acids, and they studied improvement in liver function of the future liver remnant using technetium 99M human serum albumin scintigraphy. They did find improved liver function, however, it was not statistically significant, and the sample size was low, 13 patients. Another study published in 2012 where they combined portal vein embolization with autologous infusion of bone marrow derived stem cells. In this study, the procedure was done using surgery. The access was through the transileocolic branch. Again, they showed that the FLR hypertrophy was faster, much greater, almost twice in this study. And in fact, even the survival outcomes were better. Sample size was quite low, and it still needs to be validated with further studies. The idea of combining hepatic vein embolization comes from the fact that liver donor liver transplants, in those cases when hepatic vein gets blocked, there is liver hypertrophy. So if we combine both of them, we might get a faster and a greater degree of hypertrophy. The first study was published in 2009, comprising of, but it showed that there was steady increase after hepatic vein embolization. So it was a retrospective study. They did it. They found that there was not adequate FLR after portal vein embolization, after 2 weeks of portal vein embolization. So they again reinforced it with hepatic venous embolization, and they could get another 5 to 6% of FLR hypertrophy. They also noticed that there was more increase in liver enzymes after this combination therapy, which peaked around day 2 or 3, but mostly it was transient and came back to normal within a week. So again, similar study published in 2020, but this time it was done to treat metastatic colorectal liver mets. Similar findings, small study, but it showed the fact that portal vein embolization, in fact venous embolization, works not only in normal livers, but also in livers that have been treated with neoadjuvant chemotherapy. Liver venous deprivation is more or less the same thing only, but we are doing simultaneous embolization of both the veins. So the earliest studies that were published was in 2016, and again they showed that it was safe, it produced greater hypertrophy. This study, it was a retrospective study, included 7 patients. Another study of, I think these were 13 patients only, so small sample sizes, but they were safe. They showed greater and faster hypertrophy, and again the liver enzymes, bilirubin was raised, but it came back to normal within a week. This study also made a good point that the growth rate is faster with combined technique. The kinetic growth rate here was 2.9% per week as compared to only 1.4% per week with PVE alone. So same thing, different name, but this was the largest study done with proper matching between the two groups, hepatic venous embolization. And what it showed was there was no significant difference in morbidity, post-procedure morbidity between the two procedures. However, there was significant difference in FLR growth at 4 weeks, almost more than double in the combination arm, almost 62% at 4 weeks. So again, access, different studies have put transhepatic and transjugular work, but mostly transjugular is the more commonly used. The idea is to put a plug in the main hepatic vein, leave a stump of at least 1 centimeter for the surgery to happen easily, with or without embolizing the distal terminal branches. Many authors advocate the embolization as well to prevent collateral formation. So just to end with the tear or SIRT, we all know that tear also causes atrophy of the treated lobe, at the same time causes compensatory hypertrophy of the contralateral lobe. But that compensatory hypertrophy takes time. But the advantage of tear is that at the same time it is treating your tumor, it is controlling the disease, delaying disease progression, and while all this hypertrophy is going on, giving us time to understand the tumor biology. It is sort of a test of time. So some retrospective studies have shown, this is a study done in 83 patients, and it showed that the volumetry changes were comparable to PVE, but obviously it took more time, maximum 9 months. So another study, 30% increase, but here the increase was at 3 months, and all these patients could be operated at 3 months. So I would like to conclude by saying portal vein embolization is an effective procedure for FLR hypertrophy before major hepatectomies. But when baseline FLR is very low, less than 20%, we might go for a combination therapy. It acts as a faster and a more efficient method. Radiation lobectomy may be another good option for unilobar tumors as a bridge to resection option. Thank you.
Thank you, Dr. Yadav. The last speaker for this session is Dr. Indu Shekhar. I invite him to give the talk on radionuclide therapy, role of FAPI in management of liver tumors.
Yeah, good afternoon. It's a new area of management of liver tumors. To understand the concept of FAPI, we have got tumor microenvironment. To understand the structure and also growth of the tumor, and most of the times we understand that the microenvironment will actually shape how the patient is going to do. So in the tumor microenvironment, if you look at, there are a lot of fibroblasts called as tumor-associated or cancer-associated fibroblasts, which are actually produced by the cancer cells itself. Because once the tumor is growing above 5 millimeters, the tumor needs a scaffolding, so it produces fibroblasts. And those tumor-associated fibroblasts, in addition to the scaffolding, it also produces a lot of other factors, and the release of TGF-beta, then it aids in actually growth of the tumor and also to metastasize. So this action of fibroblasts is very important in development of tumor and tumor resistance to chemotherapy and also metastasis. So what we have observed is these fibroblasts express what is called as fibroblast activation proteins. So although the fibroblast is the major constituent of the tumor, in fact, some of the studies have shown 1:50 presence of my fibroblasts. If there is one tumor cell or a cancer cell, there can be up to 50 fibroblasts related to that. And it becomes a major constituent of the tumor, especially when the tumor is being attacked by the chemotherapy drugs. So these fibroblasts also express what is known as fibroblast activation protein alpha, and this particular fibroblast can be targeted by attacking the fibroblast activation protein. So that is called as FAPI. So some of the compounds like quinolone based compounds are what is called as ligands in fact, these are being targeted by the FAPI molecules, which are FAPI2, FAPI4, and things like that. And rofapeptide tetraxetan is one of the latest FAPI molecule which is available, and this is it's a very selective FAP binding peptide. So when you inject this along with the radionuclide, it attaches firmly to the fibroblast. Once the radionuclide is inside the fibroblast, we can make a use of this as a diagnostic tool if you use a gallium, and if you use lutetium or actinium, it can act as a therapeutic agent also. So, we have for last 5 years in HCG, we have been using gallium FAPI scans. We compared it with the FDG scans. In fact, we started getting more positive pickup rate with gallium FAPI than FDG scans, because FDG basically depends on activity of the tumor or metabolism of the tumor, but this FAPI scan actually targets the fibroblasts. So results are encouraging, and then we started attempting, why not treat these tumors with lutetium. So the lutetium is tagged to the FAPI molecule, and this is injected intra-arterially by transarterial method. I mean regular taste like that. So out of this last 5 years, we have treated 46 patients with advanced HCC. And almost all patients had portal vein thrombosis, and they were not really qualifying for regular treatment. A few examples of the patients treated. This is a large tumor of right lobe of HCC with a portal vein thrombosis there. And he was not really fit for, we decided to do a FAPI therapy for him. This is the initial angio, which shows a large tumor in segment 7 and 8. And through the same catheter, we injected the radioisotope. And that is the result. You see, there's a huge tumor there with gallium FAPI scan positive. And this was done in January, and then April 23, after 3 months, the activity has come down significantly. Patient improved. After this, in fact, the portal vein opened up. We could see the portal vein much better at this stage. And then we did tests for the remaining part of the tumor. All test was done in April. After test, this is a picture in June 23, after 2-3 months. And we have been following up this patient till December 25. You can see complete resolution of the tumor. No evidence of tumor even now. No other drug is given. Well, this is was treated with 3 cycles of TACE earlier before he came to us, and then he developed portal vein thrombosis.
Last
This
2
was
minutes.
the initial picture. And post FAPI therapy, you can see reduction of tumor. And till December 25, he was doing pretty well without any further treatment. Another case with portal vein thrombosis, treated with FAPI after failed immunotherapy for 4 cycles. I'll have to hurry, yeah. And there was also arterioportal shunting in this particular patient. Despite that, we went ahead and did the FAPI therapy. Now, partially, the portal vein is open. For almost 1 year, he has been alive, doing pretty well. Okay, now our experience with 46 patients, almost all were BCLC C stage. Follow-up range from 2 months to 60 months. Mean size of the tumor was about 9.2 centimeters, pretty large tumors. And multicentric HCC was there in almost 61% of the patients. Extra was there in almost 50%. ECOG status was about, majority of them were ECOG 1. About 70% had background cirrhosis. And prior treatment was given in about 61 patients, 61%.
Time is up.
Almost everybody had BCLC stage C, and partial response was there in half of the patients, almost 47%. There was progressive disease in another 45% of patients. Overall survival, if we look at about, I would say 12 patients survived for almost 3 years. Okay, just to conclude, intraarterial FAPI can be an additional method. I'm not saying that it can replace. It is an additional method for managing advanced HCC. It seems to be effective even in metastatic disease. And there is a portal vein when you use this. And even when there is a portal vein arterioportal shunting, you can still use it. And in combination of immunotherapy, it gives better results. Thank you.
Can I call all the speakers on the dais for a pick? Dr. Suraj, Dr. Arun Gupta.
Thank you so very much. Yeah, please invite the speakers who are part of the
Dr.
session
Varun
to join
Yadav.
us. Yeah.
Suraj, Dr. Varun Yadav. Yeah.
Dear wonderful doctors, can we applaud the chair on the stage? Thank you. Thank you for sharing those valuable insights, your experiences with us. May I please invite the chairpersons for the next session to please be ready. Dr. Sandeep Punamiya, Dr. Brigadier Atul Mishra, can I please have you on the dais?
What is the yeah. Slideshow? No.
Good afternoon, everyone. Just welcome you to the session, and we have a couple of speakers basically continuing. I'd like to invite Professor Kim from SNU to speak to us on the recent advances of therapies.
Thank you for kind introduction. My name is Hyo-Chul Kim from Seoul, Korea. I'm a big fan of radioembolization, so my email address is radioembolization. This is my disclosure. So same day Y90 and streamlining Y90 can be performed in patients with low long shunt fraction. So we are IR and we have to be a fortune teller. We have to pick a patient with low long shunt fraction. So conversely, who has a high long shunt fraction? As you know, large HCC hepatic vein invasion, all opacification of hepatic vein on arterial phase image means high long shunt fraction HCC. According to our experiences, large HCC commonly have dilated vascular structure within the tumor. It is a so-called dysmorphic intratumoral vessels, and this is an indicator of a high long shunt fraction. Left case, you can see dysmorphic intratumoral vessels and long shunt fraction was 44%. Right case has no dysmorphic vessel, long shunt fraction less than 1%. So this is unpublished data. Tumor bigger than 5 cm, total patient number was 169. Among them, if tumor between 5 and 8 cm, the prevalence of dysmorphic vessel is less than 20%, about 20%. If tumor is bigger than 12 cm, the prevalence of dysmorphic vessel is over 70%. So the larger the tumor, the more common dysmorphic vessels are. So tumor without dysmorphic vessels commonly have a low long shunt fraction, and tumors with dysmorphic vessel have high long shunt fraction. Even in large HCC, if they don't have dysmorphic vessel, the long shunt fraction generally low. So I run a prospective randomized prospective registry study, same day Y90 for HCC with enlarged microsphere. Inclusion criteria are tumor bigger than 5 cm, without dysmorphic vessel, without hepatic vein invasion, without hepatic vein enhancement on arterial phase, without TIPS. So this is a so-called OMT program, order first and mapping and treatment. So at the day of treatment, we perform angiography and injection of MA scan into the head, and patients transferred to the nuclear medicine, and planar image and SPECT CT is obtained. During that, we calculate the target volume, tumor volume, and we determine the target vessel on combeam CT image. And long shunt fraction and TN ratio was measured on and then we calculate the radiation activity of each target vessels within 1 hour, and we notify the number of daughter vials and radiation activity of daughter vials to the nuclear medicine daughter vials within 20 minutes. So within 1 hour after SPECT CT, we can do Y90 treatment. So in our hospital, if the Y90 the purpose of Y90 is curative, we set the tumor observed dose between 300 and 600, and maximum lung dose is set as 15 gray. If lung dose is over 15, we reduce the tumor observed dose between 100 and 300, and then we do palliative Y90. So let me show you typical cases. In this patient already received atezolizumab and lenvatinib, but the primary tumor shows slow growth, and you can see 7.7 cm size single tumor, but there is no dysmorphic intratumoral vessels. So we planned same-day treatment. And angiography and combeam CT was performed. And then planar image and SPECT CT shows long shunt fraction 2.4%. There are only 2 tumor feeding vessels, 77 and 76. And distal 76 hepatic arteries were embolized with the gelatin sponge particle. And 77 artery treated with 0.3 ZBQ, 76 was treated with 1.2 ZBQ. And prescribed radiation activity 1.5, and tumor observed dose by partition model was almost 300. At the next day morning, we obtained the Y90 PET image. And so pre-treatment, tumor observed dose was almost 300, and post-treatment, tumor observed dose was 323. 5 months CT shows a partial response, and 9 months CT shows marginal recurrence. And retrospectively reviewed the PET CT image, you can see small defect of Y90. This is the second case. Tumor is just 5 cm without dysmorphic vessel. This is a very good candidate for same-day treatment. Y90 MAA was infused left hepatic artery, long shunt fraction about 5%. And it is kind of radiation segmentectomy, so mean observed dose was 203 gray, and tumor observed dose on SPECT CT was 100 gray. And the post-treatment dosimetry, the tumor observed dose over 1,000. So 5 months CT shows complete response. So we have to know the contraindication of OMT program. You can see dysmorphic vessel in this case, and so long shunt fraction was 21%. This patient has a 9 cm size, single nodular tumor. There are a few dysmorphic vessels, so this is not a good candidate for OMT program. In addition, you can see in IVC tumor thrombi. So on angiography, you can see leakage of contrast media into the IV. Or hepatic vein invasion and IVC thrombi indicate high long shunt fraction. In this case, right hepatic vein and middle hepatic vein was not enhanced on arterial phase. However, left hepatic vein beside the tumor enhanced on arterial phase. So even though this tumor has no dysmorphic vessel, if you see the enhancement of left hepatic vein, you can imagine the long high. So really the long shunt fraction 23%. In this case, there is infiltrative tumor in the left lobe, but on arterial phase, CT shows enhancement of left portal vein, which means severe AP shunt. So I don't like AP shunt in radioembolization patients because on angiography, control over AP shunts are common, and MAA was injected into the left hepatic artery. You can see the MAA activity in the right lobe. So if you infuse Y90 into the left hepatic artery, it means whole liver irradiation, and there is a high risk of radioembolization-induced liver disease. So if you see AP shunt on CT scan, this is not a good candidate for a Y90 patient. So let's move on to streamlining Y90. So streamlining Y90 means Y90 without MAA scan in tumors. So HCC and neuroendocrine tumor must be smaller than 5 cm, and cholangiocarcinoma or metastatic colorectal cancer smaller than 7 cm, and no tips, no hepatic vein, no oral opacification of hepatic vein, and no dysmorphic vessels. These tumors must have low long shunt fraction, so MAA scan can be omitted. In this patient, the tumor was 4.8 cm. You can see dysmorphic intratumoral vessels, so long shunt fraction was 35%. But most small tumors don't have dysmorphic vessels. So I run a prospective registry study. So inclusion criteria, smaller than 5 cm tumor within Milan criteria without dysmorphic vessel. So this patient has 3.3 cm size, a single tumor. So I don't obtain MAA scan and SPECT CT. We obtained DSA image and whole liver cone-beam CT like this. And selective angiography of segment 4A-B, you can see tumor blush. And another small feeder from segment 3 supplied the tumor like this. And selective cone beam CT shows the tumor, and I ordered 0.55 GBQ. Cone beam CT of 73 confirmed the tumor blush, and the tumor was very small, just 1 ml or 2 ml, and 0.1 GBQ is the smallest of total IR. So streamlining Y90 means kind of a radiation segmentectomy or radiation subsegmentectomy, and we don't know the TN ratio, and we don't need to know the TN ratio. And in radiation segmentectomy, single compartment dosimetry is enough. So Nima Kokavi said mean observed dose 250 for radiation microsphere is enough. Dr. Salem said 400 for glass microsphere, but I think 250 is a little high. So my target mean observed dose between 150 and 250. Even though we don't know the TN ratio, I assume the TN ratio 2 or 3 for metastatic colorectal cancer, 3 or 4 cholangiocarcinoma, 5 or 10 hepatocellular carcinoma, visually assessed by my eye on DSA imaging and cone beam CT, and I calculate the tumor dose by partition dosimetry. In radiation segmentectomy, the target tumor observed dose commonly over 600 up to 1,000. In large tumor observed dose between 300 and 600, but in radiation segmentectomy, commonly over 600. So I just sent a text message to the nuclear medicine, and the Dr. Byers will come to angiography suite 20 minutes later. So I have to wait 20 minutes. I'm studying the Tesla stock. And then we performed on Y90, and the next day, Y90 PET image was obtained, and on the post-treatment dosimetry revealed tumor observed dose over 800, and 1 month CT shows a complete response.
Last 2 minutes.
Yeah, last 2 years, we treated 487 HCC cases. Among them, 19% of patients were treated with the same day. 35% were treated with streamlining. So regular radioembolization were performed only 45% of our patients. Our treatment style was published in JVIR in streamlining and same-day treatment in this year. And streamlining for cholangiocarcinoma will be published in KZR a few months later. You can visit my YouTube channel, and I uploaded my lecture in Korean, but nowadays Google translation is quite accurate. Thank you for your attention.
Thank you so much, Professor Kim. That was an excellent talk. Due to paucity of time, we'll be taking questions maybe during the tea time, and we'll move on to the next talk, which will be case-based discussion by Dr. Sanjeev Kaga. I request Dr. Sanjeev to please come on stage.
Good afternoon, everyone. How many of you are comfortable doing dosimetry for Y90? Okay, that's great. So many of you. So we'll go through the basics of dosimetry first, and then I'll show some cases. And I'll have some, feel free to ask questions if you have in between, and at the end of the session as well. So first of all, what is dosimetry? It is a calculation of the absorbed dose to the tissue. It is not what you delivered, it is what is absorbed by the tissue that you treated, which in turn determines the biological effectiveness of the radiation to the tissue, so the tissue dies. So our aim is to destroy the tissue through DNA damage by giving enough radiation to the tumor. So there are two types in Y90. One is called a pre-treatment dosimetry, other is a post-treatment dosimetry. The post is it's already done, you just measure what happened. but pre is what you want. As much as possible, a post has to be at least equivalent to what you wanted, if not better than that. So why should I learn it? Why is it important? Because dose affects tumor response. The initial studies have shown that you need to give 60 gray to the tumor using ISVIR'es to get a good response for a colorectal metastasis. For HCC, the initial studies in Australia showed 120 gray is to be given to the tumor to good response. Subsequent studies have shown that neuroendocrine tumors require close to 200. Then somebody said you need 200 to get radiation segmentectomy. And somebody said you need 400 to get segmentectomy. Somebody is saying now 600 to get segmentectomy. Why is that so much variation in dosimetry? Think about it. Then dose also affects toxicity. If you give more dose to the tumor, that's not a problem, but there is always collateral damage because some normal vessels will be coming off from the vessel you start to embolize it, and some radiation beads will end up in the normal liver tissue. If the normal liver gets anywhere above 50 gray, you're likely to get chronic liver damage, ascites, hyperbilirubinemia, fibrosis, radiation-induced liver disease, all those things. If 60% of the liver, 60% of a normal liver, if it gets more than 30 gray, you end up into complications. So you need to decide how much more dose I want to give to the tumor while limiting the dose to the normal tissue. Okay, let us talk about absorbed dose. It is based on the SNM calculation called MERD, Medical Internal Radiation Dosimetry, which is developed by Society of Nuclear Medicine. It's a very simple formula. Absorbed dose is equivalent to energy from ionizing radiation divided by mass, how many kilograms is the tissue that irradiated. It is pretty much easy to calculate that on external beam radiation therapy because you know the energy of gamma ray or beta ray or whatever, neutron or proton, whatever you choose, and you know the linear attenuation coefficient of that beam, then you can calculate how much attenuation has happened in the tissue and calculate the dose to the tissue based on how many angular beam you send to the patient. However, it is not that easy in Y90. Y90 is an isotope that is embedded onto a particle and is given into the circulation. So Y90 bead is releasing gamma rays following beta emission. So first you get a beta emission, then you get a gamma emission. So very hard to calculate the dose. So radioactivity, that's how much GBQ you want to give, is measured based on disintegration, so 1 becquerel per second or 1 disintegration per second. Whereas absorbed dose is measured in gray or rad, Rankine or rad, or gray now. So this is Henry Becquerel who termed the one, unified the disintegrations into becquerel. And Louis Gray is the one absorbed dose. So if you don't know anything, I want to remember only this formula. If you know this formula, it's extremely easy to calculate the dose that you want to give to the patient. So remember, 1 GBQ of Y90, whether you take ISVIR'es, TheraSpheres, it doesn't matter. If you take 1 GBQ of Y90 and infuse into 1 kilogram of a tissue, that means that tissue got 50 gray. Don't ask me how I got the numbers. Those are very difficult calculations. But just remember this, just like you remembered your multiplication tables when you're kindergarten. So 1 GBQ Y90, if you inject into 1 kilogram, that will lead to 50 gray to the 1 kilogram tissue. So now, if you modify this one, okay, I want 200, so change it. You want 200 means how many GBQ you want to give? 4 times more. So you give 4 GBQ to get 200 gray to 1 kilogram of liver. Oh, well, my tissue is not 1 kilogram. All I have is 250 grams of tissue. Well, then 1 GBQ will give you 200 gray to the 250 milligrams of tissue. If you want to really do ballpark, just random guessing, in average, all of us have 8 segments of the liver, and each segment is approximately how much? Maybe 250, 125 to 250. So you calculate that way. So just go back. So I usually remember right lobe 1 kilogram, left lobe half kilogram. And that's how I remember, and then choose the numbers. Okay. So that is called single compartment model, meaning you are assuming that beads will go into entire infused organ irrespective of what is present there. Whether it's a tumor or normal liver, doesn't matter. There will be uniform distribution of the beads into the tumor, into the tissue that you injected. And this is what the radiation doses. So what I told just now, I put the numbers. So let us say you want 120 gray. Okay, let's put 120 gray. The right lobe, 1 kilogram, that's equal to 2.4 GBQ you want to give. Let us say you want to go left lobe, so 0.5 kilogram, then you want to give 1.2 GBQ. So that's how you calculate it, and then you do that. So if you want to do radiation lobectomy or segmentectomy, you just go 200 gray and you calculate the left lobe 0.5, that's 22 GBQ. If you want to add lung shunt fraction as a method to compensate, it's not a big deal whether you do it or not, but if you want to do it, you just subtract that number or 1 minus shunt fraction and then do that. So one of the main problems with the single compartment model is that your assumption is that the radiation beads will distribute in the 1 kg or half kilogram tissue very, very uniformly. That is not realistic. It probably happens in one of those patterns, right? So you still say that this first box has received, let us say it's 1 GBQ dose in 1 kilogram. This first box received 50 gray. According to SNM formula, it is same 50 gray for those 4 boxes as well, irrespective of how they are distributed, because it averages out. This concept is extremely important to understand why some people are saying, oh, you need to do 200 gray, oh, you need to do 600 gray, you need to do 1000 gray. Tumor recurrence depends on the area that doesn't have Y90 beads, right? When you inject more and more and more doses, the probability of having no beads in some portion of the tumor is going to be 0. Make sense? Recurrence is determined by not by the highest dose you gave, but the lowest dose in the tumor components. You are maximizing even distribution of the beads so that all tumor gets the Y90 beads by giving higher and higher and higher doses. When you do higher doses, the average is, let us say, 500, but within the tumor, there are some areas which have got 2000 or even 5000 gray, and some areas which got only 80 gray. Make sense? When you look at the radiation oncology literature, all you need is 80 gray to kill the tumor. Tumor is not going to survive after 80 gray, max of 120 gray. So anything you're giving above 120 gray is useless. You're just killing a dead cell there. But you're maximizing the distribution. So if there's a mechanism for you to better distribute those beads, then you don't need to go to 400, 600 gray. Make sense? Okay. So we talked about why the distribution is going to be different. When ISVIR came out, they came out with empiric formula, which nobody uses. It has no scientific basis. There's a little bit, I don't want to go through the details, but this is not, nobody uses it. And then BSA method, nobody uses it. So we understood the single compartment model. But the problem with single compartment model is, number one, uneven distribution. If you want to maximize more beads to the tumor, you need to inject more and more dose to normal liver as well. So there's a higher chances of getting a liver toxicity in a single compartment model, because you're trying to push more radiation to this perfused volume. Whereas the next model, called a multi-compartment model or partition model, takes into consideration that the distribution is going to be different. The normal liver will have a different vascularity, tumor will have a different vascularity, lung shunt is different. So each of these areas will have a different distribution of Y90 beats, similar to the boxes I have shown other side. So in that case, if that is true, then why don't you just calculate by differentiating those compartments and calculate the actual dose tumor got? And then backtrack it and say, hey, I want to maximize the tumor dose at a limited dose to the normal liver. So when you want to do compartment model, like partition model, you don't determine how much dose tumor gets. You determine what is your tolerance for normal liver to get. If a normal liver you want to shut off at 50, that's what you put normal liver gray there. And that will calculate you what should be given so that the normal liver dose is minimized to at 50 gray only. And whatever extra you get it. The tumor may get 200, 300, 500, doesn't matter to you. You are aiming to minimize the toxicity in this methodology. And the word that's TN represents tumor to normal liver ratio.
Last 2 minutes.
I request me to give me more time because one speaker has backed off, so I have more cases. Anyway, so this is a case to show the tumor enhancement is much higher than the normal liver. So you calculate the tumor to normal liver ratio and plug in those numbers. The TN ratio, left lobe is 9.7, right lobe is 7.9. You put those numbers into that, to this formula, and then calculate the dose. So that will help us to know what dose tumor gets, what dose normal liver gets. It becomes too complicated to do that. Like you put the numbers and then go back there. So instead, there's some apps that can do that. So it's a Dabber app, which David Liu has developed from Vancouver. And also there's another app called Y90 app, which you can just plug the numbers, it will get you the numbers. So other option, which I do this very oftenly, is called angiosomic multi-compartment model. So you don't determine right lobe versus left lobe. You determine which artery I'm injecting, what is the perfused volume in that artery, and what is the ratio between the tumor and normal liver. And then calculate the doses for each angiosomic segment using the partition model. That's what I always use it. Next is voxel dosimetry. It is less relevant now because it takes much harder time to do it. So we'll go to the actual cases now. So what is the convergence? So dose to tumor should be high, at least 120 gray. Consider partition model to minimize the dose to normal liver. Always try to do super selective. Just like you have done a very super selective or ultra selective TACE, you do similar TARE and you ablation dose there. Ablation meaning at least 200, maybe 400 dose to that area. When you do that, you don't have to use multi-compartment model, use single compartment model, go to selectively where the tumor is and bombard it. If there are 4 tumors, go to each tumor subselectively, 4 catheters, 4 doses, inject there. And it can be easily done, especially with Sarsius, 1 vial, they get 3 GBQ, you can distribute into 10 vials if you want and give 10 catheters. And if you have Therasvir, they can send you each vial separately for each catheter you want to use it. So both companies provide you the option to inject. So these are Therasvirs, and based on how they calculate the dosing, meaning, as I told you, the 2000 becquerels per particle on Sunday noon. So depending on when you get the beads, the actual radiation per bead is totally different. So here you can see the same bead will change radiation dose depending on when you get it. On Sunday it will be 2500, the following Saturday it will be 85 becquerels, the same bead. So if you want to inject 1 GBQ, the number of particles have to increase to compensate for the low dose per bead. Make sense? And if you take into Sarsius, they calculate differently. They actually do different calculations. So this is they give 50 becquerels per particle, but they calculate 6 p.m. of the day of delivery. So the slight difference here. What you get is 50 becquerels on the day you are infusing, whereas in Therasvir, it is on Sunday where they did it and what this is getting over a period of time. Okay? So they also do what is called a pre-calibration, meaning, oh, I know you today you want 50, what it have been yesterday? Same bead. Must have been harder. 2 days before, 3 days before, 5 days before. You can get earlier doses of the same bead because it has to be higher as it disintegrates over a period of time. So that's how. So what is the activity per bead changes when it is calibrated. So if you put them together, the second week dose of TheraSpheres is almost equivalent to the pre-calibrated dose of TheraSpheres. So don't go into this drama, one is better, other is worse. They're all the same if you're going to use second week doses. Most of us tend to use later first week or second week dose of Y90. Anyway, for TheraSpheres, you have the option to use TheraSpheres as well with the same amount of dosing as well. So let's go to cases. So radiation segmentectomy. This is a patient who has a caudate lobe HCC, and this is the angiogram mapping, this MAA scan, selective caudate lobe artery being injected. There is no other area perfused here. Here, you can go whatever you want to give, 200, 300, 400, 500. As I told you, tumor is dead at 120. You can give anything you want extra. So I did 200. So it's the same thing. You use the formula, single compartment model. You're not going to calculate too much. Dose is going to be 200 gray. The volume of the tissue is approximately whatever I wrote there. And then LSF, what the function. So, boom. One segment, 250 grams, you got that numbers. And that's what you inject. And once you need to inject 1 GBQ, such is very easy. They give 3 GBQ vial on the day, you ask the pharmacist to give 1 GBQ, inject, you're done. But if you're going to TheraSpheres, it's going to be a little more complicated because they make vials 3, 5, 7, 10, 15, 20 on the Sunday. So then you have to use this chart to see when that vial corresponds to give 200 gray for that area. Make sense? So it's a little complicated. So if you go first week, you get that 3 GBQ vial. But if you want to second week vial, you get 20 GBQ vial. So and then use that vial to inject. It's the same patient, 3 months later, the entire tumor is gone. So another patient, it is a cholangiocarcinoma in the right lobe of the liver. The selective catheterization, you can see cone beam CT, MAA scan, very selective deposition. Same thing, exactly same formula used. It's a 200 perfused volume, so 0.82. You can see after 10 months, the whole tumor is gone. Radiation lobectomy, another patient. So large tumor, I use single compartment model because the whole thing I'm going to radiate anyway. So select right hepatic artery, MAA scan, that's a shunt fraction, we got it. We calculate the volumes. And again, same thing, 200 gray I want to give it. You know the volume, and LSF, same thing. The almost 1 kilogram, I gave 4 GBQ dose. Whole tumor is gone after 36 months. If you want to do non-selective tear, but a multifocal disease, this case represent, even though it is lobectomy, it's selective tear at the end because only one vessel supplying the entire tumor is as good as a small tumor. But if you have a multifocal disease like this, and you want to do a lobar, not a segmental, which I tend to avoid it, but if you can do for various reasons, then you have to be really, really careful because you can damage the normal liver very heavily in these cases. So again, same thing, did the angiogram and the MAA scan, so then you got the numbers, and then you put the perfused volume LSF scan, and then this time I did a 120 gram, and then did the injection. But it's better to do partition model. That was the single compartment model, which I don't like to do in this multifocal disease when you're lobar injections. Then you do the partition model. This is the formula, and it's very hard to do it. This is what you get it, because I did 50. I want to limit the normal dose to liver, that's 50. If you do that, that's what the DAVR app shows, that's what the Y90 app shows. So you can use any of those things, calculate it, and inject it. So this is a post response, all the tumors are gone, normal liver is not damaged, there's no enhancement of the tumor. So last case, as I told you, if you have multifocal disease, I would rather do super selective, ultra selective, multi-dose injections. So in this case, you can see 1, 2, 3, 4, 5, 6 lesions in the liver. One option could have been do lobar injection. That's what we used to do in the beginning of Y90, but we no longer do it. We do it extremely selective cases. So here we do angiography and then go to each selective vessel supplying the tumor. So in this case, those 3 tumors are about a one segmental branch went to there, and like that other branch here, ultimately we give separate each dose, each area. We use single compartment model and we get 200 gray to each area, and you can see post all the tumors are gone, no more tumor. So in conclusion, the activity is not equivalent to dose all the time. Prescribed dose is not necessarily the actual absorbed dose. Predictive dosimetry, personal dosimetry, partition model is better, but if you are super selective, go for single compartment model is fine. If you do Y90 and then you are able to get PET scan after Y90, you can get a very good post-treatment dosimetry, which I have not covered in this case. Any questions?
Thanks. Can we have... I'd like to thank both the speakers for some really wonderful lectures. Can we have Dr. Kim?
Thank you so very much. A quick group photo, please. The speakers were part of the session. I invite you to please join us on the stage. Ladies and gentlemen, we have Professor Pierce Chow who will be joining us online. And those of you who have signed up for the hepatobiliary workshop, a quick reminder, it was at 4:15 in case you've signed up. And it's a gentle reminder, the hepatobiliary workshop at 4:15 at Heritage House. Ladies and gentlemen, can we applaud the wonderful chairpersons and the speakers on the dais? Thank you so very much. Next up, we're going to be looking at TARE and immunotherapy, evolving synergy in HCC management. Joining us via Zoom would be Professor Pierce Chow. And the chairpersons for this session, Dr. Ramkishore Gurjala, Dr. Abhay Kapoor, and Dr. Abhishek Bansal. May I please have you on the dais?
I guess this is going to be an interesting session. We are going to miss Professor Pierce around in the hall, but it's great that we could have him online. So I would request Professor Pierce to start with his talk and enlightening us on whether and when and how we should combine Y90 with immunotherapy. The audio is not there. Professor Pierce, we can't hear you. Are you on mute?
No, I'm not on mute. Can you hear me?
Now we have you.
Okay, thank you very much. Can you see my presentation? Can you see my presentation?
Not yet. It's still not come up. Can we have Professor Pierce's presentation?
Okay. So let me share it. Yeah.
Okay, we have your presentation now.
Okay, that's good. That's good. Yeah. Okay, so I am going to go into presentation mode. Are you able to see that? Can you see my presentation? Are you able to see my presentation?
Yes, we can see your presentation now. You can go ahead.
Thank you so much. Yeah. Good evening, ladies and gentlemen. It's a pleasure to be here at your conference. Unfortunately, I can't be there in person. I'd like to thank the organizers for inviting me to speak. My talk today is on TARE and immunotherapy, and I'll be describing evolving synergy in HCC management. These are my usual disclosures. One of the most important developments recently in Y90 has been the evolution of ablative Y90. Traditionally based on the pioneering work done by Professor Joseph Lau, lately from the Chinese University of Hong Kong, the aim was to deliver a dose of not less than 120 grays to HCC in order to be efficacious. But 30 years ago, when Professor Lau did his pioneering work, there was no opportunity to determine what the optimal dose should be. And what has happened in the last 10 to 15 years in the world of interventional radiology has been the evolution of very fine catheters and IR techniques, so that the concept of super selective transarterial radioembolization is possible. And with this also comes the concept of radiation segmentectomy, which the previous speaker has already spoken on, where much larger doses are given to the tumor and also to the segment. And I'm going to share with you some of the data we have from our hospital that shows that doses at more than 200 grays deliver very good response. And this is data from the tumors done between 2019 and 2024, where you can see in this summary slide that as the dose increases from less than 120 to 120 to 200 to 200 to 300 and to more than 300, the response actually increases dramatically. And overall objective response rate also increases at 9 months compared to 6 months, 78% versus 91%. So we are all convinced that Y90 can regress HCC, but the bigger question is the biology of HCC actually change after Y90? And this is an important question because, as you know, the half-life of Y90 is really short. It's 2.67 days. But we've seen how Y90 can have sustained therapeutic effect. And the minimal adverse events that we see with Y90 and the prolonged response beyond the half-life suggested to us that Y90, on top of its radiation effect, may possibly also initiate an immunological response. And this is a very compelling hypothesis. And we put this hypothesis to the test in a prospective study that was carried out at the National Cancer Center, Singapore, where we collected peripheral blood before and after Y90. And in those patients that were downstage to surgical resection, we had access to the tissues, and we were able to do RNA sequencing and cytoph and compare them to treatment-naive controls. And what we found was very interesting. We found that in the tumors treated with Y90 before surgical resection, in the tissues, we found increased local cytotoxic immune cells. We see increase in natural killer cells, in natural killer T cells, in CD8 positive T cells, and also in CD4 positive T cells that we do not see in the control samples where the T cells were mainly regulatory, as we would expect. And when we did the transcriptomic sequencing of the tissues, in the tissues that were subjected to Y90 before surgical resection, we saw upregulation of multiple activating pro-inflammatory immune genes in these tumors, and this was not seen in the controls. So very clearly, the tumor microenvironment in HCC has been significantly altered with Y90 with very significant immune modulation. And we published this very important observation in the journal Gut in the year 2018. And we were very pleased when 4 years later, Professor Masafero and his group in Milan found in their Italian patients the same response. They found increased frequency of activated T cells, pro-inflammatory monocyte populations, which peaked at 1 month after Y90, just as we found. And Professor Masafero proposed that the timely delivery of checkpoint inhibitors may enhance the immunological anti-tumor response in HCC. One of the most important developments in the treatment of HCC has been the development of checkpoint inhibitors. As you can see in the diagram here, the binding of PD-L1 to PD-1 keeps the T cells from killing the tumor cells, but the blocking of the binding of PD-L1 to PD-1 with the immune checkpoint inhibitor allows the T cells to kill tumor cells again. And this is very important in HCC because HCC has 3 immune phenotypes. In about 30% of HCC, there are no T cells within the tumor. This is called the immune desert phenotype. And here, even if you give the patient checkpoint inhibitor, you will not expect the tumor to respond because there are no T cells. In another 25% of HCC, there are T cells, but these T cells are found in the periphery of the tumor, not within the tumor. And here, if you give checkpoint inhibitors, you will also not expect them to respond. And this is the immune excluded phenotype. It is only in the last 45% of HCC that we see T cells within the tumor itself. And this is the inflamed phenotype. And here, if you give the patient checkpoint inhibitor, you will expect them to respond. And this is very important because if you look at the randomized control trials with checkpoint inhibitors, tumor response has never been more than 40%. But the interesting thing is that if you treat the patients with Y90, Y90 causes an increase in T cells across the entire spectrum of HCC. So currently, there are at least 3 randomized controlled trials that combines Y90 radioembolization and immunotherapy. The first is the one that we are currently conducting from the National Cancer Center, Singapore, where in one arm we deliver Cespir, followed by atezolizumab and bevacizumab, and in the other one, Cespir followed by placebo. The second is a trial conducted by Boston Scientific. This is an industry trial, where in one arm they deliver TheraSphere, and in the other arm they deliver TheraSphere followed by Tremi and Duva and IO-IO combination. And in the third trial, this is an IIT from Hanover Medical School, where in one arm you have Y90 followed by Tremi and Duva, in the other arm TACE followed by Tremi and Duva. And all these trials are currently running, and we expect to see the results out in a couple of years. Let me just calm down on the trial that we are currently running from the National Cancer Singapore. This is a stratum study where we actually enroll patients with larger tumors beyond the up to 7 criteria and include those with vascular invasion, VP1 to 3 and VV1 to 2. So all these patients are treated with Y90, and 4 weeks later they are randomized to receive either atezolizumab and bevacizumab in one arm or placebo in the other arm. And the primary endpoint is the best overall response rate at 12 months. And this trial is currently being conducted in Asia-Pacific countries, in centers from China, from Singapore, from South Korea, as well as from Taiwan. And in summary, improvements in interventional radiology techniques over the last decade or so has led to the concept and practice of ablative Y90. Ablative Y90 with doses higher than the conventional 120 grays is associated with very high best subjective response rate and OS. And we also see how Y90 can cause significant immune modulation in HCC, and the hypothesis that subsequent immunotherapy will enhance response is being tested currently in prospective randomized controlled trials. Thank you very much for your kind attention.
Thank you so much, Professor Pierce. That was a very enlightening talk. We are running short of time, but before we conclude, I have one small question for you. To your knowledge, is the immune response activated only in cases of HCC which are treated by Y90, or when we use Y90 to treat cases like colorectal carcinoma, neuroendocrine tumor, or breast metastasis also?
Yeah, thank you. That's a very important question. And the real answer is that I don't think anybody has the data other than in HCC. But seeing how the radiation has caused immune response, I would expect something similar to occur, but the reality is that we don't have any data in those areas today.
Thank you so much, Professor. I look forward to having you maybe in the next ISVR. Thank you.
Certainly. Thank you.
So moving on to the next talk, is talk 2 present? I think he's not here. He's not here. Trials to Treatment, Bridging Evidence to Experience, Real Life Challenges by Dr. Sanjay Baijal, sir.
The slides are not showing. Thank you. Let me thank ISVR for having me here. And this topic sort of rounds up Y90 and brings us to actually what we've been doing. And basis what is what our practice has been is my job to share with you. And effectively, it just starts with the BCLC update. I don't think I'll spend time on this because Dr. Arun has talked about this very categorically about the new changes that have happened, especially in BCLC-B. But I still feel that there are some shortcomings here, which we will talk to when we come to our own Indian INASL-based recommendations. But it's very interesting to see that the lower half of it has brought us to a more practical, clinical-oriented, and a patient-centric decision-making process, and not a very strict algorithmic approach towards how to stratify patients. Right from understanding what exactly we are going to do to what the patient expects of us, and what the data actually shares with us and what it does not. And all of that together, if it can actually be used to predict what is the most appropriate treatment, I think that's the best way we can really do the treatments. Since I work in a very busy transplant center, so this is most relevant to actually what we do day to day, that most of these patients, if they are candidates to transplant, we understand that if the prognostication is going to be influenced by the underlying liver disease more than that of by the HCC, we push these patients to transplant. And if it's the other way around, you can bridge or you can buy patient time and then move the patient onwards. Whereas on the other side, if the patients are not going to ever go for transplant, they might not be eligible at that time. But the point is that if the liver function is so poor, then is it appropriate to really give best supportive care? May not be. If you can push those patients to transplant again, and if they do not have comorbidities or any other issue which is a negative for transplant, then that's the way they should go, which is the modification in BCLC-D, which we believe. But all of this really started with Y90 being extensively studied now across all tumor burden, and this is the legacy study that we all know. They were predominantly tumors up to 8 centimeters, average was 2.7, but the tremendous results were that the outcomes, if you look at early or advanced, or if you look at patients who got transplanted or who stayed on Y90 as the only therapy, the results were not very different at nearly 3 years follow-up. Most interestingly, it was understood that the target should be to achieve tumor necrosis, and if tumor necrosis is achieved with completeness, then the chances of recurrence are as low as just 2%. But if we fail to do that, then the recurrences come higher. So what Dr. Kalwa mentioned is that we must try to do super selective and we must try to be ablative, because that is what is going to give us this prediction. If you have your dose adequately in, then you can really predict that you're going to achieve complete pathological necrosis, which will therefore actually decide outcomes. And if your dose falls short, and this is for TheraSphere, then you know that you would have recurrence. There were some interesting studies on the use of SIRT and can it actually replace TACE, and there were indications coming as far as 2016, 10 years ago. This data came in which said that if you were to do CTACE or Y90 and look at these patients down on follow-up, the time to tumor progression was more than 26 months on the Y90 arm, where it was just short of 7 months in the TACE arm. And more patients were reaching transplantation then at that time in the Y90 as compared to those in the TACE arm. So there was a message there that was showing. And then in 22, when this randomized trial happened, it was found that Y90 was so overwhelmingly better when it came to time to tumor progression and now also survival, that this study was actually terminated. And the tilt towards Y90 became more realistic and more logical and more scientific. At the same time, there were RCTs that, well, there was just one RCT, but there were a huge volume of patients who had been reported upon, and 2,500 approximately. In all of these, it was still, there was no doubt that time to tumor progression, there is no doubt that Y90 does better than TACE. But these studies went back as early as 2010. So the way we were doing Y90, which again Dr. Kalwa alluded to, from the BSA models now to this kind of a complicated dosimetry, it has changed so much. So I don't think there's too much of a message here in this. But like he said, and like this study, DosiSphere said that if you can actually do a personalized dosimetry, define that you're going to get 200 and odd gray to the lesion, and if you can really go to 300 gray, but ensure that your liver stays safe, and don't just go for a standard 120 gray to that area, would make a difference, and certainly it did. After Dr. Kalwa's talk, it's so logical, but this had to be proven, and this study did it, because in tumors where you got more than 205 gray in, the survival was that much better as compared to if you did not. And similarly, in the same group, if you look at the number of patients who got downstage, definitely the personalized dosimetry was far superior. And in patients with portal vein thrombosis, nobody got downstage if you were to just do a standard Y90. So one has to be doing Y90 with the appropriate dosimetry there. And this 6,000 patients were analyzed in the UNOS database, and this was very interesting. So they looked at what were the treatments done in patients and which of those treatments can we associate to get complete pathological necrosis. So they found that as a treatment methodology for patients prior going to transplant, TACE had been used 70% of the time. But the best part of it is that only in 18% of TACE patients they got CPN. So we were probably going the wrong path all this time. We were using TACE more and more often, and it was obviously the weakest treatment of them all. And it was Y90 which was giving us the best results, and this is Y90 being done in all kinds of dosimetry, not the most logical and the most now best methods of doing dosimetry. This is the data that we had from our hospital, where we looked at a lot of our patients who had large tumors up to VP3 portal vein tumor thrombus. We have a protocol of giving heavy dose of Y90.
Last 2 minutes.
Can I take a few minutes extra?
Definitely, sir.
Oh, thanks. We give SBRT to the portal vein tumor thrombus. The main tumor and the PVT gets the Y90. And then these patients are evaluated for downstaging. And if they are downstage, we found that the patients who have been downstaged at 5 years, we have patients with VP3, about half of them are there with us. And now 7-year data is also available. I can skip that. There's some interesting data which has talked about Y90 being better than lenvatinib. And they've talked about the overall survival and progression-free survival, again, better being with Y90 as compared to TKIs. Yep. And then came the doorway study, just got recent. It hasn't been officially published yet, but it has been presented. And they talked about a prospective study in which they used partition dosimetry, which we heard about in the previous presentation. And they looked at tumors which were up to 8 or 10 centimeters in size. And the sum of multiple tumors was less than 12 centimeters. They were all relatively well-preserved patients. And we found that the overall response rate was 98%. You just heard Professor P.S. Chow say that the best results with immunotherapy are 40%. And with Y90 as a targeted treatment, we get ORR of 98%, with complete response 92%, and 100% of local tumor control rates. You planned the dose 150 to 400 gray. The dose that was actually delivered was 513 gray, which is again exactly now conforming to what Sanjeeva really told us about. This was our experience at our hospital. Anurag did this presentation and he was awarded for that at CERSE. We do exactly what Sanjeeva was saying, angiosomal dosimetry. Every arterial territory is mapped, and we looked at the dose going to the normal liver and to the tumor of that area. And we looked at our 50 patients. We found that we had 50 tumors. They were large tumors. They were BCLC-C in half of them, and some of them had, a large number in fact, 44% of them had portal vein tumor thrombus. And we found that we were getting an overall response rate of also about 90%, even in this advanced stage of HCC. And we realized that if we had a tumor absorbed dose of 208 gray, with at least 50% of the tumor volume getting 193 gray, and more than 60% of the tumor got 150 gray, we had good results. We also then had a method to calculate the number of particles that we were able to deliver in the tumor and whether the particle loading had an impact. And we found that in our dose, we had 68,000 particles per ml. And that was therefore, I think, giving us a good outcome even at 208 gray. And therefore, the NASL modification, I think, for India makes sense. We've got a very heavy life-related transplant program happening in our country, so therefore we must aggressively try to treat the patients in the B2, B3, and even in the C1 stage. C1 and C2 are distinctly different, and we must understand that. And even patients who are in D1 and can go to transplant should go to transplant. In our hospital, we were also able to break up and identify patients who are at low risk, moderate risk, and high risk for having recurrence if an upfront transplant was done. If alpha-fetoprotein, UCSF, and FDG18 PET avidity was there, they were found to be very high risk for recurrence. All of them definitely require a Y90 before they go to transplant. Just to show you a couple of cases, this was one patient with two tumors, one big one. That's how the Y90 sat. That's the chart of the dosimetry that exactly Sanjeeva was talking about. And then that's the result at the bottom. So the important thing is that you've got to protect liver parenchyma, protect the lungs. What Professor Kim showed us, he showed us about the findings that would give you a high lung shunt. But then what do you do about those patients? And this is one of those patients in whom you've got a large volume of tumor. These are tumors scattered all over, but in the effort to do it, either you've got to be ultra selective, and if you see these 3-4 corkscrew vessels going down, those were the vessels that were supplying each tumor. So either we selectively go into each of those terribly hard to catheterize vessels, or what we did is a distal protection by using just gel foam. I think when Embocept comes here, that will going to be a very helpful tool for us. So we did a distal protection at the time of therapy and then did a relatively proximal dosing. In another patient, we used an occlusal balloon again for the same purpose. We did an occlusal balloon in segment 7. We did an occlusal balloon in segment 2 for this patient because we wanted to protect liver. And you can see we've painted out segment 7 and segment 2 that even though with a central injection, those areas have been protected. And we'll finish with this one very unfortunate person who had this massive recurrence after a transplant, huge tumors in the liver. We did the angiogram, we did the MA. The lung shunt fraction was 20%, and there was virtually no differentiation of liver and tumor. And we thought that this patient we won't be able to do. We thought we'll give him a chance. He's been through a transplant. So we did a balloon dilatation of the IVC at the hepatic vein ostium, and we repeated the MAA, and suddenly we had a very good TN ratio. So we decided to take this patient up. We did the Y90. That's the way the Y90 sat. We had the dosimetry allowed for us. The second time round, we decided to actually balloon occlude the hepatic veins and not just a caval occlusion. And we were able to achieve a dose delivery. Thank you very much.
Thank you so much, sir, for the wonderful talk. In spite of the shortage of time, I guess everyone in the auditorium knows Dr. Bajal knows more about TEAR than anyone else probably in the country. And so I don't want to miss out on the opportunity. So the message which Dr. Kalwa gave was that if you choose the day of therapy adequately, then there is no difference between glass beads or the resin beads. Is it actually true, sir? Can you achieve that many number of particles for treating large tumors with both the beads?
So I think the concept is that they come close. They come close, but at the end of it, you're going to start to use very late second week dose, and we're going to land up with, say, maybe 5-day pre-cal for the resin to really try to get them matching. But still, there would be a difference. It's not that they would be bang on, but that's the place where there is some overlap that is seen. That's about it. But very often than not, if you have very small tumors, you may not want to use second week dose in Y90. And like Prof. Kim said, that for the very small tumors, they just infuse to stasis, and they don't even do a lung shunt. And I think it's basically just volume calculation and just filling up the entire tumor with the beads, with resin.
Thank you, sir. I guess with the 2 sessions on Y90, only one thing is there which has not been discussed, that is Scout Y90. Well, a lot of centers in our country do not have a SPECT CT, and they feel that we cannot do Y90. But well, from the time Scout 90 has come, maybe I have already done about 15 cases with Scout Y90, and it is very much doable. The only problem is that if I want to do glass beads for a Scout Y90, that's difficult because, say, maybe I'll have to give 2 doses for the calculation. And then again, if I decide to further break the therapy into 4, then I need at least 6 or 8 vials, which becomes exorbitantly expensive. Maybe the companies will start thinking on that end, and there will be a day when we will be able to use glass beads even for Scout Y90.
Sanjay sir, just one question. In your the group of patients, what is the role for immunotherapy? Were they on immunotherapy before or during or after?
In the downstaging group?
In your downstaging,
yeah.
the data, your personal data from the Vedanta group.
Right. So the data, those 50 patients, nobody was on immunotherapy. they just went to TKIs after our therapy.
Thank you, sir.
Now in our, I think they've got now, 7 patients that they've transplanted with the use of immunotherapy in addition to locoregional or sometimes just SBRT alone. There has been a washout period given to those patients for 8 weeks, stopping the immuno and then transplanting, because that was the major concern. But the last one, I think 2 patients, they've actually transplanted even at 4 weeks, and they haven't had any issues with the grafted liver.
Because the new immuno plus Y90 studies are coming. I think the results are, maybe next year. And it's definitely showing some positive, like the outcome wise. So we should.
Right. Yeah, yeah.
Thank you.
Thank you so very much. Yet another masterclass at ISVIR 2026, ladies and gentlemen. I urge you to raise your hands in appreciation and applaud our wonderful chair people and our speakers, truly in the spirit of ISVIR 2026 to innovate, collaborate and innovate. Next up, we're going to shine the spotlight on LRT for liver tumors. Our moderator for the session will be Dr. Brijesh Ray. Our panelist, Dr. Dhruv Patel, Dr. M.C. Uttappa, Dr. Aniruddha Kulkarni, Dr. Vasant Kumar, Dr. Sumati, Dr. Vaibhav Patil, and Dr. Balasundaram V. May I invite all of you to join us on the dais along with the moderator for this session. I invite the moderator and panelists for this discussion onto the dais.
Yeah. Good evening all. Welcome to the panel discussion on locoregional therapies in HCC. As we all know, hepatocellular carcinoma is one disease where no 2 patients are alike. You can argue with me that no cancers, all cancers are like that, but the diversity involved in the management of HCC is unique compared with the other cancers, because no other cancer have this number of diverse management options. So when you're dealing with the treatment options in HCC, there are so many factors which influence it. The tumor burden, the liver reserve volume, the performance status of the patient, the vascular invasion, the availability of transplant in your center, or the technical expertise available in your center. So there are so many factors that influence the management of HCC. As we all know, there are so many guidelines, including the BCLC, which is a globally accepted guideline. But even though these guidelines give us a framework, in the real world scenario, we often go out of this algorithm. We often are forced to go out of this algorithm. As IAs, we almost always end up in gray zone when it comes to HCC management, especially when to push for locoregional therapy or when to switch therapies, whether to go for a combined therapy or to other therapy, or when to stop the therapy and start going forward for another therapy. So basically, we want to highlight this lack of uniformity in the management of HCC. That is what we are going to discuss in this panel discussion. So this lack of uniformity, I'm not saying that it is not reasonable or it is not good or it is not wrong, but this lack of reasonability, whether we can identify areas where we can reasonably agree upon and can identify areas where individualized treatment options can be accepted. So this panel discussion is not about finding fault with anyone or whether to find whether who is right or who is doing right or who is doing wrong. So basically we want to come to
consensus, whether we are able to come to a common ground. That is what this panel discussion all about. So why is there no uniform strategy and should there be one? That is the main agenda of this panel. So before going into the panel, I should introduce the panel teammates. From the IR team, we have got Dr. MC Uthappa, Dr. Dhruv Patel, and Dr. Andrit Kulkarni. And from other specialties, Dr. Vaibhav Patel, he is a hepatologist. Dr. Vasanta Kumar, he is an HPV surgeon. Dr. Sumati Sundaraya, she is a nuclear physician. And Dr. Bal Sundaram, who is a radiation oncologist. So we have got the whole spectrum here. So the objectives, as I said, it's a variability in the local regional treatment strategies for HCC, understand why uniformity is difficult to achieve, identify the common decision-making principles, and whether we can arrive at a pragmatic consensus for IR practice. So this is the reality. One disease, multiple guidelines, many practices. BCLC, ASLD, EASL, APASL, INASL, so many guidelines are there. But still, treatment differs across centers and operators, especially true for intermediate and advanced HCC. So Dr. Vaibhav, what could be the reason for this extreme variability?
Hello. Good evening, everybody. So if you look at all the guidelines and the evolution of the guidelines, mainly West follows the Barcelona classification, which mainly is conservative in terms of approach based upon mainly the size of the tumor. If you look at the Asian guidelines, APASL or JSH guidelines, Japanese guidelines, they are more liberal in terms of their criteria rather than size. They're more worried about the vascularity. They're focusing on vascularity of the lesions. And they are little liberal, more aggressive in terms of approach. And their main objective, more resectability. So the answer lies in two things. One is disease related. The demographic features of the HCC biology that determine this type of variation. One is on the west side, the NASH and related diseases were very common, and that's why they had a bit liberty to wait on that. While on the eastern side, mainly the guidelines were formed when the predominant etiology for the HCC was hepatitis B and C. So that's one of the main reasons. The biological behavior of this HCC also differs demographically in different parts of the world. If you see on the South Asian side, especially on the Bangladesh and Myanmar side, the nature of the tumor is quite aggressive. So there is a variation in behavior of the tumor as well. Response to the tumor, to your therapy also varies. The second aspect which caused this variability is the health-related options, the availability of the organs. So in the West, there was quite good availability of the cadaveric organs, and that's why they could have a liberty to go for the conservative approaches, forming a criteria like Milan or UCSF. So they can afford to do that, but when on our part of the world or on the Asian side, when there is a significant scarcity of the organs, we need to be dependent on local regional therapy and other approaches. That's one reason. Second, the availability of the local expertise, the local regional therapies, new advent of immunotherapy that has also shaped the variations in the classification. And also how much clinicians are adherent to the guidelines, that's also matter. Many times you deviate from the main guidelines based upon your personal experiences. So all these factors collectively are responsible for variation in the approach.
So basically biology and the lack of organ or expertise in our country. Understood. So where does this uniformity break down? So this is a 1.8 centimeter lesion in segment 8, child A. So when you are considering BCLC, it comes under very early stage disease. So you have got both the options of resection and ablation. So RF microwave versus resection. Dr. Uthappa, sir, what do you think about this lesion?
Resection, I think, Dr. Vasantwala, you want me to answer for resection?
No, for ablation.
See, if you want just a one-line answer, then we will say that ablation is a very good option. Obviously, there's a lot of data to back it up. We already alluded to the operator experience, what is available in the thing. So if we are aiming to get cure for the single lesion, assuming all other parameters and we have looked at and the child A, you want to aim to get a complete cure. And that really focuses on the size and the location. So with ablation, I think there are two parameters that's extremely important, apart from other parameters. So I would say for a 2-centimeter lesion, if assuming the experience of the operator and the availability of the facility, then a radiofrequency ablation could be a very good option.
Okay.
However, if you say that can it be done with a microwave, then the answer is yes, it will achieve probably the same result in terms of outcome. I probably don't want to bring it as a debate because our aim is to get to consensus. So I'll let Dr. Vasant answer for the resection part.
Will you resect this case?
Good evening, everybody. So, extending to the discussion by Dr. Uthappa, the debate is still open. Nothing is superior over the other mode, either RFA, microwave ablation, or resection. Any tumor, according to all three guidelines, the American Society, the APACEL, ESLO, ESMO, all guidelines say that any tumor less than 2 centimeter, both surgery and ablation can be considered. And if you consider the multiple randomized control studies, we don't have good quality randomized control studies. We have multiple cohort studies, long-term follow-up studies which say surgery in lesions less than 2 centimeter, which can give a good overall survival of 5 years and 10 years compared to the ablation. And where ablation is better in terms of less post-operative morbidity, which is quoted in surgery. There is high mortality in surgery, morbidity in surgery. But with the era of minimally invasive, I don't think there is a lot of complications, post-operative complications after surgery. So the debate is still open for surgery.
Understood. Yes, sir.
Dr. Uthappa, this is like really a cakewalk for any of us. Okay, now same size tumor. If you had at the tip of the left lobe, just next to the stomach, would you still be very aggressive? No, that I am going to do ablation only come what may, or you may involve a surgeon and just ask him to do a laparoscopically, just do a segmentectomy. Because the aim is not whether me or him is treating. The aim is to have a long-term cure for this patient. So, that is the location of the tumor would make, in a way that whether there is chaos in HCC, yes, there is chaos to some extent, but in our minds, at least I am very sure that there is no chaos in HCC. This can be actually discussed. So what would you do, sir?
So, see, I think, if you're going to take a tip lesion which is hanging off, and then you're saying, can I still ablate it? Oh, technically, probably yes. But then other parameters will again come into what is the overall goal for that particular patient? For example, you can bring so many ifs and buts. For example, is he fit for a general anesthesia?
Considering everything is
considering
same.
Everything else.
So, if you have a lesion at the tip, I would go for radioembolization. Considering that cost is not an issue, I would go for radioembolization and just ablate him.
Even for 2 centimeters.
Transarterial, why not? Why not?
Okay.
Yeah, so I think, again, if you put a lesion in this particular liver, if you put a lesion in different parts, then you will have multiple different options. Okay. So I think sticking to what the aim for the discussion is,
so
like we discussed already, I think there's no good trial, but I think operator specific, center specific, what the local MDT decides, what the patient's expectations are. And if you have a lesion like this, like you said, it's not about cakewalk. I think it is, you're going to get 100% reproducible ablative result with a very good tumor control. But so would be the surgical outcome in a center which has got the experience. So I'd probably be happy to move on.
Okay, so what we did was we did a microwave ablation for this case. So this is second case. It's a BCLC intermediate stage tumor, a 4.8 centimeter exophytic segment 6 lesion in a child A patient. So Kulkarni sir, how will you deal with this case?
Definitely ablation is out here. Okay, we are looking at transarterial therapies. Okay. In my hospital, this would go for MDT. If rest of the liver is normal, the biochemistry is normal, my surgeon is happy to resect it, and I am also happy to let it go for resection. Why? My personal thing about this is that if I do a transarterial procedure, the patient is on follow-up every 2 months. With surgery, the the surveillance is less intensive, that's what I feel. But very often, this patient will come to us. One of the things that I would want to look at in such a patient is where you are, approaching 5 centimeter, you can see some vessels hanging there in space, is whether there is a role for doing any biopsy in these patients and to identify if this is a high risk histology like the massive macrotrabecular type. In that situation, I would be very aggressive in treating this patient with a high dose radioembolization and attempt to completely ablate it and get a cure on this patient. That would be my approach in this patient.
Dr. Dhruv, do you think that there is a role for combination therapies like TACE with ablation in this particular case, or ablation alone?
Sorry, I totally agree that we wouldn't think of ablation in Australia where I work. We wouldn't think of ablation as the first option here, purely because of the size. And the first option we would think would be surgery, if possible, surgical resection. That would be pretty. That would give us a curative result and less follow-up, as Dr. Kulkarni said. In terms of combination therapy, we use combination therapy at times with TACE and ablation. More commonly when we are worried about seeing that lesion. So if you're talking about a very small lesion and it's not visible on an ultrasound, not visible on a non-contrast CT, and you want to do an ablation, to use either ultrasound or CT as an imaging modality for the ablation, we do TACE that allows us to make it a bit more visible and then go for ablation. Occasionally we go, for example, if the lesion is very close to the diaphragm and we are worried that the microwave ablation, we will be a bit more cautious and we will under-ablate. Then we do TACE before, sometimes after, to just take care of the margin and then ablate the rest of the lesion without...
You do it in the same sitting, right?
Depending on other patients, because we have a very vast geography. Patients travel from 9 hours, 10 hours, and they have to drive. Sometimes they don't have any other modes of transport. So in those cases, we would try to just finish it off in single setting.
Okay, thank you. So what we did was we did a TACE plus ablation in this particular case. So this is the third case. So this was a segment 8 lesion, HCC with a segmental tumor vein thrombus. So comes under BCLC advanced stage, BCLC stage C, where systemic therapy is being concerned. Even from the INASL modified criteria, it is for systemic therapy. So now, Dr. Sumati, ma'am, do you think that TARE has got a role in this? Will you go directly for TARE?
Yeah, since the tumor is confined to 2 segments, maybe 1 segment, and there is a segmental portal vein thrombosis, tumor thrombosis, we would definitely think about TARE, which would be more of an ablative dose. So we have to use a personalized dosimetric based approach and try to look at the arterial feeders to the lesion and try to work out a dose that would be an ablative dose. And definitely it is a lesion which is amenable to radiation segmentectomy.
Okay. And Dr. Balasundaram, so what do you think, sir? Is there a role for SBRT alone or combined with the TACE?
Yeah, good evening. So HCCs are always very radiosensitive tumors. So with the EBRT also. So generally, if you take EBRT, normally in radiation for non-radiation oncology forum, we are giving radiation 2 gray per session on every day. But in ablative dose per session, we are trying to give say 8 gray or 9 gray per session. So 50 gray in 25 sessions, like in conventional radiation, is not equivalent to 50 gray in 5 sessions, that is radioablative dose. So biologically equivalent dose, as Dr. Sanjeeva told some time back. So the BED dose is very important to have the best tumoricidal effect. So if we are able to give higher dose per session, as in radioablation, as in SBRT, now we are not calling that as SBRT, we may call it as SABR, stereotactic ablative radiotherapy. So the dose is very important. Number 2, size is very important. So even like your cases, for giving external beam radiation, the size is very important. If the size is smaller, we can give higher dose of radiation per session. That is a better tumoricidal dose. And as in this case, here the tumor is bigger size. If the remaining liver, normal liver, apart from the GTV, if the dose constraints allow for us to give better radiation dose, definitely we can think of giving SBRT. But here, I feel that since there is a PVT, some macrovascular invasion, I feel that TACE or TARE to be given prior to SBRT. We have to wait for the response to happen maybe for some weeks, 4 to 8 weeks. Then if there is any residual disease, probably we can think of giving SBRT also.
Understood.
Can I add something?
Yeah, yes.
Sir, I am a big fan of radiation, but I always want that radiation to be given through the artery. Through the artery, with the yttrium 90 beads. So I totally agree with that, HCC is radio sensitive, everything, but I like it to be given through the artery because it is given in one session. It is very high dose. The only thing probably is that we are not fractionating it like you are. But here we are looking at the patient coming in the hospital, walking in the hospital and walking home with a completely ablative dose to the tumor, to the portal vein tumor thrombus, and with its all its beneficial effects. That's why radiation, obviously, but through the artery. That is what the IR philosophy nowadays is.
Yeah.
Uttapa sir, one word answer. What will you do for this case?
I think,
Uttapa sir.
Maybe a few years back, we would probably, again, MDT setting, we would be very comfortable in doing a, personalized high-dose treatment for this tumor, because that kind of portal vein we have seen consistently very good response. Again, very reproducible in most centers. We'd offer a TARE first. But again, what is the goal for this particular patient? What did the MD decide in terms of what are the other parameters we need to see in terms of his other profile, fitness, what is the long-term outcome? So today, largely now a lot of centers are doing is we will give them immunotherapy, 3 months wait. We do a TARE, immunotherapy, and then probably bridge to transplant. More and more data is emerging towards that. Again, how the tumor response in the portal vein is something we have to assess. Today we do a further imaging to see, at the moment we're only treating this particular image which we've seen. We've got to quantify other parameters also. So again, we'll have to go into more details before we can just recommend one particular treatment. But I think TARE for this particular, what we are just seeing, will work very beautifully because I think most centers in India will get consistently very good result here. Yeah.
So there was a subtle smile on your face when you said that, when you were outlining this treatment that, do this, give atezolizumab first, and then do this, and then come for TARE. So was it a smile of approval or disapproval?
No, why I'm saying it, because the treatments in HCC has been evolving, right from a junior to where we are now. In over 3 decades, I have seen, we've been discussing in so many panel discussions. Why I'm smiling is that, irrespective of what we all may say, we still will have to customize the treatment to particular individual, taking all other parameters.
But
obviously adding on to evidence.
Sorry to disturb you, we are running out of time. Sorry.
I think.
So this is what we did. We did SBRT followed by a DEP TACE, and patient had a good response. Even after 6 months CT, there was no other recurrence or anything, and he underwent DDLT. So this was a CT which was done almost 8 years back, 8 years later. So now coming to the guidelines versus real world, as we all know, these are the scenarios, less than 3 centimeter. As per the guideline recommendation, we have to go for RF, but we do everything in the real world practice. RF, microwave, SBRT, surgery. Same with multinodular HCC TACE, we do TARE, combination therapies. And when it comes to segmental PVTT, the guidelines recommend systemic therapy, but in the real world practice, we do TACE, TARE, SBRT, and the combo therapies, and immunotherapies. So, as I already said, guidelines provide a framework, but not a fixed protocol. Dr. Dhruv, what could be the reason for this gross disparity?
Where do I start? Let's not beat around the bush, but the fact is it all depends on the resources. Resources you have at your center and the MDT, availability of the MDT, resources that you have. Your resources could be very well different than my resources, than Sir's resources or their resources. And the patient population is also quite different everywhere we go. So that that doesn't allow us to choose what is written on the guidelines, and that's why, as Dr. Gupta showed that earlier today, that 75% of the patients don't really fall exactly as the guidelines have shown. Again, guidelines are all, with all due respect, I really appreciate the hard work that is put in for making all these guidelines. They are guidelines, and it makes our life a lot easier, but it's not applicable to every single patient. If you actually look at the BCLC flowchart, you will, everybody in the room would agree that it doesn't encapsulate each and every single scenario that we see. In fact, more than half of the scenarios are not encapsulated in the guidelines. Okay. So we have to deviate every now and then to find the best solution that we can offer. Absolutely. The other thing is the expertise, as Dr. Weber said, expertise, and also the ability to actually use the devices or the modalities that you have. For example, I've never used RFA. If somebody gives me RFA, my results are not going to be as great as microwave.
Okay. Last 2 minutes.
So, ablation. Coming to the ablation, it's not a single method. So, same tumor, different ablation choices. So, the ablation strategies varies based on tumor size and location, proximity to the hilum or vessels, RF versus microwave versus cryo or IRE, and the operator experience. So, Uttapa sir, why do we still see different ablation choices across centers despite similar guidelines? Is this the variability evidence-driven or experience-driven or logistic-driven?
I think we partly covered it, Dr. Brajesh, pretty much encompassing all of that. So I think any minimally invasive technology, one is you're going to get, there is a learning curve, and then there is, like we already said, availability. So I think you've covered probably all the points. So for example, if a center, in a private sector, for example, just practical point I'm saying, let's say if your hospital has already bought a microwave machine and you have a 2-centimeter lesion and you say that, I can actually use a RF to do this, then, then obviously, you're still going to use the microwave, right? So like we say, there's so many ways to skin the cat, right? But what is available does make an impact, particularly in the ecosystem that we are all working. So I think we just have to acknowledge that and make sure that whatever ablative tool that we're using, we should make sure that it's best for that particular patient. And one example I can share is, for example, I remember we've done a case from them back where we, that time only had microwave, and we tried to do a microwave, but there was some, close to a bile duct, a small residual tumor. Then we actually, at that time, cryoablation was only available at PGI, and that time we sent it to. So it's about, making sense for that particular patient.
Understood.
So yeah, learning curve of the operator and the availability.
And tumor characteristics that you have already told, right? That make you choose your mode of ablation. That's okay, sir. I think this is the last program in the agenda, so I think they will excuse us for 10 more minutes. Is that okay?
I like your discretionary power. You should be a moderator all the time.
Is that okay? 10 more minutes? 5 minutes, okay. So, location-specific dilemmas. So, how do you deal with it? Is it based on evidence or personal comfort?
So now for location, I think, first of all, we should not do any harm to that particular patient, right? So you have to really respect the location and apply your, for example, what the source is available and how you can get the best sort of, if you're doing an ablative therapy, it's got to be as good as surgery. There's no ifs and buts. If you're not able to achieve that, then you've got to think of an alternative. And now with ablative tear, it opens up another. In fact, we have not added that. So we can actually add tear to an ablation today. And we have, personally, I have had experience with that, where the patient has said, I want an ablative option, which I can just do pure under local anesthesia, the daycare procedure. Understood. So you can do a tear purely under local. And I've had discussions in the US, for example, one of the very pioneers of tear, who they tried to recruit for a randomized trial between ablation versus tear. And patients were not agreeing to go to that arm because you can do it under local anesthesia. Understood. Whereas in ablation, largely most centers do it under general anesthesia. So I think the jury is still out on that as well.
Okay. Dr. Dhruv, in a perivascular HCC, do you believe microwave truly overcomes the heat sink better than RF, or is it more theoretic?
I think microwave does great because I've only done microwave. So before I started training, all the hospitals where I worked at, they've never done RFA. So I would be keen to know what do you think, Dr. Kulkarni and Dr. Uthappa, whether there is any difference. Like obviously we all have read the literature, but experience doesn't beat.
Okay. So between RF and microwave in the liver, I think clearly microwave is better. And we all people, most of you probably use, it's a faster therapy. You don't want to have grounding pads. Pacemaker is not an issue. Predictable burn, more roundish than what we get in RF. Very good local tumor, recurrence prevalent. So it's a time tested. So I think for liver, particularly, personally, I do choose that. I don't have a lot of experience in liver cryoablation, though we have done some cases. IRE, I don't have experience. I think, we'll have to wait. I think the centers from India who are doing more, they're publishing more results. So hopefully we'll get to see. Again, it will be site specific, right?
So you take on cryo, Dhruv?
Yes, we do cryo for liver as well. And we choose cryo when we are looking at some larger lesion when there's no other options. For example, a lesion is close to bowel or in stomach and SBRT is not an option, then we would choose cryo as a fallback position. And central lesions, we have done a few and we noticed that peripheral lesions, so lesion that is close to capsule, close to bowel or stomach, cryo works fine. We have good results, especially also gallbladder without any causing cholecystitis. For the central lesions, we noticed that we come across biliary obstruction as a stricture later on very commonly with cryo.
So, as we already learned, why is there no uniformity? Because HCC is not uniform, as we all know. Tumor biology varies, liver function is dynamic, patient reserve differs, technology and expertise vary, and evidence is rapidly evolving. Guidelines have limitations because it's basically stage-based, not biology-based, do not account for the operator skill, and they lag behind emerging combination skills. So guidelines is never equal to ground reality. So I'll just go through the last case. So this was a 58-year-old male incidentally detected CLD with a liver soil in segment 8-5 and left lobe of liver in an ultrasound abdomen. Came with weight loss and fatigue. AFP was 8, PIPCA was 54. So you can see a 4.8 centimeter lesion in segment 8-5, which is showing washout, and there were 2 washing out lesions in segment 3. So Dr. Vaibhav, how will you proceed with this case? Will you consider another mode of imaging? Will you consider biopsy?
Biopsy is not required. We can go ahead with the triphasic CT or maybe MRI with MR diffusion restriction. And personally, I will go for TACE.
Okay.
Imaging?
Any imaging? Any other imaging you do?
No, that's adequate.
And
in terms of use of the biomarkers, generally we prefer AFP, DCP, and sometimes cell-free DNA.
Okay. So, with the increasing use of systemic therapies and immunotherapy in HCC, do you foresee a larger role for biopsy? No.
Not really.
Not really.
The molecular profiling we are not yet doing, but yes, cell-free DNAs we are doing nowadays for the monitoring and then further prognostication of the tumor.
Okay. And Dr. Vasant, how does the presence or absence of cirrhosis influence your thresholds for resection, extent of hepatectomy, and perioperative risk assessment in HCC patients?
We generally see the child's puke score. Apart from that, the ALBI score has been come up in a big way right now, where they use it to prognosticate the patients whether they go for resection or not. So generally, we go with any cirrhotic patients. We see the child puke score. Based on that, we reassess the tumor location, the size of the tumor, and based on which we decide, we take up the patient for MDT, and then we decide what is the further management.
Understood. And will you consider upfront transplant for this patient or bridging LRT?
So our unit protocol is we take UCSF criteria as the criteria for transplant. Since this patient comes within UCSF criteria, we could have gone ahead directly with a transplant, but since bridging therapy is better to give it in, because the lesion, one of the lesion is around 5 centimeter, which is very close to the vessel. So I would consider a local regional therapy before taking up this patient.
Time is up.
And Dr. Dhruv, will you consider upfront transplant for this patient or bridge, sorry, do you think MDT is a must in this particular case?
I think MDT is must in any case. That's what we do for all HCC. We do MDT, and a consensus is made to identify what is the best modality that we can offer. Not as in what is the best, but what is the best here in this situation, what we are dealing with. I think this patient would be referred to transplant team at where we work, and if they approve, then they will go for straight away. But bridging therapy is always on the table. So probably I think we would go for both transplant plus bridging.
And Kulkarni sir, what will be a preferred LRT here?
Bilobar disease, maybe satellite nodules. I think TACE would be a good treatment in this patient.
Sorry?
TACE.
And sir, SBRT an option?
Yeah, this is a bilobar disease. So the volume must be very important. So the GTV volume and a remaining lung, that is called liver minus GTV. That is very, very important. If we are able to achieve the liver constraints and all other adjacent structures constraints, probably we can think of giving SBRT, but upfront for this patient, TACE is better. After TACE, we can review the patient after some time. If there is any residual disease, probably we can think of following that with SBRT. So upfront doing SBRT for this type of bilobar disease is very difficult regarding the achievement of the liver radiation dose constraints. So they may end up with the RILD. That is a problem.
Understood. So what we did was, we did TACE, So we did TACE and ablation for the larger lesion and ablation of all other lesions. And we were able to achieve a LRTR non-viable result after 3 months scan. So I'm skipping this case because of the lack of time, sorry. So what are we really debating? It's not about which modality is best. It's all about how do we choose the right modality. So, Dr. Dhruv, do you really think a consensus is possible?
That's $1 million question. I think consensus is possible, but we will always have to be, pretty much as we said earlier, that we always have to be prepared to deviate every now and then. And consensus cannot be global. It has to be local. So local as in for the institute where we work and depending on the resources that we have. And yeah, we'll have to deviate every now and then.
So shifting the goal from uniform treatment to uniform decision making, consensus should be on principles, not procedures. And these are the consensus principles: curative intent whenever feasible, preserve liver function above all, least invasive option to be selected, and it should be the most effective option, stepwise escalation of the therapy, and MDT is mandatory. So the key IR-centric question is, can this tumor be ablated or treated safely? Will this therapy compromise the liver reserve? Is selective therapy possible, and is combination therapy justified? So a quick thought on this, Uttapa sir.
Looks like we are a lovely set of panelists. We've come to a beautiful consensus, so I would probably not want to disturb this chemistry and go with your final words. Thank you, Brijesh.
Okay, sir. So practical consensus statement, uniform loco-regional therapy for HCC is neither feasible nor desirable. However, a uniform decision framework is essential. So the take-home message is, heterogeneity in HCC treatment is unavoidable. The guidelines guide but do not dictate, and operator expertise matters, and FDT discussion is a real standard of care, and individualized IR-driven strategies improve the outcomes. So this is the final question to the panel and to the audience. If you were the patient, would you prefer strict guideline adherence or an individualized expertise-based treatment plan? Anirudh sir?
If we would have stuck to guidelines, radioembolization wouldn't have reached where it has reached, because it was out of guidelines right when it started. And if you have such wonderful body of work in radioembolization sphere, that we would have completely missed out on that modality if we would have stuck to guidelines. So I would not stick to guidelines, definitely.
Thank you very much. Thank you very much.
There's a certain joy in seeing so much passion on the stage. May I invite the wonderful panelists and the moderator to quickly come together for a group picture. Next up, ladies and gentlemen, Dr. Amar Mukund will lead the session on balloon taste, redefining HCC management. Our president-elect will be up next on stage. Ladies and gentlemen, applaud our wonderful panel and moderator. And please join me in welcoming Dr. Amar Mukund onto the dais.
So, good evening all. So after indeed a great panel discussion where we touched almost everything, but unfortunately we missed out on touching balloon taste, though there was a slide where I could see just mention of balloon occluded taste. But like we were talking about tear and ablative tear, we should give some importance and some hearing to this new evolving therapy, that is balloon occluded taste. And we should understand where does it fits in, like the last question, whether we should go by the guideline or not. So again, balloon taste is another new therapy, not exactly taste. We should consider it as a new therapy rather than a taste, how it works. And I'll try to make the difference clear, how balloon taste is different than a conventional or a depth taste, and it is not exactly what is taste. So let us see. So just to understand, from where did this come? This come from a balloon catheter. And what is balloon catheter? It is just like a balloon catheter what we use, but it is a micro balloon catheter which were initially designed to prevent the reflux of embolics to non-target vessels. So very simple agenda, nothing much to do. You don't want any embolization in a non-target area, and that is how the evolution of this balloon catheters happened. But over a period of time, we understood that this not only prevents the reflux of the disease, but it also leads to redistribution of flow. So this redistribution is important, and that is what we need to understand, how it helps. So this redistribution of flow allows a better response in less hypervascular. And what is less hypervascular or a hypovascular lesion? That is very important to understand, ladies and gentlemen, because we have been debating, we have been seeing different kind of cases. Many times we see that taste is not working, taste refractoriness, or probably tear coming up. Why tear coming up? Because you have a microparticle which is probably getting into that area, and you are unable to send these chemoemulsion or beads which is slightly larger in size. So is there any way how you can put it through the balloon catheters? So yes, this redistribution is trying to help us in this particular way. So if you see the mechanism, then the occlusion of hepatic artery leads to decrease in the arterial pressure. Every organ is having some kind of pressure because of the arterial pressure, that is 120/80, and that is how everything has a pressure. As soon as you occlude it, there is a dip in the pressure in those arteries. And this causes increased portal perfusion simultaneously, because the arterial and portal buffer needs to be understood accordingly. As soon as you do a TIPS, there is increase in arterial flow. Similarly, as you occlude the artery, there is increase in the portal venous flow. And thus, if you try to put more of an agent into the artery, probably may not happen. In contrary, since HCC is a predominant arterialized lesion, so there are no portal hypervascularity which is going to happen. Thus, the vascular resistance being lower, still it will redirect the flow towards the tumor. So as soon as you occlude it with a microballoon catheter, the direction of the emulsion will be predominantly towards the tumor, and anything which goes towards the normal tumor will redirect itself and come towards the lesion. And this leads to increased lipidol accumulation into the tumor. So just understanding the hardware, what we have available as of now. So this is the hardware. This is a catheter named Occlusafe, which has a balloon tip which can inflate up to 4 millimeter. It is a compliant balloon. The length of the balloon is 10 millimeter. The length available is from 130 and second length is 150. So depending on the size of catheter you use, you can use either of them. And the caliber of the catheter is 2.7 French. If you ask how much to inflate, then you can use 0.1 to 0.2 ml to inflate. But how to inflate is very important, and that has a definite learning curve. Those who are doing neuro work would understand preparing a balloon. Unless until you prepare the balloon well, probably, yes, you are going to tend to fail. And you'll say, probably, this is not the best catheter. I don't know, it's not working. It's not moving. Somebody can help me from the AV side. The slide is not moving. Excuse me, from AV side. The slide is not moving here. I'm unable to. That's stuck. Yeah. Anyway, so this is how the balloon looks. So how the technique is different, that we also need to understand. So it is not essentially the same taste as we do it. So first of all, where do we place the balloon? That is important. So you should place it as distal as feasible. Because it is a bulky catheter, probably may seem difficult, but there are ways and means, and you have to actually understand maneuvering this catheter, because every day we are getting slimmer and thinner catheters. We are used to have our hands maneuver the way those slimmer things. So again, getting back to those bulky hardware, so you need to know how to do it. And then keeping the catheter tip just proximal to all the feeders. So here we don't get into the different feeders. We try to keep it proximal to all the feeders, because from there we inflate the balloon and try to inject. However, having said that, we also need to understand it should be at segmental or a subsegmental level. When I say segmental or a subsegmental level, then I mean to say it is not a treatment for lobar kind of a lesion or a big lesion. So here comes the size criteria. Probably the best size suited for such kind of lesion would be 3 to 6 centimeter, where you have it in one particular segment and not into a big size lesion in the lobe. Something about balloon occluded arterial stump pressure. Previously people were using it. Nowadays, after doing more than 130 cases, I feel probably not. You don't need to measure it. If you are rightly placed, have done an angiogram, you are sure. But one thing to be remembered is when you are into the middle part, into the watershed zone, probably into the segment 4, 8 and caudate lobe, then probably things won't work same way as it works in the right lobe or in the left lobe. So left lateral and the right lobe probably are the best lesions to treat, followed by segment 4, 8 and caudate lobe. And embolization may be done either using a lipiodol chemoemulsion or a DEB as per your preference. So you are not forced to use any of them, though my personal preference would be a chemoemulsion. Further, we also need to understand the end point, because this is different. This is not the same how we have been using the conventional or a DEB test. So let us see the end point. So as soon as if you see that there is a complete opacification of the tumor as well as the opacification of adjoining portal radicals, that becomes the end point number 1. But simultaneously, there may be other signs which may tell you about the endpoints, like if there is a reversal of flow. If you see carefully this picture, my catheter is in this particular artery, but here you can see a reflux into the other artery. So if you see a refluxing back from the arterial arcade, probably you are done with this artery. So here the end point for this artery is when you see reflux, because now the drug will get into the other artery and the other territory, go and again put the catheter into the artery where the reflux is, and then do another set of injection into it, maybe 0.5 to 1 ml, and you will be completed with the procedure. Third, reflux of chemoemulsion despite inflation. So here if you see, the tip of catheter is here. However, just proximal to the balloon, there is a reflux. That means the artery is dilating. It is dilating more than the lumen of the your balloon. That is, it is coming by the side of the balloon, getting into other artery. That's another endpoint. Probably you won't be able to push more drug into it. and if there is a manual perception of an increased resistance during the injection or administration of the maximum threshold of the drug. What are the evidences available? So let us see, this is a European multi-center trial, and if you see here, this is a complete response in 58.9% of the patient, and this is a set of 43 patients. So yes, if you see and if you compare versus the conventional or adaptase, these results are much, much better. Further, let us see one of the systematic review. Not getting into so many papers, just look at this systematic review, which recently came 2025 in BMC Cancer, and it included of 1,166 patients. And there they saw that this technique led to a high lipidol deposition with superior effects on complete response rate. So if you see complete response rate, definitely better. Retreatment rate much lower, and progression, local progression rate is definitely delayed. So yes, in all three aspects, you are getting a much, much better response. So why not this therapy? So should we convert all our C cases into DEP cases? That remains a question. But yes, I may answer it like for a smaller lesion, suppose it is a dome lesion, 2 centimeter. You are not happy doing an ablation, maybe conventional test fits in there. However, anything more than 3 centimeter where you are combining microwave, I think this may be an area where these balloon tests are going to help you much. Now, navigating the beast, because as I told you, these catheters are a bulky catheter and not everybody would be able to take it deep inside it. So navigating the beast is the thing which I personally say, because it is a big catheter. So you need a good sturdy guide wire which will enable you to take this catheter deep into it. And you have from the cardiology side this Termo run through, or you may have some other catheter wire as well, which is sturdy enough but capable of getting into the artery without damaging the artery. Those are the best wires to take these catheters. And I'll show you certain examples. Like these are multiple tortuosity. So you can navigate, by passing different branches into such kind of curve. Let us see this hairpin loop. If you see here, this is a 180-degree curve, just from the top to bottom and again going into here. Now see this. This is again a 80-year-old gentleman. You can see multiple curve, and again this one reverse curve and another reverse curve. And see this figure of 8. So if you see this figure of 8, this seems very, so you can navigate. So despite having, so what people say, you need 1.9 French catheters or 1.7 French catheters. Not really. If you navigate it well, probably you will be able to push it inside. And this is one of the example with that figure of 8. Let us see these two tortuosity. So this is how difficult it would be. You can understand by looking at the picture. Yes, we also had a difficulty, and this is where my catheter was stuck. So, but careful navigation and just some patience will help you in getting this, crossing this kind of curvature. And I have done many such cases. These are just a couple of few, because the experience goes over 100, 20, 25, reaching up to 30. So this is how you go. You do a depth test. This is the portal vein opacification, and this is a follow-up scan. So if you talk about our experience, then we have done over 130 B tests in last 2 years. We have analyzed data for 50 patients with at least 12 months follow-up. I'll be showing you the data. And the ongoing work is analyzing the outcome of BTS in hypovascular or relatively less hypervascular lesion, where normally you are unable to deposit the drug, the amount of drug which you want, you are unable to deposit that kind of drug. Showing you some of the example like bilobed HCC, you can see here, these are the 2 lesions. Sometimes some people will say, I may ablate it, but I feel sometimes these may be difficult. So as per your preference, you may try, do this, and this is the kind of result. This is this image I have shown previously. You can see a good deposition, and this is a 6 months follow-up, where this lesion is essentially non-visible. You can see a very tiny area over here, and this is how the lesion looks. Let us talk about slightly...
Last 2 minutes.
Slightly bigger. I think it's a 20-minute session, probably. This is what I was provided with. So if anyone can enlighten me on that. Anyway, so 4.5 centimeter HCC, a larger size HCC. And again, you can do a pretty good work. You can see here, you can see the balloon catheter over here. You can see how the inflated balloon looks like. And you can see here, this is the tumor, and just adjacent to the tumor, you get a good lipidol deposition. This is how it looks. Those necrotic areas won't take up a contrast. Rest area is nicely lipidized, and this is a 6 months follow-up. And let us see, this is a 12 months follow-up. So even in a larger HCC, you see a shrinkage of the size, the size coming down, and there is no recurrence. So this is what is the beauty. So if in a single go, like we talk about ablative tear, probably there is some area, some role of balloon test to also be played in that arena. Let us talk about hypovascular HCC. This was a hypo, so sorry for the typo. It is not hypo, it is a hypo. And you can see this is almost similar on the venous phase, very near to the right branch of portal vein, very near to the gallbladder lumen. And again, going ahead, we did it. This is how, and this is how you look. So you can see how there is a further retraction and a complete response and a type 1 deposition of lipidol. That is what we call it, because we have 4 kind of deposition, and this is the type 1 deposition. Finally, totally hypovascular. This is the totally hypovascular area in the arterial phase with complete windowing. This is what you can see. So this has been made like that so that people can identify how this hypovascular, because the windowing has been made. If it has been the normal window on which the MR projection would have come, probably it is difficult to recognize that there is any enhancement. But the washout is typical. AFP normal, and PIVCA over 300. So this is what this patient was. Diffusion restriction is seen. We did on angiogram, there is some faint opacification, we were not sure. So these were initial cases. But as soon as we placed our balloon catheter over here, we can see here, and you can see this nice deposition of the lipidol. So previously, which was appearing totally hypovascular. And let us see the 12 months follow-up. This is how it looks. Another case of hypovascular, again you see this is the CT scan, arterial and the venous phases. You see here, we get inside, we are deeply inside into the left hepatic artery near the bifurcation for segment 2 and segment 3. Here is the balloon, and you can see typically the deposition of lipidol into the tumor, not getting into the non-target area, and this is how it looks after that. And this is the deposition. And you see the amount of deposition in this area, previously which was appearing so hypovascular. And most of us would agree that doing a normal conventional test or a DEB test wouldn't have given us such kind of a response. One case quickly to show you how SBRT refractory, so we were talking about SBRT. If you go to a surgeons or a hepatology forum, you will find radiation people talking about SBRT. Let us see, many times it doesn't work, even the ablative dose doesn't work. This is the 3 months follow-up after SBRT. That is what they claim after 3 months. And then you see this is the vascularity, what we got, how much amount of drug we were able to inject, and let us see a 1-year follow-up. So this is a 1-year follow-up. So this is what? Another TACE refractory. In fact, it is not TACE refractory, every treatment refractory. This patient received SBRT, this patient received DEB TACE, he received conventional TACE and immunotherapy, all kind, nivolumab, A plus B, and only stride was remaining. When we got this patient, we said, let us try balloon TACE in this. And this is what we got. You can see these cases, and just for your information, I can show that this is 1 month follow-up, that is in the March, this is what it was seen, and let us see in November 2025, the PET CT, again a complete response, those areas which were not responding. And this is the paper which we have already sent in Indian Journal. So the protocol was to study the short-term outcome of B-TACE for HCC. And the tumor assessment was assessed using LIRADS and LRTR MRECIST criteria, and progression-free survival and Kaplan-Meier methods were used to and further predictors of response were also evaluated. Lipidol deposition was classified as from type 1 to type 4. It was predominant CTP B lesion, 78%, and average lesion size was 4.3 centimeter. And what we got, in almost 54% of the patient, it was a complete response, non-viable. And if you see progression-free survival at 1 year was 81% in patients who got type 1 deposition. So if you get a type 1 deposition, it's very good, but that doesn't mean type 2 depositions are bad. We can see here is even 65% of the patients who had type 2 deposition. This happens because of the heterogeneity within the lesion, where you have necrotic areas as well as hypervascular area. So therefore, you may see a type 2 deposition in some of the lesions. And this is what we got. And finally, coming to complications, let us not forget that complications is very much comparable. If you see, none of the complications is higher than any of the said TACE methods. This is the Kaplan-Meier, where we can see over 80% survival in patients who got a complete response, and complete response was in almost 55% of the patient, which was very similar to the European trial, but that was for 6 months. This I'm talking for a year. So our study summary which we submitted is BTACE showed an excellent outcome with low complication rates. Predictors of improvement include type 1 lipidol deposition, fewer lesions, and low pre-treatment AFP that may be related to tumor biology. So with this, I come to the end of my talk with the take-home messages. BTACE is an exciting new development for the treatment of intermediate size HCC, that is 3 to 6 centimeter. BTACE leads to a higher complete response rate, lesser retreatment sessions, delay in local tumor progressions and recurrence, and BTACE may be an alternative for patients with C-TACE refractory HCC. And the adverse events are comparable with conventional and DEP-TACE, and never more than that. What do you expect? Thank you so much, ladies and gentlemen.
Thank you so very much for taking us through an absolutely amazing session, letting us know about the latest techniques. Thank you so very much once again, Doctor. Next up, ladies and gentlemen, the session will be on PAE, Optimizing Techniques for Impactful Outcomes. I invite Dr. Bhavesh Arun to please join us on the stage and take us through the session. Ladies and gentlemen, can we applaud and invite our next speaker onto the dais? We can do better, you know that. This is the last session of the day, so give your all. 1, 2, 3, come on.
Good evening. I think it's been a tiring day for all of us. I'll try to quickly zip through the presentation on prostate artery embolization, some of the patient selection criteria that we follow, some of the technical aspects that we follow in our patients, as well as some of the data as well as the evidence associated with that. So can we have the slides on, please? Duplicate. I think that solving a little bit of a AV issue associated with the slides. I'm sure a whole lot of you are doing prostate artery embolizations on a routine basis. you want to? Okay. No, it's not in that. So that was done. Do उसको वापस.
This one.
Yeah. Good evening. Sorry for the little glitch, but I'm going to run through some of the patient selection criteria as well as some of the technical aspects associated with prostate artery embolization and eventually some of the recent data associated with that. I think what I would end up talking to you a little bit on is the background, the current issues with the prostate management, what are the techniques available, how to do the procedure in terms of indications as well as the evidence. Now, we all know the reason why we get symptoms associated with BPH, but I think what's most important to realize is how do you evaluate prostate artery embolization or any prostate symptoms. Largely an IPSS score, and all of us know it's a 35-point scale on which even the urinary quality of life score is also included, and that's how you evaluate your any patient in whom prostate management or treatment is done. Typically, this is how the chart looks like. A 3-point change in IPSS score is what patients will perceive that there is some improvement. Most important is that if you have a 30% reduction in IPSS score, that's when you know that this patient is going to improve clinically as well. So the aim of the therapy is to improve the IPSS score by at least 30%. In terms of what are the current management options and what are the issues associated with that, you have a alpha-1 blocker. One of the most important issue associated with that is retrograde ejaculation. The 5 alpha reductase inhibitors, again, same loss of libido as well as erectile dysfunction. Now these are, mind you, these are common complications or side effects of these drugs, and patients are extremely oriented towards that as well. In fact, if you'll go through patient satisfaction index on Google, and you'll realize that all of these drugs do have a lot of sexual side effects as well as erectile dysfunctions, and patients are really unhappy with that, with these procedures. The current gold standard TURP or the open prostatectomy, and we all know that if the prostate is less than 80 to 100 grams, TURP is what has been offered from the surgical site, and the IPSS score improvement typically in that is in the range of 15 to 16 points. As far as the higher size prostates, bigger prostates, more than 100 grams prostates, open prostatectomy is what is required, and obviously we are not doing, surgical sites are not doing the TURP procedures in that. Though the IPSS score improvement is not dramatic in that, it's somewhere between 13 to 18, so results are not very, very promising there. All of these surgical procedures do have a lot of morbidities as well as side effects associated with that. Some of the most common ones again being erectile dysfunctions, but urethral stricture, urinary retention, UTIs, transfusion requirements, and I've seen patients requiring transfusion requirements over a couple of months as well. So it's that kind of an irritation that can become incontinence. And in fact, if you see the UK rope study, and in that the retrograde ejaculation post TURP was as high as 47%, and which is quite high. The PA data in that showed that it was in the range of 0 to 2.3. So that's quite promising as compared to the TURP. Obviously, a lot of other minimally invasive surgical therapy options are available now. The Euro lift procedure, as well as the laser therapies, the prostatic lift, microwave ablations. Obviously, all of these generally tend to help in smaller prostates. The moment the size goes up, you have difficulty in the outcomes as well. Obviously, I'll run through some of the data associated with PAE as well. And why are we talking about PAE as well? That now it's since last almost 8 to 9 years, it's got US FDA approval, and you have multiple centers showing you long-term data in favor of PAE. Usual workup that you would do with any of the prostate-related procedures, you do the PSAs, you do the ultrasounds, the urodynamic studies, apart from sometimes an MRI to look out for a focal lesion, and SOS, sometimes a biopsy. What we additionally are now doing, all of us, are a CT angiography to map out the blood supply and the vascular supply to the prostate, and to map out how many arteries and what are the origins of these arteries supplying the prostate. Most of the times, the procedure is either successful or it's going to land in incomplete procedure at the level of a CT angiography. And if you've done a CT angiography well and you've evaluated that and mapped out which vessels to go into, most of the times you'd be able to hook all the arteries and you'll be able to go and embolize all of them. I think in terms of indications, in patients with failed medical management, bleeding dominant prostates, patients who have comorbidities associated with that, some of the patients who are older patients who are already on antiplatelets because of associated coronary artery disease, all of these patients, patients with recurrence post-TURP, and patients who are on long-term catheters with or without UTIs post-TURP. Now, all of these patients can be taken up for prostate artery embolization. In terms of technique now, you have both accesses possible, both radial as well as femoral artery access, and you could use either of them. Typically, you take the interiliac artery angiograms on both sides, choose the microcatheter that you have in mind, anywhere between 1.7 French to 2.4 French, and I'll show you a couple of them. The particles being, the PVA particles being non-spherical, or the spherical particles are also available. Sometimes you would have to do a coil embolization of the non-target vessel so as to make sure that you don't have non-target embolization. The angiographic endpoint, obviously, you're looking at is stasis in these patients. In terms of PVA versus spherical, for almost all practical purposes, multiple papers, all of them suggesting that the spherical particles are the ones which will give you a more predictable and even distribution, as well as you will get a better distal penetration as well. In fact, there's a beautiful paper where they compared prostate artery embolization with PVA particles with microspheres, and in fact, if you can see, when they've used microspheres, the prostate volume, as well as both in the total prostate volume as well as the transition zone, both of them, the p-value was significant, and the prostate volume reduction was significantly higher in microsphere group versus the non-spherical PVA particles. If you talk of, this is again one paper where they've done good 81 patients using spherical particles, again microsphere, and if you talk of every parameter, right from quality of life index to IPSS score to the prostate volume, over 2 years you have significant reduction and improvement on all parameters. So in fact, lot of options available in terms of using the spherical particles. In fact, there's a very beautiful paper where they compared all the different spherical particles which are available, comparing embospheres with hydropearl from Termo and embozine. Hydropearl seems to be giving much more even distribution with very less clumping happening within the spherical particles as well. In terms of the catheters and the hardware that we use, obviously when you're coming from femoral, and we all are used to doing the uterine fibroids and since years together, so we are used to using Cobras and the SIM1s and the microcatheters, but you have the Ravi catheter, the glide cath available which is 135 centimeters. So you can take a radial access as well and come from top. We've done around 8 or 9 cases of prostata embolization through radial access. We find only one issue that's the only catheter available. So in case if you have some trouble, the micro catheter that's available is 150 centimeters. So you hardly have a play between 135 and 150 centimeter. But yes, radial artery access option is available now here. Our microcatheter of choice a lot of times is either a 2.4 prograde French prograde, which is 150 centimeters, or a prograde lambda, which is a 1.9 French. So this goes distally to make sure that you have a proper embolization technique followed because of that. Though this is not available, a Swift Ninja is something which is a steerable one, which probably at some point in time would be available to us, and that would help us navigate some of these angles as well. In terms of embolization particles or the material available, a recent publication in JVIR did demonstrate the use of glue in these patients. Though we are not comfortable using glue, again our fear is if it gets occluded proximally. Obviously some people have used it with very good comfort, so in case if it's good in your hands, you can use glue as well. These are some of the examples. You have large prostate with urinary retention. On an angiogram, you can very well demonstrate the vascularity supplied from the right prostatic artery and likewise from the left side as well. So once you've hooked these specific vessels with the help of microcatheter, you can embolize using these particles. Now, cone beam CT is something which is very, very essential when you're using, you're doing prostata artery embolization. It makes sure that you have very precise embolization, as well as it does make sure that you don't have non-target embolization as well. So this is what is followed in most of the times, and obviously the perfect technique that all of us are aware of needs to be done. Again, one more example, and typically like in this patient, when you have an abnormal vessel probably which is going down, anastomosis which is going down to the penile artery, you can, anastomosis you could embolize with the help of the coils, and then you can go ahead and embolize using PVA particles. Sometimes you have these very difficult tortuous anatomies, and here a microcatheter like a prograde lambda, which is a 1.9 French, obviously we preferred, you can choose the wire of your choice, we prefer a Fielder FC with that, but you can use these microcatheters to go very distal because it does take a lot of tortuous vessels as well. And this is how the example was post embolization. Now sometimes we do have some centers where we don't have cone beam CT, and we did one study, again this was published last year. Anirudh sir is here. We've done quite a few cases with this technique where instead of having a cone beam CT, we used agitated saline. Once we've reached the target vessel site from where we want to inject, we would inject an agitated saline. And from there, so like in this case, when once we've reached the site, we injected the agitated saline, and we've demonstrated that you are exactly going in the prostate desired site of embolization, and then you would go ahead and embolize. Again, like in this patient where we reached there and we injected agitated saline, but we found that it's not exactly going into the desired left lobe, and that's when we decided to not embolize from that site and then go ahead and found another artery. Like here. So the same patient, we went ahead and then super selectively went distally and then injected the agitated saline, and you could demonstrate and then embolize from there. So in case if you don't have cone beam CT, this is one such technique which comes in handy to help embolization. Most of these patients are generally discharged within first 24 hours. A catheter-free trial is given at 2 weeks and then at 3 weeks and 4 weeks. All of these patients obviously have to be on some sort of anti-inflammatories and antibiotics for a short period of time. A little alkalinization is required because these do patients like acetal syrup, because they do get some urinary burning as well. We've done around 28 odd cases. Initial ones were unilateral, and though in unilateral ones also you do get clinical benefit, but we know that it's not going to be lasting long, so you have to go ahead and do bilateral embolization in most of these patients. This is our data, but I'll show you some of the evidence associated with prostate artery embolization, and that should excite us why this procedure should become more regularly done for your patients. Now, most important is the studies, randomized control studies, where they've compared PAE versus sham, PAE versus TURP, and then you have long-term studies, some guidelines, as well as where does it fit in. So in terms of Pisco et al., I mean, in PAE versus sham, and they've demonstrated that for all practical purpose, it is a procedure that works. IPSS score significantly improves in patients in whom embolization was done versus in whom sham procedure was done. There were 5 randomized control studies comparing prostate artery embolization versus TURP, and all of them showed similar improvement in urological symptoms as well as quality of life score. TURP is supposedly little better in terms of some functional parameters. However, PA is associated with much lesser adverse events and shorter hospitalization time as well. In fact, 1 year outcome comparing it with laser enucleation as well showed that there was no significant difference in IPSS score improvement in the missed procedure versus the prostate artery embolization. Then that terms also we do score well, and we should be able to aggressively offer this procedure to our patients. In fact, a recent part-time trial, and this is a very beautiful trial where they compared patients in whom after a monotherapy medical management for prostate artery embolization, instead of converting them, they divided a patient and divided half of them into combined dual therapy versus directly going for prostate artery embolization. So in fact, the IPSS score, the quality of life score, as well as prostate volume reduction was dramatically higher in patients in whom the embolization PAE was offered versus going for a combined medical management as well. So in that terms also, this is something which is exciting. In terms of safety parameters, and we all know both from the sexual dysfunction as well as retrograde ejaculation, TURP does not come anywhere close to PAE. PAE significantly scores over reduction in the adverse events in most of these patients. In terms of medium and long-term outcomes, and you have patients here, they have done 630 patients with good 10-year data, again talking in terms of both safety outcomes as well as long-term IPSS score improvement is significantly higher with PAE as compared to both TURP as well as missed. And in terms of cost effective also, effective versus these missed procedures also, PAE does score in quite high. Now, talking of long-term data, and this is one paper where they've done more than 1,000 patients, close to 1,072 patients, and you have a good 10-year data, again IPSS score improvement, quality of life score improvement, significantly higher. It did reduce the lower urinary tract symptoms significantly. 89% urinary catheter removal was possible. However, re-intervention rates at 5 years was close to 20%, and this is something which you should keep in mind, that re-intervention rates are on a higher side with prostate artery embolization as compared to surgery. This is again a non-inferiority 5-year data, again similar lines. In terms of guidelines, now we do have, though it's still a weak evidence, we do have our presence in European Association of Urology as well as American Urology Association, though the guidelines still are not giving a very strong evidence to that, but still at least we've started featuring in both the European as well as the American Urology Association guidelines. In terms of most important being the retention of urine and Foley's catheterization. And I think this is one multiple papers which have proved that you have good 89 to 90% chance that within first 2 weeks the Foley's catheter could be removed in patients with prostate artery embolization offered. So this is something which is exciting. What's more important is that at least patients should be offered the option, and I think this is what something most patients deserve. You need to give all the options apart from the standard surgical options to your patient. Talking of specific issues in terms of hematuria, I'm sure it's a no-brainer. Prostate artery embolization in both published in JVIR as well as urology demonstrated that PAE tends to reduce hematuria much better than TURP. In terms of size, now when you have patients with less than 80 grams versus patients with more than 80 grams, so in both the scenarios, similar clinical benefits. And I think when you're talking of a large size prostate, it's a no-brainer that open prostatectomy versus prostata embolization, we score way higher in terms of outcomes and clinical improvements versus open prostatectomy. In terms of irritative as well as obstructive symptoms, there are a couple of things. Obstructive symptoms significantly improved. However, irritative symptoms did have some issues, and we were not able to give consistent results in our irritative symptoms as well. I've already shown you the long-term data. The advantage is obviously most important being that we can do the procedure under local anesthesia, short stay, you can continue antiplatelets while doing the procedure. So I think this is something which is exciting with a very, very good support from, and this is a multi-system, multi-country position statement that's come across the globe, right from the Chinese, the Circes, the Asia Pacific, the Australasians, and all of them agree to that. I think the take-home message would be that you have to offer this option to most patients unless and until you have a possibility of infection which may not allow you to offer an embolization in these patients. It's a very good option, especially in patients who have large prostates without any upper limit, and I think this is something which should be noted. Patients who wish to preserve erectile as well as ejaculatory function, patients who are not fit for surgical procedures. Catheter independence is something which you can surely achieve within 2 to 3 weeks in most of your patients for prostate artery embolization. Whenever you have bleeding specific prostates, this is something which beats hands down. And lastly, obviously every patient needs to be individualized, and you need to offer all the options to your patients before you go ahead and decide whether this therapy is good for your patient or not. Thank you.
Thank you so very much, Doctor. Ladies and gentlemen, we're gearing up for the GBM. So if any of you want to take a quick break to refresh and come back, I urge you to do it very quickly. Remember to carry your ID cards with you. This is to enable the attendance. In a few minutes, we will be commencing with the GBM, the much awaited GBM meeting.
Good evening, everyone. So next will be the GBM, which is scheduled along with the 26th annual conference. I request all those who are life member and full member to stay in the room. All associate members, corporate members and student members, I request you please to vacate the room. Thank you. Only full member and life members in the hall, please. May I again request all the non-life and non-full member to please vacate the room. Only life member and full member are permitted to attend the GBM. So non-life member, non-full member, a kind request to please vacate the room. And I also request you to please move to your left because the chair would be sitting in the center there. Please move to your left. My left, sorry. Please move to my left. Yes, please. All those chairs over there, please sit over there. Let's go. Hello, AV, laptop. Sir, I also request all the senior members to please come to the front. The rules committee, membership committee, and nominating committee, please sit in the front, madam. Chandramohan sir, please, I guess. May I request all of you who are standing, please take their seats. सर गिरीश सर जस्ट 1 मिनट रुक जाइए, मैं बुलाता हूँ. AV, can you please help me change the laptop? AV. AV, can you please help get the laptop on the podium, please? Please get the laptop here. Laptop, please get it here.
We'll break and join anyway. Good evening, everybody. Welcome for the general body meeting. For the progress of society, this meeting is very important. And at the beginning, I just would like to look at the quorum, whether quorum is adequate or not. Quorum is adequate?
No, sir.
Not adequate? Okay. So we will take a short break and rejoin.
Okay, sir.
Okay. 2 minutes. We are going out and coming in. It can be, yeah. If you say that you have gone out and come, that's also fine. Yeah. We will consider that you have gone out and come. You can quickly check your WhatsApp messages or something.
It requires 1/5 of the entire thing. So we have got to the, as per the last registration, 1,422. So 1/5 of that one. No, that is all the life member and the full members as per the constitution who are eligible, who are part of the GBM. So that's the definition of GBM or the constitution, right?
Yeah, now we are going to join after 2 minutes.
After 2
one and a half minutes remaining.
Informal comment, but many people may not be here. Is it okay? Huh? Okay, you want to tell him?
Good evening, friends. Just an informal comment till the GBM actually gets reconvened. On behalf of all members, we will really like to congratulate this executive team, especially Dr. Shyam, Secretary, Treasurer, and the whole executive team, and especially Dr. Deepashri to organize such a beautiful conference. So let us give her a big hand. Thank you.
Okay, we have joined again. Okay. Welcome again for today's GBM.
Those standing, please have a seat, and I request the last person coming in to please close the door.
Okay. All right.
Huh? Yes. Again, I request all those who are not life members or full members, please vacate the room. Students, corporate members, associate members, I request you to kindly vacate the room.
Okay.
All right.
Can I ask Dr. Nitin, Secretary, to show today's agenda? Can you display today's agenda?
Yes. So this is the agenda that has been circulated. So with all, it would be conducted in the same order. So if everybody is okay, then we'll adopt the agenda points.
Okay. So we'll start with number 1, ratification and approval to conduct online voting. Okay. Online voting. So whoever is in favor of online voting, please raise your hands. Photographer, please come on the stage.
Photographer.
Stage மேல வந்துட்டு photo எடுத்துடுங்க.
Yeah, from the center also.
Okay.
Just, President sir. President sir. Just need a clarification. This is for online voting for 2026 or 2027?
For now, today.
2026.
Today. So whoever is in favor of today, please raise your hands. Yeah. E-voting. E-voting. Yeah. Online voting. Online voting. Online voting.
So please,
online
please
voting.
I request Secretary to please clarify what is the meaning of online voting, who are eligible and who are not eligible to vote
that will be told.
for 2026.
We will be clarifying that. We'll be clarifying.
Online means that we are sending it to all the members for the voting, all the active life members.
Yeah, we will be discussing that soon.
So
it will be for the eligible.
Then only we can do the voting.
Yeah.
I think after discussing the thing.
This is specifically the topic is of online agenda. So we'll have to first conclude
I think
whether
before
it is
raising the hand and people should be clarified, then only the people should raise the hand.
We'll clarify. We'll clarify.
We'll discuss on the agenda point whether we need to go for an online voting.
Okay.
And sir, you'll have to clearly state whether it is
So
been
we
approved or
can
not.
ask the online election process. We can ask the committee recommendations. We can request the chairperson to come and give the valuable comments.
Regarding the online voting process?
Online voting, yeah.
Okay, so I would request the online election process committee, Dr. Sanjeev Sharma, Pankaj Mehta and Rajesh Kundada, sir. We can just explain about the online process.
Secretary sir, President sir, just one second I'll take. Sir, we are not discussing it. First of all, last GBM there was a mandate for constitutional amendment which was raised in 2023 and 24. And in the last conference, all the guidelines were to be formulated by certain committees as per the provisions of the Constitution, which has been duly done all throughout the year, and everything has been circulated. So this is not the forum where we have to present the report, because everything has been circulated online on time before, and everybody had enough time to go through it. So let us understand that again debating on it doesn't make much sense, because again we are because constitutional amendment has certain processes which has already been followed. So let us stick to it.
Sir, you have already requested the floor to vote on the online agenda.
So I think it has to be.
Please.
No,
sir, please.
Yeah.
So let me address the President.
Okay.
We have heard you, so please allow us to proceed.
So now we need to know who are all the eligible members as per Constitution. So can you just highlight who are all the eligible members?
The eligible members, and that also has been very clearly circulated to all the members, that as per Constitution, who has paid the membership due is eligible for contesting or holding any office bearer's post or casting the vote. So this has been very clearly mentioned in the Constitution. And in 2017 GBM, a resolution was passed that it has to be made active, and a fee of 2000 plus GST was fixed. And in 2018, again, it is minuted again, reiterated that it has to be enforced. But from 2018 till members have been paying the dues. There are many members who have diligently paid over the last 5-6 years. But now, since October, we have again recirculated, reminding that that amount has to be paid, so that only those members who are active are eligible to contest for any office bearers post, and also able to cast vote. So life or full member who has paid active dues, that is rupees 2000 plus GST amounting to 2360, are called active members, though there is no proper definition in the constitution, but in the GBM it has been passed that they will, who have paid the annual dues, will be called as active members, and all those members are eligible to vote.
Okay.
Excuse me, can you please close the door over there?
Yeah.
Can you please close the door?
Okay. So thank you everybody for considering this. Shall we move on to the next point?
Sir, you need to say that it is approved.
It is approved. It has been approved. Yep. Please go ahead.
Sir, it's not still cleared. Is it a online voting or it's a e-voting physically done in this GBM?
It's online voting.
Sorry, online voting, how we can say that if you are done online voting, that means the whosoever active member not present in this GBM can vote?
Yes.
How that can be possible? You are going to mail them, you are going to send them a message, and you are going to window period of 2 hours only. How much is that possible? You are going to send a message to the members that from this date to this date, we are going to open a portal that is called online voting. You can't say the members that we have approved in the GBM. So this GBM can only listen to you, but for the members who are sitting at home, not presenting the GBM, you can't just give them a window of 2 hours. That will be not legally, because anyone can legally take our society into the legal system, that a legal notice can be issued. Why the 2 hours or 3 hours window period is given to me? I haven't seen any mail, I haven't seen the WhatsApp at that point of time. So this is not feasible.
Point taken, sir. We will respond to that. We have got the rules committee over here. The rules committee can
Dr.
say
Suresh, please.
What is the interpretation of online voting.
So the rules committee has considered the proposal for online voting, and those recommendations are given to the executive committee, and that was put for approval in the GBM. Now, I agree with Dr. Ajit that what he said, that if those who are probably sitting at home, if they are the active members or those who have paid the annual fees and they are full members, so they are also eligible to vote. So within 2 hours or 3 hours, we cannot expect them to be alert and see the mail and vote. I think if the GBM agrees, this is just a proposal, then we can give them a time for 24 hours, and then within 24 hours they can vote online.
Thank you, Dr. Suresh. Dr. Balaji, Brigadier Chandramohan sir first.
I agree with Dr. Suresh's suggestion. Instead of 24 hours, give them a window of 3 to 5 days. Decide now. Because if everybody has to wait, somebody may be committed and may not be able to vote. And the right to vote is a very good organization. And it is a very time-tested vendor which you have chosen. There is no disparity as far as the integrity is concerned. They will give us an audit report which can be verified also by any independent agency. So you have selected a very good vendor. Only thing is, give them a window of more than 24 hours if everybody has to vote.
Thank you, sir.
So, dear President, see, we have decided that we have to go to online voting. This time, like, we can have it online voting for the people who are present right now here, because you have taken a decision this time. Why can't you do the same? See, we are all for online voting. We are not against online voting at all, sir. But you have taken a decision right now, and you are telling either 2 hours or 24 hours is not valid, sir. In any of the organization, there is a time period of around 10 days or something like that. In that period, you have to vote. You cannot decide right now, and you cannot give 24 hours also. I don't think so it is right. I'm very sure, sir, even one person put a legal case on the society, it will be bad remark. So I request the House or President that you take a decision. This time let us have like what we were having, but online, you want to do it online for the people who are physically present here, please do it. But if you want to give the right to anybody anywhere, 1 day or 2 days also not enough, sir. Where did you describe it before? You didn't describe it before.
Thank you. Thank you. Dr. Suyesh.
So as everybody is saying, like for example, Dr. Yadav Munde for his health purpose, he could not come. Or even Dr. Aman has to go back for family. So there may be some more commitments, family commitments or work commitments because of which people are not coming. So all of them should get the opportunity for online voting, and that is the basically intention behind online voting. So I think, but the GBM can take the call whether 24 hours is sufficient or whether we should give the period for the conference, and then we can agree upon that as a majority.
Agreed, sir. So you can just call for the vote, sir.
Okay, Dr. Ajit Yadav.
So I think, sir, in the last GBM, it was clearly decided by the GBM, and we can see the minutes of the meeting. It was decided that in 2026, we are going to have the physical voting in the GBM. We did an extraordinary GBM. We fighted so much in that also. We agree to that. Online voting should be done 1 month before the conference. All the contestant has to apply for the online voting. Then scrutinization can be done, and election time can be done in a 10 days window period. But now, if you are saying day before you circulated a message that before 8th you have to take active membership. So whatsoever it is, the people here only, they take the active membership because they didn't know whether the outside people who are not present here, they didn't know about this rule that we are speaking now, that they can be eligible. If we have to tell them, you can vote from your home because this is completely online, we are going to give, that should be clearly written in your mail.
Okay.
So, if
sir,
that was not clearly circulated,
point
so
taken,
that
sir.
was not circulated, so this is not legal to have that.
Point taken, sir.
Dr. Uttapa.
Thank you, President. See, I think we have all attended many GBMs, and I think in the interest of the society, we all have, I think, very consciously agreed it's a big milestone moment for the society to go to online voting. I think we had very painful moments in the past. So I think the GBM, with your leadership, you should take a decision. What would be the best form, which is legally compatible with legally, and making sure that every voter is respected and honored. So what is the best methodology which we can adopt should be decided by the GBM, and what should be, what I'm trying to say is it should be carefully decided. We can't have a milestone moment for the society taken very casually to be done like, even initially somebody mentioning, in the 2 hours we'll vote. I think that's, it will be taken down, historically it will set a very bad example. So please guide us that we are going to take a very conscious decision. Again, I repeat, it's a milestone moment for the society and we got to get it right. Thank you.
Thank you. Thank you, Dr. Tuba.
So I think it is completely sitting in the GBM and saying this is going to happen, not making aware of what is actually going to happen. It is completely hiding the things from each and every member of the society. This is completely wrong going, and I think the executive committee members and this GBM will take a wise decision and will not allow. See, we all agreed in the midterm so-called that I personally feel is again unconstitutional, but still we all agreed that 2027 election will be going online in a proper way, and it was not properly mal-informed and this is completely wrong for the society.
Thank you, Dr. Arun. Dr. Rajesh.
President, sir, I believe those people who are not present, who have even, sorry?
Not audible. Lift the mic, sir. You are not audible. आपके height के लिए.
It is not coming. ये नहीं आ रहा है. फिर छोटा ऐसा. So I honestly feel the people who have come in the conference, even like Dr. Pankaj Mehta, because of his illness, he could not come. He is registered and he could not come. So there are lots of people who are interested, and you just can't keep them away from voting. So what I feel is, you give them time, you give them emails, and I believe there are lots of competent people who are the contestant. They will ring them 10, 20 times and will make them aware also. So just by an email, you can't wake them up. There are enough people who can wake them up. So stipulated time within this conference should be given, and the election should happen within the conference, and this is what I honestly feel.
Thank you. Yep. Last comment.
So I think, sir, if that thing is
need to address the
previously,
chair.
so आपने
Address
लिखा
the
था इसलिए
chair.
बोला, आप mail आप भेज रहे थे, इसलिए मैं आपसे
No, but
पूछना
the
secretary,
address
sir.
should be to the chair.
So the mail was
You
sent.
can come and sit here.
The mail was sent on 8th. जब तक 8 को रात को 12 बजे तक जो एक्टिव मेंबरशिप लेंगे, that means कि you people are going to know that this is going to happen, that whosoever is active member can vote, but we people don't know.
So I
that
think
means a group of people, they know about this thing and they made their people active member, and a group of people who don't know about this law, they didn't make the active member who are not not present in the GBM. So this is completely unfair in terms of whatsoever happening in GBM is completely unfair. एक इसके लिए आया था, दूसरे फोटो बार बार लेता था, पिछली बार मैं स्माइल नहीं कर पाई, इसमें याद दोबारा आया कि अच्छी फोटो आ जाएगी. Thank you.
Thank you. Thank you. Dr. Naveen.
I guess the mail for active membership was sent.
It was sent from
long back.
October onwards that you need to pay to have your rights.
Everybody needs to know that, to attend and be eligible, everybody needs to be an active member. Not that.
It was not, yes, I agree. It was not sent on 8th. It has been circulating
long
since
back.
October that it has to be paid
Yeah.
to have membership rights, including voting.
Yeah. So it has been already sent.
It
So
has
this
been sent, and it
so
is
the previous comment doesn't hold good.
So we have given sufficient notice, sufficient circular, even through WhatsApp it has been sent, and a point very well taken, nobody who is sitting at home should miss the opportunity to vote. I completely agree with the members, but for the very same reason, I think that should happen even this year, because there are people who have paid the fees, who are there, who are not present over here. So why deny them the chance of voting? We are talking of doing this one from the next year, but who have already become the member, why not give them the chance?
Okay.
The very same logic applies here also.
Okay. Now, what we'll do is we have listened to the discussion.
You need to come there, sorry.
One quick comment, Arun
Yes,
ji?
just a quick
Yeah,
comment.
quick
I
comment.
totally
Please go ahead.
agree with that every person of the society has the right to vote. So defining it 2 hours or 24 hours is completely a bad idea and completely illegal. If it has to be done, it should be planned accordingly and should be done. That's why I totally support that 2027 elections should be completely online and 2026 elections should be physically.
Okay, thank you.
So
thank you,
sorry,
Dr.
just
Arun.
one more clarification before Pawan talks. The mention of going through the minutes in the last GBM, it was very clearly documented in the minutes that whatever discussion happened happening in 26, 27 was not applicable, because only one agenda point was cleared by the EC and which was proposed, and that was online voting, which was approved, and regarding that itself all the ratification is going on.
So it is completely malinterpreted by you are suggesting that minute says that online election was approved, a committee will formed and this thing will happen, right? Agreed on that?
On 26,
that
it
was not clearly.
Sorry sir, 26 was not
Okay,
mentioned.
okay.
26 physical was not mentioned.
So,
Okay.
26?
26 it will happen physical was not
So
mentioned.
it clearly says that
Sorry,
all
sir.
this happen after that the decision will be taken. This is your interpretation, and because you are
the minutes
Dr.
were
Arun,
circulated
okay.
within 3
Now,
3
now
months
what I'll
of
do
the
is, due to
GBM.
shortage of time, I'll
Sir,
quick
just
comment,
one
Dr.
minute,
Pawan,
sir.
quick comment, and Dr. Kaurabi, and after that, I'll take GBM suggestion.
Yeah.
See, no one is going to take a decision individually. Whatever the GBM gives the mandate, we will go accordingly.
Sir, one thing I want
Okay,
to
Dr.
say.
Pawan and Dr. Kaurabi.
We are contesting election. We are getting daily email nomination and active member and this, that. In that you can put that one note. कि this decision should be taken before 10 days, कि who are eligible for the vote and who are not eligible. Now you are telling 1 hour before the voting or whatever. That's wrong. You
Sir,
have
it
to,
is very clearly mentioned that the voters list will be, the decision, it will be finalized by the election committee.
but you can't give contestant 2 hours. Ki now you know ki all are these are
That
voted,
we
you
have
to
not
contact.
mentioned that it
We are
is-
not
sorry,
decided.
have
We are not
never-
decided.
We are not
I think
mentioned
we
those
have,
I
words.
feel
no,
you
no, we
should
are not
give
decided.
enough time to
GPM is
the
going to decide. Okay?
contestant, enough
Yeah.
time.
Okay,
What
thank
I
you,
want to
thank you. Dr. Kaurabi and Dr. Sanjeev sir, since he is the senior member, we will
Sir,
request
since
him.
last 4-5 years, each year the agenda is for online voting, online voting. I would suggest last year it was already passed for the online voting, and the entire year the process was done in a step-by-step manner according to the mandate of our constitution. So it's simple, just take a majority and take the decision. That is my appeal to the president. Thank you, sir.
Thank you. Sanjeev sir.
I was resisting the temptation to stand, but at the end could not. So my humble request to you all is, Arun, my friend, this word legal is very ambiguous. What is illegal about the timing to vote? Is there any legal document to say that 2 hours is not enough, 24 hours is not enough, or 7 days is not enough, or 1 month is not enough? Is there any time limit defined, any legal document? I am not aware of that. So to repeatedly emphasize and scare the audience that it will become illegal and we will have a court case is wrong. Number one. Number two, what cannot be done in 1 hour cannot be done in 1 day, cannot be done in 1 month. So reasonable time limit should be there. Yes, I understand and I agree 2 hours is a bad time limit. It's not possible. 24 hours is a reasonably good time limit. If you think that these two big panels that are there, first of all, I am sorry, I am too old, but this philosophy of panelism is moving away from science to panels is a very bad practice for a society. And we must promise ourselves today that we will abandon this practice henceforth. That's very important. I discussed this with many candidates yesterday, including Ajit. I think, for 15 years, this society moved on consensus, without any animosity, without any fights. It's only in the last 10 years that we are seeing some groups, some animosities, some panels, very heated arguments for and counter. This is not good for this society. I think we should come back to, after all, how many of us are actually interested in sitting there on the GBM? 5, 10, 15, 20, 30, 40, not more than that. Why can't we devise this roster? Oh, this is my turn, this is your turn, this is your turn. After all, what is it in that seat that is driving everyone? I don't understand this. I would much rather be happier if all of you are talking about science. Chandar was talking about what we should do, how we should change the way IR can become the byword. So at the cost of digressing, I can tell you it is science which can change. You can win the tough war by being better scientist, not being by force or by any other argument. And these platforms should be used to improve our science, not to make some more refined panels all the time. But coming back to this point, I think 24 hours is a reasonably good time. You can make it 36 hours. Try to close this within the ambit of this conference. Okay. But, we've done a lot of work to fine-tune on this right to vote. We interviewed many companies, and believe me, these guys are good. We did a mock drill, it worked, and every vote tallied actually. And they showed us we've counter-checked with many associations. They are doing a wonderful job with them. There is no reason. Trust each other. The problem is mistrust. Or you said this, you meant this. Let us not get into this. Let's have faith in each other. Let's trust each other and let's move together. Let's bury these hatchets here and now. You know, it's not you and him separate entities. We are all together for a cause, and that cause is interventional radiology. Let's not that go out of focus, and cause becomes politics, and who becomes who, and why my word is not there and your word is not there. I requested for an agenda to the GBM this time. I don't know whether it is there or not there. I think you should make it an agenda for discussion this time, that in a lifetime of the membership of this society, any member can contest for 3 times in 3 posts in election in his lifetime, and space it out for 5 years or 4 years or whatever you want, so that it keeps moving and everybody gets a chance. Then all this argument and fight will go away and everybody will be happy. But back to this point, back to this discussion, my humble request to you is extend it to 24 hours, 36 hours or whatever period. Close it, do it online and be happy. What does it matter whether A becomes or B becomes? We are all friends, and we are all have good intentions. What's the big deal? Thank you so much. Sorry for sounding very silly.
Thank you, sir.
Sorry.
Brigadier, sir.
I've been telling both the sides. I told Dr. Bajal yesterday at the airport in Delhi that this is the first time both sides have elected you or nominated you. So you must take a lead and do away with elections. Just sit down both the sides, pick up the best candidates who have the interest of society. And I am still telling you, my request is, please take it from this GBM onwards. It is just 10 minutes job, and let's do away with elections. Because that is what Dr. Sanjeev was telling. I fully agree with, we were discussing how to take IR forward, and that is going to be done by science and nothing else, what Sanjeev was saying.
Actually, I should tell that when GBM points were requested, there were nearly 80 responses, which Dr. Nitin has rearranged, and I think he has got about nearly 50 points going to be discussed after this. And so I would like to say at this point of time that is 24 hours reasonably okay? How many of you think 24 hours reasonably okay? Please raise your hands. One second, Dr. Okay. How many of you think 12 hours okay? 12 hours? 12 hours?
Sir, for timings, can I say something?
Okay, one second.
For if sir, just for wait.
Yeah.
If in a GBM, if we are sending 24 hours, maybe 26 hours, all people are here. I can take the mobile for my student and I can just take it, and I can, for whatever time you are giving, more the time you are giving in the GB or in the conference, I can influence the people here with taking their mobile if they is my student. So it's not a perfect solution for that. If you want to do election, that will be in the GBM. We had that election for the voting. If you are saying that so many members are there outside who can't vote, I totally agree with you. But that percentage is less than 1%. Out of 350 voters, it's hardly 2 or 3. So next time, properly we can have that plan, and then we can tell all the members, this is going to happen, and this is the plan we are going to do for the online election. This is the timing and everything. So why we are in hurry to do online election now, and we are extending from 2 hours to 24 hours to 3 days, and why? And secondly, to Dr. Sanjeev Sharma said, I am totally agree with that. And I am saying, I don't have so much good in English, हाथ थोड़ा कमजोर है अंग्रेजी में, लेकिन साइंस तो हमने बढ़ाई है सर. We in the last 10 years, our society grown from 400 members to 1300 members. So sir, it's a democracy is growing. It's not about that we are fighting. It's a democracy. It's a family. Family भी बड़ी होती तो भाई भाई लड़ते हैं. हम भी भाई हैं सर. साइंस बड़ी है. 1 करोड़ की कॉन्फ्रेंस है, 7 करोड़ की कॉन्फ्रेंस हुई है, 400 से 1300 मेंबर बने हैं, नए प्रोसीजर आए हैं, पीआई यूए थायराइड एब्लेशन 5 होते थे 500 होने लगे हैं, आउटा के केसेस 1000 होने लगे हैं. साइंस बड़ी है सर. साइंस बढ़ने के साथ परिवार बढ़ा है, परिवार के साथ पैसा बढ़ा है, पैसे के साथ ये चीजें बढ़ी हैं. सो इट्स नॉट ओनली साइंस, इट्स अ डेमोक्रेसी ऑल्सो.
थैंक यू. Dr. Rajesh.
Let me tell you, the enough sensitization regarding online election was done in previous meeting, previous GBM. Even a single point agenda was discussed on online voting, even in extraordinary GBM. I believe too much of discussion on online voting. It was virtually approved last year. Enough discussion, not that we have not sensitized people, every people is sensitized. And second point, The thing is that we have problems with panel. So I agree with panel, problems with panel. So even we should not have panel discussions. We should have a multidisciplinary discussions in next conferences.
Thank you, Dr. Rohit. Quickly, all of you, please.
Quickly. Just to be clear to everybody, this is all online voting is all ratified and discussed. Everybody is happy. No change. But what you're doing right now, sir, like now we'll give you 12 hours, 24 hours. That is not right. If you had sent an email a couple of weeks ago, see on the 9th, between 6 to 8 in the evening, there'll be online voting. Be ready. So people are ready. This. All of a sudden giving 12 hours, 24 hours is not right, sir. It is not right at all. I don't know if it's legal, I don't know if it's illegal, but it is not right at all. It should not be. People should be told there is online voting happening on the 9th of January 2026 between 6 p.m. to 8 p.m. Please vote. And all life members can vote. And I'm happy for that. That's for sure. But this particular thing is not right. And raising of hands, signing 12 hours is enough, 24 hours is enough. That's not right.
Okay. Thank you, Dr. Rohit.
Sir, I think we have had enough discussions. Now it is we can have, because the general body, we can see a lot of attendance, and if you see 1/5 quorum would also be complete by now. I see, you can take any kind of voting you want, and please close this matter. Everybody will have a different opinion for that thing. So please conclude it.
Understand. So we are going to, we have several other things to do. Now the important thing is, how much time we should give, for voting.
So, sir, may I take a question?
Sir, not how much time. First, we have to vote whether we should do physical voting or online voting. So, it's not timing. It's first we have to decide whether the physical members present here should vote or online to all the active members. So, it's not, if you are voting for 12 or 24 hours, that means you are not going back to physical voting here, physical e-voting. So, they can go do the e-voting. Or online voting. First, we have to vote on that. If GBM is agreeing to that, it's okay.
Sir, I just wanted to understand one thing. So, if we take whatever decision, so let's say immediate or whatever, that this decision has to be ratified by GBM.
You cannot implement
Now we are ratifying.
You cannot ratify in the same year, no, sir. You cannot ratify in the same year.
So that's why I'm asking. We take a decision instead of like.
Okay.
Sir President, I've requested Khandelwal sir and Baijal sir to take the lead, sit along with the two teams, and please have a mutual understanding, and let us not have election this year. This will be better. I'm telling you, this is how. See, we have finalized the president. In the same way, we will compromise between two groups. I'm requesting. This is my request. Okay. My man. No, you don't want. I'm requesting.
Okay, thank you. That we'll listen to the election nominating committee soon, because they may be ready who are all the shortlisted candidates.
Sir, again, I would like to remind that we are continuously debating on same point. Second thing, sir, online has been approved by the last GBM. It was just to be ratified. Only the guidelines had to be made, and we have already made the guidelines. I was part of the executive. It has been circulated, and we will ask the secretary if he has received any kind of objection from any member, because all the guidelines were circulated much before. Second thing, regarding 24 hours. If it is 24 hours, even those people who are traveling to maybe Europe or maybe US, although they are not allowed as per the norms, only citizens of India, and who are doing interventions in India are allowed, they also will get a time, in case they were allowed, to land, open their mobile, and so 24 hours is a good time. And more so about canvassing. Canvassing has been going there, sir. Every person has been canvassing. Nobody can say that they have not received messages. And if I'm not wrong, last year in the WhatsApp group also I've seen people are annoyed with all kind of messages, and even this time there have been enough calls, enough messages. So canvassing is on. It is not like how do anybody knows who is coming here, who is not. So it was on before the beginning of this conference. It is going on, and 24 hours, whoever wants, they can canvass. Thank you, sir.
Okay, thank you. Dr. Swati.
No comment. My just small request is there. This is not lifetime selection, no? It is only for 1 year. The posts which are there for 3 years, wait. The posts which are there for 3 years, that is secretary and I think treasurer. They are not contesting.
Sir, madam, if you ask me, request the GBM to make this 1 year instead of 2 years.
Yeah, let's take whatever. These are for 2 years. So only few posts are there and that only for 1 year. Why are we talking as if this is for lifetime? Finish off 24 hours, finish off the elections. Next year, come back with a normal this thing. How much fighting for small things?
Okay. See, we all know each other. Many of our are friends. And it is a time that GBM we actively discuss. And this discussion is important for the society growth. So my humble request is after so much of discussion, let us go for online voting. This is my personal opinion. And keep it for maybe, as Sanjeev sir told, 24 hours. So that we can inform all our friends. Okay. And so shall I consider this an acceptance?
सर अभी तो GBM के 2 घंटे बचे थे, कल की कॉन्फ्रेंस अच्छी निकल जाती, अब आप पूरा भी कल का इलेक्शन में निकालने वाले हैं हम. So एक और दिन कॉन्फ्रेंस का भी पूरा इलेक्शन में निकलेगा. It's better to have that in 2 hours here rather than spending another day of conference in the election is going to spoil everyone's day.
Okay, thank you, Dr. Ajit. You already told that point. Okay, sir, Dr. Indushekar sir, you are ready with anything. Okay, but anything we cannot do. See, it is like a new nursing staff had come and they said give any guide wire. Any guide wire we cannot come. You say what guide wire it is. Okay. Sir, now we are going to have a final comment from Dr. Indushekar sir, and kindly go, sir.
Yeah, thank you. Well, I feel that everybody agrees for online voting in this audience. We don't want definitely paper ballots and all that. Last year we have had, and we don't want to go through it again. 1 point. And the second point is that there is a confusion whether non-attendees can vote. I mean, people who are members but have not come. Now, via media, what I'm thinking is who are all registered. Some people have gone back because of the commitments. Those who are registered for this conference should be made to vote. That may be a simple thing. So online voting for people who have registered for this conference can be easily sent a message and they can vote immediately. In 2 hours, the whole thing will be over.
Sir, the point is well taken, but we agree, and maybe this is a good suggestion, but I would like to say that there is a written document, a constitution. A constitution is a binding for the society, and let us go by the constitution and take the mandate. Thank you, sir.
Thank you.
There are many people who cannot genuinely attend the meeting because, for example, my colleague, he cannot leave, both of us cannot leave the department. So I don't think it is right to deprive him of the right of voting and choosing his representative.
Thank you. I think after this discussion, we have listened to all your comment, and we are quite sure about the majority of opinion, and take final opinion.
See, we will go to address to the President. We will go as per Constitution. As per Constitution.
Okay.
If we are going to amend the Constitution, then proper procedure has to be followed. Amend the Constitution, then what other people they are suggesting we can follow. Otherwise, at moment, we have to follow the Constitution only.
Sure, sir.
Right.
Sure, sir. Okay, sir. All right, sir. So we'll go ahead with the e-voting. So, sorry, online voting. Sorry for mixing up, and please do not record it. So we all have go for online voting, and all active members. All active members, okay? Okay. 24 hours, okay?
No, only active members or registered they are asking.
Yeah.
Active members.
Okay. Active members, raise your hands. Okay.
Sir,
okay.
that is a constitutional amendment and will go through
Yeah.
the complete
Yeah.
process for
Yeah.
3 years
Yeah.
if you want to
Okay.
do that.
Okay.
You can't change the constitution because we were struggling to do online constitution since 2023. It took us 3 years to reach here. Again, if you want, then you will have to change it.
Yeah.
So constitutional amendment is a constitutional amendment. We all should go by the constitution. We are very clear on it.
Yep. Thank you. So, all right. So, thank you everybody for your suggestion. I think our society is really moving forward with all this discussion. So, okay. All right. So, now,
Sir, online voting 2 hours or 24 hours, you please clarify.
okay. 24 hours, how many hands? Okay. Active member.
Only active
member 24 hours. Okay. All active members. Okay. Yeah. Okay. So I listen to you. So there are two categories.
Sir, you can't have online voting. I'm telling you, it is against constitution. Please, sir, I will request secretary, sir, to please understand that what is full member and you read it out. Please read the constitution. If you read the constitution, all full member who have paid their registered and dues, all their annual dues, and this is what you have circulated time and again, maybe 100 times over last 1 year. So you can't now say that only those people who are present. You are snatching the right of a voter who is not available because by virtue of constitution he is allowed to vote. So please don't go against the constitution.
Point is well made. So
all active member, not those who are registered in this conference.
Okay.
Sir, can I say something? The same thing that all the members should go take a active membership, that is been circulated by President-elect sir in the ILBS group. That you take the membership, I am going to make it happen, that you are going to vote without going to the conference. And that's why he is struggling here.
Sir, no personal comments. I would take objection against it. It is a personal comment and I would refrain from making any personal comment, and I will again advise the House not to take personal comments. And I'm a normal member of a society and I have all rights to canvass as per. I have a voting right as well and I'm not contesting this year. So that should be very clear to the House.
Thank you. Dr. Ajit, please,
Sir,
please be seated.
ये इसका मतलब ये रूल इनको पहले से पता था और हमें नहीं पता था.
I'll tell you.
सर एक मिनट, ये रूल सब
No. Nobody knew.
We have to stop at some point of time, sir. And I would request you to kindly take a decision.
Okay. Now it is my turn. Shall I speak?
Yes, sir.
Shall I speak? Okay. All right. See, the emails were sent by secretary. He is not going to contest. Okay. Secretary has sent. And what GBM is going to take decision, nobody knew. Because this is a collective decision taken by all of you. That is the one which has got the strength. So without knowing GBM, what decision is going to take, okay? Yeah. I think we'll now
one last, sorry.
ultimate last.
To get radiology post, you have to be in the first 5 or 10 ranks across the country in the university. I don't think it is easy to influence such people. कि इसने बोल दिया उसने ऐसे कर दिया. It's not possible.
So we accept it. So I think this matter is closed and we'll listen to the election.
You need to clearly tell, sir, that
So clearly telling is all active members.
All active members. And what's the duration?
Online voting, 24 hours. Okay. So, okay, shall we take it as this clapping is considered as approval? Okay. Thank you.
Thank you.
Which one? Okay. Videographer. For video recording purpose, we need one raise of hands. Only one hand. One person, one hand. Okay. All right. Okay.
Sir, statement.
24 hours. Online. 24 hours. Online voting. Active member. 3 keywords. Okay. Okay. Hands down, please. Hands down. Okay. So now the election comes. Are they ready with the?
Yes, sir. I would request the
people who have. I think that will be more interesting than this. Huh? I have seen. I have taken snapshots and I have counted also. I am not telling the number because there may be one or less, more or less.
You want it, we will get it. Once it's ready,
Sir,
The nominations have come in, and for the president, Dr. Baijal stands unopposed. As the president-elect for the year 2027 will be Dr. Baijal. Yeah, 26, 27. Means he takes over in 27. 4 candidates for the vice president's post: Dr. Uttappa, Dr. Jawahar Rathod, Dr. Ajit Yadav, and Dr. Sanjeev Kumar. We'll put up the Excel sheet in a short while. It's being typed. Joint Secretary, 4 posts, 4 candidates. Dr. Naveen Mulimani, sorry. Dr. Yashwant Patidar, Dr. Lennon D'Souza,
They can stand it.
and yeah,
Naveen Mulimani is there, and then second one was
Yashwant Patidar, Lennon D'Souza, okay, Lijesh Kumar, yeah. Now for the executive committee, there are 11 candidates totally. Dr. Pardon?
5 posts.
5 posts. 5 posts, 11 candidates. Dr. Anil Kashi, Dr. Rajkumar Rathi, Rajkiran, sorry. Rajkiran, I read it wrong. Dr. Tara Prasad Tripathi, Dr. Naveen Chandra Shekharan. Yeah. Dr. Rangarajan Rajgopal. Okay. Dr. Jinesh Valakada. Dr. Pawan Kumar. Dr. Purvi Malik, Dr. Puneet Garg, Dr. Preetam Chatterjee, and Dr. Avichala Takshak. Okay, so we'll put up the slides, Excel names again in a short while.
Sir, it's 7:32, sir, now.
Now, once it's what was the time now? 7:32.
Whether anybody wants to withdraw.
Anybody wants to withdraw, you still have a chance. You won't. Okay. Dr. Avichala is withdrawing. Anybody else? So that means there is totally 10 candidates for 5 seats for the executive committee.
So do we give time or she gives in writing is okay?
Sir, can you give them half an hour time, sir?
15
Girish, sir?
minutes, sir.
15 minutes. 15 minutes so that they can start the process. So all candidates who are here, 15 minutes time for any withdrawal. Thank you. So shall we move on to the next point?
Yes. So the next agenda point was the role of president-elect. This has been circulated to all the members, and I think you had sufficient time to go through that. Any clarification required, we have the chair of membership committee, sir, and Mandeep madam, Rochan Pan sir and chair, Ramurthy sir, yes. So, sorry, this was by the rules committee, I'm so sorry. Rules committee chair Dr. Rochan Pant and Kamal Patak, Swati Halbe madam and Suyesh Kulkarni sir. So these were the rules committee and they have formulated this and submitted to the EC. EC has proposed to put this in the GBM. So
Do you accept?
any clarification or is this accepted?
Any clarification? Do you accept? Pass? Pass. So this will be amended. Okay, thank you. Next agenda. Amended. Okay. So you have approved and then you're going to be amended. Pass. Next point, please.
So there were a lot of queries regarding the membership categories and they wanted a clarification. And again, this proposal was forwarded to the membership committee chaired by Ramurthy sir and members as Dr. Mandeep Kang and Dr. Rochan Pant. So they have also submitted their recommendation which has been circulated to members. So any clarification regarding this, we have Ramurthy sir who can just address any queries.
Just need a clarification. This will be approved as per the rule committee. This will be passed by the GBM and will get executed from 2027 as per the constitution.
The rules committee can clarify.
So we'll ask the rules committee. We have all committees active, so very easy for
I
me.
agree with Arun. Sometimes we agree. Please do not laugh. Sometimes we agree also. So yes, what he is saying, the membership committee has given their recommendation.
Yes.
This should go to the rules committee, and rules committee will see as per the spirit of constitution. If it is all right, it will be forwarded to the executive committee, and then it will come for the amendment of constitution.
Agreed.
Right, and same applies for duties of president-elect also, because the rules should remain the same. It will be applicable from when the GBM ratifies it next year. Anything that has to be approved by GBM, na?
See,
The first one was
let
by
me
the
complete.
rules committee.
See, when we had president-elect post, we did not know the rules for the president-elect. That's why it is newly formed.
That's what I'm saying.
It's a newly formed. So since it's a newly formed, we can, okay, rules committee.
So, constitution.
I'll just point, sir, because I have been president-elect for a year, sir. So I will put my point as in front of House and everybody to listen. Because the constitutional amendment or GBM passed that there should be a post of president-elect. It happened. But when I got to know what powers I had. Actually, I had nothing. I was just in executive. And I couldn't do anything. So I thought, because junior wing also, when it was created, was not through constitutional amendment, but we adopted it. It didn't go through any of the processes. So I said, okay, fine. So let me take the junior committee along and whatever I can contribute in that sense. Having said that, again, if it takes 2027, then probably the incoming president-elect again would not know. So I would ask the House and in fact guidance of the president for this year, what will be the roles of president-elect, because Bejal sir is a very, very respected person. So we should have a well-defined role which he knows, otherwise he will be in a dormant stage. So
I think बात यही कही हमारे भाई अमर ने कि जो हमको पसंद आया वो हमने अडेप्ट कर लिया, तब उसमें हमें इंतजार करने की ज़रूरत नहीं है, तब कॉन्स्टिट्यूशन किनारे रख दिया गया। जो हमें लगा कि ये हमारी चीज़ अगेंस्ट है या समझ में नहीं आ रही है, तो उसमें फिर जो है कॉन्स्टिट्यूशन आ गया। So this has to be go as per. Let me complete.
No personal comment. No personal
It is not a personal comment.
Sir, बार sir, Amar bhai और इस तरह के words, I will please sir. No personal. No, I gave my opinion to you. I think Dr. Arun should give his opinion to you
yeah.
because
Everybody
you are the
agrees.
chair of the house.
Yeah.
Second thing, I didn't do anything. I am telling you because मुझे पसंद नहीं आया. मेरे पास कोई काम ही नहीं था एक साल को करने के लिए. I just did anything for whatever spreading the knowledge along with the juniors because they need the knowledge. That is what I could do. I'm just telling you, sir, what I did.
Okay, this matter is closed.
No,
This
so,
matter is
so,
closed,
so
I'll
President,
tell. Yeah.
decide if I have used the term Amar Bhai, is it wrong? And it is क्या Dr. Amar की dignity को जो है नुकसान पहुंचाता है?
Okay, please be seated. I'll tell the final.
So,
No, Amar, please.
Amar, please be relaxed.
आपने कहा कि जो तुम अमर को पसंद आया वो उसने कर लिया.
No. See, one thing is, sir, I'll tell one thing.
Arun is absolutely right. The rule should be the same for every item.
Yeah.
If it is to move through the rules committee, everything has to. So this should also. That's it. We should not discriminate.
Sir, let me just clarify. Sir.
Okay.
The
Sanjay,
mistake
sir.
has been made by the society by creating a post without identifying the role and responsibilities. That's a.
Sir, rules committee has gone through it, sir.
The point is, the role and responsibilities should have been defined at that very moment when the post was created. If it is not created, we have to abide by constitution. Any change has to move through rules committee. It has to come back to the GBM and get ratified. Whatever time it takes. That's it.
Okay. Okay.
Sir, I think this as shown by the Nitin sir is the rules committee amendment for recommendation for the president-elect.
So it is by the
now
rules committee.
our role is to pass or not pass.
Okay. So that point is correct. Okay. Please go ahead.
So, see the role and rules, the responsibilities of the president-elect was recommended by rules committee and now it is put for amendment. So, to be accepted by the GBM. And regarding the acceptance, once GBM has accepted something, it can be implemented. It is given that at the end of the GBM, it will be immediately implemented. So, there is a technicality where you adjourn the meeting and reconvene it and say that all the decisions taken by the GBM will be immediately applied. So, that's why the president-elect was started after it has been amended. But it has come through the proper process. So, for the GBM, it has come through the proper process.
Okay. Thank you.
I agree with that it has come to the proper process. So, what I have learned from Suyesh that the legal way of anything amendment should be ratified by the GBM and it is started from the next year. That I have learned from you because you have more knowledge about the constitution. So please keep your words, Suyesh bhai.
Okay. Thank you. Thank you. We'll go to the next point.
So the membership category, the GBM is okay with
Membership
that. No
category,
clarification, so
okay,
it goes,
pass. Pass. Okay, pass. I think we have 45 points remaining. So please go ahead.
So,
yeah, 45.
Fast forward करते हैं. Sir, withdrawal.
So next is secretary's report. After the finalized candidates are shown, finalized candidates for the election.
C type pen drive. AB.
By the time he's
Dr.
doing
Swati,
that-
by the time
he's
they get
doing-
ready,
I just
Swati
wanted
madam,
to
please
tell
go
you,
ahead.
you have to give instructions how to go about online voting. We are doing it for the first time.
We'll do that, madam. That we'll call the election committee to tell us.
So should I call them first till they get the Excel sheet? We can ask one of the online election process committee member to
Anybody is
talk
available
about
here?
the process.
Online election process? Who is here? Please call them.
Sanjeev Sharma sir, Pankaj sir or Rajesh.
Can I call all of them here? Dr. Sanjeev sir, Dr. Rajesh. One of you please explain to us. He will be able to finish the rest of the points. The rest of the points will go very fast actually. Because there are many all important points are there.
Good evening, everyone. we have selected Right to Vote platform for the online voting this year, and it will show all the candidates who are contesting for the post. Means president is not means it is unopposed, so president's name won't be seen, but vice president and executive members who will be contesting will be seen. And the things are very easy. And after you vote, cast your vote, you will also get an email saying you have voted to this person, and this will be only for you. No other person will be knowing that whom you have voted. So it is secret that way, but you should know, na, when you say that okay, I have voted X, it is not going to Y. So that is what Right to Vote will do for you. And whatever timeline we have framed, it's very easy process. I am 120% sure no one will face any problem, because when we conducted a mock election at Nagpur, we validated the right to vote. People voted online and people also voted on ballot. And what we had people, and this ballot people were at Nagpur, and they did in front of an advocate, so that people don't write something different name on ballot and do a different online voting. So we wanted to see that both matches perfectly. And we also took the receipt, and a few also had sent the video, and we could find that there was no disparity in voting by ballot as well as on online. So it was validated by the election committee. So we don't have any doubts about the vendor whom we have chosen. And the process, I honestly should tell you that we didn't explain how to vote. As soon as people received the link, it was so easy that vote, go to candidate, select and submit. So it's very, very easy. If anyone finds any problem, we will also give you a helpline, so that, or you can call me, anyone who really requires any help. So things can be done. And I'll share, sir. I'll share. So in that thing will be shared on email by Secretary, sir. And I believe it will so I just need to tell you should tell me what is the election time now. When I have to submit the entire names of the candidate to the person. In 1.5 hours, everything will be done. He will also inform me that everything is done online. You will receive the emails immediately after it is made. The election is made open.
Can you say around 9 p.m.?
Election committee will tell me the time which when it starts now and when it will end.
Okay, around 9 o'clock is okay? 9 o'clock is practicable?
I have to give the information to the people.
You give the information.
I'll tell you, sir. But by that time we discuss now, the online voting will start.
Just one comment.
It won't take much time.
Yes. The entire premise of online voting being done is to save the conference time to, it's like so now actually all these things means now they are us only. Now we are again needing to ask for them to raise, why couldn't this have been done earlier? That's the entire question actually.
Yeah.
Right.
Yeah.
So why are we wasting the conference time again?
Yeah, so
we lost in Kochi, we lost a lot of time for voting.
Yeah.
The same is going to happen to Chennai actually.
Yeah.
So 24 hours is a lot of time. All these things should have been done earlier. If it was decided earlier, means I think it was, were we waiting for the GBM to ratify that?
No.
Is it that?
No,
if that is that, then it's okay.
Yeah.
If it is not, it was pre-decided, all these things should have been done earlier. Let Chennai not suffer the fate that Kochi has.
See, recommendation can be done for next year.
Yeah.
Next year, see, what we are thinking is, and maybe election committee can help us. See, perhaps the election process can start earlier, and this amendment, we will be discussing this point subsequently.
Definitely.
Please be seated. We will be discussing this point.
Sure.
It will come at the right time.
President,
That time we will discuss
one,
about that.
one question.
We'll move on to the secretary.
Yeah,
Sir, please.
See, I agree about the online voting, but you should not send the result in the email that I have voted for so and so person.
So that is a part of verification. So only you will get. If you have sent, you
But
will
if
get.
somebody,
Nobody
you know,
else will-
somebody forces you, like I'm in an institute and my professor forces me to show me all the thing that you have voted.
Sir, can we move to this?
Shall we move to the next? No, your point is valid. Okay. Okay.
So this email is optional. We can deny this facility. That's not a problem at all. It is just for your verification, and this is perfect 100% optional. This can be stopped without no problem whatsoever.
Okay.
This can be stopped, Shyam. That's not an issue at all.
Okay. Okay. Sir, can you?
So what will happen is you will immediately get a mail that you have voted. That's it. That's it. And they won't not keep any record also of your transactions. That is also 100%. There is no ambiguity on that.
Okay.
Yeah.
See, we are using this platform from Delhi RIA and Breast Imaging Society for so many years. We don't get a mail. It just says you have voted.
Okay.
Yeah.
So
I
if you
think-
don't
No, they
require
have
want
given
the
the
email,
option.
we can cancel
we
it.
should not give the option of email.
Sure.
Only you have voted.
We don't exercise that option. We drop it.
Actually, only thing can be done is that mail can be sent that you have voted. That's all. That's all. This is the only thing. That is a confirmation that the such and such person has voted. That facility can be there.
Okay. Okay.
But not whom you have voted or what you have done.
Thank you, sir.
You have voted, that confirmation can send to the email. That's all.
Okay. Thank you, sir.
See, sir, that option is optional. Let me tell you why we took it in mock, because what happens is if
decided that we
No,
don't want it, so drop it now.
No.
Why are we prolonging the discussion
For-
unnecessarily?
Okay. Thank you. Next
right.
point, please.
All right. So even the secretary report has been circulated to all members on 31st December. So this is, I'll just quickly run through that just as a clarification if any. And I would like to, thank the entire executive committee. So whatever work that we have done over the last 1 year. So as a secretary, it was my job to communicate, but that does not mean I was the only one. All the executive have done good work so that all that is contained in the secretary report reflects that. Now, all these committees were very early, it was constituted so that whatever is required to be kept moving for the committee, for the society, it went on smoothly. And I would like to thank each and every member, the chair and the member of the various committees who have contributed in their capacity for all the recommendations that they have given. We were having regular meeting every month. So from March till date, we have held regular EC meetings, and most of them were again reviewed in subsequent meetings for any follow-up that required. So one of the major events that the EC took was the midterm CME. That was the that took place in Guwahati. So this was the inaugural. That is the first conference that was held by the Northeast chapter, which all of those who attended, you would agree that it was a fantastic one. I would like to thank the organizers of the Guwahati midterm who have come here. Thanks a lot. And there were around 311 registrations, 215 abstracts submitted, 72 had podium presentation, and we had 2 winners. It was the first time we introduced the pre-conference hands-on workshops. It was on 4 themes, and that was also well received. We also did live vertebroplasty workshop on a spine model, which was again well received and also recommended. We had a follow-up with the junior wing committee. They insisted that the thing has to be kept for the annual conference also. So tomorrow and on the day 4, there will be a live vertebroplasty workshop. So if you are not registered, please do register for that. And there was a memorial session that was held for Dr. Akash Handik and the Northeast chapter. They were even gracious enough to contribute towards the Akash Handik Memorial ISVR quiz. And I request the GBM to please approve the annual ISVR conference that is being held be in the name of Dr. Akash Handik. Moving to the next big event by the EC, that was 2026 annual conference, yes, which is going on, and day 1 and day 2 has been quite successful. Good the entire the room is full, and again there have been some feedback regarding the selection of faculty, many heartburns, telling that there are many juniors have been given, the seniors have missed few roles or given inappropriate role. We actually followed the mandate of the 2025 GBM, and which it requested, or it rather did give the mandate of the local organizing committee be given a free hand to to choose the faculty and the scientific program, and we did respect that in letter and spirit. So the entire exercise of identifying the faculty and planning the scientific program was entirely done by the local organizing team, with Dr. Deepa as a chair, and there are many other leads, and I think they have done a fantastic job in creating one of the good scientific programs. There is no doubt in that. Yes, some seniors' names were missed out, and some were not given the appropriate one, and I take the responsibility for that one. That's an oversight from my end. And there were total number of international faculties around 49, and total number of national faculty was around 300. So the total number of delegates that was registered 2 days back were 450. So altogether, I would say there were around 700 to 750 registration. This was beginning. And when I inquired now, the total registration number I am told is 1,100. So that's a fantastic registration. The other change that we thought of again was, why not make this as a working lunch rather than take a break where people go out for 1.5 hours, and then we struggle to get them back. So the idea was floated to have a working lunch, and yes, there are those who have approved that, or who are happy with that. There are a few who are disappointed, but I think overall the feedback that we have received and the EC members that have received is that was a good suggestion. And if just by the show of hand, is everybody happy with the bento box that was suggested by the organizing committee? I think that's good.
So this can be continued in the upcoming years.
So I think, so Dr. Deepa is here. Dr. Deepa? Yes, all right. So we also sent invitation to various international societies. So there were representation from the SIR, SIRSA, BSIR, APSVIR, the Korean Society, and also the SPIR. The BIMSTEC country we tried to cover, the Nepal, Bangladesh, of course, because of geopolitical reason, the Bangladesh we didn't get any representation from them. And even China, they have not come physically, but they would be joining online on day 3. We had a discussion when we represented at SIRSA. There was a discussion regarding involvement of Indian faculty in their program. So based on that, we also did send a feedback Google form to identify who are interested, and the 20 members, the name of 20 people were forwarded to the SIRSA, and we have requested them to select the best in whatever is possible, which fits in their scientific program. Also, there was a great move towards the labeling January 16th as the Global IR Day, which was again, it was taken forth by Dr. Sham. After coming back, he has worked on that. And also there was a proposal by the SIRSA president to discuss on the World Federation of IR. Sir, you can just quickly, in a minute, just tell what the discussion was which you had today.
Yeah, today in the global meeting, we proposed this having a World Federation of Interventional Radiology. And it was basically like an introductory discussion. And I think we have to keep discussing this year in various conferences. And overall, looked like it was a positive response from the international societies. And we have similar examples in many other societies like obstetric, World Federation of Anesthetists, World Federation of Neurosurgery. So when they are all having, why don't we also have? But to suddenly have this kind of networking, it will take time. And I think overall we are going to go in a forward direction. It may take maybe 1 year or 2 years to form proper guidelines. So this initial discussion was done, and even during the inaugural program, we requested the international leaders regarding the same. Thank you.
Thank you, sir. So another significant, as for the scientific progress, was developing the ISVIR guideline and consensus. So soon after the EC was formed, I would actually like to thank Dr. Kaurabi. She took the initiative. She formed the various the topics, and all the seniors were requested to be a lead. And we actually, there are 10 topics, out of which 3 have reached to their conclusion. That was reuse of single-use device guidelines, which got published a day on 6th January, so which was led by Dr. Shyam Kumar. Thank you, sir. That was a phenomenal work. Then ISVIR guidelines on mechanical thrombectomy. So this has also been submitted to JCIR, and it's under consideration for publication. And very recently, that was by Dr. Matthew Cherian, and on the last one, the benign thyroid nodule ablation consensus, that has been completed by Dr. Ashuballa and her team and has been submitted to JCIR. And there are work under progress. There has been discussion going on for geniculate artery, thyroid artery, trauma embolization, prostate artery, and fibroid. And I request all the team lead to take it forward. I know you have been working, but if you can complete it and keep this year as a target for publication, it would be another major achievement. So next, coming to the JC, sir, should I close it? Yes, yes.
So these are the final list of nominees for the different posts. The election will start at 12 midnight and finish by tomorrow 12 midnight. And so we can have the results in the morning, day after tomorrow.
See, one good thing today, all of you are sitting inside. Otherwise, by seeing the list, everybody would have gone for voting. You are all sitting here so that we can discuss important points for the society. Thank you. Thank you. All right.
Okay. Any volunteers, can you please get a cup of coffee to the President, Treasurer, and for me? Please.
And also others. Like, is it like that?
President, Treasurer, and me.
Okay, we request somebody to provide tea, coffee. For the
You can go out and have.
No. We'll give to the GBM and people
Sir,
sitting this side.
next agenda.
Okay, next agenda is Journal of Clinical Intervention Radiology. I request the editors, Dr. Naveen Kalra and Dr. Sanjeeva Kalwa. Can you kindly come off the stage? Dr. Sanjeeva, can you tell us about 2025? Can you tell us about 2025? How was the submission?
We don't have the data.
No,
I
like
don't have the slides.
Yeah, you can just tell in general. May I request you to tell in general?
Naveen is not here, but we were able to successfully publish 3 issues. One good achievement is that the number of submissions has increased compared to last year's. The more global representation of submissions, which is a good thing for us to know that JCR is considered a good journal across the world. So and then the rejection rate has increased, which is around 40% now. We would like to bring it up to probably 25% success rate. I mean, 75% rejection rate, that will be considered a very good journal. So right now we're at 50% rejection rate. Still we have a lot of case reports than original papers. So I request all DM students who are doing research in your institutions, please submit your thesis to JCIR. That will be a good service you could do to JCIR. And second request I have to all the members of this committee or the society is that we need more reviewers to review the manuscripts. It's very hard for us to get the input from the reviewers. There are only 45 or 50 reviewers for the journal, and we would like to get more people. So one request I can request all of you is all DM students, the minute they get IR DM, they should register as a reviewer. So they can learn how to review in the DM courses itself. So they continue the research methodology and they write good papers when they grow up. So that's all I have. Thank you.
I must say that Dr. Sanjeeva Kalwa and Dr. Naveen Kalra have been doing a great job, and it is a real honorary job. I request a big round of applause from everybody. Thank you, Sanjeeva.
So I think the names of the candidates have been announced. So do we just ask the candidates to come and
okay, should we listen to the candidates?
For 2 minutes. Can we put the slide?
Can you put the slides?
Not
yeah.
required.
Because some candidates may not be known to everybody. If they can just come and say hello to the GBM, it will be great. Okay.
So can we have the name? Yes.
Sir, I will start with Dr. Bejal, sir. You can thank them. And you can please tell us how you are going to take the society forwards.
I think that part hopefully will happen next year once your votes come in. And thank you all for acknowledging that So, like I mentioned in that only one message that I sent out to everyone was that I think it's time. I felt guilty that I was not giving back to the society. That has given me everything that I am today. So with that thought in mind, I thought that I must come and do my bit and try my best to take the group. But it will happen only with all of you together. Thank you.
Dr. M.C. Uttappa. So we'll go according to this order.
Thank you, my dear friends and colleagues. And it's a real pleasure that I stand before you, putting my name forward for the Vice President's post. I was actually telling people that I made the decision. I want to contribute more in the role. I will assure each one of you that I will do my best in my ability to deliver whatever is being put forward by the executive board and team. I have great vision for interventional radiology in India, and that was one of the reasons that I came back to India about 18 years back. And the last 18 years, I have seen interventional radiology grow immensely. And I want each one of us who are here and who are at home to feel extremely proud that we've chosen a profession which means a lot to patient care. I think there is a lot more that we can do collectively, and I humbly request that to vote judiciously and empower each one of us to be able to do a lot more for the society. So thank you for the opportunity, and long live the spirit of IR. Thank you.
Dr. Jawahar Rathod and Dr. Ajit Yadav next. Dr. Sanjay Kumar, I request you people to be in the front row. Please come. 1 minute, okay. So for this post, Vice President, since you have already given 2 minutes to Dr. Uttappa, it is fair to give 2 minutes to everybody. After that, 1 minute. Yeah.
Should I? Yeah. Good evening, respected seniors, colleagues and dear friends. I am Dr. Jawahar Rathod. I am professor and head at Government Medical College, Nagpur. I am head of the department. I am contesting for the post of Vice President. If given a chance, I will work with all my honesty and sincerity, as I believe in the teamwork, transparency, advocacy and student-centric activities. Thank you.
Dr. Ajit Yadav.
गुड इवनिंग जीबीएम। मेरा एक ही एजेंडा है, मैं वाइस प्रेसिडेंट के लिए खड़ा हूँ। अगर मैं जीता तो आप जीते, और मैं 24/7 365 डेज अवेलेबल रहूँगा आप सबके लिए। मेरा मोबाइल नंबर मेरी मेल में और आप सबको पता ही है। अगर मैं जीता, आप मुझे कभी भी फ़ोन कर सकते हैं, दिन हो चाहे रात हो। आई विल बी अवेलेबल फॉर ऑल ऑफ यू। थैंक यू।
Dr. Sanjeev Kumar.
Good evening all. I am Dr. Sanjeev Kumar from AIIMS New Delhi, and it's my privilege to stand before you. In my 17-year of journey through the intervention radiology, my approach was mainly patient-centric and enhancement of evidence-based medicine in the intervention radiology. I am actively involved in various activities of the state as well as national chapter of the ISVIRs, and I am also involved in various policy-making decisions of the ICMR and other Government of India bodies in shaping IR in the country. If given the opportunity to select as a Vice President of ISVR, I will definitely strengthen the academic activities of the society. I will support the young interventionalists and uphold the scientific excellence of the society. So request you all to please support me in my this endeavor. Thank you all for your opportunity.
Dr. Naveen Mulimani. After that, Dr. Yashwant Patidar, Dr. Leonard D'Souza, Dr. Lijesh Kumar. Please be seated in the front.
Hi, good evening all. Thank you, the entire ISVR. I'm a first time person who's contesting here. I'm Dr. Naveen Mulimani. I'm a professor and head at Department of Intervention Radiology at JNMC Belgaum. It's a tier 2 city from where I came, and I went there and I've started DM intervention as an academic program. I believe in just 2 proverbs: work is worship and together we grow. So my whole commitment will be for transparency, student-centric activities, basically for national and international education. So our people should be more competent as compared to the Western world. That is what I believe. Our trainees who are going to treat us in future should be more competent than what we are. That's what we should expect. And basically, if elected, I would fulfill all these duties. Thank you.
Dr. Yashwant Patidar.
Good evening, respected seniors and dear colleagues. Myself, Dr. Yashwant Patidar, professor at ILBS Hospital in Department of Intervention Radiology. I have experience of 18 years of IR service, and I am also a part of fellowship program successfully running since the 2011. So approx 14 years of fellowship program. I want to serve the society to empower the training program and young IRs and up to par of the international level. Humbly request you all to support and vote for me for the Joint Secretary post. I am contesting for the Joint Secretary post. Thank you.
Dr. Lennon D'Souza.
Good evening, everyone. My name is Dr. Lennon D'Souza. I am an associate professor of interventional radiology at Father Muller Hospital in Mangalore. I established interventional radiology at this hospital 8 years ago, and today we have moved on to 3 IRs in the same hospital, performing over 110 cath lab cases a month. And we are due to start the DM course. Recently, we were rewarded by our management by giving us a biplane cath lab with an IRCU that is an IR ICU, as most of you all are aware of. I am contesting for the post of Joint Secretary. I served in the Central Executive Committee last year, and I'm also Karnataka ISVIR Executive Committee member since the last 3 years. Since the last 1 year, I have worked with the Executive Committee, especially on the Ayushman scheme across different states in the country and other scheme related problems, but of course there is a long way to go for this. I want to continue working on these scheme related problems, and in addition to the Ayushman scheme, also with regard to the CGHS scheme as well, which needs a lot of fine tuning for the interventional radiology perspective. I also advocate that as a specialty, that we need more marketing and more ways that interventional radiology will be seen as a primary specialty by patients and by general public. And hopefully some of the work that was started last year with regard to marketing can see fruition this year. Thank you, and kindly consider me for Joint Secretary.
Dr. Lijesh Kumar.
Hi, those of you who don't know me, I am Dr. Lijesh Kumar. I work in Lisi Hospital, Kochi. I was the ex-secretary of Kerala ISVR and one of the organizing members of last ISVR Kochi, and contesting for the post of Joint Secretary. And vote for the best person, means whoever feels the most eligible for that, just vote for that. Thank you so much.
Now for Executive Committee member, Dr. Anil Kashi. We will go in this order. After that, Dr. Raj Kiran, Dr. Tara Prasad, Dr. Naveen Chandrasekhar.
I'm Professor Dr. Anil Kashi. I have experience of around 20 years, and currently I'm serving as a treasurer for ISVR APN Telangana, and I'm proud to say that with our collective effort, we were able to make big strides in terms of turf war, where we were able to fight with a particular fraternity for our own good in terms of our IR procedure, and we were able to successfully give a good result for the betterment of IR. And in the same vein, I would like to express that as a council member, if elected, I would like to scale up at a national level and make sure that there is an academic ownership and a strategic growth for interventional radiologists across the country. Thank you.
Dr. Raj Kiran.
Good evening, everyone. Myself, Dr. Raj Kiran Rathi, and I am Associate Professor at Dr. Ullas Patil Medical College, Jalgaon. I am doing my private practice at Akola, Maharashtra. Actually, I am contesting for the post of executive members. By now, you have all received the messages. Sorry for that disturbances. I am not running for the post. I am running for the society which has given me my identity. I am carrying the values of my mentor. He believes in working hard, and party hard also. As a given me a chance for an executive member, I will bridge the gap between the young IRs and the seniors, and I will like to carry your problems, your things to the committee members, and will try to solve them. Thank you so much.
Dr. Tara Prasad.
Good evening to all my respected
seniors and colleagues. So I am Dr. Tara Prasad Tripathi. I belong to Bhubaneswar, Odisha. I work as an assistant professor in AIIMS Bhubaneswar. So I belong to basically a traditionally low profile area for IR. So I have had the first hand experience of all the hardships that have to be faced to start IR in such a region. So I'll try to incorporate those experiences in the executive body, and will try to decentralize the IR to those small areas. And as we can see, the executive body has my teachers and teacher of my teachers, Bejal sir, Amar sir, they are teacher of my teachers. So I'd follow all the advices and try to be 100% committed to whatever work is assigned to me as executive committee member, and finish those assignments. Thank you.
Dr. Naveen Chandrasekhar.
Hello, good evening to everyone. I am Dr. Naveen Chandrasekhar. Presently, I am working as a consultant intervention radiologist at Gleneagles BGS Hospitals in Bangalore since last 3 years. And I love doing my work, that's intervention radiology, and to my full potential. So now I want to do something back for the society. That's where I can try and test my potential to work for the society as a young ISVIR. This is what I can do, so that please consider me for the post of executive committee member, so that I can tell next year what did I do for this present year. So please consider me, and thank you so much.
Dr. Rangarajan. Something different has come.
Incidentally, he's my mentor and guide also. So, hi, I'm Dr. Rangarajan. I was with the faculty at AIIMS Jodhpur, where I was teaching the interventional radiology students, and now I've recently moved to AIIMS Madurai to set up the department. I'm the first radiology faculty there. And if elected, I would like to improve the opportunities for the young IRs, which I have been advocating for the past years in the GBM, and would like to continue the transparency and also help in initiating some sustainability initiatives in ISVR, which we did conduct a survey also. So I was awarded the CIRSE Fellowship Grant, so I could observe the society a little bit. So the working of the society, basically it depends on a group of like-minded people, and that is what makes things happen. You just can see with all international societies. And for any questions in Tamil Nadu, we'll go to Thiruvalluvar. So I would like to quote him. So this is a Kural. A lot was discussed in the inaugural meeting also. Anbu arivu thethram ava inmai ava inmai innangum nangudayan காட்ட தெளிவு அன்பு அறிவு தேற்றம் அவாயின்மை இந்நான்கும் நன்குடையான் காட்ட தெளிவு. So how do you select a leadership? He should be a kind, wise leader with clarity and a mind free from avarice. So I would like all of you to vote for me. Thank you.
So before Jinish can come, we have with us Sai, who has been coordinating all the IT activities. So the badge is integrated with the scanner. For the sake of the attendance, he has got volunteers who within 2-3 minutes they will just scan. I know that most of you have signed, in case if you are not, and this will be just a digital documentation of the people who have been there in this hall. So please allow his team to just scan, so that all the names who have attended the GBM here will be documented. Thank you.
Dr. Jinish.
Good evening. I am myself Dr. Jinish. I did my MD from AIIMS Delhi, and from 2018 onwards I am working in Sri Chitra, now working as an additional professor in Sri Chitra, Trivandrum. So the previous experience, I was the Joint Secretary of Kerala ISVIR from 2023-24, and last year I was the executive member in ISVIR, National ISVIR. So last year I was able to help do some doing the guidelines for reuse devices, and also the part of newsletter. I was the editor of the newsletter ISVIR, and we published two editions, and the third is in pipeline. So I think if I get elected, next year my motto will be two things. One thing is to increase the social media awareness, because I think in the Kerala we have a very high good social media platform. So I'd like to bring that Kerala model to India, so that, because it's the one thing social media we lack, especially interventional radiology, and as told by the chief guest in the last meet, it's the social media, we need more social media awareness, and still it's already a proven model in Kerala. We all know that's a proven model in Kerala. I want to replicate that model to the Indian ISVIR. That's one thing. Second thing is to improve the research status, because that's one area we lack. I don't be able to do it completely, but if there is something we can improve the research status, that will bring India to forward for the international status of interventional radiology. Thank you.
Dr. Pawan Kumar.
Good evening, everyone. My name is Dr. Pawan, and most of the people know me. I am working in Goa, and now I am working with my startup. I have only one thing want to do for ISVR, especially for young people. If you see in metropolitan city and North India especially, the vascular part, arterial part, is going to the vascular surgery. 90% we already lost. So I am trying to that young IR should get that arterial work. So I am working for the aortic work from last 5 years. I am doing conference and master class. And I just want to do that vascular thing should remain with IR. Else if vascular will not remain, then IR is gone. That is only my work.
Dr. Purvi Malik.
Good evening, respected seniors and colleagues. My name is Dr. Purvi Malik. I'm working as a consultant interventional radiologist in a tier 3 city actually, in Ajmer, Rajasthan. So my candidature rests mainly on 2 points. I want to bridge the gap between the younger generations and the seniors, be it academic conferences or at any point and level, and to increase the representation of women in IR. Thank you.
Dr. Puneet Garg.
Good evening, everybody. I am Dr. Puneet Garg, and I am working as professor in Department of Radiology at Safdarjung Hospital. So I am doing my bit to spread awareness, to spread education in Delhi NCR region through conducting CMEs, workshops and all. And I can say that I may not be the brightest here, or I don't have extraordinary skills or personal achievements to brag about. So why should I contest this election? Because I am representing an institute which is more than 2,500 bedded hospital. We have a team of 10 IRs with different subspecialty, and everybody is equally encouraged and motivated to do their part and doing procedures. We are doing more than 2,500 procedures, DSA procedures per year. So I think for that reason I should represent them. I should be the face of my institute to be, contribute to the society.
Dr. Pritam Chatterjee.
Good evening, everyone. My name is Dr. Pritam Chatterjee. I am a senior consultant endovascular interventional radiology at Apollo Hospital, Chennai. I am the current secretary of Tamil Nadu Pondicherry chapter of ISVIR, and I hope all of you are having great time here in Mahabalipuram. I was instrumental in starting the fellowship program in interventional radiology at Apollo Hospitals almost 5-6 years back, and by God's grace, last year we got the approval for DRNB interventional radiology program, so we're starting, and we're doing a lot of work in Tamil Nadu for the young generation. I just have one question for all of you. Do you all love IR? Please raise your hand. Great, that's very great to know. So do you all love IR? I saw so many hands. Do you think all the IRs who are there should be doing IR? Yes or no? Please raise your hands. So I am standing for you all. I want all the IRs to continue to do IR work. So that's what is my motto. I want IRs to do IR work, not vascular surgeons, neurosurgeons, neurologists doing. So that is my motto. Please vote if you think I deserve it. Thank you very much.
Thank you. So one notice has come here. Election process will start at 12 midnight and will end at 12 midnight to tomorrow. Okay. We'll... Yeah.
Done?
We are done. We are done.
The last line has been read out.
Yeah.
Okay.
So we'll go
That was a welcome
continuation
report.
of the secretary
Yes,
report.
yes. Quickly, so there were digital initiatives initiated. One was the launch of IR Pulse e-newsletter, which Dr. Jinish has already mentioned. So I think that was a very good initiative from the present EC, and it has been well received. And I thank again Dr. Jinish for coordinating this effort and publishing 2 IR Pulse e-newsletter. And another achievement we had on the digital initiative was to have
audiovisual display has to come.
Sorry?
Audiovisual display has not come.
Oh, sorry. Can I have the presentation, please?
Audiovisual, can you show the presentation? Laptop from the podium.
So the another success was the having the own app of ISVIR. It was launched during the midterm. We are trying to build more features into that so that whatever is available on the website will be readily available even on the mobile. I just continue to say meanwhile. So even there was the membership till the last GBM, that the total number of life member was around 1,399, and so far we have received total of 177 applications, and that for 51 we have around for the life member, and around 66 new application for the student member. So if all those things has been evaluated and forwarded to the membership committee, and with the permission of the membership committee, it will be kept in front of the GBM, and if ratified, the total number of life member would be, or life/full member would be 1450, and total number of student membership would be 191. Of course, we will continue the drive of having more student member into the ISVR membership. So in the year we had around 15 endorsement done. So thank you all of them to all those who conducted the CMEs and workshops and got it endorsed by the ISVIR. So now quickly we can go to the treasurer's report. After that, Adarsh, you can be ready for the junior wing report.
I think this endorsing small CMEs or any activities you are conducting, it will be very nice, because that will show that it is a genuinely IR oriented course, as well as more ISVR members will come to know that such an activity is happening, because we can use the network of ISVR to disseminate the information. So it will be a win-win situation. So anybody who is going to conduct CMEs in the coming year, please ask for endorsement. As of now, we are not charging. Okay. We are doing it free. It's a service as of now. But I do know that certain society, they charge. You want to charge? No. Oh, okay.
There was a lot of halla about GST reduction by the central government. On that note only, we'll be presenting the financial report for the previous financial year actually. Just for the record, we are a national scientific not-for-profit association, and I'm going to be presenting the treasurer report. And the work taken up this year is that the maintenance of documents, accounts have been continued. One thing is good that now we're timely filing TDS and all the income tax, and I'm with the immense support of President Sir, Secretary Sir, and I would like to thank Gaurav, our executive, office executive, who's been doing the running around work, and Mr. Satish, our accountant, and the DAGA team from the CA team. Thanks to the support by the President Secretary, previously whoever treasurer used to come was communicating on his or her personal email ID. So now we have an official treasurer email ID of ISVIR Society, so that wherever I demit the office, that continuity maintains with the next treasurer, and that account handover can happen properly. As per the constitutional mandate, actively participating in the JCR activities, Lennon talked about the panel and the TP issues. We are doing that. And that GST thing, that was a big thing. And the last signatories were actually Suesh sir and Vimal sir for many years, and that was not updated. And even we had some problems with sponsorship this year as well. So finally, that has been changed. The current secretary and the treasurer are the new signatories. And hopefully, we have streamlined the process so that it happens every time whenever the secretary or the treasurer demits the office. So that's something that we've gone. In terms of the profit over the last 5 years for the society, this is self-explanatory in terms of how we have really grown, how the conferences have grown, and how our profit has also grown. So I'll be presenting the audited reports for the financial year ending March 31st, 2025. So that's kind of beyond my ambit, because that was the time when the previous EC was actually doing. But just for the record's sake, so these are the income and expenses for that financial year. The central head office had a profit of around 39 lakhs. Kochi conference, we had a profit of around 75 lakhs. And I think that's a good amount, and that really helped the ISVIR move forward. We got around 2,000 of profit from the Aurangabad conference. And one point I would like to highlight, we have the secretary and the treasurer for Delhi ISVR here in the GBM audience. Delhi branch has their own bank account, but they don't have the PAN card, and they have been using the central ISVR PAN card account. And so it is a lot of problem for us to really audit an account which we don't have access to. So I think I've been promised by Krishna sir and Ankur sir that I think hopefully this will happen this year. So the statement that we have from their side is that their income was 1.5 lakhs and the expense for their annual event was something like this, and a deficit of around 3 lakhs, which actually comes into our loss, the Central Society loss. So it gets difficult to really explain to the income tax authorities in terms of how that's happening. So that's one mismatch, and I think hopefully it will be corrected soon. This is the previous year, I'll just let it be. These are our 5 FDs our society has in different banks, and PNB, SBI, the major one. Security deposit is of a BSNL connection that we had the central office. We no longer using MTNL phone, so we have asked for that refund from the BSNL as well. So that will come. Certain points I wanted to highlight in front of the GBM is that we have these 2 accounts which we don't know who the signatories are. In the name of ISVIR, and probably it was open during the time of the conference. So we are in the process of really changing the signatories. We are filed legal affidavits in terms of the current ISVIR executive is this, and that's how we want to change. In terms of reaching out to us for any financial concerns or anything, now we have a dedicated email ID both for the treasurer as well as the accountant for the society. These are the contact details, and they can be contacted for any information. In terms of sponsorship fees, I think I can skip this in the interest of time, if that is okay from the GBM side. We will circulate this, okay? And so this was again Kochi conference, income and expenditure, different subheads, event expenses, hotel expenses, travel expenses, and what was the total income and the total expenditure. Same for Aurangabad, the midterm that happened last year, event expenses, travel expenses, and everything was done. Wanted to highlight this point. These are a few companies that have really not fulfilled their promises, what they promised to ISVR in terms of paying sponsorship fee for our annual conferences, and almost a big deficit of almost 57 lakhs that is due. We have spoken to them, we have shooted a lot of emails, secretariat, our office executive. I think we've got certain headway in terms of some of these companies will actually kind of by the end of this conference hopefully will pay a deficit amount from even previous years. GST, as I told you, we have really streamlined the process, and it took us a bit of time to really change the signatories, but that has happened now, so that process has been streamlined. And this was one topic that I think very close to previous treasurers' hearts. Rajesh Mundada sir is here. I think we had a big discussion in the EC as well in terms of the benefits of the Companies Act versus Societies Act. And I think so I will kind of skip this, but just a food for thought for all the GBM to really ponder over this if we really want to move ahead on this aspect of, it will help society in a lot many manner. Lot of other in terms of taxation benefits and all those things. So because it was not as an agenda point, so we'll skip this, just a food for thought for the GBM. That's it from my side. Thank you so much. Any queries? Thanks.
Have you loaded your presentation there? Can we have on the screen, please?
So, good evening everyone. So, I am Dr. Adarsh Kumar and I will be presenting the work we have done as ISVIR Junior Wing 2025. So, this was a Junior Wing committee comprising of myself, Dr. Ujjwal, Seetam, Rajat, Shreya, Apratim, Pooja and Vikas. So, actually we were preceded by a wonderful previous Junior Wing who has actually laid down the foundation on which we could build upon. So initially we started with our master classes, so we were able to conduct master classes on the MSK, the PAD, the venous intervention with additional sessions of senior junior interactive sessions and international insight series, and we were also able to conduct a special manuscript writing session. So this is a summary of all the master classes that we have conducted during our tenure. And these were the 6 international insight series master classes that we had conducted with speakers and niche topics. And these were 3 senior junior sessions in which there was a presentation by a junior fellow or a resident and moderated by a senior faculty, and it was received much of positive response from the trainees. And also we were able to conduct a panel discussion on SFA intervention between 2 faculties. This is just a summary of the analytics. Over the past year, we have seen that almost 9% increase in views was there compared to the previous year, and a total of 16% increase in the watch time. And we have had new subscribers, almost 124 to our channel. In addition, we had created a group, a WhatsApp group for early career IRs, in which we used to actively post the ongoing live masterclasses, and we have observed that with this, we were able to increase the mean participation also. And we were also able to get constructive feedback through this WhatsApp group and also share academic activities, including various journal articles and also any workshops that were planned. We were actively rethinking about the teaching. We had conducted a survey in which the respondents actually were interested in the interactive Q&A sessions, the peer-led sessions, simulation-based teachings and problem-solving workshops, based on which we had conducted the senior junior sessions and the International Insight series. And we had also conducted a special manuscript writing session under the guidance of Dr. Naveen Kaldar sir, Dr. Sanjeeva Kaldar sir, Dr. Shyam Kumar sir, Dr. Harish Bijade sir, and Dr. Kamal Kishore. We were also able to conduct hands-on workshops in 3 times in Delhi and once in Mumbai. And all these workshops were done with flow models as well as including Mentis simulators and short theoretical concepts and also cath lab training. These are just snippets from those workshops. And we had actually taken a survey regarding what the participants actually found most useful. They were the interactive sessions, the practical demonstration, and the procedural knowledge. The suggestions we received were to continue these workshops, more of case-based learning, to expand the content, and interactive and hardware-focused workshops. Last month, we were able to conduct an ISVR Junior Wing IR challenge for the MD and DNB residents to increase their interest towards IR. Total of 100 participants were there as 50 teams, which was conducted on AHA Slides and Zoom. And these were the winners. The first and third places were from PGI, and the second from Army Hospital R&R. Dr. Seetham also represented us at CIRSI for the IR Junior Global Summit that was held and interacted with various junior wings across the globe. So under the mentorship of the Junior Wing Executive, we were able to execute different activities, including patient information sheets, disease-specific consent forms, 2 surveys, including IR Sustainability Survey and Insurance Survey, and 2 which are in pipeline are the clinician information sheets and a drug handbook for the early trainee IRs. So,
can you go back to this? Yes. I think all of them, they deserve a big round of applause. Because this is fantastic effort. Creating the patient information sheets and doing a IR sustainability survey, clinical information sheet. I think all of us practicing IR at our level, we definitely would not have been achieved what these junior guys have achieved. Thank you so much.
So this was the patient information sheet. It is actually a 200-page booklet that encompasses various procedures, almost 40 to 50 procedures, in which there is a questionnaire like patients, the frequently asked questions and an answer with schematic diagrams on various procedures. This will be made available through the site in a Word format also, so that everyone can download and use it. And we have also devised various disease-specific consent forms pertinent to nearly 50 procedures. This will also be made available in a Word format so that it can be converted to the local language and can be used across different regions. The clinician information sheets are still in the pipeline, so this is just, we were planning to these are the one sample sheet that we have devised in which certain niche procedures, a summary of the indication, the preparation, the key steps, the equipment, risks, the post-procedure for more clinician awareness, especially when moving towards Tier 2 and Tier 3 cities. So this was the IR sustainability survey which we conducted to assess the energy utilization practices, the waste disposal practices and the water consumption practices across centers. And this manuscript has been written and we have submitted it for peer review. So this was another IR related procedural codes and utilization, just like we were discussing in the other hall. We were able to conduct a survey and there were various drawbacks which we found related to the IR procedural codes and their utilization, which we have handed over to the insurance subcommittee. And for this conference, we have actually collected certain How I Do It videos from nearly 10 faculties. So this will be displayed in the monitor outside the hall. So we are grateful to all the faculties who have actually contributed to our How I Do It videos. And these are actually, I'll highly recommend everyone to have a look. These are just wonderful videos. And all this, we are very grateful to the Junior Wing Executive Committee group, including Dr. Amar sir, Nitin sir, Shyam Kumar sir, Amarinder sir, Lennon sir, and Rangaraj sir. They were constantly helping us throughout all our activities and regularly monitoring the progress. So just coming to the last slide on funding, totally we had a Canva subscription amounting to 4,000 and our slides amounting to 800, so which we have split among the 8 of our members. Zoom link was received from the ISVR Secretariat, and for the ISVR Junior Wing IR Challenge Head for MD and DNB residents, the ISVR, we are very grateful that the ISVR offered a gift voucher of 30,000 and free registration and accommodation for all the participants. And the funding for all the Junior Wing workshops was based on an MOU between the ISVR and the sponsoring companies. So that's it from our end. Thank you.
Thank you so much. So, moving to the next one. So we had opened a circulated Google form for representation, seeking any comments from the members, and there were almost 90 responses that had come. So all those 90 responses that we received, it was all compiled, and those which felt that it needs to be put in front of the GBM, I had circulated that again with the Secretary's remark. So we'll quickly go through that. So whatever the GBM mandates us, the next Executive Council, the committee will work on that. So the first point, anyway, let me start. It is by Shyam Kumar sir. So because the President wanted to have his suggestions in the beginning. So the first point would be from the President regarding the ISVR Central and State Committee Council. So till it's connected, you can just start mentioning about state.
Okay, actually we took a role model of IRIA for connecting among the state chapters. And some chapters are having innovative ideas, whereas that idea may not be available for somebody else. So linking all the state chapters together, in summary, it is a president, secretary of all chapters, and EC members, and newsletter editor, and journal editor. So these people we want to put together and make one group, and they can have probably online meetings once in a month or so, according to the suitability. And so this is the suggestion what I'm having. And is it okay? Okay. Raise of hands. Okay. Thank you. So is it approved? Okay. 2 hands. Okay. Thank you.
Okay. I don't know. There's some AV issues. The second one is by Shyam Kumar sir on ISVIR ref.
Okay. Regarding educational wing, ISVR ref, the chairman post was not filled for some time. So this year we had a meeting in the EC and we got a suggestion. We got the name suggested Dr. Ashuballa as a chairman of ISVR ref. Is she here? Okay. All right. Thank you, Dr. Ashuballa. So she can make a group of people and make a plan for 2026.
Is this seen without putting it full screen? Okay, so the third agenda point would be again from Shyam sir for regarding ISVIR legal counsel. Legal counsel.
So a lot of my points are coming. Other is to have a legal person with us so that whenever there is a need, we know whom to approach. Others will be searching at that time. So if you have some legal person with us and you pay some amount of token money, whether there is a case to file or not, or case to fight against it or not, we have one person. Is that okay?
Hello?
Pass? Okay, pass.
I'm so sorry, this, they're not able to project
You
that.
want to check the other podium?
The fourth,
Is it?
the fourth one, sir.
Please go ahead. You want to take a mic? You can speak to the mic.
My suggestion is that instead of paying something to someone, whether the case is there or not there, just have an empaneled 1 or 2 or 3 people. You will get empaneled people. And we pay them as and when the case occurs, if at all a case occurs.
So there are two different suggestions, whether to have a person regularly or... So what we can do is we can give it to the rules committee, upcoming rules committee, they can look into that. Or upcoming EC can decide whatever is practicable to them. Is that all right? Mhm. Okay. Okay. So what we have done is, when this idea came, EC took a small decision of keeping someone's name as a temporary for the last 2-3 months. Then we thought we'll put forth in front of GBM and they take a call. So Dr. Naveen, can you tell, sorry, Dr. Nitin, can you tell us? Okay. Dr. Jignesh, can you tell us about that? Why did you propose that?
There's a brief story behind this. Actually, we fought a case against a urologist who was doing PAE, and he wanted to do workshop hands-on training for PAE to urologists. So when we fought this case, and there were representations in front of the medical council, which is a legal statutory body. So we didn't have any legal help. So we were talking to our friends and all this. We didn't have a correct person. So it was a struggle, and then we finally found out one nice chap. So we went there. And because our legal points were fine, and when the other person saw that, he withdrew the case, and he wrote an affidavit that he won't do the procedure, he won't do the workshop, and this will not be repeated. So we could cut this thing at the earliest. And after this, the council also gave us the affidavit, and then we circulated. So this is the time when we thought, when I spoke to Dr. Nitin Shetty, and he said that we do not have a legal help for the ISVR. There's no legal counsel for ISVR, like how a chartered accountant will be there for accounting. And that's why I wanted to propose that the national body for the betterment and this legal help needs to have one legal counsel.
So what is the financial implication there that the society will have to bear?
Yeah, so when we spoke to the company which had pan-India presence, and then even the EC discussed with them, so the main motive for the company was to have an association with this medical body, because they are associated with many corporate hospitals. And their main motive was not about money. They wanted a very basic fees to appoint one of their junior counsel to be on contact with everyone. But when there is a particular case against one doctor, like medico-legal or something, the charge would be separate only on that. But otherwise, for a generalized help and reviewing, drafting, pan-India, including in any state council, would be free of charge, and that includes this fees, and they were ready to take 15 to 18,000 per month. It was coming below 2 lakhs per year. So, but the money was not...
What does the GBM feel? Should we, with Ridesh sir, your submission, you wanted this clarified.
So if I can also add, sir, as I would agree with sir in terms of financial implications, to hire someone will be slightly a bit of financial implication, versus we can always choose as impaneled lawyers, because see, right now we may feel like, as he's saying, कि एक junior lawyer को junior उसको appoint कर देंगे. So we really do not know how that person will...
No. The junior lawyer will be appointed by the firm, but the firm will take all the decisions.
I'm saying that let whoever is, we're totally okay with fighting whatever amount, if we need to go to Supreme Court also. That is my opinion. I'm saying not as a treasurer capacity. But if you're looking at financial implications, I would agree with sir what he's saying, to have an impaneled group of lawyers, and then maybe let the EC take a call on that, whichever, depending on what need arises, you can take a call on that.
Yeah. The final motive should be that we need to have a legal counsel.
Shall I suggest something? we will empower the EC to take a decision for 2026. If they can get somebody as a panel without paying, well and good. If they are not able to get that, they can think of second option of keeping somebody with a low amount of fee. Is that all right?
Yes.
Okay. Let the EC take a call.
I'll just add one last thing. We all know lawyers. Lawyers are professionals. They charge per hour, per case.
No problem.
Correct? Yeah. Any amount you give, and the statement that they would pan India for any member, they will do free drafting. No, let's just listen to me. Is not. I mean, it's not true to the world today. Okay?
Okay.
So
okay.
that's
Thank
it.
you. Thank you.
Okay.
So you
moving on
can
to
minute
the-
saying that EC will take a decision
Yes.
for the coming year.
Next is Dr. Lijesh here. So, this is regarding the revenue. If there is any revenue generation that happens from a conference, the suggestion is to give part of it to the state chapter. So,
shall we revisit when he comes here?
All right.
Okay, we'll go to the next one.
Perhaps someone can just pass the message.
Somebody
that
can call
Dr.
Dr.
Lijesh's
Lijesh.
point is being discussed. Sorry. So then, this was Chandra Mohan sir's. That's online voting. That part is sorted. There's representation from many members from the forces, and even I had few mails received by them regarding the nomination of one armed force representative in the executive council. And yes, there was a signed proposal and seconded by Ajit and seconded by Dr. Arun Gupta, that was received by the Secretariat.
So the basic agenda was to increase the seats of ECM, because now it is a grown society. The 5 we can't represent the whole of a country. We should increase the seat of ECM from 5 to 8.
No,
And
this is for the first one, the point number 6, that is the armed forces.
Oh, so that was 2 agenda was mixed in one. So and out of 8, 7 is going to be for election and 1 is nominated by the defense. And the defense nominations we can ask all the defense person. They will nominate one person for ECM every year, and we are going to include that defense IR in our, because defense is not related with any state. So they are central members of IR. So we are going to, we don't want any election for them. We want key nomination should be done from their side only.
This practice is already there with IRA. It's nothing new because we don't have a state. We are on transferable jobs. So we are a corpus of almost, I think, 30 plus intervention radiologists as one core. And the numbers are going to increase. So we would like to have a small core group in which we will represent one person who will take this IR activity in the armed forces also.
So what's the next step, sir? So this will be amendment of the constitution, or what? How do you proceed from this? Just for documenting. So the amendment now we have to give it to rules committee, which will, and we can ratify it in the midterm also, so that it comes into force by the 27. So this recommendation will give to the rules committee, so they will just approve that, and then in the midterm GBM we can call for a special business meeting and approve that, so that, and ratify that, so that 27 this can be in practice. Is it okay?
For another year, but that's not a problem. It would not
No,
start
but
the
anyway, we
special.
can't take,
No,
see, 27
but don't start the extraordinary GBM in the midterm, because this is not the whole of the members are not going to be there. So don't start the the normal agendas to be put in extraordinary GBM. I think extraordinary GBM is just for the extraordinary circumstances. So this is not an extraordinary circumstance. We can wait for another year. That's not a problem. If you want to send it to rule, I have put that the amendment clearly. If you want to pass into GBM, there is no need of rule committee in that, because it's an amendment that include one nomination and for increase the member from 5 to 8. If GBM is going to pass here, what is the role of the rule committee in that? It's a clearly written.
Dr. Ajit, point well taken, but then if you are adding one member extra, nobody is against this one. What I am saying is that if we are adding one member, let us just go through the rules committee and get it ratified. There is, at the end, for whatever has to happen, it will happen. We can't have for this year. Whatever has to be done is for 27. So let us just do it fast.
Right. So try to understand. Everybody want everything to be passed, and he has put this name. The only message Ajit wants to give, that extraordinary GBM should be for the extraordinary matter. For the
Agreed.
future,
So we have,
let me complete.
So we have Kamal Pathak sir here, so we'll ask from him whether without going through the rules committee, whether it is applicable. I mean, whether we can accept that. So
no, I am not saying you go through the proper rule. And
okay, you are saying that ratify in the next GBM.
Yes,
okay,
yes.
Right.
So extraordinary GBM should not be there for this point. This will create a wrong precedence for the future. Right?
Point
We should look for 10 years.
All right, so then it is passed. Point number 7. No, we need to. No, we have to forward it. No, the EC has to forward it. Okay, next point we can just, it's in a similar line and it can increase ECM seat. That's for the same thing, no? This point that you mentioned. Okay, then Sanjeev Kumar has got a proposal for creation of nominated post. Please, Sanjeev. Women National Representative.
Yeah, so over the period of years, what I feel is that there is an underrepresentation of ISVR, especially in the international communities like SIR, HERSI or APC VIR, where most of the members actually from the ECMs are mainly the male members and hence they represent the country. But I really feel the need for a female nominated representative. We may not add a seat which needs a ECM, or they may not be a part of ECM, but just a national representative, female representative, who could represent in every part of these conferences along with the ECM members. Like a president, secretary, treasurer, they usually represent this, the ISVR at different forums. So she could be part of that, and that could be done based on the merit basis. We can ask nomination from the interested female, and then a group or a committee or someone can decide on who should be selected. That's my suggestion, and this is really come up because there were multiple discussions with
Dr.
female
Sanjeev,
colleagues.
if you can raise the mic, please.
There were actually multiple discussions from the female colleagues, and they said that they, because of their duties and home responsibility and along with the professional responsibilities, they are many times not able to come to the election process and all those. So this will really make them easier and have a woman representative who will represent the national ISVR in all the forums. Thank you.
So what's the final conclusion of this agenda point, sir?
So will this be coming through the election? Because it is written as a nominated post.
So I think this same point was, the point is well taken, and I think it's a very positive note. In the GBM, I remember in the Goa, the same.
So no voting rights basically. So one women representative in the EC, no voting rights. That's what it's being told.
So just to clarify that in the Goa GBM, the same point was raised, and with all the females IR, it was asked to them whether they want a reservation for that, and all the females in that GBM said we don't want reservation. Just to remind us.
Okay.
Not against. I totally agree.
Totally right that was raised in the Goa GBM, but that was actually a reserve post in the ECM. That was not a nominated post, and most of the females who were sitting there, they said that they don't require any reserve post in the ECM. So this is not about the reserve post. This is just a woman who represent the national ISVR in all the forum, and that is the need, I think, because when I talk to many of my colleagues, actually, they also feel the same thing. So I just request everyone and all the GBM to please.
But for which post do you suggest? Is it EC
be,
member or
it will
the
only be a nominated
only a
post.
representative. It cannot be part of the EC. So we can
She
have.
will not be the part of EC, but she could be a representative in different international forums.
How do we select them?
Sir, it could be asked on the nomination basis.
Only if there are no females in that EC, then it can be. If there are two, then.
But there will be separate election for that also, sir.
No,
there will be separate election.
This represent on self.
Yeah.
But why not we encourage our female IRs to go for the nominations and go for the election. Now they're online election. They don't have to come to the conference. So they, if she is working also,
Swati madam.
yes.
I don't think we need nomination and all that.
Okay. Rajesh sir, next.
Sir, for the smooth transition, as we have a post of president-elect, why not additional post of secretary-elect? For the smooth transition in the society, we have taken a post of president-elect. So why not secretary-elect? Because he has to understand. Why not? Why not? See, the thing is that suddenly what happens is, next year when a person comes to a post, he doesn't understand the functioning of the society. So, if we have taken a secretary for 2 years,
make it 1
so,
year.
No.
Really?
No.
Then it will make sense to have an additional elect.
Why I honestly feel that the society should run properly. 2 years is perfect. But then a year before, a secretary-elect post, a treasurer-elect post, it makes lot of sense because they have to understand. And smooth transition is mandatory. Otherwise, again, there is a gap of 1 big year to understand. If someone doesn't tell, it becomes a big problem.
I have a suggestion for this problem. You have 2 posts of joint secretary, no?
Yes.
In that, make 1 joint secretary and another joint secretary for in bracket secretary-elect. Finished. That person automatically becomes secretary next year, so that you don't have to have 1 more post created, amending the constitution and all those things. You can do that.
That's why going to election. Which one is going to be the
That you have to write. Instead of 2 joint secretaries, you say 1 post is joint secretary and or make 1 as secretary-elect, another becomes joint secretary.
Thank you. Dr. Pankaj.
President sir, what we can do is the secretary who has completed 2 years tenure, he can be part of the executive for next 1 year and he can guide the next secretary. That's what we do in IRA also. Once we have completed 2 years tenure, next year we are part of the 1 year of the executive.
It's correct.
Because you cannot take the rights of the secretary. And because if you make a secretary elect, the secretary cannot work independently.
Dr. Pankaj's point well taken. I think we'll keep defer this one, please.
But I think it's a good choice because whenever we president elect भी अगर हम बना रहे हैं तो उसको हमने क्या right अभी हमने देखा था ना, he has no capacity to vote, he has just as observer in the ECM. So similarly secretary elect is going to be the same. So rather than having secretary elect an additional post, we can have a immediate past secretary as a part of ECM with the same rights. He can guide the secretary. Why to create an additional post?
So
you don't have to worry about.
I think most of the administrative related everything it can be given by the president. I think as a secretary we would not be giving anything more. That's what I feel. But I think that transition, because of the president elect, it is going to be smooth because he would be knowing all the matters that has been come to the committee and all the decision that has been taken. So that would be a smooth. President elect is a sensible decision, and this is okay, sir. Let it.
Same thing. Immediate past president we can include in the executive. I think that is the sensible decision.
He is anyway there. Immediate past president is anyway there.
No, immediate past secretary.
Sorry.
I think that we can include.
10th point go jate, sir. 10th point. That was Balaji. Yes, sorry.
Yeah, Dr. Nitin, I had 2 points, but you have put only 1 point. So one of it is
as received. So point number 10 we'll address, sir. If it is come later on, then we'll address at that time.
It was not there because I have searched the entire thing.
Whatever has been received, everything has been.
I have submitted. I have discussed with you also, if you remember.
So we can see that as an additional point if it's to be taken.
I'll tell. So sir, President sir, as I request that, representation should be from all over India. It should not be allocated to only one part of India. So we all feel that, it has to be, the important posts have to be rotated. We can divide into north, east, west and central, and then we can divide this like one year it will come from north, 1 year it will come from east. Can we please do that?
So, but all right, okay. Thank you.
Yeah, there was one more point, sir. Like I've discussed with you, if you remember, the earning of each conference, I said I requested that 20% to be sidelined before spending, 15% to be given to the central committee and 5% to be given to the state committee. Is it okay?
No, 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 please, let everybody understand the implication. That was Lijesh's point also, but we need to take, I mean, before spending to give would become difficult. So whatever is on the earning, the floor can take a decision, if at all, if something has to be passed. But before Dr. Balaji, it would be difficult. How much? Because real-time variation can always happen during the conference.
At present, do we have any provision of giving it to the state chapter?
No, we don't.
No,
That's
we don't
why-
know. So I think
let's
not.
See, that is a point given by Dr. Lijesh also. So you are waiting for him to come back, then we can discuss it together. Yes, sir, please.
I don't know when this point has been amended, but the earlier guideline was the conference proceeds, whatever is the balance amount. After making a statement of closure of account, the entire amount had to be submitted to the center, and from out of that, 25% would be given back to the state. That was the thing. So the entire 100% of the amount goes to the center. Center allocates remaining balance, if any. From out of that, 25% will go to the concerned state branch, whichever has held the conference.
Okay. Thank you, sir.
So I think long back it was decided by the ISVR that the central committee will take the responsibilities of the conferences, and the concept of that any state chapter is doing has already been gone. Thus all the conferences are taken care by the central committee.
All right.
Thank you.
So, next point, sir, your proposal to have 2 national orations during the annual conference.
Okay, so this one, I am suggesting mainly because currently we have 1 national oration, and our society has grown large, and there are so many eminent teachers, and I think it's the right time that we increase 1 oration to 2 national orations. Currently, we have 1 national, 1 international, and I was just looking at our umbrella society, IRIA, where we have, Dr. Pankaj, we can tell how many orations you have?
Sir, we have 6 in IRA and 2 in ICR, but this year, from this year, it will be reduced to 50%, 4 orations.
4 orations, yeah. Okay. So this is a proposal. Anybody would like to?
Sir, we can have 2, sir. So now the members have increased, so please.
Yes, sir. Yes, sir. Okay. Yes, sir. That's true. Okay.
So we have the next proposal, sir. So what you're telling is very much in line with the point number 12. We have Anirudh sir's proposal. Sir, proposal to have a national oration in the memory of late Dr. Deeptiman Roy.
Most of the members know him, and he was involved, Deeptiman Roy was involved in training a lot of people. He was also one of the founder members of the Interventional Radiology Division at Tata Memorial Hospital. So this is my proposal. It's up to the
That
committee.
is the
national oration in his name.
Ramurthy sir, you told it has to be some amount to be given to the central committees. Okay.
President sir, I want to make one request. Like last evening, we had so coveted national and international oration, and starting at 8:15 until 9:30, and nobody was there in the hall. I would suggest that these orations are conducted in the day when people are there. Conducting after the inauguration function is not paying due respect to the orators.
Point taken, sir. I think that's what we have also discussed. I think it was too late yesterday for the oration to begin. Right.
So regarding point number 12.
So if that proposal of 12 is okay, then the proposal 11 also will get activated then.
Yeah, both are connected to each other. Sir, please go ahead, sir.
In the institutions also, we have more than 1 oration because there are several departments. And the guideline, at least in my institution, is for an oration, that concerned department or whoever is sort of proposing that should deposited an amount of 10 lakhs. For instituting a gold medal, the deposit is about 5 lakhs. So that's how the orations beyond the society or the institutions go. So as part of society, we have one national, one international. Any new oration you want to give it on someone's name, I think ideally speaking, there should be some kind of a corpus amount created. And from out of that interest is when, you make those medals or certificates or whatever it is. That's how it's usually done.
So, yeah. So the Maharashtra state chapter will have to give the corpus for this.
Because there are financial implications in terms of their travel and all those things as well.
So that's what they are giving the corpus. That's what. Yes. The travel will come through that one. The one which once they give the corpus, from that it will come.
So actually we, Chandigarh, Punjab and Himachal Pradesh chapter, we have started the oration. We have our local GBM 2 years back, and then we decided to start the state chapter oration. So the amount which is the financial all thing is given by the state chapter. Otherwise, in the name of the oration, there has to be the corpus. And just I am announcing this. So this year we are going to Dr. Bejal. So I think Bejal sir is here. So we have a conference in 7th and 8th February, and this year we are giving state oration to Dr. Bejal sir. Thank you.
So moving to the next point, Matthew sir and Dr. Pushpinder had this regarding the selection of venue. So, Pushpinder. So the proposal is to have the national conference close to the main city or the airport so that the travel part becomes easier and also to avoid resorts.
Yeah, so I think point is very clear. I think it took us about 1.5 or maybe about 2 hours here, and in Goa it took almost 2.5 hours. So logistic wise, it's easier for the managing team to make the things ready closer to a city for traveling purpose also, especially for people who have a connecting flight. So they first come to a major city like Delhi or Mumbai and then come to the city of the conference, and then further road trip is there. So that's my personal opinion, but they can be.
He's behind you. Sorry.
Dr. Shuru.
So I knew that Pushpinder will raise this topic this year. That's why next year's has been posted 15 minutes from the airport and in a conference venue which is not a resort.
Perfect. I already met the criteria. Lijeshka. So we discussed that along with this one, Balaji's point. So what was the, I think Dr. Arun did mention that it was already decided, it was decided that the central committee would be taking care of the funding and everything, and so we have not resolved that issue whether, if anything has to go back, that is after the revenue, we know how much has been spent and what is remaining, and we have still not decided upon the percentage that needs to go to the state.
But there it will definitely be there, right? Because last time, after ISVIR
we have not concluded on that one. So.
Because after ISVIR India, we could not go back to the industry to ask for ISVIR Kerala annual conference. So we conducted that in a very small shed. Nothing was there. So I think the city that organizes a national conference should be compensated for organizing that, because it's
point taken.
Yes.
But we don't know how to come at the percentage or figure. Abhishek, any idea?
Actually, I think it should be both ways. If there is a loss, then the state should bear it. It should be. I think
I'm sure we had
sir,
profit.
Not your
Yes.
case, sir. Not
So,
your. I showed the treasure report. I'm not talking about your case, but there have been instances, sir, when there have been loss and center has faced the brunt of it. So I think Yeah, Malab,
It should be fair. Yeah, agreed. I agree.
No,
with you.
just
But the
just
percentage,
formulate.
can we decide now, or you want some time
Just
to decide?
formulate a guideline and just stick to that.
No, it's already there.
So I think we are okay with the
I think it's
giving.
already there in the constitution, and if you can see in the constitution,
The
it is,
percentage has
yeah,
to be
percentage
decided.
also given, 75% of the total, whatever the profit is goes to center and 25% is
No,
goes
now
to
the
the state.
situation is reversed, right?
No, no.
So I
So
think
that-
Dr. Arun did confirm that, it is.
So see, at present, there is no state chapter who is conducting the conference. If we are doing the Delhi, it doesn't mean the Delhi chapter is doing, or is doing Calcutta. So so it is the central committee. So there should be no division of the money to the state chapter. So if you can decide that yes, for compensation, do you want to give us some seed money for there, that's still.
No, but if in the future we are asking for the state chapters to apply for the national conference, that means we are inviting them, so that we have to give the money.
But Dr. Arun just clarified, no, that it will be
that-
central who will
sir,
be
that,
applying.
that we decided in 2018, because at that time there were very less state chapter was there, but now we have more than 16 state chapters. So now again we can revisit that rule.
So we'll send it back to the rules committee and see whether it is required. I learned few things from Dr. Ajit. Thank you for that. So please.
So, Dr. Uttappa, I just wanted to share the experience from Karnataka and see if that helps the GBM to make a decision. The point was when Karnataka chapter was formed under the leadership of Dr. Indushekar, and we did the conference in 2016, that time the onus on raising the funds was very much from the state body. And we had never done a national conference. So when we did it, we were able to raise funds. And from the saving, the central committee allotted us based on what Ramuti sir just alluded to. So that actually gave us a huge boost to the society to start doing some academic events. So I think it's a very good idea for the effort which the state body does from the saving to give a percentage. And that was already there. Now, why it was changed was the following year when the conference was held,
No, I think, sir, it was all after like Dr. Arun Gupta mentioned, it was already discussed in the GBM, and it was decided that central will take. So, there's a suggestion to revisit, so
I think it's a very good idea, and I think we should strongly propose that. Yeah, thank you.
So, Karthik?
Yeah.
Yes.
Yeah. Last comment
So
by
next one
Dr.
for
Pankaj.
Puneet Garg, are you there?
Sir, yeah. Dr. Pankaj, last comment. After that, it will go to Rules Committee.
Sir, sir, what Abhishek said, it has happened in many societies. So what was it happened in IRA also. So how it was safeguarded was that whatever the collection is done in IRA, 13% of that has to come as profit. Suppose 8 crore is collected, so 13% has to be come back as profit to society, and then so it safeguards that whoever is organizing, they take care that whatever monies they collected, a percentage has to come as profit.
So, sir,
one more.
Okay, last comment by.
Sir, if I can just add, I think to the rules committee, you can recommend for both midterm and as well as annual, sir.
We'll do that. We'll do that.
So, sir, with the president's permission, can I just take a quick break? Abhishek, please continue. I'll be back in 2 minutes.
Okay. What about break for others?
They don't have to leave the podium. No. Puneet, please tell fast and.
Sir, PA.
So, President Sir, in my humble request, I would like to say that if an institute wants to conduct an independent CME or a conference, so I would like to say that maybe Central ISVR can give some seed money, because this is a practical problem that I've faced a couple of times, where the funds and the sponsorship come after the conference, and there are certain expenses which you have to pay to the vendors. Before the conference or at the time of the conference, like hotel accommodation and everything. So that will give us encouragement and the confidence that yes, we can pull it through. And so that's why I was just saying if some seed money can be given, and I've already written here that what can be the modus operandi for this.
Sure. Anyone else would like to comment regarding this point?
Sir, if I may just add, I think from, your case, you have been organizing such big conferences in Delhi and they have been huge success. But if we generalize that for the whole society, sir, there may be someone who may not be able to even return that seed money back to the society.
Then affidavit can be, I have written, affidavit can be signed, like it should be made a legal document. Because I think 6 months back, Abhishek, you were there, the expenses were 35 lakhs and we were just...
Agreed, sir. For sir, big institutions, big, I think it's okay. But again, then as a central committee, we cannot say no to one and say yes to one. I mean, for the GBM to decide, because that's something a big gamble, because if somebody is not able to return...
We can have the IRIA model because there are 4 CME. So whoever want to conduct the small CMEs, then the certain amount comes for that CME and there are certain rules. So that model can be followed here, because many state chapter, I raised this point in EC also, because many a times we get difficulty in getting the sponsorship. So this is, we can have a 2 or 3 CMEs which are, then certain amount can be given and the rest of the state has to bear.
I think
like IRIA model.
Sir, actually there should be two models. One for state chapter which have ISVIR state chapter. If that event is being done in collaboration with state chapter, then the state chapter can fund that event. But in state chapters where you don't have ISVIR state chapter, that can be considered for some seed money from national IR.
Sir, many times it can happen that state chapter may not support you because of the obvious, political reasons and political inclination. So I think, a central committee, central body should take care of that.
So I think if we start this, it will be so everyone possibly, there are so many conferences going on, it will be a huge burden for the society, and I in my personal capacity, I don't agree.
Yeah, and understand both the views actually, and it is good to give seed money. I'm wondering how the central committee will be able to handle this, like who to say yes and who to say no. It will be a big problem, and someone may see it as I have favored my friend. And
Sir, if I am allowed to speak for this, I think there are certain things which again comes with a lot of experience, and if we take an example of IRIA or ICRI, probably any person willing to collaborate and have such kind of things, there may be some named events, maybe, and that can be a totally ISVIR event. So that's not an endorsing thing. Then there may be some seed money, and as I understand and I know most of the society, the seed money is very small, maybe 50,000 to 2 lakhs is the seed money, which is not actually much for any hotel thing. So having said that, we have to take a pragmatic decision, and I agree with Arun sir for that what he has said is absolutely fine. So that will be a burden for the society, and sometimes, yes, I have a huge, respect for Dr. Puneet for putting this point. But, as Dr. Abhishek also pointed out, maybe sometimes there may be some problem, and financial problems will reflect on the central committee, whoever is in the office. So we need to take it in a very...
I feel this can be discussed further in one more meeting and then take a decision. And otherwise, see, for me, no problem. But the challenge will come to Dr. Amar Mukund and I can just say approve and go. But you people please discuss further and take a call.
I feel, sir, for big institutes it will not be a problem, but it will be very difficult for central committee to say no to a particular institute, and then if we don't get the funds back, sir, it will be a huge problem for us.
So that's what I said, that it should be communicated at least 2 or 3 months prior, and it should be, discussed with the executive committee, and then they can decide.
Yeah, point is well taken. Point is well taken. Since we have another 20 points to discuss.
Only one. If in such a case we can have something for the state chapters to be also done, probably central committee can help forming some guideline for the state chapters. Like he said, there may be some political thing. Probably state chapter is the best way to conduct such kind of events.
Thank you. Thank you. We'll move on to the next point. Ajit Yadav.
So, sir, it's about the active membership fees that we are taking 2,000 rupees every year, and it was started in 2017, and it's now 2025. There is so much of inflation. So, I think it's time to raise that, because we are giving ultimately this 2,000 rupees in form of registration refund to all the members who are attending the conference. So, it shows the seriousness of how much is an IR. So, maybe 2,000, 3,000, or 4,000, whatever it increase, but because according to inflation, we can have a rule, like we can say 3,000 onwards and 10% every year up to 5 years, and then we can again reassess, because we have to increase the fees so that can reflect the seriousness of the members.
Anyone would like to add to the same point?
I think the 5,000 amount, I feel a bit. 10% inflation, 10%? Okay. What's the amount now?
Treasurer.
I'll be happy. So just for understanding, look,